We are good to go.
Dr. Anjana Deshmukh is MBBS, MD Internal Medicine, Aurangabad, working as a consultant physician diabetologist at Dr. Hegdewar Hospital, Aurangabad since 30 years. Over to you, ma'am.
Yes. Good morning, everybody. First of all, I would like to thank the organizer for giving me an opportunity as a chairperson. As we have enjoyed yesterday's academic feast, today also, I am sure that today's opening batsman, Dr. Sanjay Gandhi sir, will also enlighten our difficult cases in management of diabetes, which are practical to us. Sir is MBBS and MD Internal Medicine in 1989. He is attached to Pune Hospital and Research Center, Pune, Sahyadri Hospital, Pune, and Sanjeevan Hospital, Pune. He is having a diabetes patient club in Pune since 2002, presently operating only Pune with more than 5,000 members catered for. The most economical comprehensive diabetes care in private sector, fees of rupees 750 annually. A1C club, which is every members get his HbA1c test free of cost quarterly in the year, 4 HbA1c tests in a year. Annual fees is just rupees 1,500 only. The programs are, presently he is conducting diabetes prevention program called Can I Get Diabetes for the non-diabetic relatives of the patients. Conducting a special activity picnic, Varsha Sahal, for diabetic patient with their family members for improving the lifestyle management of patient every year. Till now, more than 8 picnics arranged in and around Pune and Ahmednagar. We have started the diabetes and U program at his clinic also. So his special interests are economics of diabetes management in India, especially pumps and digital monitoring. Over to you, sir.
Thank you very much, madam. Good morning to all. Madam from Aurangabad has extensively introduced me. I'm really thankful for your words, madam. I shall be sharing my first slide. Is it visible? No.
No, sir.
No.
Wait a minute. I did something wrong. Share screen. Yeah. Is it visible now?
Yes, sir.
Yeah. So good morning to all. And I'm really thankful to Dr. Unnikrishnan sir, Dr. Veda Purandare, the all CDI team. I'm thankful to Dr. Anjana madam for my nice introduction. And I shall be a, opening batsman for today on the day 2nd of CDI 2022. And what I'm going to talk to you is about managing difficult cases in diabetes mellitus. Not it mean by I am an expert in managing diabetes. Not it mean that I can guide you on my management of diabetes, type 2 diabetes mellitus or type 1 diabetes mellitus for that matter. But this is what actually I experienced. This is what is my individual view. And this is actually our A1C club, which we make diabetes management easy. So these are my disclosures. Nothing financially, not attached to any pharma, not attached to any product. These are my real world cases, my own clinical experience. And it is not to criticize anyone, but it is what actually we have experienced during this COVID period, pre-COVID period. And that's why it is open for discussion, open for criticism, for healthy and joyful clinical practice. That is what we actually all mean for. And we mean for, and we do it for betterment of human life. So let me go to the agenda of today. My presentation would be based on 4 major aspects of diabetes mellitus management, type 2 diabetes mellitus and basal insulin. That is the first thing. High dose of insulin in type 2 diabetes mellitus, whenever we give, we must have a thought process in our mind exactly about what we are doing. So that is second part. Difficult type 1 diabetes mellitus patient, and thereby implicating the importance of insulin pump and monitoring for each of type 1 diabetes mellitus. And the last case for G6PD and sulfonylurea. So let me go to the first case, and it is actually the describing Indian scenario of slum diabetes millionaire. based on Slumdog Millionaire. We know that we are in post-COVID social status, and especially this case comes from 2020-21. We have already had a disturbed family and individual economics. Younger new onset of diabetes mellitus patients, whether it is related to COVID infection itself or unrelated or undiagnosed COVID infection. And obviously, all these were reluctant for hospitalization in spite of severe hyperglycemia. The causes for reluctance were obviously economics, obviously fear of COVID, and the family disturbances, obviously. Death of one of the member in the family also could be a reluctance for hospitalization for those patients in COVID era. So this is the first case. This is a real world case. A 42-year-old male seen by me on 19th of August 21 with weight loss, polyuria, polyphagia, and weakness just for 3 months. His father had expired because of diabetes. His BMI was 23, which was acceptable, He's a painter assistant because of the COVID. His painting job had gone, slum dweller, new onset of diabetes. He came to know about this because he went to a general practitioner for weight loss, and he came to know about the hemoglobin of 15.9, WBC normal 5500, and the fasting sugar of 426, PP sugar of 577, HbA1c of 14.9. Now this patient coming in OPD, and what all of we do and what do we do, what I did, we actually advised him obviously for hospitalization considering the dehydration status, the hemoglobin 15.9 plus the severe hyperglycemia. I was planning to give a insulin to him, but he was reluctant for hospitalization. Obviously, slum dweller, no insurance, fear of COVID, did not want to go to general hospital like Sassoon or Navle because of fear of COVID patients around the hospital. So we went on multi-prong approach, and more importantly, basal insulin was emphasized. He was taught about insulin technique, injection technique. His wife was taught about injection technique, and then obviously all our OHA, including sulfonylurea-glucoside, pioglitazone, metformin, everything was started because it was, I had actually taken in writing for him that he is not willing for hospitalization, probably for the legal purpose or whatever, in my OPD itself. So one more important thing I advised him was SMBG mandatory. I gave him a free glucometer, and he actually did regular monitoring of sugar and came down within, say, 6 months to 5.8 of HbA1c. Now this is his, actually the SMBG monitoring. I had advised him fasting pre-lunch and pre-dinner. I agree that this is not something magic I have done. But what I was trying to tell you is I was also in a panic with severe hyperglycemia, reluctance of hospitalization. Something happens to young man like this and out of job, what to do? And still we could manage it with SMBG emphasized and basal insulin and lifestyle modification at the first, actually, in this particular case. So this is another case in the similar line, real world case seen in May 21 with new onset of diabetes and fasting of 368, PP of 623. All of you should note the numbers, and A1C of 12.9. And obviously he also had weight loss of almost 6 kg. Family history was positive. BMI was little on higher side. He was driver by profession, but he lost his job. Like this, all Ola, Uber drivers, the school vehicle drivers, all they lost their job because of the COVID and the closure and lockdown and all that. Then he started vada pav, business, wife was making vada pav and he was selling it for, those who are on the road. But then even that did not work for financial reason for him. He was jobless. So all these, weight loss of 6 kg and all, with more important thing is this WBC was normal 9900, platelets were okay. Urine did not show any ketones, but sugar was 3+. Triglyceride was abnormal. Total cholesterol was normal. LDL was okay, and creat was normal. So this background of laboratory was there with me. Again, reluctance of hospitalization was there with me. No insurance, fear of COVID to go to any hospital or any other. Many of my colleagues and myself also was worried whenever new patient comes without any, not giving history of fever, whether he has had crocin or not, whether he himself is a COVID patient and what I will get from him. So all these things was there during that, the 2021. We again went for multi-prong approach. Basal insulin was the mainstay. Similar thing, pioglitazone and gliclazide and metformin and vildagliptin, multi-prong approach, and SMBG was made mandatory. And he also came down within 4 months to A1C of 6.7 and gained some weight, about 4 kg, and the sugar was okay. Now, the crux of telling you this all is the basal insulin in type 2 diabetes mellitus is very useful. It should be started early. It should be thought of. SMBG is important. That is my, say in this line. We also have a very peculiar thing in our India, poverty and still non-compliance, probably because of non-education. We have not taught our patients well about the insulin, about the regularity of monitoring or what. This lady, Nirmala, 46, roti maker. In Pune, there are many students. It's like Oxford of East. So many students are there. People make 700 and 400 rotis, chapatis in a day. And out of that, they earn their, bread and butter. And those chapatis are sold in many, even including Kirana shops. So such thing happens. And we all know this. We are not into the economics of India. So she was diagnosed as new onset of diabetes in 2017 with weight loss and all those symptoms with sugar of 341 and triglyceride of 555, the typical Indian the triglyceridemia. Again, reluctance of hospitalization, multi-pronged approach. But what happened? Within about 4 months, she came down to good control of sugar with, just simple OHs. But then she lost to follow-up. So poverty with non-compliance was there. And she reappeared in 2019, July, with 533 of sugar, A1C of 9.9, PP of 450, irregularity of medicine, again, reluctance of hospitalization, basal insulin was given, and then that took her down to normalcy within 6 months of 7.5 of A1C. What I want to emphasize out of 3 cases is only basal insulin emphasized early use in type 2 diabetes mellitus, and the importance of SMBG, spending time with the patient is important. So what lessons learned? Reality understanding, we need to understand the Indian scenario. It is not like Western world. For SCPs, we have to use basal insulin early. SMBG enforcement, SMBG teaching is very important. We need to spend time with the patient and more importantly, relatives as well. Quite often patient comes alone and we have told him everything, but he goes out of the clinic and forgets everything. And then the complications to the patient, acute complications do happen. For policymakers, it's so important that our all type 2 diabetes mellitus and including type 1 diabetes mellitus patients should receive free medicines. Glucometer should be free compulsorily. RSSDI has taken this initiative ahead. Dr. Bansi Sabu is actually very active on those lines. And education is important. Role of social media and TV. I want to see more ads of the glucometer and have you checked your sugar? What is your glycemic load? Rather than the Sunny Leone with some person or rather than pharmacy ad. I want to see the patient education ads between my major TRP programs on TV. This is my message. Now I am on the second part of my, the presentation. Whenever there is a high dose of insulin we give to type 2 diabetes mellitus patient, more than 1 unit per kg body weight per day, we have to think times. 10 times we have to think. 2 cases I shall be presenting. The first one is Mr. MM, whatever, I saw him in 2018, July, 38-year-old male, insurance surveyor by profession and Pune resident. He had diabetes since 2015. And at the diagnosis, his sugars were pretty high. He had jaundice history in 1996, pyelonephritis as a presenting symptom for diabetes mellitus, and family history was positive. More important is his treatment history. He went to Dr. A in Pune itself, and he received units 40 of Mixtard in the morning and 20 of Mixtard at night, but he still remained uncontrolled. Reasons unknown or multiple reasons could be there. He himself also could be the culprit for it. But then he went to another doctor, Dr. B. He gave Huminsulin 30/70, 90 units in the morning and 60 at night. This has been going on since January 2017. And I saw him in July 2018. Of course, gliclazide and metformin was going on. Actually, this person gained weight from 86 kg to 96 kg, then 98 kg from Jan 17 to July 18. What I am trying to mention here is young male with little higher BMI. We should think about number of units of insulin we are giving. BMI went to 33.91 and the sugars were still uncontrolled, 8.3. He had triglyceride up. And then what we did actually was we removed or slowly reduced his insulin doses, gave him GLP-1 RA, and the A1C was still 9.5. and the follow-up visits in 2019, 2020, and February 2021. You can see the person lost weight from 86 to 76.7 kg weight loss with good glycemia control, A1C of 7.9, though not very, at the target, but still, and only OHA was going on. Even the Victoza was, or rather I can say the GLP-1 RA also got stopped. Our patient did not accept it so well. What I want to emphasize by this case is whenever we give insulin, don't remain blind about it. Think of the dose of the insulin. Think of the weight gain as a side effect of insulin, especially in young type 2 diabetes mellitus patient. And these both Dr. A and Dr. B were very famous endocrinologists of Pune. I am not against anybody, but I want to emphasize, and this is teaching for myself also, to keep the thought process whenever the insulin dose is more than 1 unit per kg per day. Now, this is similar second case, came from Navi Mumbai to Pune to see me, maybe through one of the relatives, and he was seen on 18th of February 2019, 74 kg person. He again was on insulin of insulin 50, 40 units in the morning and 40 units at night. And obviously he had dyslipidemia, hypertension. So he was on all possible things like Olmazest and Jalra and Jardians and all these things. But still he was uncontrolled. His January 19 sugars were 340 of PP and A1C of 10.4. February, which he came with these sugars of fasting 260 and PP of 321 on insulin and all these things. But what was dangerous thing was, he is a civil engineer, he's a smoker, he's an alcohol user, his exercise was almost near nil, and his insulin dose was pretty high, 80 units per day. So that is what actually I want to emphasize here again, though a very simple message, but an important message. So we continued on OHA, antihypertensive, but reduced the insulin dose with greater emphasis on lifestyle modification. The sugars came down, A1C was 5.89, weight reduced from 74 to 70.6, insulin was slowly tapered, again emphasized, and cessation of alcohol and smoking was very emphasized, working style, exercise was emphasized, and he was off insulin in June 2021 with 69 kg of weight and HbA1c of 7.4. Again, I want to mention, and these are real world cases, these are my clinic cases, all hard documents and soft documents are available with this. What I mean, again, want to tell you, insulin dose in any type 2 diabetes mellitus patient, when goes above 1 unit per kg body weight, we have to think 10 times. I shall be going to this very important case of type 1 diabetes mellitus, Miss R, 12-year-old female, twice admitted in Pune hospital with DK and type 1 diabetes mellitus in May 2020, and then in August 2020 with COVID, DK and type 1 diabetes mellitus. She actually came in October 2020 with GAD 65 antibodies, more than 2000, obviously. Type 1 D-dimer was very high and she was 40 kg. Very surprisingly, I can tell you, her sugars were high. We repeated again and it came to 555 and she hardly dose of insulin. 1, 2, 2, and that we increased to 550. Lantus was there 3 units. We gave her Mixtards 8 units. Now, what I am trying to tell you here is 12-year-old female, 40 kg of weight and the insulin dose. And now with this increase in insulin, slight increase in insulin, she came down to 200 of sugar, 250 of sugar. But then we again went ahead to increase of insulin, but she used to get daily hypo from March 21. You can see here, all the hypo readings are there. And it was so difficult to manage. Yeah, I'm going a little fast now. The weight gain had happened from 40 kg to 49 kg. And here this patient actually should have received free insulin pump, which I could not give her. This is her yesterday's sugars. And you can see again the hypos continuously with just 3 units of Mixtard in the morning and 3 units of Mixtard in the night. And because yesterday, day before yesterday, she had 323 and 358, the dose was increased to 4. So such a brittle diabetes, type 1 diabetes mellitus patient should receive the insulin pump and insulin free with SMBG glucometer. Now, this is an important case. I brought it out from 2006 data. And this is a case who are admitted under my care in KEM Hospital, Pune from August 25th of August 2006 to 8th of September 2006. And he was discharged with 46-year-old male from Nasik. He was actually relative of my one of friend. Diabetes mellitus, hepatitis with G6PD deficiency. He was started on glimepiride, new onset of diabetes, but then this was the discharge medication. More importantly, he was thoroughly investigated in that KEM stay, and colloid liver scan actually did not have any evidence of chronic liver disease or fatty disease or cirrhosis. Gastroenterology reference was done. G6PD screening test was diet discoloration time 90 minutes, which was positive for G6PD deficiency. The further assay was not done. Thalassemia and all where studies were done. Now this important case actually implies that G6PD is there around and it affects quite good number of patients. And while using sulfonylurea, we should be very careful. All his hepatitis assay was done and was normal. Mitochondrial antibody was negative. All those things were done. But then later on, he was put on insulin, and these are the follow-up October sugars. Now, this is an old patient, but these are actually his LFT follow-up chart from 2006 August, 28 of bilirubin and 1330 of SGOT and 1617 of SGPT. And this is how the follow-up chart was done. PTINR was normal. So, the severe hemolytic jaundice with high direct bilirubin, G6PD on glimepiride. So this is what actually I wanted to emphasize. A slight small discussion on G6PD. G6PD deficiency is a rare X-linked enzymatic disorder affecting the red cells, and it affects 400 million people worldwide. It is commonly seen in Africa, Asia, Mediterranean, Middle East, and India and Asia. So associated with hemolysis because of reduction of the glutathione and leading to denaturation of hemoglobin in the setting of oxidative stress. Now this hemolysis is usually asymptomatic. And while using sulfonylurea, we should be very careful. It gives the load because of the destructed RBCs to reticuloendothelial macrophages in bone marrow, spleen, and liver. And the drugs which are very important for G6PD to avoid are sulfa drugs, antimalarials, and obviously the sulfonylurea. So this is what actually the case, though very old case, it makes a very important mark in my brain whenever I use sulfonylurea. So hemolysis is a known side effect of sulfonylurea, and it is reported only approximately in 1% of cases. Acute hemolytic anemia is a rare side effect of sulfonylurea, but we should remember about it. And thank you very much for your patient listening. Weekends are very beautiful because of CDI conference this time, but they don't last longer. And therefore, I request Dr. Unni to repeatedly make CDI part 1, CDI part 2 every quarter of the year. Thank you very much, all my friends, and I'm open for any question.
Thank you very much, sir. I think learning through case-based scenario is very important and helpful for physicians like us. And I think sir has done it very nicely. So it will be helpful in our managing day-to-day patients. So thank you very much, sir. Forum is open for questions. Anybody has question?
There are no more questions, I think, in the chat box.
Dr. Sanjay, I have one quick question as a physician. We very often see such patients very well explain that most important part is non-compliance and lifestyle management. Then comes the medications. One quick question, what really makes the physician look for glucose 6-phosphate dehydrogenase? Because usually we don't do the testing on a regular basis, right? So what should be the red flag which makes the physician think, okay, this person probably has G6PD deficiency?
No, I appreciate this question very much, but there is no clinical marker, or the person should just, we should remember that we have given sulfonylurea to this patient. If at all, anytime he develops jaundice or he develops, because it is asymptomatic hemolysis happening, any very good control of HbA1c itself is a very important marker for destruction of RBCs. Because of loss of hemoglobin, the HbA1c comes down from 14 to 7.5 within 1 month. And that should probably hit my head. I agree, nobody does the A1C within 1 month. But if the A1C is there in the past, maybe 2 months prior or otherwise, or even if within 3 months the HbA1c has come down very fast. The percentage of hemoglobin A1c coming down very fast is one of the laboratory marker. And obviously urine showing direct bilirubinemia, the bilirubin and if at all patient has got jaundice or you can see his yellow eyes, then only probably you can suspect it is a very rare incidence. It is one of the rare case. I have not yet reported it internationally, but worth reporting internationally.
Excellent clinical pearl, sir. Thank you so much.
Thank you, sir, for your excellent speech. And I thank you, Dr. Ranjana Deshmukh. And I would like to proceed ahead for our next lecture, What After GDM. And I would like to invite Dr. Tarun Mishra, which as a chairperson. Dr. Tarun Mishra is an MBBS, SS Medical College, Rewa MP, and MD, Barkul Ullah University, Bhopal. And DM in Endocrinology, LLRM Medical College, Meerut, UP, DNB in Endocrinology, SP, SGPGI, Lucknow, UP. He has working experience, work as a junior consultant in Indraprastha. He also won Best Speaker Award at national level by Endocrinology Society of in type 2 diabetes mellitus. His area of special interest is use of insulin pump therapy and CCMS diabetes. I would like to invite Dr. Tarun Mishra, and over to you, sir.
Thank you, Madam, for kind introduction, and thank you, Dr. Unnikrishnan. And topic is gestational diabetes, subsequent glucose intolerance, and coronary calcium score in clinical perspective. Women who have gestational diabetes are 40% more likely to develop coronary artery calcification later in life than those who have never had it, and attaining the normal glycemic levels does not diminish their lifetime risk of atherosclerotic cardiovascular disease. And women with gestational diabetes might have screening for cardiovascular risk factor every 5 to 7 years. Women with previous GDM may benefit from enhanced traditional cardiovascular risk factors like dyslipidemia, hypertension, and hyperinsulinemia. So I over to Dr. Beninu for your talk.
Thank you very much, Dr. Unnikrishnan and the Chalaram team, and congratulations for a wonderful conference. We know that GDM not only produces adverse effects in the mother and the fetus during pregnancy, but it also produces long-term problems like cardiovascular disease and type 2 diabetes in the future in the mother, and also produces issues in the child as well. This is the IDF Atlas 7 that was taken in 2014, and it shows that Southeast Asia, 1/4 of all births are affected by high blood glucose during pregnancy, which is very high compared to the global births, where 1 out of every 7 has GDM. And India has other challenges as well. You see that 50% of the Indian population is under the age of 25 and 65% of the Indian population under the age of 35, which means that India has a young population and the large number of women in the reproductive age. It's not only the population, but the maternal age is going up, and the prevalence of diabetes is coming down, and therefore we are going to see a lot of GDM in the future as well. Besides, of course, there is a question of accessibility to healthcare, which is not enough for the people, for the women with GDM. They also have less resources and they may not be able to follow the guidelines in all the pockets of India, leaving a problem with GDM management. As a result of GDM, women and their offspring confront a series of problems, including adverse maternal outcomes like miscarriage, stillbirth, increased risk of maternal hypertension, and preeclampsia during pregnancy, birth injury, and preterm delivery, and adverse neonatal outcomes like fetal death, spontaneous abortion, congenital malformations, fetal placental abnormalities, and altered fetal programming. But it also increases in the long term the risk of type 2 diabetes and cardiovascular disease in the mothers. It's not only that, maternal diabetes is also linked to offspring that develop obesity, diabetes, and of late there's new data showing there are also neurodegenerative and psychiatric diseases as well as low intellectual and verbal coefficients, language and motor impairments, attention deficit with hyperactivity disorders, and problems in psychosocial development in the offspring of these mothers who had GDM. There's a threefold increase in the risk of type 2 diabetes in women with the risk of GDM, and the yearly conversion is about 2 to 3%. The risk of metabolic syndrome in women with previous GDM is about 3 times when adjusted for age and BMI. But importantly, this is a message for today that vasculature of women with a prior case of GDM is permanently altered, predisposing them to cardiovascular disease. This was a Danish study in 241 women with previous diet-treated GDM between 1978 and 1985. And they followed up these women for 6 years after pregnancy. 18% developed diabetes and 17% developed pre-diabetes. They then followed up these women for 13 years later with a median of 19 years. And they found that 40% of the 151 participants had diabetes already, and 29% had pre-diabetes. Another cohort of 330 women who had GDM between 1987 and 1996 were followed up for a median of 7 years. And at the end of 7 years, they found that 41% had diabetes, 37 of them had type 2 diabetes, and 26% had pre-diabetes, meaning thereby that GDM predisposes a woman to have type 2 diabetes in the future. And in India, the risk is much higher. 50 to 70% develop type 2 diabetes in a short while, within 5 to 10 years. This is a WINGS database that IDF did in collaboration with the Diabetes Research Foundation in Chennai and also with Abbott Pharmaceuticals. And they found that at the end of 1 year, 1 out of 5 women develops glucose intolerance. I think this is very alarming news, because when they stratified them, they found that only 78.6% had normal glucose tolerance at the end of 1 year. 7.3% had isolated IFG, 6.3% had isolated IGT, and 2.9% had combined IFG and IGT, and 3.4% already had diabetes, giving a total of almost 20%. Further, we have Indian data, one from Pune, from Dr. Yagnik and Shaileja Kale, which shows that there's a high risk of diabetes and metabolic syndrome in Indian women with gestational diabetes mellitus. And this happens very quickly within 5 years of delivery. Another similar study in South Indian women coming from Karnataka by Gattu and all also says the same thing, that gestational diabetes and the incidence of diabetes in the 5 years following the index pregnancy in South Indian women is high. So there is a risk of GDM also in future pregnancies. So in the index pregnancy, if the mother has GDM, then in the first subsequent pregnancy, the chances are 40%. And in the second subsequent pregnancy, the chances of having GDM are 75%. But those who do not have GDM in this first pregnancy, their likelihood of getting GDM is much lower, around 21%. It's not only the hypoglycemia, but it is also the weight gain that happens during pregnancy and obesity before and after pregnancy. So you see, if the BMI is high in the first pregnancy, they have a lot of visceral fat, and there is a gestational weight gain which is out of proportion. And so when these women become pregnant for the second time, they already have an increased preconception BMI, they have an increased fat mass and visceral fat, which gives rise to the metabolic consequences of increased GDM, increased preeclampsia, and increased hypercholesterolemia. And more of the gestational weight gain is further retained. So later in life, in midlife, these women have increased BMI and increased liquid fat, which gives rise to increased risk of type 2 diabetes, increased risk of cardiovascular disease, and increased risk of metabolic syndrome. So you see the cardiometabolic implications of postpartum weight changes that happens in the first year of delivery has an adverse cardiometabolic profile as early as 1 year postpartum in women who do not lose weight between 3 and 12 months after delivery. This study was done by Sinan Q and also Ravi Ratnakaran from Canada. And you will see the adverse cardiometabolic risk factors here. The systolic blood pressure increases, the diastolic blood pressure increases, the HOMA-IR, as seen, all of this seen in the dark bars here, where the women had gestational diabetes. The HOMA-IR, the insulin resistance, increases markedly. The adiponectin goes down and it produces an adverse dyslipidemia. Just diabetes in pregnancy can also lead to a cycle of diabetes affecting the future generation. So you see a mother, pregnant woman with diabetes who has an infant or a daughter born will finally grow up to be a young woman with diabetes, and then she will be pregnant and the whole cycle continues again. That's because the fetus is bathed in a dysglycemic environment. And further, if it is a female fetus, then her ova are also bathed in this hyperglycemic environment, which changes the in utero programming. And in early life and adolescence, this girl who will become pregnant will give rise to further diabetes, a condition known as intergenerational programming and transmission of diabetes. So the first 9 months actually shape the rest of your life, and therefore it is important to take care of gestational diabetes and manage them well, or in the preconception stage itself. So we can do something for them. We can modify the risk factors by implementing measures like lifestyle changes and changing the diet, etc., so that we bring down the obesity and overweight, which is a very high risk factor for gestational diabetes and cardiovascular disease. Also, the excessive gestational weight gain. I think these women do not come for follow-up to the physician and the diabetologist. They actually go to the OBGY and finally are lost to follow-up, and then their weight gain keeps on increasing till they come to you next for their next baby. The westernized diet is well known to be actually high calorie dense, and that can give rise to obesity and also the chronic diseases, diabetes and cardiovascular disease. Genetic polymorphisms, advanced maternal age, and the intrauterine environment, whether it is low birth weight of the fetus or high birth weight, can also predispose women for future GDM, for future diabetes and cardiovascular disease. A family history and other diseases of insulin resistance, such as PCOS, is a high risk factor for GDM. The maternal hyperglycemia in GDM actually produces an abnormal metabolic risk profile, which actually you can see on the right-hand side, the beta cells, because of the hyperglycemic environment in the mother, increase the mass of the beta cells. This produces hyperinsulinemia even after delivery of the baby, and this hyperinsulinemia makes the woman susceptible to insulin resistance and also alters the signaling pathway to the skeletal muscles and subcutaneous adipose tissues, giving rise to insulin resistance and future diabetes. It is also the diet which is the risk factor for diabetes and cardiovascular disease. Being overweight and obese overwhelm the beta cell insulin production and insulin signaling pathways, and diet that are high in saturated fat, refined sugars increase the risk of GDM, while diets that are high in fiber, micronutrients, and polyunsaturated fats are consistently associated with a reduced risk of GDM and cardiovascular disease. Saturated fats directly interfere with signaling pathways. Processed meat could also be responsible. It gives rise to beta cell toxicity. And we know the amino acids which could be substrates for hepatic glucose production and hepatic lipotoxicity. So diet itself can induce inflammation and endothelial dysfunction, both of which are pathogenic factors for GDM. Besides, birth weight is also important in the pathogenesis of the risk factors for GDM and CVD. Low birth weight is often the result of undernutrition in the womb. The fetus thereby compensates for this undernutrition by altering the expression of genes in fat storage and energy utilization, and further association with a reduced beta cell mass. And these alterations persist even after birth, a phenomenon referred to as developmental programming, and contributes to the development of obesity, metabolic disease, and cardiovascular disease. On the other hand, overnutrition in the womb can result in fetal overgrowth and beta cell fatigue because of continuous hypoglycemia even before birth, predisposing them to hyperglycemia during times of later metabolic stress. So you can see these are the biomarkers there: subclinical inflammation like rise of CRP, rise of PI inhibitor, increase of interleukin-6, and low adiponectin produce vascular dysfunction in women with gestational diabetes, which can be permanent and produce cardiovascular disease in the future. This is a hospital database which recorded more than 1 million deliveries in 2007 and 2008. And among these, 62,000 women almost had a history of GDM. And they found that after adjusting for age, diabetes, obesity, and hypertensive disorders in pregnancy, GDM was associated significantly with a higher risk of CVD. You can see the odds ratio 1.25, with angina pectoris an odds ratio of 1.9, and hypertension at an odds ratio of 2.7. So a history of gestational diabetes can give rise to early cardiovascular events in women, and the study showed this for the first time, that GDM is an independent risk factor for cardiovascular disease in the 7 years following delivery. And therefore, it suggests that we have to have effective management strategies of the risk factors earlier in these women to avoid this. The cardiac study, which was presented in February 21, just last year, it was basically designed to examine the development and determinants of clinical and subclinical cardiovascular disease and their risk factors. And they found in the cardiac study that gestational diabetes history and glucose tolerance after pregnancy was associated with coronary artery calcium in women during midlife. And you can see from this graph, on the y-axis is the probability of the woman being free of coronary artery calcification, and on the x-axis you have the number of years after the birth, first birth, and you see the various shades there in the graph. The gray shades, which are lined and dotted and also dashed, are the women who did not have GDM, but they became pre-diabetic and later diabetic, and you will see that they had a greater probability of being free from coronary artery calcification, while those women who were, you can see the graph red in color, who had GDM, even if they became normoglycemic after delivery and had pre-diabetes or had incident diabetes, they had a greater probability of having coronary artery calcification in the future. And this study was done for almost 20 years, which means that midlife atherosclerotic cardiovascular risk among women with previous gestational diabetes is not diminished by attaining normoglycemia. Another study, the reaction study, also reiterated the same and said that women with gestational hyperglycemia are more likely to develop diabetes and cardiovascular disease with the odds ratio of 2.5 and 1.9 respectively. And importantly, they also found that even without progressing to type 2 diabetes, gestational hyperglycemia was associated with an increased risk of cardiovascular disease. It not only, this problems are not only seen in the mother, but also in the offspring. So maternal diabetes during pregnancy can give rise to early onset of cardiovascular disease in the children born from these mothers. This is a population-based cohort study with 40 years of follow-up, and you can see the graph here going up in those who are exposed, in the children who were exposed to hypoglycemia or the mothers had GDM compared to the children who were born to the mothers who did not have GDM. You see that the graph is much steeper in the ones who are exposed, and on the y-axis you can see cumulative incidence of early onset CVD in the offspring, and that is very alarming because they can have actually cardiovascular disease pretty early as young adults, as you can see the graph going very steep after the age of 35. Now this study also showed that in the offspring, the heart disease or the cardiovascular disease was particularly heart failure, hypertensive disease, deep vein thrombosis, and pulmonary embolism. And the increased rates were more pronounced among offspring of mothers with diabetic complications. It's not only glycemia, but if the mother has hypertension during pregnancy, then this translates to also hypertension in future after the delivery of the baby, because hypertensive disorders of pregnancy herald a syndrome of accelerated cardiovascular aging, and you can see here coronary artery disease, heart failure, aortic stenosis, mitral regurgitation can be higher in the women who had hypertension during pregnancy. But there's a silver lining to the dark cloud. Higher intensity of lactation was associated with improved fasting glucose and lower insulin levels at 6 to 9 weeks postpartum. So lactation has a favorable effect on glucose metabolism and insulin sensitivity, and that may reduce the diabetes risk after GDM pregnancy. Another study, the Finnish Gestational Prevention Study or the RADIAL study, also concludes that if there is a moderate individualized lifestyle intervention, it can reduce the incidence of GDM by 39% in high-risk pregnant women. And these findings may have a major health consequence for both the mother and the child. So you see, GDM has a marked impact on the future health of both mother and offspring. The prevalence of GDM is increasing in most population, and it is very likely that GDM plays a significant role in the global diabetes epidemic, because it is GDM that begets diabetes and cardiovascular disease. And hence, effective intervention strategies and screening post-delivery is very important. It should be implemented. All the risks have to be looked after, whether they're individual risk factors, also socio-economic risk factors, or environmental risk factors for prevention of the short-term complications during pregnancy and immediate delivery, and the long-term complications in the mother and the fetus, and also reduce the metabolic derangements in the mother after delivery. Every baby deserves a healthy mother for a long term. Thank you very much.
Hello, can you hear me? Dr. Tarun, would you like to ask the questions from the chat box so ma'am can address them?
Thanks, Dr. Beni Nagul, for excellent presentation. One question, I want one question, ask one question. What should be the screening strategy for the cardiovascular risk factor for women who have history of gestational diabetes? As mentioned, hyperinsulinemia, dyslipidemia, other cardiovascular. How frequently it should be done? What should be the guideline for screening strategy for cardiovascular disease screening?
Basically, after the mother gets GDM, we have to see or look at the risk factors of cardiovascular disease. And the most important, which I feel is relevant today, is the maternal weight gain that happens during pregnancy. Unfortunately, the women are actually lost to follow-up, and they do not come to us so frequently. They go to the pediatrician, they are busy with the child, and therefore we cannot implement lifestyle changes. And this continues, the insulin resistance that happens during the pregnancy continues, and then it may give rise to risk factors. They might come to us with pre-diabetes or diabetes. That's the time it is too late. But we can also look for dyslipidemia. We can look for the other risk factors of heart disease, and basically do a coronary artery scope. If you can do a coronary angiography, coronary CT scan, a CT angiography, you can pick up the calcium score in these women. That would be the earliest test that we can do to look for cardiovascular disease. If the score is 0, that means this woman is free of coronary artery calcium. But if the score is increased, then we have to implement actually the treatment, or maybe she might require intervention. But in my practice, I have seen very few women with cardiovascular disease, and the most commonly seen is not actually coronary artery, but it is heart failure. So I see a lot of patients with heart failure, say 10 years down the line. In fact, even in general diabetes, we see women more with heart failure than coronary artery disease. I'm sure that is, I don't know about your experience, but we tend to neglect that heart failure. You do echocardiogram, CT angiography, and also you can do the carotid intima medial thickness to actually find out whether they have cardiovascular disease. Besides looking at the risk factors like hypertension and.
Thanks, madam, for nice presentation. The topic is open for other questions and comment for audience participants.
I believe Dr. Sanjay Gandhi has a question now. Sir, please go.
Well, yeah, thank you very much for opportunity to ask a question for Dr. Beni Nagul, madam. My thought is we have now understood that the severe risk for the mother as well as the offspring will increase by his age of 30, 35 and all through the cardiac study. But then how do we prepare in a preconceptional phase to those mothers, to be mothers? Apart from PCOD patients, those normal female who have family history of diabetes mellitus, say parents or anybody, should we prime them about or giving information to them about the hyperglycemia, about the diabetes? How do we prepare them?
Actually, really speaking, you don't really wait for preconception. In my practice, any woman who comes in the reproductive age, and that reproductive age can be any time post-menarche, and it could be till menopause, that is 51. And if they're married, at least in our country, they're likely to get pregnant anytime. So at that time only, if there's a woman patient coming to us, we have to start preparing them and tell them that in case you are trying to get pregnant, then please do the preconception protocol that is given by the ADA guidelines. Basically, 90% of the pregnancies are unplanned everywhere. It's a global thing. So therefore, you start preparing, look for thyroid, dyslipidemia, and most importantly, I feel in my practice, weight gain. If we can reduce the weight gain and obesity and overweight in these patients and then prepare them for pregnancy in the preconception stage, I think it will give a good result. Also look at the vital parameters, blood pressure, and even pre-diabetes. Sometimes we may not pick up the pre-diabetes in these women. And the other risk factors, especially if there's a family history of ischemic heart disease and hypertension, it would be worthwhile to do their electrocardiography. Basically, you also look for thyroid in the pre-pregnancy planning stage itself, because all these are metabolic derangements, and all metabolic derangements can give rise to risk factor of hypoglycemia in pregnancy.
Okay. Thank you, madam.
Thank you. If there are no further questions, we'll go ahead and move on to the next session. We will be talking about...
Thank you very much.
Thank you, ma'am.
Thank you so
for your time. Thank you, Dr. Tarun. Let's move on to the next session. This is going to be about the clinical perspectives about the digital diabetology. I would like to introduce our chairperson, Dr. Ganesh Javalikar. He's a principal consultant at Max Healthcare, Sanket and Gorgon, and he's a secretary treasurer in ISPAE and Pediatric and Adolescent Endocrine Chapter. He is also an associate editor for GPED newsletter. We would like to also introduce our next chairperson. Welcome again, Dr. Sanjay Gandhi. He is an internal medicine physician who does an excellent comprehensive diabetes care. And he is presently conducting several programs, including diabetes prevention program called Can I Get Diabetes for the non-diabetic relatives of the patients. He's also conducting a special activity picnic for diabetic patients, their families, to bring more importance to the diabetes care. So without further ado, we would like to ask the chairpersons to introduce our next speaker, Dr. Dab Gohan, please.
Very good morning to everybody. And I'm really happy to be here for this fantastic session. Good morning, Professor Cohen. I'm meeting you after 2019 Kolkata meeting, although virtually. And it's a privilege to introduce you to our esteemed audience. So we all know that the insulin pump therapy is evolving, and we now also are having access to the hybrid closed loop pump in India. And it would be really interesting to hear from Professor Cohen, who is a professor of medicine at Tel Aviv School of Medicine, and he's also the medical affairs director for Global Medtronic Diabetes. And he will be speaking to us on automating insulin pump therapy to improve patient care. Over to you, Professor Cohen.
And thank you for joining me today in this summit to discuss automating insulin therapy to improve patients' care. My name is Professor Ohad Cohen. I'm a professor of endocrinology and internal medicine at the Sheba Medical Center, and also serve as the Global Senior Medical Affairs Director for Medtronic Diabetes. Now, technology has completely changed the way we treat type 1 diabetes. If I had to summarize this in 3 sentences, I would say 1, the role of all, the person with diabetes, the HCP on those who are treating the person with diabetes, and the whole concept, nurses, educators, their role is changing. It's diminishing in the way that they treat the glucose, but now they can also spend more time on treating the person. The second important change is the increasing role of mathematics, algorithms, machine learning, and artificial intelligence in the treatment of the glucose of those with type 1 diabetes. And the most important third change is we go now from being unable to reach the goals in the majority of patients to succeeding in getting to the goals of the therapy in the majority of those with type 1 diabetes, which is the major change. Now, what was the situation before automation? We all know, we all are aware of the challenges of treating diabetes type 1. How do we know? We look at the outcomes from many countries who have no issues of reimbursement, who can cover for many types of insulins and many types of monitors. We can see that in Norway, less than 22% of those with type 1 diabetes reach the glycemic goals. In the UK, 15%, Italy, 30%. So the majority are still not in good control. Now, why are we not succeeding in getting to the control we want with those with type 1 diabetes? Well, there are many reasons, but I think the most important reason from a therapeutic point of view is that we are trying to treat a disease of tomorrow or the glycemic control of tomorrow according to what we have learned in the past. Now, since every day is different and the changing lifestyle, the changing events of a day makes every day unique, it's hard to treat the same way different days. Now, this has all changed when algorithms are taking control of the glycemic of the treatment of glycemia. As you can see here, with the Mellitus 780, the basal rate is changing not according to what happened yesterday, but according to the dynamics of the glycemia every 5 minutes, according to a controller or a control theory called PID, but also takes into account many other factors to provide a more stable glucose while the insulin is changing every 5 minutes to adapt. Now, it's important to understand that this control mechanism is general for all those who are using this device. But every 24 hours, the limits and there's adjustments that are done that are personal to that specific user. And this is done automatically every 24 hours. So we have a basal rate, which is determined by an algorithm, which then goes into specific adaptation every day according to the specific characteristic of the user. On top of automating the basal rate, the 780 system also automatically provides correction boluses. These correction boluses are also mimicking physiology by being provided very early in small doses once the glycemic level is just above the target that is provided to that specific user. Now, these correction boluses are not just done by simple calculation. They also go through what we call a simulation phase. This simulation phase looks at what will happen or what is predicted to happen once this small correction bolus is provided to the user. And this is looked in the future window of 2 hours. Now, even during this window of 2 hours, it is predicted that the glycemia will go below a certain threshold. This correction bolus will be lessened, will be cut off a bit in order to provide the most appropriate amount of correction boluses. And not only the correction bolus goes through this simulation mode, also the meal boluses go through a simulation mode. And that is the device or the algorithm simulates what will happen in a window of 4 hours after a meal bolus is provided. And in case that this meal bolus is predicted to cause hypoglycemia in the future, it will be also cut down, so it will be very safe, but also not lose the effectiveness. Now, I cannot go more deeper in this short time into the algorithm, but you really understand that this such level of therapy, which is intended to provide the right amount of insulin at the right time, done every 5 minutes with simulations, which takes nanoseconds for the algorithm to do, but for us as healthcare professionals and for those who are using it, it's actually impossible to compete. So how do we know? What's the data to show that actually these systems work as good as I predicted they will do? Well, we have robust data for many inputs. As we see here, devices, before they go into the commercial world, before patients are using it on a regular basis, they go through in silico modeling, which is, in other words, a clinical trial with virtual patients. Their algorithm is optimized and run before it's being utilized in the first person. Now, after the in silico modeling, it goes to a short pivotal study to provide evidence that the algorithm or the prediction or the in silico model actually imitates what's happening in human physiology. So small number of patients who are using it for a short time just to get the proof of concept that things are actually work according to the model. Then it goes into the real world, and since users' data can be provided in a seamless way and gathered to analyze the real world data, we can also have data from real world users in numbers that provide a clear picture and a robust picture of the advantages or the accomplishment of using this device. So if you can see this, what's interesting in this picture is that almost all the three outcomes coming from different ways of looking at data and looking at the device achievement are actually very, very similar. And not only similar, very good results in having most of the users reach the glycemic goals. How do we see this? In a presentation from the different timing ranges, we can see that both in silico, pivotal, and the real-world evidence, more than or close to 75% and above the time of the day, the users will be spending their time in the correct range of 70 to 180. The GMI, or an estimated A1C, we can see that it is also below 7, 6.6 in the in silico model, 7 in the pivotal study, and real world is actually even closer to the silico model with a GMI of 6.8, and this is for 4,120 patients. Now, these achievement, it must be mentioned, is achieved with very little hypoglycemia, much less than the accepted consensus of less than 4% of time spent below 70, 2% below 70, 0.5 below 54 in the real world data. Now, further robustness of the data comes from when you increase the population who is using it. So we see this real world evidence from 4,120. Lately, we did another additional analysis from Europe, from over 16 countries, with a huge amount of information from 12,870 patients. This data provides another proof of the robustness of the device. Here, 12,870 users reached a GMI very similar to the first 4,120 of a 6.8%. 75.8% of the time are spent in range, but most importantly is the achievement in the percentage of those who reach the goals. Remember that only 25 or 30% reach the goals before using technology? Using technology reverses the picture. 75% now reach the goal, and only the minority, 25%, do not reach. And those who do not reach the control are very, very close to the goals. So 75% reach a GMI of less than 7. 75.4% reach a time in range of more than 70% of between 70 and 180. 83% reach the target of having less than 4% time below 70. And here you can see also the combinations. So first of all, we see that there's robust data to show that actually the device used in human practice mimics the virtual patients. How about consistency? Does it only work in certain areas, in certain geographies? Here we say two important data points. One, that if you look according to the countries that has been using this in the last almost 2 years, we can see a very consistent results or outcome in different countries, different reimbursement system, different medical systems, and so on. We can see that all the countries, the time in range is above the target of 70%, very low time spent in hypoglycemia, and a GMI of almost constantly between 6.8, 6.7, all of them less than 7%. And this is with big numbers. But is this also consistent with time? We're able to follow 2,566 users over 6-month period, very stable. So it's not a phenomenon of a new device. Those who are using it are taking more care of their glycemic control, more care of their diabetes. Actually, since it's an algorithm-driven therapy, it doesn't change with the time, and it's consistent. Now, is it consistent also in children? Remember, we always say that children are more difficult to treat because they're less predictive. It's harder to predict their behavior, their meal patterns, maybe androgens, beginning of the menstrual cycle. Maybe there's endocrine issues that might cause that the diabetes will be less stable. And it was always accepted that children usually have higher glycemia than the adults. And some of the associations actually considered different targets for children versus adults. Now, since the algorithm does not know if it treats a child or an adult, we are not then surprised that if you look at this real-world evidence of the 12,870, some of the users actually provide information about their age. And it is here we see the analysis according to the split of below 15 and above 15. And what is very interesting is that the outcomes are very similar in both age groups. So this famous concept that in the age of 15, you have the peak of the A1C according to the type 1 exchange and looking at other cohorts of people of type 1 diabetes, always providing this kind of a peak at the adolescent age. This peak is no longer a must when a technological algorithm leads the therapy. Same as goes to the achievement. The high achievement rate that in the total population of 75%, if you split it between the age, you see very similar results. So maybe slightly less in those less than 15, maybe because they are less predictive, but we can see that this huge success of 75.3% reaching a GMI of less than 7, almost 70% reaching a time in range of 70 is maintained in a different age, even though there is a slight less a percentage of those who are reaching time below range of less than 4%. So overall, very similar results between the age groups. But how does the automation does it? What's the trick? How come when the technology takes over, you get better results? This is a very interesting point that I would just want to mention briefly. Well, interestingly, the more technology takes over the control, that means more insulin is given by the algorithm and less provided by boluses that are announced by the users, the better control. And when the partitioning between what is given as basal versus what is given as bolus gets closer to the physiological 50-50, the control is better. And this is provided by the algorithm, as we can see here. If you look at those who are younger than 15, usually, and this is a global phenomena, the insulin program or the insulin prescription usually shows that the 40% is given as basal and 60% is provided by the user as boluses. In the adults, usually it's the opposite. More is given in the basal, or it's close to 50-50. In this case, we can see 48% given as basal and the 52% given as boluses. So there's differences in the way we as physicians, nurses, and educators treat the different age groups. Now, when the technology takes over, you see that these differences are no longer that apparent. You see an increased use of the automated basal and auto corrections given by the automation increases to 54%. So it's closer to the 50-50 split. The same with the adults, 60-40% now. Given 40% is given by the manual, or not the manual, by the patient given or boluses. Do we have specific examples from areas in the world? Many, but I will only mention two because it shows two different age groups. We have a very nice papers and that summarize the experience in Spain by Professor Pilar. She's showing her experience of 52 users who were transitioning from a suspend before low automated system, the Millimed 640G, to the Millimed 780G, showing a very impressive achievement of 80% time in range and a GMI of 6.6 and a A1C, which you see it's not the same, very similar, of 6.7, all way between the target of goal of the people with diabetes. On the other, in another region, this is from Sidra in Qatar, in Doha. Sidra's, the results here on adolescents, where transitioning not from a device, but from MDI, from multiple daily injections, to the 780. And in 3 months, a huge increase in the time in range from 42 to 78.8, with a reduction of GMI to 6.6, was presented by Professor Gohan Petrovsky, who is treating these patients and has presented and published in many papers. What's very interesting, when you follow the patients with type 1 diabetes, the adolescents, from the Sidra Medical Center, you can follow the path of technology and how technology step by step increases the outcomes, improves the outcomes, from MDI with 42.1% time in range to sensor augmented pumps increasing to 53.7, and then goes up to 80.2% 2% time in range in a very short period. So after at least, after just 1 month, they reached these high goals of time in range. But what's important is very, very low time spent in hypoglycemia. Can we get better results? How do we get to the better results? Here, I just want to tell you that, you know, to get the optimal results, there are two important predictors from those who are using the MiniMed 780G. One, it has to do with the user behavior, and the other has to do with how the pumps are set. So we can see that on the 12,870 patients, those who are bolusing 5 to 6 times a day, that means they are really announcing their meals before they eat. They get a slightly better than the average of the users. So we look at 2,500 patients with their bolusing 5 to 6 times a day. We can see that the time in range increases to 76.5, and almost 80% reach the goals. The HCP, the nurse, the educator, role is to provide the optimal settings on the device. Now, if you use the optimal settings, in this case, in this device, it's a target of 100 milligrams per deciliter and an active insulin time of 2 hours. When you use these optimal settings, you reach time in range of 80.7, and already 93% reach a GMI of less than 7, and over 90% reach a time in range above 70. Now, if you combine all these good behaviors and look at those who do both, bolus before meals and use the optimal settings, then you get to an incredible number of 81.6% time in range, low hypoglycemia, but look at the achievement. 97% reach a GMI of less than 7, 94% reach a time in range above 70. That means almost, let's say, practically all those who are using the system in the right way reach the goals that we want to have in people with type 1 diabetes. There's going to be a very interesting presentation showing how good does using 780 in those who are failing MDI is in a randomized control study. This was called the ADAPT study. It has just finished. We've just summarized the data, and this will be presented in the March ATTD meeting in Barcelona, in April meeting in Barcelona. So stay tuned to see what is the magnitude of this improvement in a randomized control study. And with this, I want to thank you all for attending and have a rest of a conference, a successful one and an interesting one. Thank you.
Thank you, sir. So any questions from chairpersons to the speaker?
So I think Dr. Gandhi, would you like to take over, or would you like to ask?
Professor Cohen, actually, it was a fantastic presentation. We saw that after using the optimal settings and the boluses, the TI or the time in range was achieving up to 81% and odd. But seeing all this, I, as an Indian physician, and I was almost always interested in the economics of the pumps and the digital monitoring and the AGMs. I feel pain that my type 1 patient in India are only looking at those results, but are not achieving even the 10% of it. So can I ask your plan for Indian type 1, any special plan?
So this is a tough question, and we all know, we all face the prices and the issues of the economics. So from a health economic perspective, the study that I've just discussed at the end of the of my talk wanted to show what is the magnitude of this change, and to change it into investment and health economics. How is it worth the investment to get this a high reduction from 8 to what we call the goals? What is the health implications? And now each region, Each country has to do the calculation how much they are spending to get these results. Now, it's important that, in economies struggling like in India, there needs to be two things. There has to be a prioritization and your decision on where to spend most of all. We just heard the important story of how important is early age hyperglycemia. Maybe start with the children, find out what you can, and start saving as much as you can. That's the situation. So first of all, we provide your physicians and you all the information there is. You cannot be, not knowledgeable, because you're very knowledgeable, and the fact that you're knowledgeable does provide some kind of, I would say, frustration that you cannot reach these goals with your patients, and I fully understand. We bring the data, and for the rest of and even the economic data, the rest is now up to you and your people in Medtronic in India to discuss how you can continue, prioritize, and find ways to at least access some of the patients some of the time, because every patient you provide this good control will have a tremendous effect of the rest of his life.
So, Dr. Abhijit, I think, has asked about what is the cost of device in India. So there's a lot of questions pertaining to the cost. I think it has been priced a little more than what 640G is as of now. It is priced between 600 to 650,000 rupees. That is 6 to 6.5 lakh rupees, if I'm not wrong. I'm not sure if the cost includes the CGM device cost also, or whether it doesn't. The question that I wanted to ask Professor Cohen is with regards to hypoglycemia. I mean, what advantage does hybrid closed loop therapy offer with respect to hypoglycemia compared to a sensor augmented pump therapy?
So it's a different philosophy. The sensor augmented pump therapy, what does it does? It takes the program of the basal rate that we provide as physicians and health care and shuts it down when there's a predicted hypoglycemia. Now, remember, not all of predicted hypoglycemia end in hypoglycemia. So sometimes we shut this down, not when it's supposed to be shut down, and the result is we don't have hypoglycemia, but then we have a slight post-hyperglycemia. Having these two concepts now change into that there's no basal rate. Now, the 780 and the 670 have no basal rates. So the basal rate is not shut down and turned on, it's turned on and off, or provided according to the dynamics all the time. So it's a different philosophy, which provides for a safe, even slightly even safer reduction of a hypoglycemia, but on the other hand, also cutting the hyperglycemia. Again, so you get even more protection of hypoglycemia, but most of all, you also reduce the hyperglycemia.
Yeah, that advantage is very clearly illustrated in all your slides. The second question which I wanted to ask is, like, right now, whether we are using basal bolus or whether you're using conventional pumps, we have to kind of keep on reviewing the basal rates and adjusting the basal rates. So how does it work in hybrid closed loop? You set some initial basal rates, and then the system calculates or system predicts the basal rates. But then does that mean that we don't have to review the basal rates at all forever, as long as the patient is using the hybrid closed loop?
95%, you're right. So the new algorithms are very robust by the way that when you use it correctly, it's 95% you'll read automation. Only 5% you're transitioning to open loop. So the way that you fine tune the basal rate is less important because only 4%. So first of all, it's less of a problem than other or previous algorithms used in other pumps. Number two, when you do use the automated insulin delivery, it actually helps you to figure out what is the right total daily dose. So you can always look at the total daily dose, you can cut it by half and do a simple one basal rate and just revise it once every, I would say, half a year for the children and after 1 year for the adults, but it'll be much easier. So it's not going to be very complicated. By the way, in the future, this also might be done automatically without even human touch, we call it. It can do it using the cloud and all these, but this is a regulatory issue that you'll be able to have the correct settings provided straight to the pump from the cloud. It's for the regulators, they're afraid of this. Oh, what's going to happen? No doctors always, the cloud is going to treat our patients now. So this is very interesting from a technical, it's possible, but from us, from practical, just easy. Look at the total daily dose, half the amount, give it and divide by 24 hours and give it as a single basal. It's only going to be used very seldomly.
There's a question in the chat box by Dr. Das that what's the evidence of use of hybrid closed loop or 780G pump in type 2 diabetes? Or what is the practice, or what is the...
So Dr. Gandhi discussed the economics. Now, type 2, where the economics is shoots through the roof, then we have to be very careful who we choose. So we are now, there's actually just started a study in the US for type 2 because it's reimbursed there for type 2. That probably, what's the best opportunity to treat users with the closed loop? I would say start with type 1, start in the women, that start with children. Type 2 is very interesting, but I think it's going to be for a low numbers and has to be thought more carefully because of the health economics. And I will say another thing. Type 1 is insulin replacement. That's the rule. That's what we have to do. We have to replace insulin in the most physiological way. Type 2, the whole meeting is a lot to do with type 2. There's a lot of other things to treat type 2, because even if you treat the glycemia in type 2, you still have the cardiovascular, the obesity, the hypertension, the many other aspects that medication is now taking care of it even more. So where to invest? Start with really what's burning, and then we have other things to worry. So theoretically, there's a study going on. Would I say in India where to put where really to put the emphasis? I would say in the most vulnerable type 1s in the country at this stage.
Professor Cohen, I would ask you a simple question. We are aware about type 1 almost getting abolished with insulin replacement through implanted beta cells or artificial pancreas and kind of thing. Do you have any plan of refurbished insulin pumps to be transported from Western world, getting refurbished in Medtronics itself and used in India? Can we have some such trial?
First of all, I'm not the person. It's a regulatory question. It's a great idea, which I believe. I think there's some even regulatory issues in India not to go with refurbished devices as a principle. So there's a lot of issue to do with internal Indian regulatory processes to allow this. But maybe these are some of the ways. But I know that there is a reluctance to do this as from a national approach, which I understand. Why should you also only be refurbished? But this is something that has to be done not from a clinical or medical affairs director, but somebody with more regulatory and governmental affairs discussion.
Okay. Thank you. I think we are completely running out of time. So, yes. Dr. Shraddha, wonderful lecture, Dr. Cohen, great insights by all our chairs and all our panelists. Over to Dr. Shraddha Lumpatki for taking the next session forward. Wonderful lecture, Dr. Cohen.
Thank you, organizers.
Dr. Cohen, for such a wonderful lecture. Thank you, our speakers, for giving your time. So, we moving ahead towards the next session, which is on comprehensive cardio-renal protection. I would like to invite our chairperson, Dr. Anu Gaikwad, to chair the session. Dr. Anu Gaikwad is a MD Medicine from BG Medical College, Pune. She is director of Gaikwad Diabetes Center, Bhosri. She is diabetic chairperson, Lions Club International. She is a senior consultant in diabetes and medicine at Accord Saint Hospital. So over to you, ma'am. Please introduce the speaker.
Good morning. I'm Dr. Anu Gaikwad. I'm very happy to introduce a very senior person and dynamic person in diabetology, not only in India, but all over the world, Dr. Shailaja Kale Madam. She is a MD FRCP and concerned diabetologist in Pune. She is a director for the conferences, various conferences. She has a faculty at European Society of Cardiology also, and joint secretary for RSSDI, member of Advisory Board of Diabetes in Pregnancy Group India, Advisory Board for Obesity Guidelines for India, and regional convener and national faculty for postgraduate courses in diabetology various. Overall, she is a very excellent and eminent speaker and a good teacher to teach diabetology for the newcomers also and for the persons who are practicing in diabetes. So over to you, ma'am, Dr. Shailaja, ma'am.
Yes, thank you so much, Dr. Anu Gaikwad.
Thank you, ma'am.
So I will just share my screen. I'm just minimizing the video so that I can see my slides. So congratulations, the whole Chelaram Diabetes team and Dr. Unni for a successful and very interesting conference going on for last 2 days. Yesterday and today also, I think there is a lot of good. I just heard the talk, Dr. Very good questions from Dr. Sanjay. I think it is very important for us to have cheaper pumps, which is so important. So I think, Dr. Gandhi, you should come out with something. We use it. I have a job to do for next 15 to 20 minutes about using this approach of type 2 diabetic person sits in front of us and we start writing prescription. Age-old guidelines was first jolted in 2019 by EAC, European Society of Cardiology, where they first time said that you may not use metformin as a first-line agent. That was a very big thing. So pendulum was not swinging away from metformin, but it was swinging away definitely from metformin monotherapy. I remember the jam-packed session in EAC in 2019 in Paris. So a lot of EASD people were not willing to accept that. But now, 3 years down the line, after 2019, we know that is true. So 2019, I think first time EAC said, if there is a patient has a high cardiovascular risk, atherosclerotic cardiovascular disease, one can use SGLT2 inhibitor as a monotherapy. And that was a big debate went on there, but there was so much of evidence that time. So I think EAC was the first one to come out to change this concept that I may not use metformin for this patient, but I will only use SGLT2 inhibitor. Now, after 2019, so many things have happened. We have all SGLT2 inhibitors used in non-diabetic patients, which they are helping this cardio-renal centric approach. So definitely now we are using it, but I remember this 2019 when the first time EAC and then it was also EAC, EASD together session where they said that we can use SGLT2 inhibitors as a first line agent as a monotherapy for a type 2 diabetic patient with high CV risk. Also patients of drug 9 as well as on metformin treated patients. So the first choice was given to the SGLT2 inhibitor because of so much of evidence and also GLP-1 receptor agonist. And even after that, now we all know there is an individualized choice for everything. So that patient sitting giving metformin, but you are justified that if I just write on canagliflozin to a patient who has a high CV risk is justified even by guidelines. After 2019, 2021, and this year, 2022 American Diabetes Association guidelines, they are saying that is 2022 Standards of Medical Care by ADA has also accepted this. As soon as patient sits in front of me, I have to say whether ASCVD yes or no first. Then I can think of what I will write in my prescription. So if there is ASCVD yes, then there is a cardiovascular risk very high. If it is ASCVD no, there is no kind of evidence of atherosclerotic cardiovascular disease, then I need to do very aggressive cardiovascular risk assessment. Not only that, so 2019, we are more wiser now. which we are saying now, it's not only ASCVD risk, yes, no, which is again we all are doing, but it is also important to stage my patient's GFR and proteinuria and see where there is a renal function staging. So these two things are crucial when I start writing my prescription for a type 2 diabetic patient. So what is the cardiovascular risk and where do my patient's GFR and protein in the urine make my patient in that KDIGO guidelines, where do my patient fit in? Unless I answer these two questions, and I cannot go to have a choice of anti-diabetic drug, which will have a A1C goal. So this is number one, define the cardiovascular risk and define the kidney risk. So I think this was very, very important in 2022 ADA guidelines. So the whole approach, which was, I still remember about till 2017-18, there were so many debates about the A1C goal. We all remember those dates, that there were a lot of criticizing comments, editorials written in newspapers that how diabetes doctors are pushing lots of medicine and insulin for no reason, because there was some confusion about these A1C relaxed goals and the intensive goals. The focus shifted from that now, 4 to 5 years down the line, on cardio-centric, because we have evidence. See, anything problem in diabetes management, if we have an answer, then there is almost a lot of things happen and we can have a better choices. Because there is an option available now, we are doing this using SGLT2 inhibitors very early. First thing, the patient sits in front of me, I need to answer cardiovascular risk and the renal risk assessment. I will like to spend 2 minutes here on this slide. That ASCVD, yes and no, yes, we all understand. If it is atherosclerotic disease, yes, it's a secondary prevention, it's called as secondary prevention, and then we have a standard set of guidelines. What about ASCVD? No. I feel if I'm having some 100 patients, if you are seeing, 90% of the patients will have ASCVD no, or maybe for 45 to 50%, more than 50%. And these majority, or we can say garden variety of type 2 diabetes, I don't like that word, but there is no evidence of atherosclerotic cardiovascular disease, then these patients lie in a big spectrum. So this is a big spectrum of patients here who can have a simple atherosclerotic risk or who can have a very high risk. So my patient who is ASCVD no can have just simple type 2 diabetes and some obesity with everything normal, or I may have a patient of type 2 diabetes, there is no evidence, stress test is negative, and still he has smoking, first degree family history, cardiovascular risk positive, he has mild blood pressure, so he the risk factors much higher. So this patient, these two patients, I cannot categorize in one group. There's a big spectrum of patients who said ASCVD no. So my sincere, I feel that we should be more aggressive in assessing the cardiovascular risk of all our patients, not only to use canagliflozin or SGLT2 inhibitors, but also for all other treatment parameters, mainly statins. So definitely we need to be aggressive in assessing the cardiovascular risk so that we can use these wonderful drugs like SGLT2 inhibitors much earlier and helping our patients to protect kidney as well as the heart. So this dilemma can be answered only by quick assessment. So when we say ASCVD no, you can see here the canvas was the first study which was published after Impaired, that there are patients which were included not only with established coronary artery disease, but also with patients with CV risk factor, compared to Impaired, which was 99% of patients were established cardiovascular disease, then declare and the canvas. So canvas actually, we can say 50% of patients were having only cardiovascular risk or the CV risk, which we can classify as ASCVD no. So these are the patients which were included in canvas with canagliflozin trial. And you can see this is a better pictorial kind of a diagram, which tells us immediately that in canvas of canagliflozin, almost 30 to 40% patients were just multiple risk factors. One more thing I want to mention here is that when we use cardiovascular risk assessment engines, there are a lot of important factors which are not taken into consideration, as like duration of diabetes, first degree family history of a major cardiovascular event, which is so important, which is not taken into account when we are using risk engines. So our job as a treating physician becomes more serious to assess CV risk. So we need such programs as Canvas of canagliflozin, where there were patients of multiple risk factors. We all know Declare had a more kind of a patients with the multiple risk factors, with that is the blue people are ASCVD no, but have high risk of cardiovascular disease. We all are familiarized with this diagram that cardiovascular risk endpoint was significantly reduced in all SGLT2 inhibitors. Mainly it happened because of the reduction in the heart failure risk. But in Canvas, just to remind everyone, for non-inferiority, it was quite significant, but also the p-value was 0.01516 for the superiority. So that was first started from canagliflozin. Then we know about the rest of the SGLT2 inhibitor trials. So in Canvas, we all remember the major adverse cardiovascular event, heart failure hospitalization, death because of heart failure hospitalization and cardiovascular death were significantly reduced. Then we all know there was a reduction in renal outcomes as well as albuminuria progression. So all these things came from Canvas, and that's how canagliflozin, then the story started about cardio and renal centric management of type 2 diabetic patients. Few words about a very high risk of heart failure in diabetes mellitus. And it has again correlation with A1C. Many a times it has nothing to do with coronary artery disease. It's a disease of microvasculars, the small vessels in myocardium. So maybe on the coronary angiography, the coronaries are absolutely clean or normal, but there is a very high risk of heart failure for every type 2 diabetic person because of the intrinsic problem in the myocardium, as well as the small vessel disease in myocardium. So it may not be related to coronary arteries. So this is very, very important risk. It accelerates deaths, the cardiovascular mortality increases. Usually it is associated with atherosclerotic disease, but it may not be, just to remind everyone again, and it may be associated with most of the time with the renal dysfunction. So when you see the Canvas program again, now we say preserved, we say mid-range ejection fraction, and of course low or reduced ejection fraction heart failure. But what even at that time of Canvas, that time also it was shown that there is a significant reduction with canagliflozin across the range of ejection fraction heart failures in the heart failure. So even with the middle range or a preserved ejection fraction, there was a significant reduction in the heart failure risk in the Canvas. Just a few reminder about a very good kind of a message which we received from Professor Naveed Sattar. That is because I have taken this point to discuss, because we see a lot of young patients with type 2 diabetes, lot, say 35, 40, 45, and those who get diagnosis of diabetes at young age. So let's have these figures from Naveed Sattar's papers, that how much is the risk of heart failure in these young people who are getting type 2 diabetes diagnosed at the age of say 35, 40, 42, which we routinely see. As I was mentioning, the risk is much higher with type 2 diabetes diagnosed at a younger age. So age at diagnosis of type 2 diabetes matters a lot when we are calculating the risk of not only cardiovascular disease, but also the heart failure risk. Let's see this paper published in Circulation a few years back from Naveed Sattar, which is a Swedish, from his paper from Swedish National Diabetes Registry. What he has done on the, you can see, sorry for the slide, but it is like, what is the age of diagnosis of a type 2 diabetes person? And the blue dots are, there is no history of cardiovascular disease, and how the hazard ratio for cardiovascular disease increases. So I have just written here in the red About cardiovascular disease, hazard ratio is almost 3.5 times higher for those who are getting diagnosis of diabetes below the 40 compared to someone who is above 50 getting diagnosed, it's 1. So it is much higher. But what is more interesting is the heart failure risk. Someone getting diagnosis of type 2 diabetes below the age of 40 years with no prior cardiovascular disease, hazard ratio for heart failure is 4.7, maybe 5 times higher. If you're getting diagnosis of diabetes above 50, between 50 and 60, it is 2.3. So it is, you can see it's double the risk for our younger patients who are getting diagnosed. Though this is a Swedish national registry, we have been meeting Dr. Nabil Sattar every now and then in so many different meetings. And he has said this same registry, same data has been analyzed on different registries across the world. And every time they are getting the same kind of conclusions that someone getting diagnosed early, the risk of cardiovascular disease and heart failure risk mainly. So early diagnosis of type 2 diabetes, the risk is 5 times higher with no prior CVD. Just that someone is getting diagnosis of type 2 diabetes early, I think this justifies the early use of SGLT2 inhibitor or maybe canagliflozin or use of SGLT, which are such a cardiocentric protecting drugs. So that if I use just someone getting diagnosed type 2 diabetes at the age of 38 and I just use the drug SGLT2 inhibitor, I think I'm justified when I'm looking at the risk of heart failure as well as a cardiovascular disease. Just few additional points with canagliflozin has been seen that hyperuricemia, which increases the risk, which is also a part of the insulin resistance syndrome, but in particularly, you can see there is a major reduction with this wonderful SGLT2 inhibitor canagliflozin, whether it is 100 or 300, there is a reduction in the uric acid. So there are patients who show hyperuricemia along with diabetes, which is also helpful. Now there are lots of papers, if you can see in 2021 ADA till that time. So there is a evidence of canagliflozin helping our patients of non-alcoholic fatty liver disease. There also they are showing a very good effect. And now I think last year's ADA, we have seen papers, biopsy proved that how these SGLT2 inhibitors are helping this liver fibrosis or adiposity in the liver. Not only the biochemical improvement, but also histological improvement has been seen. This paper also discusses how NAFLD is improved with the help of canagliflozin. Now, heart has been discussed and we all are using it. Now the focus is still gone ahead because we know that when we see the hypothesis of how SGLT2 inhibitor work, we have a lot of connection between the heart and the kidney, and each benefits each other. Two organs really. So the cardio-renal approach, one has to decide the stage of patient. So diabetic nephropathy is much common in Indian type 2 diabetic patients, and we have a lot of kind of epidemiological evidence for that. So the risk of not only deaths goes up, death because of cardiovascular death increase if there is a compromised renal function. So if there is a patient and I'm writing even for the first day of diagnosis of type 2 diabetes, I need to know the proteinuria and the GFR. So proteinuria helps to know the stage, how much is the glomeruli or how much is the protein leak, the podocyte injury inside the glomeruli. But if I want to follow the patient, the GFR is more important. So we need to calculate GFR for each and every patient for each and every visit. So I personally feel every type 2 diabetic person who comes for a follow-up, we have to treat it as a new patient because you have to go through everything again and again and again. So maybe follow-up patients take more time than the new patient. I think all of us agree on that. So kidneys are extremely important. Just like to remind everyone that these wonderful molecules of SGLT2 inhibitor, way back the research of canagliflozin first started among the three, and it was initially tested mainly for albuminuria. Because Impaired came later on, and because they needed a license to use this drug, there was a CVOT happened. But initially this drug was tested, it came for mainly diabetic nephropathy, reduction in albuminuria, all the initial papers of canagliflozin were concentrated how it helps the nephropathy. Then the canvas happened for the licensing purpose, and then of course empiric happened and the focus shifted to cardiovascular risk. But we all know that initial canagliflozin, which showed that there is a help which decreases worsening of nephropathy. It's not only A1C, BP and blood pressure, weight and blood pressure, but it also, yes, very good effect of, actually I just forgot to mention that variability of blood pressure was much reduced, and it was the only paper with canagliflozin seen in the canvas trial in the analysis when they tried to see how it affects the blood pressure. So not only blood pressure reduction, but blood pressure variability also improved with canagliflozin. So these initial studies of canagliflozin came for on compromised GFR and how it helps glomerular and tubular damage. So these were the initial papers with canagliflozin. So it shows that how it protects change in GFR over the time. These are the small kind of papers published. The rate of decline in GFR reduces with canagliflozin. Also proteinuria is reduced. And it was like compared with glimepiride. So these were the initial papers. Then came the canvas, which actually showed across the range of GFR. There were about 20 to 25% of patients of canvas with compromised GFR function. So it was like there were some patients below 45, somewhere between 45 and 60. And across the range of GFR, there was no heterogeneity. And actually canagliflozin was helping even in patients with compromised GFR. That was the first observations came from canvas, that whatever is the GFR, there is a help in reduction of systolic blood pressure, the body weight, albumin creatinine ratio was significantly reduced with the help of canagliflozin. These observations with canvas, we all know that helped. There was some heterogeneity there was not for primary outcome, but there was some for stroke. There was some postulation that it may be helping more to reduce these cerebrovascular accidents. So canvas actually started rolling out that canagliflozin actually helps much more even in the compromised GFR patients, may not be for A1C, but mainly for the preserving renal function. Then we all know Credence happened. And Credence, I still remember when it was first published in, I think, Australia, in the nephrology conference. And we still remember the dramatic way it was presented. And this p-value was read out, 0.0001. I think everyone remembers that. And it was really exciting time because till that time we couldn't do much to our patients with compromised GFR. And actually Credence first time showed that how much canagliflozin is helping our patients, which for all the composite renal outcome were much significantly improved. End stage kidney disease, doubling of serum creatinine and renal death improved, as well as cardiovascular mortality is much significantly reduced if I am using a canagliflozin for a patient whose GFR may be 35 or 40. So again, so Canvas and Credence trial, you can see that Credence patients with compromised GFR, this is the light colored bars in this slide, are helping. These are from Credence, and they are helping across the cardiovascular outcome as well as the renal outcome. So even patients with compromised GFR, canagliflozin is really helping our patients for their cardiovascular death, renal death, and protecting the kidneys for further damage. So to arrest that further continuous damage in type 2 diabetes, we have this wonderful molecule with the evidence from Credence. The Credence was so, it was so enlightening and so much of a paradigm shift that we all know that guidelines change. I will come about it. This slide is showing that canagliflozin use in Indian patients, and it does show the similar effects of A1C and weight loss. Even though you can say that baseline BMI is not much higher in Indian patients, still has a very good effect on blood pressure, A1C, and the systolic and diastolic blood pressure. So actually after the Credence, the guidelines changed for the use of SGLT2 inhibitor, and 2021 guidelines are recommending using canagliflozin in compromised GFR. Still the cutoff is 30 in KDIGO guidelines. 2022 guidelines are available for public review. I think after a few months, we will get 2022 guidelines as well. So after lifestyle and SGLT2 inhibitor, so it is just cutoff is 30 for KDIGO, but we know that after DAPA kidney, the cutoff has still gone down to 25. So I need, in the credence, there was one more very good observation which was seen. If I'm treating my patient with the GFR of 38 and I put that patient on canagliflozin, we all know there is an initial reduction in the GFR with SGLT2 inhibitors. It goes down maybe below, say, 25 or 22. Still, the canagliflozin was continued in credence and it showed benefits. So one need not worry about that initial reduction of GFR. We can continue these SGLT2 inhibitors. Similar observation was seen in DAPA kidney, and the cutoff for DAPA is almost gone to 25. Now, what about patients with GFR below 25? That's the big question being discussed with all nephrologists. And I think they strongly believe that whatever is, there is a residual kidney function which may be preserved if we use drugs like canagliflozin or dapagliflozin, even with that compromised GFR. Still, it is off-label. Still, the label use at present is 30 for cana and 25 for DAPA. But there is a very strong recommendations coming from the nephrology world that residual kidney function may be preserved. So we will get to know about it in next few years. But still, we came a long way after credence that we are using these drugs. So there is one more, KDIGO guidelines are making us aware that we need to assess the risk of hypoglycemia in that patient. If patient is on insulin, sulfonylureas, one needs to be careful because it's a compromised GFR. I'm adding a canagliflozin, it can produce hypoglycemia if patient is on insulin or sulfonylurea. So one needs to be careful. Also assess the volume depletion in some patients. So whatever AKI has been seen, either there is a urosepsis or there are other factors which are pushing that patient. So though it is less, but these two things one need to assess when we are using canagliflozin in patients with compromised GFR. This is from the KDIGO guidelines. These two things one need to assess in a patient when I'm using these drugs with compromised renal functions. So to conclude, there is a paradigm shift in management of type 2 diabetes. It's exciting times because we can offer something to the patient and we feel good that yes, I am writing something so that my patient is going to improve. So it's type 2 diabetes management had changed. It's rather than looking at the A1C, first I need to see the cardiovascular risk. I need to see the GFR and the kidneys. Then comes what should be the A1C goal for these particular patients. SGLT2 inhibitors have shown benefits in cardiovascular and the kidneys. So it's a cardio and renal centric approach where we can really give benefit to the patient. So I am a strongly I will recommend early use of SGLT2 inhibitors like drugs like canagliflozin with so much of evidence from credence as well as from the CANVAS program for cardiorenal protection. I still remember when I was a part of CANVAS R, and it was so frightening time. I just want to share that the patients with compromised GFR with that borderline creatinine, with this drug of canagliflozin we used to give them the jars for the urine collection, and 2, 3, 4 jars used to be less for them because there was so much of renal output. And it was really frightening initially. And as a clinical trial investigator, everyone goes through it. And unless you believe in the science, it was difficult. But CANVAS R it was criticized also initially. And now we have come a long way after credence, where we are talking of preserving renal function with this wonderful molecule, canagliflozin. Thank you so much.
Thanks a lot, ma'am. It's a very nicely explained by you about the importance of the SGLT2 inhibitors in type 2 diabetes, and the same time the importance with early, when there is early diagnosis of type 2 diabetes, at the same time when there is having hyperuricemia, NAFLD, and the nephropathy, not to forget. So, and again, you have very nicely covered that, tell that about 2021 guidelines about that also. Dr. Sanjay Gandhi has 2-3 questions in the chat box. I'll read the first question that he has asked that about hypoglycemia would be a next risk strategic decision after atherosclerosis CVD, especially in elderly type 2 DM patient. Your primary strategies, please.
Yes, I completely agree. I think in ADA 2022 guidelines, the sequence is ASCVD, yes, no, renal function, and the hypoglycemia risk. So absolutely, it's very true, Sanjay. We want to achieve everything, cardiocentric approach. We want to protect heart, we want to protect kidneys. We want an intensive A1C reduction, but with no hypoglycemia. And of course, no weight gain. So these two things are, and hypoglycemia is crucial because severe hypoglycemia is a risk factor and a risk marker for early death. So we don't want to push. As well as we need to assess a patient whether this patient can go in hypoglycemia. Very important point, Sanjay. Thank you.
And one more. What about EMPA, CANA, DAPA? What do you prefer and why?
I think all have shown the good results. It's a kind of a class category and all are showing, but still when you write, you need to see what was the patients used in the empagliflozin trial, canagliflozin trial and dapagliflozin trial, which gives us additional confidence that this patient fits in this particular kind of a study program, so I can use it. So always we need to see what are the patients which were recruited for that particular trial and we can use that drug accordingly.
Are there any questions? What is your opinion about
Remo? Yeah, it's about, I think, remogliflozin. And Dr. Umarji, thank you for bringing out that because everyone is using it. It's an SGLT2 inhibitor. So it works. It works. It reduces A1C. It reduces weight. It increases fungal infections. But if there is a high CV risk patient, we lost the chance of using a very good Indian trial of cardiovascular risk and remogliflozin. But the molecule is good. It reduces A1C. We don't know about the cardiovascular risk outcome because there is no evidence with that molecule. So, but otherwise it's an SGLT2 inhibitor. It works very well for A1C reduction. I don't know about CV risk reduction with remogliflozin.
Ma'am, this is last question. With the time, considering we have to answer this last question by Sarang Barwin. Can we use SGLT2 inhibitors in case of obese patients with impaired glucose tolerance?
Yes, definitely. I think the canagliflozin 300 milligrams, which is available, has a very good effect on the weight reduction. So that early use, the label indications for obesity, it may take some time, but because there is an impaired glucose tolerance and which we know that cutoff is now even 2022 guidelines for Indian IGT is 5.8, which was their way back, Dr. Mohan has presented. So 5.8, it starts IGT for Indian patients. So yes, I think we can use this high dose canagliflozin, which has a better effect for weight loss.
Any role in type 1?
There are trials which they have used SGLT2 inhibitors in type 1, but not, it cannot be recommended because it is still used in some clinical research programs and there are no guidelines which are saying the euglycemic ketosis is quite common and one needs to be careful about it.
Okay.
Now, but I completely agree in a patient with massive proteinuria is in front of us with type 1 diabetes. We do want to use these wonderful molecules. I can ask anyone if we have some more evidence for using these patients with diabetic nephropathy with type 1 patients.
Thank you. I think it was a wonderful session. And thank you, Dr. Shailaja Kale, madam, and Dr. Anu Gaikwad and everybody. We move on to the next session and over to Dr. Sunila to introduce the next chairperson. Welcome, Dr. Bose.
Hi, good morning.
Yes, so Dr. Bose is a professor and head of
Medicine department.
BJ. Yes, of course, medicine department, BJ Medical College, Pune. And he's also the ex-professor HOD ART, Nodal Officer, Department of Medicine, Government Medical College Hospital, Kolhapur and Latur. He's a very well-respected and very good academic and has got excellent clinical insights. And over to you, sir, for the next session.
Yeah. Now let us begin with the session. Shall we start?
Yes, sir. We can start.
Yeah, I'd like to call upon the Dr. Dakshata Padhe Madam for a talk on FibroScan for non-alcoholic fatty liver disease detection in diabetes clinic. Over to you. Dakshata Madam is MBBS. Just hold on. Yeah. She has done diploma in diabetes mellitus from Mumbai. She is a preventive diabetologist and director at Concord Diabetes Center. She is awarded for state of the art diabetic food clinic in 2018. She has done a lot of work in preventive work in pre-diabetes, and I think it was accepted at ATTD 2018 RSS DI. Not only this, but she has done a preventive work in podiatry, and it was also accepted at ATTD 2016. Dakshata Madam, you can carry on. Thank you so much.
Thank you so much, sir. At the outset, let me thank Dr. Unnikrishnan, sir, and team CDI for making me part of this excellent scientific program conference, which I was honestly looking forward to be part of it since last so many years. So it is a very fortunate day for me. Thank you, Dr. Unnikrishnan, sir, once again. And I think my session is a pre-recorded session, so I'll be here for panel discussion and question-answer session.
Yes,
we can start
go
the
ahead.
session. Hello, everyone. At the outset, let me thank Dr. Unnikrishnan, sir, for giving me this opportunity to speak on the topic which is very close to my heart, a very much needed preventive area in the management of diabetes. So today the topic given to me is FibroScan for NAFLD detection in a diabetes clinic. Whenever we are treating diabetic patients, our patients with diabetes, we always follow our Bible, that is ADA recommendation. And to my surprise, actually, I was just going through the literature, and in ADA 2019 recommendation, it is already recommended that patients with type 2 diabetes mellitus with elevated plasma ALT levels or steatosis on liver ultrasound, they have to be evaluated for NASH and liver fibrosis. This is very important point. The rationale for screening such patients, we know that is based on increasing evidence that NASH with advanced fibrosis is associated with liver-related and extrahepatic morbidity, mortality like cardiac manifestations and liver cell carcinoma. Now let's look at the numbers. Unless we read the number, we don't know how much is the problem. So this is the global prevalence of NAFLD. If we look at Asian area closely, Asia has incidence prevalence of NAFLD around 27 to as high as 30%. So the burden is really huge. Talking about the interplay of obesity, metabolic syndrome, insulin resistance, type 2 diabetes, dyslipidemia with respect to NASH. When patients already come to us for the first visit, patient is already in the stage. I don't think we get any patient who has healthy liver at the outset when the patient is diagnosed. It is always in the stage of inflammatory stage, NASH or maybe NAFL. Very rarely we see patients at diagnosis have cirrhosis, but we need to be very, very proactive. Now today I'm not going to go in the details of NASH pathophysiology, but today the topic is FibroScan. So I'll be directly talking about complex multi-hit process, which kind of speeds, accelerates process of hepatic steatosis to NASH and fibrosis. To our experience and from the literature, it's not just obesity, insulin resistance, diabetes, or metabolic syndrome, but there are many other factors like hypertension. Uncontrolled hypertension accelerates this progression. Genetic factors, postmenopausal status, older age, microbiota, many factors are involved. And what do patients with NASH die from? This is a very good study. 12 years follow-up, 619 biopsy-confirmed NAFLD patients were monitored for 12 years. And the major cause of mortality, almost 38% was cardiovascular diseases. Other causes, other cancers, non-liver cancers was 18%, and cirrhosis complications or probably HCC was very, very low. So NAFLD and mortality, CV is always the main cause. Liver disease only third cause of mortality, and multi-morbidity patient-centric care model is very, very required. This disease is invisible to GPs. GPs, family physicians are dwarfed by chronic diseases, sterility, mental health, reproductive health, child health. So we really need to be very, very proactive to tackle this problem. We need to have referral pathways. We need to have a streamlined management system where, there is how to select patients for referral is very, very important. That needs to be taught on the first primary care health worker. Non-invasive fibrosis assessment has to be applied for each and every type 2 diabetic patient. How to design a referral pathway? You educate, and finally, education about evaluation and primary prevention is very important. Now, these are few NASH registries, and they have done fantastic job, and we all hope to see Indian flag amongst these registries very soon. Now, how do we evaluate patients? First, we rule out ethyl alcohol consumption and negative chronic liver disease screening, and maybe on ultrasound we see there is fatty liver. Very simple FIB-4 score is available. I'm going to go in detail in next few slides. It's a very simple test. This test should be done for each and every patient, and if the FIB-4 score is intermediate, that is between 1.3 and 3.25. These are the patients who are going to require some radiological investigation and ideally elastography, that is fibroscan, to see whether the patient has developed any cirrhosis and how much is steatosis present at present. Now, these are diagnostic modalities for NAFLD. Recommended modalities USG. Then we have, liver panel enzymes. We have liver biopsy, serum biomarkers, and last but not the least, fibroscan. Fibroscan is quick, easy, and convenient. It is non-invasive. Complication risk is almost zero, and sensitivity specificity is very good. Sensitivity 80 to 90% for detecting fibrosis, and it correlates the degree of inflammation better than any serum fibrosis markers in cirrhosis. When we are talking about diagnostic modalities, first thing is in outpatient clinic, in our OPD clinic, FIB-4 requires only 4 parameters. Age of the patient, SGOT, SGPT, that is ALT, AST, and platelets. NAFLD has got few more additional parameters, but FIB-4 is the most convenient score system we can use in outpatient practice. And this is a simple formula which is available online. You just have to enter age, AST, ALT levels, and platelets. And this patient, if you see 67-year-old patient, this is just an example of one patient we entered values. And if you look at his SGOT, SGPT levels are not badly deranged. But look at the FIB score. FIB score is 2.1, and on fibroscan, patient was already in F2, F3 level of fibrosis. So this is a very, very important calculator score or preventive score, I would say, for fibrosis. Using this score, I'm just sharing one small paper which we presented at Paris NASH meeting. Around more than 400 women were evaluated. They were basically retrospectively analyzed, and our FIB score was calculated. History of alcoholism or chronic liver disease was excluded. These patients were excluded. And the FIB score between less than 1.4 is normal. Between 1.4 to 2.6, we had around 58 women. 2.6 to 3.2 were 5 women, and more than 3.2 FIB score, patient already had developed fibrosis. the number of women out of 438 were 7. And mind you, all these women were asymptomatic. They did not have any idea. They did not have any symptoms as well. Then eventually lifestyle modification, pharmacotherapy was started. These patients were further evaluated by fibroscan and the monitoring is going on. And in the last 1 or 2 years, we are getting excellent result, reduction in PIP score and reduction in the stiffness index as well. Liver biopsy was the standard for seeing histology in NASH patients, but with the pandemic of NASH and fibrosis, I don't think getting each and every patient biopsy is a very, very good option. So these are few, I would say the liver biopsy is not a viable approach in routine practice. It is invasive, painful, sampling variability, observer variability, and we have limited workforce capacity in our outpatient clinics. So 1 in 1,000 patient can have severe bleed, and 1 in 10,000 patient have mortality risk. So 100 million individuals were to be biopsied, then almost 1 lakh life-threatening bleed and 10,000 deaths can occur. So this is the kind of risk liver biopsy can pose for any simple NASH patient, NAFLD patient. So what do we do now? How do we go about it? Now we have this transient elastography, which is fibroscan, today's topic, is a non-invasive method of assessing liver fibrosis which can be performed at bedside or on outpatient basis. It is basically vibration controlled transient elastography. Now let's see how it works. This uses pulse echo ultrasound technique to quantify speed of mechanically induced shear wave within liver tissue. Now, liver stiffness has been well validated to correlate with severity of fibrosis. At the same time, hepatic steatosis can also be, so along with stiffness, steatosis can also be quantified by this machine. There is ultrasonic attenuation of echo wave, and which basically is called controlled attenuation parameter. So in simple words, we come to know about stiffness and we come to know about the steatosis as well. So fibrosis and steatosis, both the things can be measured with this machine. Now, how does it work? I just mentioned that, but the more the fibrosis, this line is very important. If the liver has more fibrosis, this tissue is going to be stiffer, faster shear wave progression, and higher kilopascal values. So very important that if fibrosis has developed, the values are going to be more because stiff tissue will allow shear wave to progress very, very fast. This is the basic principle of this machine. Now this measures liver stiffness in a volume which approximately coincides 4 centimeter in length and 1 centimeter diameter. That means it is 100 times bigger than a biopsy sample, and it should be more representative of more representative of liver parenchyma. And the skin, it is below 25 to 65 millimeter underneath the skin surface. But if you compare with biopsy sample, it definitely gives a bigger picture. It has been validated in a NAFLD and useful tool for rapid non-invasive assessment of liver fibrosis and determining need for a biopsy. Now, how do we perform this test? Very simple. It takes just 5 to 7 minutes, not more than that. It is a bedside test. Patient can be non-fasting, but at least 2 hours fasting is advisable. Patient will lie in supine position. I'll just show you the picture. Patient is lying in the supine position, legs towards the left side of the bed, and right arm has to be behind the head. Intercostal areas are measured. Xiphoid appendix, go parallel, go in the mid-axillary line, and the probe is put in the intercostal spaces. The zone has to be free of tight muscles. Arm should be bent. So this is the simple position. Once the measurement area has been located, operator presses it is exactly the same area where the liver biopsy needle punctures. The puncture is taken. So once the measurement area has been located, operator presses the button on the probe to start acquisition. software determines whether each measurement is successful or not. If the value is not successful, it is not recorded. If it is falsely high or low, it is not recorded, and results are expressed in kilopascals, and it always corresponds to the median of 10 validated measurements. So take 10 validated measurements are taken, and only median of these measurements is taken. So accuracy is 80 to 90%. This is how the report card looks like. Down, if you see just below chronic cholestatic diseases, the kilopascal liver stiffness from 1 to 75. 75 is too much, but 1 to 23 is given. We haven't seen anything beyond 20 or 25. F1 to F2, F3 to F4. Now the stiffness zones are also, the range is different for each liver disease. If you see for alcohol, the stiffness measurement starts at some different level. For NAFLD, it is different. So I'm just going to show you one card of NAFLD. This patient had stiffness of 11. Now, 11 stiffness directly coincides to F3 level. F3 means patient has already developed fibrosis, lifestyle modification, pharmacotherapy, and patient needs to be referred to the hepatologist. Now, this is FibroScan algorithm. High-risk patients or undiagnosed patient or treatment going on for NAFLD patient, FibroScan should be done for these patients. If patient is in early NASH, liver enzymes are normal or elevated, the follow-up should be maybe, they say 5 to 6 years, but I think yearly follow-up is must. If it is F2 level, there is indeterminate NASH. There can be liver biopsy if there is high index of suspicion of any other causes, or just lifestyle modification and pharmacotherapy can be started. Anything above F3 fibrosis, all the levels, I mean the kilopascals are given on the report card when the report is given. So anything more than F3 hepatologist reference, and eventually lifestyle modification and pharmacotherapy is started for these patients. So this is a clinical study in which 246 NAFLD patients with FibroScan and liver biopsy were studied. FibroScan seems to have a good accuracy to distinguish NASH patients into NAFLD population. And FibroScan performs significantly better than all studied blood markers or any fibrosis score in F3 and F4 level. So when fibrosis, let's say, more than this FIB score or NAFLD score, FibroScan has a better prediction value. Now, where should we, there are some situations where we should be careful. It shouldn't be used in pregnant patients. And a NASH patient, NAFLD patient who has coexisting acute hepatitis, hepatic congestion, hepatic amyloidosis, it can be falsely elevated. So we have to be careful in such situations. Now, this is how the screen looks like. It's a very simple procedure, real-time overview, final results at one glance, and smart interpretation. Now I'll show you how. First, we see ultrasound signal, then without pointer it is difficult, but elastogram is the list of individual measurement. We just understood that 10 validated measurements are taken, and in the box below 224 is basically value of steatosis, which we are not very much interested in, but we need to know the stiffness value. The stiffness value is 6.3 kilopascal. That means it is normal. And probe selection is also very important in obese patient who have false high or false low reading. We need to use Excel probe. Now these are the advantages: reproducible and independent of operator. It explores volume of liver parenchyma, which is almost 100 times larger than biopsy specimen. It can be carried out on OPD basis, and patients do not experience any pain. I just mentioned it's rapid, just maybe 5 to 7 minutes, non-invasive, patient-friendly, and last but not the least, it is very suitable for periodic monitoring, and progression of NASH or reversal of NASH has to be monitored. Only FIB score value monitoring is not going to be helpful. Many times enzymes are normal, but fibrosis can worsen. So you have to have periodic monitoring, and with FibroScan, it becomes very, very convenient. This is how we do risk-based stratification. I'm just going to read the values of FibroScan. If you see on the third level below non-invasive risk stratification, second last line, if FibroScan is less than 5 kilopascals, it is there is no evidence of Nash. If FibroScan is between, the stiffness value is between 6 to 12, we need to immediately, this patient falls in intermediate risk profile steatohepatitis, and if a patient is already at stage 2 or 3 fibrosis, and if your stiffness level is more than 12 kilopascal, that is a pink box I'm talking about. If stiffness level is more than 12, then patient goes to fibrosis stage 3 and 4, high risk profile, direct hepatologist reference, and further treatment will be, and further evaluation of complications is initiated. Now let me just discuss few of the patients. All these patients were asymptomatic patients. They were routinely subjected to FIB-4 score as a protocol. And this patient is the first patient is a 61-year-old female with past history of RCC. 2019 pre-pandemic, when patient had her FIB-4 score was 0.65. In 2021, during her routine evaluation, FIB-4 score was found to be 7.5, which was very surprising, and we did fibroscan for this patient. The fibroscan showed very high stiffness, which was in favor of Nash, NAFLD, leading to fibrosis. This patient was referred to hepatologist. Treatment was initiated. Patient had already developed some varices, but this patient was referred to hepatologist because of FIB score early reference, and patient had not developed any complication. In 2022, FIB-4 score came down from 7.5 to 4, and the stiffness value also came down from 21 to 8.3. Sorry, this patient follow-up fibroscan is still not done. FIB-4 score settled from 7. No, sorry, this patient had already was in progressive fibrosis, and from 7.5, the score has now advanced to 8.3. So probably during pandemic, her LFTs were not done, and we could have picked up this patient maybe in 2020 with lower score. But unfortunately, this patient's fibrosis is progressing in spite of treatment given to her. But patient is clinically stable. This is a very interesting case. 49-year-old female patient, A1C was around 6.0, weight around 69 kg, a corporate woman. FIB-4 score in December 2019, pre-pandemic, was around 2.09. Fibroscan done in January 2020, just before pandemic started, was 8.8, slightly on the higher side. PIO, SGLT2, lifestyle modification started. This patient was during online working. She managed to lose around 7 kg. She concentrated on her lifestyle modification diet, particularly. December 2021, excellent result. FIB score came down from 2.09 to 1.8, and the stiffness also set.
Please display Dr. Sanjay Gandhi's CV. We'll address any questions at the end of the session, time permitting. Thank you. Yes, Dr. Obese, please go ahead.
Yeah, let us go to the second talk of this particular session. And here I would like to invite Dr. Sanjay Gandhi. He will be talking on subclinical COVID-19 and new onset type 1 diabetes mellitus case series. Dr. Sanjay has done DNB and a postgraduate diploma in diabetology. Currently, he is practicing at Diabetes Clinic and Research Center. He is consultant diabetologist. His area of interest is type 1 diabetes mellitus, obesity, and diabetic food. He is one of the trustee of Diabetic Research Education and Management, and ex-secretary of Diabetes Association of India, Nagpur. I think we are supposed to take the question answer session later after finishing the all three.
Yes, time.
Yes.
Yeah, Dr. Sanjay, please go ahead.
Good evening. I would like to thank Dr. Krishnan sir for this wonderful opportunity to present our data at the prestigious Chelaram Diabetes Institute International Diabetes Conference 2020. I will be talking about a quite new topic, which is subclinical COVID-19 infection and new onset type 1 diabetes, a case series from our own clinic and our own center. So I will discuss this topic into two parts. In the first part, I will talk about our own experience regarding COVID-19 infection and new onset type 1 diabetes. And then I will also share some data from across the world, followed by conclusion. So first, I would like to tell that we at our clinic we also run a charity which is called as Type 1 Dream Trust, or which is an exclusive Type 1 diabetes charity, and it is a referral center for children with Type 1 diabetes from low socioeconomic background, and we have almost more than 2,000 patients registered who receive free treatment and as well as treatment modification and guidance from time to time. And all these patients, they are referred to our clinic after they are initially diagnosed or stabilized by their local pediatrician, physician, or in their local hospital. And these are some of the examples of our patients. You can see that they come from smaller towns, from low socio-economic background. And if we talk about COVID appropriate behavior, then what we found that it was fairly dismal in this population of type 1 diabetic patients, as there was overcrowding, there was use of inappropriate mask or inadequate masking, and poor practice of hygiene protocols, and probably increasing their likelihood of developing COVID-19 infection or getting exposed to COVID-19 infection. Now, there has been a lot of discussion and data regarding COVID-19 infection and diabetes in general. And specifically talking about type 1 diabetes, then there are some studies which have shown that there has been lack of access to type 1 diabetes treatment, especially in developing countries like India, where availability of insulin, especially in smaller towns, was difficult. There is more diabetic ketoacidosis at the time of diagnosis, probably because of lack of awareness amongst the population or fear of going to hospitals during the COVID-19 wave. Then there is also data which shows that there is delayed diagnosis and probably increased mortality in patients with type 1 diabetes who develop COVID-19 infection. On the other hand, there is also some data which shows that patients who are already having type 1 diabetes, because of appropriate online consultation following better lifestyle practices, there was improved control in type 1 diabetes. So there are mixed bag of observations as well as far as type 1 diabetes and COVID-19 infection are concerned. Now, we all know that type 1 diabetes progresses in several stages. So, although the onset of disease is very abrupt and explosive, but there is a long pre-symptomatic stage wherein a patient who is at very high genetic risk of type 1 diabetes, then it is followed by immune activation and invasion of the beta cells, leading to beta cell failure or reduction of insulin secretory capacity, followed by development of autoantibodies, and finally culminating into clinical or overt type 1 diabetes. Now, it has been studied worldwide, and that viruses, they play a very important role in the pathogenesis of type 1 diabetes. And widely studied viruses are enteroviruses, Coxsackie, B virus, rotavirus, and rubella infection. So generally during early childhood, there are a lot of infections with these viruses such as enterovirus. Then there is a phase of viral persistence wherein the virus persists in the beta cells of pancreas. There is development of autoimmunity, and then there could be some other accelerating infections or we can also call them as precipitating infections, which lead to overt manifestation of type 1 diabetes. So, although enteroviruses have been well documented, we are not sure whether COVID-19 infection is having such an association with type 1 diabetes. So, at our clinic, we observed that during the COVID-19 pandemic from 2020 onwards, there was an unusually high number of patients who were newly diagnosed with type 1 diabetes and who were reporting to our clinic, both after the first wave as well as the second wave in our city. Prior to the onset of pandemic, that is before 2020, at our OPD, generally we used to see at least 4 to 5 newly diagnosed type 1 diabetic patients every month. And this data is post second wave. The second wave started in around February 2021 and it went on till June to July 2021. So this data is post second wave, that is the 2 months, June and July 2021. And we reported almost 22 patients who were new onset type 1 diabetes, 11 boys and 11 girls. All of them were in the age group of 3 to 16 years. And out of them, 22 patients, 15 patients had diabetic ketoacidosis at onset of type 1 diabetes. And all these patients were treated elsewhere, and once they were stabilized, they were referred for further treatment at our clinic. Only one patient out of these 22 patients at onset of diabetes had a COVID-19 positivity. Rest all of them were either not tested or not suspected to have COVID-19 infection. So none of the patients had symptoms suggestive of COVID-19 just prior to onset of type 1 diabetes, or this is what we obtained from their history. And 11 patients, they gave a history of contact with COVID-19 positive patients in their family members. So there was history of contact in almost 11 patients or 50% of patients, but in the rest of the patients, there was no history of any exposure or direct contact with patients. To establish some sort of association with COVID-19, we decided to perform COVID-19 antibody levels in these patients, and out of 22 patients, 16 patients had positive COVID-19 antibodies. These antibodies were IgG antibodies, which were direct specific for the receptor binding domain of the spike protein of COVID-19. And 6 of the patients were negative for COVID-19 antibodies. This graph tells us the number of patients who reported to our clinic every month-wise from the start of pandemic. So if you look here from January 2020 till March 2020, that is prior to the onset of pandemic, we used to have around 5 patients per month. But after the first wave, which began in around April 2020, lasted till October 2020, we saw a surge in newly diagnosed type 2 diabetic patients, almost up to 9 to 10 patients. And then the second wave began in February 2021 and went on till June 2021, post which we saw almost 22 patients that we have published in Journal of Diabetes. And this led us to believe that there is some connection between COVID-19 infection and new onset type 1 diabetes. Now, this data is not from a single center, but there are several other reports from across the world. So to support my hypothesis, I will also discuss data from 2 other centers which were recently published. One is from San Diego, USA, which is a pediatric tertiary referral hospital, and second is a German diabetes registry. So from the USA, Rady Children's Hospital reported that during 2020 and 21, during the pandemic year, they had 187 patients registered with newly diagnosed type 1 diabetes. In the previous year, that is 2019 and 20, they had only 119 patients. And if you look at this graph, then if you look at this black line, it shows the forecast that if there was no COVID-19 pandemic, then this would have been the incidence of newly diagnosed type 1 diabetic patients. But because of COVID-19 infection or pandemic, after 2020, there was a steep rise in newly diagnosed type 1 diabetic patients. So they reported that 57% rise in type 1 diabetes during COVID-19 pandemic. In their 187 patients, 4 out of them, out of all these patients had COVID-19 infection. The second was a much larger data from the German Diabetes Registry, which is a nationwide registry in Germany. And they looked at more than 5,000 newly diagnosed patients with type 1 diabetes who reported to 238 centers in Germany. And again, here we can see the same trend that after 2019, during the two pandemics, that is 2 years of pandemic, 2020 and 2021, there has been a significant rise in newly diagnosed type 1 diabetic patients. Now, apart from these reports, the first people to report the association were from UK in 2020, and there are several such reports from across the world, from Romania, other reports from Germany as well as from Italy, where they are linking type 1 diabetes and new onset type 1 diabetes and COVID-19 infection. Now, let us look at some of the possible causes why there could be some reason why the incidence of type 1 diabetes is more during the COVID-19 pandemic. One obvious reason is that the virus can invade the beta cells of pancreas. The beta cells exhibit the ACE2 receptor, which is the binding site for COVID-19 virus. So there can be the viral uptake by the beta cells of pancreas, leading to cell dysfunction, followed by beta cell failure and development of overt type 1 diabetes. This could be a very clear-cut logical reason why COVID-19 can lead to type 1 diabetes. But the German group, they also proposed some other theories. They postulated that probably COVID-19 infection may not be a direct cause of new onset type 1 diabetes, but it could be indirectly leading to new onset diabetes. Because during COVID-19 infection, there were stricter lockdowns across the world, the lifestyle of people changed. So they put forth the hygiene hypothesis, which says that occurrence of infections is inversely related to autoimmune disorders. So whenever there are infections are less, the autoimmune disorders will be more. So although there are certain viruses like enterovirus or rubella virus which have been postulated to cause type 1 diabetes, but there are routine pediatric infections, routine pediatric respiratory and GI infections, which may have a protective effect against autoimmune disorders. So because of the lockdown, because of restricted activity, social isolation, lot of pediatric infections were less, leading to increased autoimmune disorders, which is the basis of hygiene hypothesis. The second thing possibility is that the change in microbiome. So, which is called as the biodiversity hypothesis, which says that whenever the built-in environment, the biodiversity of an individual changes, that is the external and internal exposure changes, there is a rise in risk of immune-mediated disorders. So because of this excessive hygiene, because of social isolation, lesser infections, there was change in microbiota. So there was a net loss of microbiota, which could have been the reason for development of immune-mediated diseases like type 1 diabetes. So these were some of the points that they said, that stringent hygiene, lesser pediatric infections, change of behavior towards children, social isolation, poorer mental health, anxiety, and depression. This has also been linked to etiology of type 1 diabetes. So probably not the direct infection with COVID-19, but the indirect environment that was set up, which led to increased number of type 1 diabetic patients during the last 2 years. So with this, I would like to put an end to my talk, and this talk raises more questions than it gives answers. But one thing is quite clear, that there is strong evidence which points towards rise in new onset type 1 diabetes during COVID-19 pandemic. There are some unanswered questions whether COVID-19 infection is the cause for development of type 1 diabetes, or it behaves as a precipitating illness, or is it just a bystander? That is, the environment changed due to COVID-19 infection and thus leading to precipitating type 1 diabetes. Secondly, if it is the cause of type 1 diabetes, then can COVID-19 vaccination of these small children prevent development of new onset type 1 diabetes due to COVID-19? So these answers will be are not yet known, and further research in coming years will tell us whether what is the connection between type 1 and COVID-19 pandemic. There is a large registry which is called as the COVID-IF project, a global registry which is looking at new onset diabetes during the COVID-19 pandemic. And probably when the results of this registry are out, they will give us a better answer. What is the association between type 1 and COVID-19 infection? With this, I would like to conclude and thank you once again for this opportunity.
Thank you, sir. Please display CV of Dr. Nandita Arun. Yes, Dr. Bose, please go ahead.
Thanks, Dr. Sanket. Now let us move to the third talk of this particular session. And I'd like to invite Dr. Nandita Arun, who is the Director Consultant Diabetologist at Chennai. She is the founder director at India Diabetes Research Foundation. She did her undergraduation in Sri Ramchandra Medical College, during which she has attained gold medal in preventive and social medicine, and post-graduation MD General Medicine at Sri Ramchandra Medical College, Chennai. She underwent training of research at the prestigious University of Cambridge, training for diabetes at Christian Medical College, Vellore, and diploma in diabetes from Cardiff University, UK. She has also, to her credit, conferred fellowship by the Royal College of Physicians, Glasgow, and fellowship by International Medical Sciences Academy. I'd like to call Dr. Nandita Arun. She will be talking on outpatient management of diabetes during COVID-19, various case studies. Thank you.
Very good afternoon, and thank you to the organizers, especially Unnikrishnan sir, for having me in this program. I'm very happy to be here. Thank you, dear chairpersons, as well. So today I have been given a very interesting topic, and I thank Unnikrishnan sir for actually giving me this topic, because this is something which is very relevant to the current situation that we are all in, which is the outpatient management and the transition of management of diabetes during these COVID times, and how the landscape of diabetes care itself has been transforming over the past couple of years. As we all know, there is a boom of technology, and we literally now have the world at our fingertips. With our cell phones in our hands, our laptops, the world is so well connected that everything is available just at the click of a button. The COVID pandemic has in fact pushed that even further, and consumer behavior has definitely changed. We are now furthermore pushed into using technology into our daily lives, and this has changed the way that shopping is being handled, banking itself, money transfer, everything is now almost become online because of the sheer comfort, the time saving, and the convenience that is behind it. And the same applies not just to something as simple as shopping, but even health-seeking behavior has also changed, not just from the patient's point of view or the consumer's point of view, but for doctors and healthcare providers. And the entire healthcare system itself has been transforming over the past couple of years. Since the COVID pandemic, there has been a sharp rise in the use of telemedicine and technology in healthcare delivery. So when it comes to the role of information technology in the healthcare field, it can be applied in 3 different aspects. Overall, the concept of information technology or communication technology in healthcare is to improve the quality of healthcare for patients as such. And when it comes to the patient's perspective, it helps the patient to reach out to their doctors irrespective of the geographic location, improves access to healthcare at click of a button, the convenience behind it, and also technology has many other aspects, especially when it comes to chronic disease models like diabetes care. From the patient's point of view, it helps the patient share their daily data for self-management of diabetes, different tools that they have, etc. From the physician's point of view, the information technology in healthcare actually helps physicians again to reach out to patients for data retrieval, for saving their data, and of course for hospital information systems, reducing waiting time in the clinic, and so on. It also, of course, helps with research purposes, and that goes without saying.
We've lost.
So when it comes to diabetes care, the major changes or the application of technology with specifically pertaining to diabetes care is in various fields. First, in the diagnostic field, as we know,
I think we are not audible. We are not audible here.
Glucose monitoring system, which has been one of the latest trends in management of type 2 diabetes, type 1 and type 2 diabetes for that matter, where we have the time in range and the time above range and the ambulatory glucose profile, the new concepts which have brought about the importance of glycemic variability. Similarly, when it comes to therapeutic care, we have the insulin pumps, and with technology being integrated into the insulin pumps, there are a whole lot of sophisticated pumps which are now available. Beyond that, we have mHealth, which is nothing but mobile technology, which includes something as simple as even text messages, WhatsApp messages. We have various apps that are downloaded on smartphone devices, which helps patients in various aspects of healthcare. We also have telemedicine platforms, which would include video calls, voice calls, or again, short messaging services or text messages, which helps the healthcare provider communicate with the patient. So when it comes to something as simple as text messages, mHealth or mobile health has actually been something that has changed and been effective as a tool to help change health behavior. And this is a study in which we actually looked at the application or the use of text messages as a tool to improve glycemic control in patients with newly detected type 2 diabetes. So something as simple as regular text messages sent out to patients who are newly detected to adhere to their prescriptions better actually resulted with a significant reduction in HbA1c and fasting plasma glucose in the intervention arm, as we can see between the red and the blue graphs that we see over here. In a 2-year interval, we found a significant improvement in outcomes in patients with just a simple tool by using a text message. We also had what is something called the Diabetes Initiative, which was a pan-India initiative in which text messages were sent out to subjects to improve health-seeking behavior. And this was widely accepted. So something as, again, simple as a text message was useful and very effective and a powerful tool to help in reducing the not just the incidence of type 2 diabetes, but also improve dietary adherence by 41%. 54% of the subjects improved their physical activity, and the program was widely accepted, and patients subjects also accepted that it improved their knowledge of healthcare and diabetes through just something as simple as a text message. The lockdown effect on diabetes management is something that has been published recently and well accepted, that due to the COVID pandemic and due to the lockdown, many patients who could not reach their physicians were not motivated enough or to take care of themselves during the pandemic due to binge eating or eating of junk food, or the fear itself which pushed them the other way, psychological stress that they went through during the pandemic. In a publication by Kare et al., they reported that 40% had a worsening of their glycemic control and required intensification of medication post-pandemic. In another publication, they showed that 23% reduction was found in SMBG, and 87% of subjects reported it was due to mental stress. So this is what has been reported as a so-called lockdown effect, which has shown a huge impact on worsening of glycemic control in patients with diabetes. But this pandemic has definitely shown, as I mentioned earlier, a transition in healthcare overall, all the more in the chronic disease model management of diabetes as such. And there is the transition from mobile technology to telehealth, from mHealth to telehealth. So this this survey has actually shown that during the post-COVID era, the demand for telemedicine has found a sharp rise. 70% of users are now switching to online consultations, and they say that 60% of them will be willing to do their follow-up consultations through a teleconsultation platform. And 74% of them, the reasons behind why patients are now preferring telemedicine platforms over the face-to-face consultation, the most common reason that patients cite, and this is a survey that was conducted among patients, that showed that 74% of patients perceive the risk of infection while going to the clinic. So the fear of infection while going to the hospital just for a regular checkup was one of the main reasons why patients adopted the telehealth platform. 51% of them were afraid of going to the clinic for just a non-critical illness. 49% or more than 50%, almost 50% of subjects reported that it saved their time and travel period. So it was much more convenient to access healthcare and to see their doctors through the telemedicine platform than to go into the clinic. And this just shows that the wide acceptance of patients for telemedicine or healthcare, telehealthcare. This is a publication from Dr. Jyoti Dev sir, in which he has looked at it from the Indian perspective, and where he describes telemedicine as any telecommunication that helps to support the healthcare system. And when it comes to telemedicine application in chronic disease like diabetes, it is all the more applicable because diabetes, as the paper refers to, is a chronic and a costly disease, which involves the patient to be dedicated to the disease 365 days a year. They need to adhere to their prescriptions. They need to see their doctor every 2 to 3 months, being a chronic disease. And success of the treatment is is dependent on the patient's adherence to their prescriptions, self-management, and also seeing their doctors regularly. So when such regular, frequent visits to the doctors are necessary, something like telemedicine will definitely go a long way, which helps patients keep in touch with their doctors and see their healthcare providers more frequently. The current telemedicine interventions which are available in management or in healthcare as such, we have, as we looked at, we have text messages, we have voice messages over the phone, or we have live streaming or videos or video access through YouTube and so on. And then we have, of course, the email and different platforms. These are the various platforms which are available. But whichever the platform, it has definitely been a clear transition over the past couple of years. When it comes to the application in various fields pertaining to type 2 diabetes, we have most commonly the one that is being used is the telephonic consultations. And then we have the use of applications like the smartphone, the applications that patients have for using it, not just for their communication with their doctors, but in terms of also keeping in touch with saving their daily SMBG records, various apps that help them to keep track of their daily diets, apps that help them with insulin dose adjustments, and also educational programs and so on. Now, of course, we have to agree that of course, beyond the advantages of digital diabetes management, there are some challenges as well. But before we look at the challenges, let's look at some of the advantages of telecommunication and telehealth in management of diabetes. The first most important is increased efficiency. It is time saving, convenient, the flexibility, and as we saw the various reasons that patients themselves come up with, it is cost effective, convenience, saves travel time, the waiting period of in clinic, and so on. There are, of course, some challenges like any other system with the telehealth and digital diabetes management. The biggest challenge might be patients' concerns with confidentiality, training of staff that is required, and in a country like ours, poor access to network services, low digital literacy rates, availability of various apps or platforms in the regional languages would be some of the challenges that we may face. The other challenges when it comes to diabetes care is that some patients may also have some patients may have a reluctance with accepting telecommunication. Patient satisfaction sometimes may not be as much as we can achieve in our in-clinic consultations. Sometimes it is difficult to build that confidence over a telemedicine platform. And last but not the least, the lack of a universal protocol or recommendation when it comes to telemedicine, because this is a new field. However, the Ministry of Health, Government of India has actually come out with a telemedicine practice guidelines in 2020, especially with the recent sudden rise in the number of teleconsultations. They actually came up, and this came out in March 2020. And these are very clear guidelines that make it very quite uniform and standardized telemedicine care in our part of the world. So I've just sort of included some of these for us to have some clarity, because at the end of this talk, I want all of us to have take-home messages and to have some clarity, because I'm sure that most of us listening here do have telecommunication platforms with our patients, and probably see patients, if not on a daily basis, we definitely do use the video consultations or a telephone consultation or WhatsApp or whatever platforms for our consultations. So it's extremely important for us as clinicians to be aware of the legal implications of these consultations. So the first most important point when it comes to a teleconsultation is that the doctor must uphold the utmost importance of standard of care in their teleconsultation as much as an in-person consultation. And this should be kept in mind, and there should not be any compromise in the care provided. The efficiency and the effectiveness of that one consult must be as effective as an in-person or an in-clinic consultation, which is the most important point to keep in mind. Beyond that, if the doctor feels that it is an emergency situation, or if there is a need for a referral, or if there is any life-saving measures that need to be intervened, then it is the duty of the doctor to advise the patient to seek emergency care close by, or to advise for a referral to a higher center. We must also be clear about the first consultation and the follow-up consultation. So the first consultation would be a patient that we see or consult for the first time who we have not consulted with before. A first consult would also be a patient who we have consulted with earlier, but more than 6 months ago. A follow-up consult would be any patient that we have seen within the past or the previous 6 months in an in-person consultation. And when it comes to a patient consent for the teleconsultation, there are two types of consent for the consultation. It can be an implied consent and an explicit consent. So when it comes to an implied consent, if the patient themselves initiate the consultation, then the consent is supposed to be implied. It is understood, since the patient himself is reaching out, it is understood that we do not have to, that the patient has given their consent. But however, if the healthcare provider is reaching out to the patient, for a consultation, or if the doctor is reaching out to the patient for a consultation, then an explicit consent will be must be documented and is mandatory. When it comes to issuing prescriptions, it is extremely important for documentation to document a clear prescription, and it must be explained to the patient very clearly to make sure that they have no doubts. If the patient is a minor, they must be accompanied by a caregiver or who has to be an adult. And we must, during our consultation, of course, a clear history taking and etc. must be well documented. Last but not the least, before I end my talk, when it comes to teleconsultations, of course, we have various platforms. We have, I'm sure many of us as doctors are using various platforms. We at ARH from Chennai, we actually launched our own app recently, which is called Dia Home, which brings diabetes care to your home. This is available on the Google Play Store and the Apple Store for patients to download, and any doctors can get onto the platform and use this as a platform for consultation with your patients. The speciality of the Dia Home app is that this is a complete circle that provides a complete circle of care, a comprehensive 360-degree diabetes care to the patient, which involves a patient care team where the doctor, the physician assistant first calls the patient and takes a complete history of the patient, and then beyond that, the tests or whatever needs to be done is actually arranged by the physician assistant after a complete history and a comprehensive history is taken. And the tests are all arranged at home. So the tests which are arranged at home is not just the blood tests, but includes the foot examination, the Doppler biothesiometry, the eye examination, the body weight, blood pressure, and including an ECG can all be taken at the patient's convenience in their home. And it's only the last, the next step is where the diabetologist or the doctor consultation steps in, beyond which the patient will then be also put on into a patient, be connected with the patient educator and the dietitian. And last but not the least, the completion of the circle is that once the prescription is issued, the pharmacy also makes sure that the drugs are delivered to the patient. So this 360-degree Dia Home care actually makes sure and ensures that the patient does not have to leave their home, and a complete care is provided to bring diabetes care to the home of the patient. So this is a dedicated Dia Home app that we have launched, which provides a complete circle of care, and it also has a lot of online healthcare support for patients to reach out whenever they need for 24 with the 24-hour healthcare team that provides that clears their doubts on insulin doses or any doubts that the patient may have. And this has been a big success and been a boon to many of our patients. With that, I'd like to end my talk, and I'll be happy to take any questions. Thank you.
Thank you, Dr. Nandita Arun. Dr. Borse, Dr. Sethia, Dr. Padhe, Dr. Pensi, and Dr. Arun are available with us to answer any questions, sir.
First of all, let me thank all the three speakers, Dr. Dakshita, Dr. Sanket, and Dr. Nandita, for having a very lucid talk on various different topics. Specifically, are there any questions from the audience? Are there any questions? If not, then I'd like to ask certain questions.
Please go ahead, sir.
Yeah. Dakshita madam, tell me about something about the fibroscan. You know, fibroscan that we are supposed to do in a patient of diabetes having suspected non-alcoholic fatty liver disease. First time when you want to do it, the fibroscan, first time in the life of the diabetic individual, when are we supposed to advise it, and when are we supposed to again repeat it to just follow the pattern of the development of the liver disease, either in the form of say non-alcoholic steatohepatitis to fibrosis to cirrhosis. So how often we are supposed to advise this particular thing? Because fibroscan is not going to be it is going to be a costly affair all the time, and every patient may not afford this particular thing. So I like to have the certain words on this particular topic.
Thank you so much, sir. So actually, just to mention at the outset that this is an expensive investigation, but I would like to share with everyone that Abbott is doing this investigation free of cost. If you, gather 10 to 15 patients in a month on one day, so this investigation costs around 10,000 rupees, 7 to 8,000 rupees, but this is done free of cost from Abbott, one of the, hepatic division. So since last 4 to 5 months, we've come to know that, this is the kind of facility we can give to our patients. So no patient has spent any money from their pocket, whether they are affording or non-affording. Now, FIB4 is a triage investigation, you can say. FIB4 is something which is absolutely non-invasive. You just have to ask for LFT and CBC. So the way we asked HbA1c and lipid on first follow-up of patient, we always ask for LFT CBC. We enter those reports in FIB score calculator, which is available on online, and we start recording FIB4 score. Cutoff is 1.3, lower cutoff is 1.3. So whoever is having at least more than 1.5, patient doesn't have to be symptomatic. If we wait for symptoms, sir, it is too late. So once FIB score is 1.3, automatically that patient, and his details are entered in the diary for the next scan. So patients whose FIB score is between 1.3 to 2, we try and tackle that patient till fibroscan. If FIB score is more than 2, patients are absolutely asymptomatic. We have seen FIB score as high as 17, 18, 21. On investigation, patients are absolutely asymptomatic. So these are the patients who are called on a monthly basis for fibroscan. So simple non-symptomatic patients, but if FIB score is between 1.3 to 2 or maybe 2.1, these are the patients who are called for fibroscan. Then if the fibrosis score is, stiffness score is not more than, you can say 8 or 9. If it is more than 10, patient directly goes to hepatologist. But if it is between that range, lifestyle modification, patient education, and right pharmacotherapy, and follow-up fibroscan and FIB score after 3 to 6 months. And this is an absolutely free of cost service, sir.
Okay, thank you, madam. Thank you. And you said that it is not to be done during pregnancy.
Yes.
Any
Because
specific?
the shear waves are, the vibration waves are not recommended in pregnancy.
Okay, after
There is a difference between sonography and these waves.
So immediately post delivery, we can go ahead with this.
100%. And we were not very sure about alcohol cutoff. So the study which we started was for women. And to our knowledge, many of the women whose cutoff was more than 1.3, BMI was normal, sir. But they gave particularly history of GDM in the past. So I feel we should be proactive in our GDM or pregnancy with type 1 or type 2 diabetic patients, and should be doing first FIB score or fibroscan in lactation period.
Thank you so much. Thank you so much. Now I'd like to ask Dr. Sanket.
Yes, sir.
You explained the, the evidence of the type 1 diabetes mellitus in patients with the subclinical COVID-19 infection. Not only in subclinical, but I think in a clinical or whatever symptomatic individuals, those are going to be there. We have come across many cases having deranged BSL, could be because of, say, COVID-19 infection itself, or could be because of some drugs like, say, steroids that we used to use. And everybody knows that how the steroids and the coexistent diabetes mellitus had created havoc during the second wave, patients landing into mucormycosis and so on. Just one question: your subclinical COVID-19 cases were evaluated for pancreatic workup, like, say, amylase, lipase? Was there something like, say, subclinical inflammatory process in the pancreas that was identified or not identified?
These patients were very classical presentation of type 1 diabetes with very abrupt onset of symptoms like polyurias, ketosis, and a lot of them had diabetic ketoacidosis. So generally, based on clinical grounds, we term them as type 1 diabetes, and workup for amylase lipase was not done.
Okay.
In these patients.
Okay. All right. Because we know, in clinical COVID-19 infection, when we tried to do in many patients, we found that there was a lipase and the amylase rise that was there, and it was a transient type of diabetes that was identified in clinical COVID-19 infection. I think if there are no more questions, any questions from the audience here?
I have a question for Dr. Nandita about the Dia-Home app. It's very unique, and you're going to give the care at the patient's home. How has been the response to that, and how do doctors appreciate this particular app? Because this is something novel done during the pandemic.
Thank you, sir. The response has been absolutely fantastic from patients' point of view. Patients are really finding it a big boon, and not just for patients within or inside of Chennai, even from other parts of Tamil Nadu as well. They're able to connect and seek care from doctors across borders. So it's literally connecting patients to doctors across borders from north to south, or all over. And that's really become a boon to patients. They're very, very happy with it. Doctors are also very, very comfortable because the app is, from the patients and from the doctor's point of view, the app has been very user-friendly and easy to use. Secondly, because it provides the complete circle of care where we it's literally called Dia-Home because everything is taken to the patient's home. So it's become very comfortable for patients and also for doctors to order tests and to get the test done very quickly with to be able to see the patient with the reports and with the assistance of the physician assistant. So when the consultation is done, it's not just the doctor and the patient during the consult, but also a physician assistant who is connected. And she assists the doctor to go through the tests and updates the doctor on the patient history. So it makes it a lot more efficient and user-friendly and also time-saving for doctors as well.
Thank you. And one question to Dr. Dakshita Padye. Very good presentation. Your views on, you've been working on this FibroScan for diabetes and NAFLD for some time. Where is your research now headed and what are your future thoughts?
So this ATTD 2022, the FibroScan
Yes.
paper is accepted, and I would like to share the results that out of almost 30% of the patient, I mean, we did FibroScan for the patients whose cutoff was more than 1.3. 30% of those patients, absolutely asymptomatic, had a FibroScan showing stiffness values pretty high. 3 patients were referred to hepatologists. They already had developed varices, but not esophageal bleed. But maybe these patients will be managed by a hepatologist lifestyle modification, as we know that by guidelines, more than 10% of weight loss reduces fibrosis by 30%. And within 3 to 4 months, we have seen stiffness score coming down. LFT CTC should be a part of routine panel of ADA evaluation. ADAs are Bible, and we do ECG, lipid profile, urine microalbumin, retinopathy, everything so religiously for our patients. Just prescribing one LFT CTC and entering those values in FIB4 calculator, which is so easily available online, we can diagnose NASH very proactively, and just patient education, lifestyle modification, and correct change of pharmacotherapy. I think pioglitazone is a wonderful drug which is used by hepatologists in non-diabetic patients. In view of its action on insulin sensitivity, we as a diabetologist or whoever is focused in diabetes practice should be using this drug proactively. And now we have SGLT2 also. So these are few drugs which can be used in the initial period of NASH before fibrosis has set in as an anti-inflammatory agents along with their anti-diabetic property can do a lot of good to our patients.
Thank you and great work. And just to acknowledge Dr. Sanket Pense, when I was a professor in Amrita Institute, Dr. Sanket did his training under me, and he was so hardworking and diligent during those days. And I really feel proud to see this presentation by you, Dr. Sanket. And where is your research work headed in this field? What do you think will happen?
Regarding this particular topic, I think we need to follow these patients for a longer time because there was some questions from my colleagues that whether this diabetes in children is transient or it is permanent. So that also we need to follow these particular group of patients. And that is our main thing. And second area of interest that we have is to screen our own patients. We have a large number of patients with type 1 diabetes to screen whether some of them may be having actually MODI, maturity onset diabetes. That is our newer area of interest nowadays. So we'll be working in that area. Let's go. Thank you for your comments. Thank you.
Thank you. And over to Dr. Bose for his final views and then to the organizers.
I am muted.
Unmute, Dr. Bose. Please unmute, sir. Sir, we cannot hear you. Please unmute.
Dr. Bose, please do unmute your mic. You can just press the space button.
Audible now? Am I audible?
Yes, sir.
Yes, sir.
Yeah. Thank you. First of all, let me thank Dr. Unnikrishnan, Dr. Veda, and all the coordinators of the CDI team for calling me as a chairperson for this particular session. It was really entertaining, exciting, and something. Three different new ideas were there from all the three speakers. The fibroscan, specifically in diabetic individuals, when to do it first time, when to do go ahead with it, what is the importance of the various values of FIT4 score, right? So I think it is going to be really useful for the practitioner when to send this particular patient for fibroscan, and definitely we can stop the progression of the Nash into fibrosis, and once it is fibrosis, okay, this should be our aim, that the patient should not be landing into cirrhosis. So at fibrotic stage only we are supposed to diagnose it early and treat it as fast as possible. Thank you, Dr. Dakshata, for your lucid talk on fibroscan. I like to say thank to Dr. Sanket also. Though the number of cases were very few of the type 1 diabetes mellitus, and I think it's a good thing that the COVID-19 now is disappearing. Good to say that, because the kind of workload that was there amongst all the physicians, amongst all the doctors, it was really disturbing for last 2 years. But let's hope that now that the fourth wave is not arriving and we are coming to the end of the COVID-19. But anyway, that was a nice thought-giving talk on subclinical with the new onset type of diabetes, type 1 diabetes mellitus, whether really the antibodies are playing role, specifically the COVID-19 antibodies, or it is altogether a thing that was to be identified, even if it would have not been the COVID-19, still remains unclear. But then really exciting talk by Dr. Sanket, and the way to handle the diabetic patients by Dr. Nandita Arun regarding the way to approach and way to go ahead with the diabetes detection, the various the mobiles, the telemedicine, how to make the use of this thing. I think it was narrated very lucidly. Thank you all the speakers, and let me again thank Dr. Unnikrishnan, Dr. Veda, and team for giving me this opportunity. Thank you very much. Yeah.
Thank you, Dr. Bose.
Thank you, sir.
Thank you, Dr. Sethia. A very warm thank you to Dr. Dakshata, Sanket, and Nandita for a wonderful presentation. We will move on to our next topic. I would be happy to hand over the mic to Dr. Shraddha.
Thank you, Sunila. So moving ahead with our next session, which is DPP-4 inhibitors. What do the time in range trials say? For this, I would like to invite our chairperson, Sarita Kulkarni. She is a consultant physician at Jahangir Hospital, MBBS from BJ Medical College. She is co-guide for DNP medicine students at Jahangir Hospital, conducting head-up tilt table test at Jahangir Hospital for diagnosis of syncope. So, welcome, ma'am, and over to you. Please introduce the speakers.
Good afternoon. It's a great pleasure for me to introduce our speaker for this topic, Dr. Suhas Erande. He is a consultant physician and diabetologist. He is the member of the American Diabetes Association, the International Diabetes Federation, and is also a member of the scientific committee for RSSDI at Mumbai. Welcome you, sir. And without wasting much time, I directly request him to start his session.
Gentlemen, and welcome to the Chelaram Diabetes International Meeting.
I'm Dr. Erande, briefly going to talk about clinical implications of glycemic variability, one of the important metric of measuring glucose, and then what we have tried to do, the top TIR study. So glycemic assessment, as we have understood from long time, fasting blood plasma glucose, postprandial plasma glucose, and then laboratory HbA1c, glycated hemoglobin, last 12 weeks of average sugar, and we have associated HbA1c, corroborated that with micro and macrovascular complications. However, we also understand that this metric probably falls short of assessing hypoglycemia, that is quality of life for the patient. It does not provide information on the frequency, duration, and the magnitude of short-term fluctuations in glycemia. It does not reflect intra and interday glycemic excursions and gets easily affected by hemoglobinopathies and maybe renal failure, chronic liver diseases, iron deficiency anemia, which is fairly common in India, etc. So HbA1c can't alone tell the full story of glycemia. So over a period of time, the HbA1c, fasting plasma glucose, PP plasma glucose, called as glycemic triad, we incorporated a few more parameters, fasting, PP, HbA1c continue, and then hypoglycemia, which is extremely important for the patient and for us to avoid, and it's related to quality of life and maybe even cardiovascular complications, and then glycemic variability. So GV, popularly called it as, is a consistent predictor of hypoglycemia. One side of the glycemic variability is hyperglycemia, the other is hypoglycemia. Hypoglycemia is associated with significant morbidity and increased mortality. Frequent and large glucose fluctuations are independently able to contribute to diabetes-related complications. Large fluctuations in sugars, they generate oxidant strain, procoagulant status. Then the cellular function also can get altered. It can delay the nerve conduction. It can make the retinal and the glomerular capillaries a bit leaky. So all this can result into complications, and increased GV is associated with mortality, especially in ICU. Our intensivists fairly appreciate that. So GV is a better predictor of hypo than HbA1c. That's an important statement. So this is how it goes. Increased risk of severe hypoglycemia if we categorically go on teasing and analyzing GV. Increased risk of cardiovascular events, the famous Accord trial, VADT trial, I need not delve into that. Also affecting the cardiovascular autonomic function, the silent myocardial infarctions, the orthostatic hypotensions, lot of other things. Microvascular complications, we will again delve into that down the line, and then macrovascular complications. The carotid intima media thickness also is related to high GV. So GV at a cellular level, look at the slide in detail. This is a one typical cell of the body. So that's the cytoplasm, that's a nucleus of the cell, that is a mitochondrium. And glycemic excursions trigger oxidative stress, increase intracellular reactive oxidant species. So defective angiogenesis activates pro-inflammatory pathways and long-lasting epigenetic changes as well. So what we ultimately have learned from DCCT and UKPDS, the metabolic memory or metabolic legacy, that actually generated in the cellular nucleus and organelles. So in the cellular nucleus, what is actually more? Polyadenylyl ribose phosphate, PARP. Then that generates glyceraldehyde 3-phosphate dehydrogenase, GAPDH. And then that GAPDH reduction can induce polyal pathway flux, methylglycoxal production, so increase receptors for advanced glycogen end products, increase advanced glycation end products. It can induce the nuclear factor kappa B, increase induction of PKC, hexosamine pathway flux. So these are the biochemical ways which can actually create hyperglycemic memory and different complications. This is a popular slide, you know very well. Continuous glucose monitoring on which we really can assess and analyze glycemic variability. This is an example of that. This is a sensor on the back of the arm. This is a reader. And then continuous glucose monitoring provides a robust data about the short-term glycemic control, maybe 7 days, 14 days, etc. Provides metrics such as time in range, which we will discuss down the line. So these are all three gentlemen have same HbA1c. However, here you can see that there is lot of hyperglycemia, lot of hypoglycemia. Only 40% of the time the patient is in range, 40% of times he is in a hyperglycemic range, 20% of times hypoglycemic range. In the next example, this is fairly better. 70% of the time the patient is in normal range, 25% he is in hyperglycemia, and 5% of time he is in a low or hypoglycemic range. And the last example, 100% in range. In practice, this is very difficult to really come across. So these are the recommendations from the International Committee of Experts. All of us are aware that one of our, you can say, good friends, in fact, one of our investigators in the top TIR trial, which I am going to present, Dr. Bansi Sabu, our immediate past president of RSSDI, was one of the members who wrote about the time in range in the international consensus. So they said that you have to wear the CGM device for at least 14 days, and percentage of time the device is active should be 70%. That is more than actually 10 days. And we look at many parameters like mean glucose, glucose management indicator, time above range, which is above 180 or to 250, time in range, that is 80 to 170 to 180, and then time below range. Two ranges again, between lower than 70, grade 1 hypo, lower than 54, grade 2 hypo. Next slide. So that is a ADA 2022 guideline as well. So time in range, depending on whether it is a young or old person, depending whether it is type 1 or type 2, depending on whether, if it is a lady, whether she is pregnant or whether it is a gestational diabetes mellitus, the time in range recommendations can vary. But for most of the people, it is 70%. Sugar should be between 70 to 180, the interstitial sugar on the CGM report. Between 70 to 180, that's the time in range, as you can see the green band. And then there are time above ranges, as I told you, above 180 or above 250. Time below range, which is above less than 70 or below 54. And they should be really less. So around 17 hours of the day, the patient should be in time in range. Beyond that, maybe around 3 to 4 hours, maybe in the hyperglycemic range. And for a very short period of time, hypoglycemia. That's the most important priority. We have to avoid that. Next slide, please. So this is the importance of maintaining time in range. We can always corroborate that now with either microvascular complications. You can see here, if you have a reduction in time in range, so increased time in hyper or hypo, then there is a 60% risk of retinopathy, which is going up, 40% risk of microalbuminuria, and 25% risk of diabetic peripheral neuropathy. So the microvascular complication risk goes up. Coming to our study, this is the teneligliptin effect on glycemic control through parameters of time in range. So naturally we have used a continuous glucose monitor when we were doing top TIR study, and this is a prospective multi-center open label study to assess effect of teneligliptin on glycemic control through parameters of time in range metric using a CGM monitor. So teneligliptin, why we chose teneligliptin? Because it is the most widely prescribed gliptin in India, orally administered at doses of 20 milligram most of the times, or maybe 20 BID or 40 OD depending on the consultant. There is a limited data on the effect of teneligliptin on TIR parameters, and that is why this study was taken up. So to evaluate the percent of time in range in patients who were on metformin background therapy and now on teneligliptin, TIR, TAR, TBR, glycemic control, tolerability, these were the secondary objectives. And as I have already told you, apart from myself, yours truly, Dr. Erande, Dr. Bansi Sabu, and none other than our own Dr. Dr. A.G. Unnikrishnan of Chelaram Diabetes and of the diabetes world was, you can say, the investigator. Study drug was of course teneligliptin on the background of metformin, and unless a rescue therapy was required, these two were the drugs which were continued. This was the general flow of the events. Day 1 to day 4 was called as baseline. Day 5 to day 14 was the post-treatment phase, because on day number 5 we started teneligliptin. Day 33 to day 46 was the post-treatment phase. Mind you, from day number 1 we had put the patient on a continuous glucose monitor. Naturally, the changes whatever happened through the baseline to post-treatment phase 2, they were assessed. As you can see here, parameters of GV, parameters of coefficient of variance, and then TAR, TAR2, TBR, TBR2, TIR, all were assessed. Of course, fasting PP and HbA1c were also assessed. Male and female patients between 18 to 65 years of age, HbA1c above 7.5, generally below 9.5 or even 9, but up to 10 was allowed. And of course, type 2 diabetic patients who were gliptin 9, very important, only on metformin therapy in the background. And then naturally type 1 diabetes, insulin therapy patients, severe diabetic with especially ketoacidosis, hypersensitivity, etc. they were ruled out. They were not included. And this was the sequence. CGM device was inserted on day number 1 if the patient satisfied the exclusion criteria, normal RFT, normal hemoglobin, normal LFTs, etc. CGM was started here. Teneligliptin 20 was introduced from day number 5 onwards. CGM device was taken out on day number 15 because the duration ends. There was an interlude, teneligliptin continued. Second CGM device was put on day number 33, continued till day number 47. And day number 1 to 4 is called pre-treatment, 5 to 14 is post-treatment phase 1, and 33 to 46 day number is called as post-treatment phase. So that's the total, you can say, spread of the study. And we naturally assess the efficacy parameters, assessment of all primary and secondary GV endpoints, HbA1c, fasting PP glucose, monitoring and recording of all adverse events. So these were the results, my friends. We tried to actually analyze all the patients, intention to treat analysis population, and 59 patients were actually involved in the measurement, continuous glucose monitoring pre-phase 1 and phase 2. In one patient, because the sensor actually got out, it got dislocated, so that's why you will see that 55 got reduced to 54, and then per protocol analysis population was held as 54, 42 because they were in the range of HbA1c between 7.5 to 10.5 at baseline. So these were the results. Fasting and postprandial blood glucose, baseline 183, fasting came down to 161. Baseline PP 241 came down to 211. So both fasting PP came down. HbA1c 9.35 came down to 8.48. And these were the other parameters like body mass index, HSCRP, LFTs, RFTs, sugars. Naturally you have seen that they have came down, and HbA1c reduction is biostatistically significant. And this is the histogram again. These are the 42 patients, 7.5 to 10 of HbA1c in the baseline. So mean percentage time in range 70 to 180. This is the baseline 64.96, improved in the phase 1 to 75.07, maintained to phase 2 75.68. Mean percent TAR above, that is time above range, above 180 31.69 came down to 22 and 20.26. Glucose management indicator, which you know is a CGM derived HbA1c, and that improved from 7.05 to 6.76, 6.64. And this is the tabular presentation of the same data. As you can see here, average blood glucose, glucose management indicator, glucose variability percent, you can see here that came down 1.19, phase 1 1.16 maintain, p-value 0.0001, and then time in range 64.96 improved to 75.68, again biostatistically significant. Time above range came down, time below range also actually stagnated, certainly increased, but you can always appreciate that we are trying to control the patient. Next slide please. So time in range 70 to 180, and that's the number of patient baseline 45.81, phase 1 63.66, and phase 2 73.98. That's the improvement in the time in range. So teneligliptin, my friends, was generally well tolerated, and I am sure you will agree because you are also using them. There were hardly any report-worthy side effects, and we just compared the top TIR study against other studies, like for example this study where 100 milligram canagliflozin and 20 milligram teneligliptin, they were actually used. Patients shifted from teneligliptin to canagliflozin, which was called a switch group. So first teneli, then cana, and in the second lot or the second half of the group, cana added to teneligliptin. So both cana and teneli, and the last is teneli versus placebo, but these are elderly patient, more than 65 years of age. And you can see here the sample size which we had is fairly, you can say, in tandem with the other trials. Duration also is similar. A1C inclusion was also practically similar, and we have practically, you can say, 0.87% HbA1c lowering, 0.84% HbA1c lowering. Time in range improved by 10.72 with us, and cana teneli 11.5% improvement. Elderly patients, the improvement was seen as around 19. So comparable parameters. Next. So my friends, teneligliptin in our top TIR study reduced the GV. As I have already shown you the various parameters of measuring GV. There was a significant improvement in the mean time in range at the end of the study compared to the baseline. There was a significant improvement in the mean time above range. It came down at the end of the study compared to the baseline. There was also significant improvement in the mean HbA1c at the end of the study, that is 42 days versus the baseline. And teneligliptin led to early glycemic improvement, baseline to phase 1 itself, that is within 10 days. We have also seen that, and it was fairly tolerated. So my friends, as a conclusion, top TIR study, teneligliptin is not only useful early after the start of use, but it certainly improves the parameters of glycemic variability, and it improves the time in range. So that's what is our top TIR study. I thank you so much for patient listening.
Thank you. Thank you, Dr. Suha. Go ahead with any questions if she has.
Thank you, sir, for the very insightful presentation on this novel topic. So time in range is indeed very, very crucial for preventing the microvascular complications. We can take a couple of questions from the audience.
May I ask a question?
Yes, sir.
May I ask a question?
Please go ahead, sir.
Unni sir, you are already an investigator.
Okay. Not about the study.
Whether you are allowed to ask questions.
No, not about.
You are one of our team members.
Not about the top tier study, but
I
was just thinking about teneligliptin, very economical drug, and somebody has generated evidence that's really good because it improves the time in range. And that is good news for the entire DPP4 family because it is good for all the gliptins. So I was just asking your views on how the use of gliptins will now evolve in the era of gliflozins coming up, SGLT2s coming up in a big way.
I fully understand. Yeah, and I fully understand and appreciate the importance of the question for practitioners, because our attitude or our overall approach is now more of patient-centric and outcome-oriented type 2 diabetes management, as the famous ADA compendium by Professor Hertzel-Gustin and Professor Melanie Davis. We are certainly insisting on cardiovascular outcome trials before a drug is allowed to be sold in the anti-diabetes drug market. So gliptins, up till now, they don't have something which is a cardiovascular benefit or superiority. At the best, the TCOS trial or the Examine trial or maybe the Carolina trial, they have shown a CV neutrality at the best. So from that point of view, the question remains whether gliptin will certainly fare all right with the stiff competition from the gliflozin group of drugs, which are certainly cardiorenal, metabolic, safe and superior in lot of MACE parameter or Mayer parameters in the RCTs. However, the importance of glycemic variability and I have tried to show some correlation with the microvascular complications, with the CIMT, the macrovascular complications. And down the line, I'm sure that quite a few studies will certainly allude to improved time in range and correlate with the complications more robustly or more emphatically. So till that time, an incretin group of drug, oral and affordable, like teneligliptin and maybe some other affordable gliptins also, if they have shown an improvement in time in range, reduction of glycemic variability, that should certainly carry the day, at least till a foreseeable frame of time, that these drugs should be relevant in the treatment of type 2 diabetes. We are not actually arguing against the side effect or those patients where we can't use gliflozins if you are comparing. However, as a general typical diabetic patient, certainly these should be fairly HbA1c lowering, fairly safe as far our 1.5 decades experience is concerned. And now this little evidence of GV improvement and TIR improvement. That's what my view is.
Thank you, sir.
Thank you, sir.
May I ask one question? Sir, which is the gliptin of your choice? Is it teneligliptin or what is your choice? What do you use in practice more?
Yes, technically speaking, I am using all gliptins which are available. So there is nothing like not using any particular gliptin, sitagliptin, linagliptin, and then the teneligliptin, vildagliptin, obviously, vildagliptin both BID as well as once a day. The literature up till now, scientific literature, the sitagliptin and linagliptin also have a devoted cardiovascular outcome trial to support their stand in the market. The important, and vildagliptin though doesn't have a CVOT, but still it has a lot of metabolic, systemic reviews and meta-analysis, all those. Comparatively, teneligliptin doesn't have that kind of a scientific literature published to back it up. However, this is a very small attempt to show that, well, teneligliptin also has some kind of a scientific package. Number two, the affordability and the amount of experience which teneligliptin certainly has built in the last half a dozen or more years in India. I'm sure that that tilts the balance fairly, you can say, equally in favor of all the gliptins right now. So barring saxagliptin, which has a handicap of heart failure hospitalization risk, most of the gliptins available in India, we certainly have a fair scientific, commercial, practical balance to the use of all these. So that makes me use most of the gliptins practically in equal proportions.
Thank you, sir. So
I think there is a question in the chat box from Dr. Pramod Umarji about QT prolongation.
Yeah.
If you could elaborate on that, sir.
Most definitely. There are some points. In fact, I have published one Q-set trial.
So you're not audible, sir. Dr. Erente, you're not audible.
His video is paused. It is hanged.
Is it audible now?
Yes, it's audible now, sir.
Yes, sir.
Okay. So that QSET study has already been published. Though the number was only 66, the study was taken, you can say, at a multi-center level down the line. And Dr. Bansi Sabu was again in the forefront of that QSET study. And it has been certainly, this is an Indian setup. We have certainly measured the QT interval by different formulae. And Brajet formula is something which we certainly use, but we also had used Framingham and other formulae. So our observation was the QT interval was not prolonged in these particular patients of type 2 diabetes, where either 20 or 40 milligrams of teneligliptin was used. These are not thousands and thousands of patients over a period of 5 years or 6 years. No, this is not that robust and that prolonged trial. But in a span of 4 months, 5 months, 6 months, QT interval was not adversely affected. It was not adversely prolonged when the patients were put on teneligliptin. The dose, as I told you, most of the cases 20, few patients also 40 milligram per day.
So are you worried when you give 40 milligrams at all and about the QT interval, or do you monitor it just out of curiosity?
Yes. In fact, Dr. Unnikrishnan, I would certainly be cautious about using any, you can say, drug which is on paper likely to prolong the QT interval, because diabetes itself, especially prolonged duration of diabetes, the patient has diabetic cardiomyopathy, the patient is on insulin or insulin secretagogues. All these, hypoglycemia, all these are likely to prolong the QT interval. So the diabetes and the phenomena related to diabetes itself, rather than pharmacotherapy, are certainly going to be troublemakers for practice. Using non-diabetic drugs, there is a huge list of non-diabetic drugs which also can prolong QT interval. Having said that, I believe that if we are using teneligliptin 20 milligram, well, yes, most of the occasions there is no problem as per the observations. But 40 milligram unusually used. I can certainly see that we are not using it that popularly, that frequently. So 20 milligram, no problem. 40 milligram, at least in the QSET trials, we didn't have a problem.
Dr. Sarita, could you also tell about your experience with gliptins? Because we have sitagliptin, saxagliptin, vildagliptin, teneligliptin, evogliptin, allogliptin. I'm sure that the more innovative names will come up. As a physician, your thoughts on the gliptin class? They are here to stay, isn't it, even now?
Certainly, gliptins are really a good class of drugs that we can use. And even though we have the SGLT2 inhibitors now, gliptins have their own place. And especially with when teneligliptin came, it was affordable for the Indian scenario. That was a very promising drug, because initially sitagliptin was very expensive. And of course, now vildagliptin is also, most of the patients can afford that as well. So they are definitely very promising class of drugs. And as sir very rightly pointed out, HbA1c cannot tell the complete truth about the glycemic control, and glycemic variability is a very, very important aspect which we have so far not been focusing on. And I think as more and more new trials come with different drugs, we will also have to look at the glycemic variability aspect more keenly.
Thank you. It was a wonderful session.
Yes.
I really enjoyed, listening to Dr. Arande. Wonderful style of presentation and important original, our own research, being presented, gratifying. And Dr. Kulkarni, Dr. Sarita Kulkarni, thank you for your comments as well. And we move on to the next session. Dr. Avdesh Kumar Singh is already here. Welcome, Dr. Avdesh. And Dr. Sunila and Dr. Shraddha, please do introduce the chairperson and speakers.
Thank you so much, Undi. Thank you.
Thank you.
Thank you, Dr. Sarita. Thank you, Dr. Arande. So moving ahead towards our next session, a critical appraisal in pandemic diabetology. So I would like to invite our chairperson, Dr. Atul Joshi, to chair the session. He is a consultant physician in Pune since 1995, intensivist at Pune Institute of Neurology till 2004, consultant physician at Sahyadri Hospital, consultant physician at Kothurud Sahyadri, principal investigator in global multicentric paramivir trial in 2010. So over to you, sir. Please introduce the speaker.
Yeah. Thank you, the organizers, Dr. Veda and Dr. Unnikrishnan, to consider me as a chairperson for this session. Let's move on to our next session. Let me introduce Dr. Avdesh Kumar Singh. I don't think he needs any introduction, but formality will do that. He's an endocrinologist, diabetologist from GD Diabetes Institute, Kolkata. And he is also a chief consultant endocrinologist and diabetologist, Sun Valley Diabetes and Endocrine Research Center, Guwahati. Of late, due to the pandemic, we have learned to see everything from the COVID lens. So I like, let's go to the topic, non-insulin antidiabetic agents in patients with type 2 diabetes and COVID, a critical appraisal. Over to Dr. Avdesh Kumar Singh.
Can I get a permission to share my screen? Yeah. Thank you, Chairperson, sir. Thank you, Dr. Uni, for giving me the opportunity to share my thoughts on this topic. Always a pleasure to and colleagues. So let me find out where is my presentation. Hope you can see my slides now.
Yes, we can, Dr.
Thank you. Okay, so, that's a pretty interesting area. I mean, when the COVID started in somewhere in March 2020, we were very keen to understand how anti-diabetes drug will behave in people with diabetes and COVID-19. And somehow I was very keen to understand the safety of anti-diabetic, drugs in patients with COVID-19 and type 2 diabetes. This led me to write a number of papers. I wrote at least 50 papers on COVID-19 in past 2 years now. And one of the highly, cited paper, which was this recent edition in 2022, we wrote a review. This was invited review from Annual Review of Medicine. This journal published only one, issues once in a year. So they invite the best of the people in the world to write their invited review. You can't write unless they invite you. I was privileged to write this review for Annual Review of Medicine. And we compiled entire data of diabetes and COVID-19 and what has happened in this in February 2022. So that's the, the very fresh from the oven. Now we looked into the entire data of diabetes, anti-diabetes drug, the new onset diabetes in patients with COVID-19. So I will share what we learned in past 2 years, especially focusing on anti-diabetes drug, which Dr. Uni has given me a responsibility to talk today. Now, the first question which was raised early during 2020 is, does diabetes increases the severity or death in patients with COVID-19? That was the billion-dollar question during 2020 when we come to know that COVID is pandemic, and we wanted to know what happens to the diabetic patient if they contract COVID-19. Now, at that point of time, there were many papers were coming from, in particular from China, and those papers were suggesting that people with diabetes are likely to have a very severe COVID-19 and they are dying more compared to the non-diabetic population. So therefore, we thought to really pull the data of the severity and death to understand really, whether patients with diabetes are dying more or having a severe COVID-19 requiring mechanical ventilation. So this was one of the first paper I wrote in collaboration with UK colleagues. You can see people from UK, Kamlesh, Melanie Davis, and entire team. And I led this meta-analysis. They requested me to do a meta-analysis of all the studies done in patients with diabetes to understand whether we are associated with increased severity and death if you have got a diabetes. So this paper published in Diabetes, Obesity and Metabolism, and we looked into whether patients with diabetes has got a chance of increased severity. As you can see, these are the comorbidities associated with COVID-19, of which diabetes in particular, if you see, increases the severe COVID-19 by twofold. Means if you have got an uncontrolled diabetes in particular, your chance of getting a severe COVID-19 requiring ventilation is twice compared to non-diabetic population. What about the death? It is pretty in the same direction. If you are diabetic and your chance of dying is almost twice than your non-diabetic counterpart. So this was one of the first meta-analysis of 15 retrospective study at that point of time, consisting of 16,000 diabetic patients where we could show that people with type 2 diabetes in particular had 2 times higher risk of severe COVID-19 and 2 times higher risk of dying from COVID-19. And since then, number of papers came into the effect. We also could, notify, you can see a second paper here from the same group of team, and this was led by Sam Sadi from UK. And here we are trying to suggest that not only diabetes, but people with obesity, they are also having a chance of having a severe COVID-19 and dying from COVID-19 is quite high. This is a BMI based on more than 25 versus less than 25. You can see the severity and mortality is quite significantly higher. People, those who are obese. So clearly 2 things came out very, clean cut at that point of time, that if you have got diabetes and you are obese, the chance of having severe COVID-19 and dying from COVID-19 is pretty high. And as I said, since then, a number of meta-analysis came into the effect, and we pulled all these data into this annual review. And you can see all the meta-analysis put together here in front of you in your screen. You can see every studies that looked for diabetes as a risk factor for severe COVID-19 or death. The data were all concordant, suggesting from 2 to 3-fold chance of having a severe COVID-19 and therefore increase in death. Now the second question is, does that mean that only severity or death also is the important factor? Now, who is dying from COVID-19 if we have got a diabetes? That's the second question we try to understand. Every diabetic patient or those who have got uncontrolled diabetes? That was the second question which wasn't answered at that point of time. So we also looked into that. You can see this is our paper which we looked into, and we looked into 500 odd patients of COVID-19 and grouped them into a propensity matched analysis. We matched 250 odd patients into 2 arms, those with a controlled diabetes and those with uncontrolled type 2 diabetes, to understand whether diabetes per se increases severity or it's a control of diabetes that matters most. So what we did is, we included 500 type 2 diabetic patients, well matched on a propensity scoring, so that there should not be any bias, to understand whether, control of diabetes has got anything to do with severity. And, as expected, the data you can see people having poorly controlled diabetes were many-fold high chance of having a severe COVID-19, acute kidney injury, acute heart injury in the form of different biomarker, clearly suggesting that uncontrolled diabetes are those people having a higher propensity to have a severe COVID-19. And also, they are the same people who are dying more, almost twice. You can see this is 5-fold higher here, increase in death in uncontrolled diabetes. So the second thing which we learned, that it's not only diabetes, but people with diabetes who have got uncontrolled diabetes, they are more prone to have severe COVID-19, and chance of dying from COVID is, quite higher if you have got uncontrolled diabetes. Then, now the third part, which was very interesting to, to learn at that point of time, that we could see many people coming with new onset diabetes or at admission hyperglycemia in unknown diabetic were pretty high, and it was coming from every corner of the world, that we are seeing a good number of patients with new onset diabetes who didn't have diabetes in the past. So we also worked on that part. What is this new onset diabetes and at admission hyperglycemia? I'm not going into detail because of paucity of the time, but then clearly these data suggested that the people who had a new onset hyperglycemia or at admission hyperglycemia were having a high chance of severe COVID-19, and they die more frequently than compared with those who had a pre-existing diabetes. So that's one third story of diabetes and COVID-19. Now the final part was, this is what my topic is, about anti-diabetes drugs. Now in the very early part of COVID pandemic, this paper came from India, from PGI Chandigarh. Sanjay and Ramesh wrote first commentary in DRCP suggesting that, hello, let's not use, X drug because there is a chance of, implications related to ACE2 receptor. As you all know, COVID is a binding receptor as a angiotensin converting enzyme 2. So any anti-diabetic drug that has a potential to increase ACE2 might be associated with a harm. And in this paper, Sanjay and Ramesh proposed that some drugs like pioglitazone or GLP-1 receptor agonist or SGLT2 that increases ACE2 may do harm if you use in patients with COVID-19, unlike DPP4 inhibitor or HCQ that have got nothing to do with ACE2 might be useful. So that was a proposition at that point of time, but in absence of any clinical data, right? So, the panic started in the diabetes community, with the diabetologist community, that what to do with regard to anti-diabetic drug if I have got a patient with COVID-19. And in absence of data, we all speculated at that point of time, and you can see this was the first paper, in fact, in the globe, and we wrote this, guidelines to the world how to handle diabetes and anti-diabetes drug. This was the paper which we wrote from India, and we recommended that, hello, if you have got a diabetic patient with COVID-19 in a hospitalized patient setting and in a patient who are having a severe COVID-19, 2 drugs should be avoided. One was metformin and one was SGLT. Just in anticipation that metformin may cause increase in lactic acidosis in a setting of hypoxemia, and SGLT2 can potentiate euglycemic DKA in patients with severe COVID-19. Remember the caveat we wrote, that we don't have any evidence. We think that this could be a possible association if you use metformin and SGLT2 in patients with COVID-19, in particular those who are having a severe COVID-19. Now, when we wrote this paper, then entire world came into effect, and you can see this paper came in Lancet Diabetes and Endocrinology, and 13 investigators across the world, they came with a proposal, and they also suggested not to use metformin and SGLT2 like we suggested, but they additionally went into board to even suggest not to use a GLP-1 agonist as well in all patients with COVID-19. They went even one step ahead. We only suggested not to use in severe COVID-19, but this Lancet paper suggests let's stop metformin, SGLT2 and GLP-1 in every patient with COVID-19 and type 2 diabetes. So that was initial fear, at that point of time. Even from people from the UK came into, and they wrote a position statement in diabetic medicine, and they were exactly same like we proposed, that don't use metformin and SGLT2 in severe COVID-19. So their suggestions were exactly similar to what we proposed. So the fascinating part, at that point of time, remember these are all suggestions in early 2020, when we didn't have any evidence, any study with anti-diabetes drug in patients with COVID-19. And then for last 2 years, a lot of change has happened. This paper we wrote that really we need to stop those drugs in patients who are critical and having severe COVID-19. And when we reviewed the literature, we found, there's nothing to be panicked. I mean, there is no need to, stop these drugs in every patient. Maybe if you have got a patient with severe COVID-19, then there is a justification to stop metformin and SGLT2, but there's no need to panic. There is no bad data with anti-diabetes drug in a critical care setup prior to the COVID-19. And this we proposed, we wrote this commentary in DRCP. Now then, since then, a lot of things has happened, and we went 2 years ahead now and learned a lot about anti-diabetes drug. So let's look into what is the data at the moment with anti-diabetes drug. And when we are talking anti-diabetes, we are talking about non-insulin agent other than insulin. So we have got data mainly from metformin, DPP4, SGLT2, and GLP-1 at this point of time, because we studied these anti-diabetic drugs in patients with COVID-19. The best data which came with metformin was this study. You remember, this study is called Coronado. This was a first prospective study done in France, and that looked for the safety of anti-diabetes drug in patients with type 2 diabetes and COVID-19. In the Coronado study, out of 2,500 odd patients, nearly 1,500 patients were receiving metformin. And you can see this data is all-cause mortality at day 28. This study did suggest that patients who were using metformin had less death compared to those who were not receiving metformin. So the Coronado was one of the largest study done with metformin that find that metformin user had less death compared to non-metformin use. The only caveat of this study that these are the patients who received metformin before admission into the hospital. This is not a data where metformin was used in hospital after the hospitalization. This data is pre-hospitalization metformin use versus metformin non-user, and this data suggested those who took metformin prior to admission had less compared to non-metformin use. And since then, number of the studies have published. You can see this is our review. We compiled all the studies done with metformin in patients with diabetes and COVID-19. And we can come to three conclusions. That there are studies that find no benefit, no harm, no benefit. These are some retrospective studies. There are one study that find that metformin can do harm. And then we have got good number of studies that find metformin is possibly doing benefit in patients with COVID-19 and type 2 diabetes. And then we have got meta-analysis, at least 4 study of metformin looking into the outcome in patients with COVID-19. By and large, the data suggests, and let's not go into detail, this data suggests that if the patient is on metformin, that would do a wonder, in terms of reducing severity and mortality. That's the data in nutshell. But is it conclusive evidence? Answer is no, because none of these are randomized controlled trial. These are retrospective studies, and these are mainly prior metformin user, not seen metformin use during admission. So therefore, we cannot commit that metformin is doing wonder. This simply suggests that metformin is doing no harm. So if you have got a patient with type 2 diabetes on metformin, don't stop the drug. It won't do any harm. The next drug which was also investigated was DPP-4 inhibitor. And you can see this was one of the first paper we proposed that DPP-4 inhibitor might be doing wonder in patients with COVID-19 because of various mechanisms. And I'm not going into detail because DPP-4 inhibitor was one of the entry receptor for the elder brother of SARS-CoV-2 that was MERS-CoV. So it was suggested that if you block DPP-4, you can possibly block the entry of SARS-CoV-2 as well. And it was proposed that using DPP-4 inhibitor might be useful. Now, if you look into the data, this is 2 studies that actually took the center stage at that point of time. These 2 papers published in Diabetes Care simultaneously. You can see both the paper came from Italy, and this paper studied sitagliptin in patients hospitalized with COVID-19. So on your left-hand side is one study of 338 patients, and the second study is again from Italy, and this looked for the DPP-4 inhibitor as a class, although very small number of patients. But this study did study the in hospital use of DPP-4 inhibitor, sitagliptin here, or any DPP-4 inhibitor, and the outcome. And it was surprising or rather unbelievable to find in both this study, the author suggested that there is a significant reduction in a DPP-4 inhibitor user compared to a non-DPP-4 inhibitor user. So the first study you can see, this is too good to believe, almost 56% reduction in death. And this study find, 87% reduction in death in those who are using DPP-4 inhibitor versus non-DPP-4. And this came in diabetes care, with an impact factor of 21. Just imagine the kind of data. However, people could not believe that this could be true. And we all waited for a randomized control trial because these are retrospective studies done in Italian hospital. And when we looked into the entire data of DPP-4 inhibitor, again like metformin, the data is not pretty conclusive, but there is a suggestion that this is not harmful. So you can see again 3 kind of studies. Some studies found no benefit, no harm. Some studies found even harm with DPP-4 inhibitor. Some studies shown possible benefit, and then meta-analysis suggesting, overall some find benefit, some find no benefit. Collectively, this data do suggest that DPP-4 inhibitor is not harmful. That's very clear. Whether it is doing benefit or not, that we don't exactly know in absence of randomized controlled trial. And therefore, we were waiting for RCT, which was going with the DPP-4 inhibitor. And I will present you the first RCT, which has come very recently. This was done in Mexico. This is a study done with linagliptin in patients with COVID-19 and type 2 diabetes. And there were 2 arms. Patients were receiving linagliptin and insulin, and 1 arm is receiving only insulin. And this study finds a significant reduction in patient requiring ventilator, those who were receiving linagliptin with insulin compared to insulin alone. So this is a small RCT for the first time giving us a hint that using a DPP-4 inhibitor in an in-hospital setting could reduce mechanical ventilation requirement compared to non-DPP-4 inhibitor. So this is a first evidence. But then it's a pretty small study to make any conclusion. Well then, so because of these data, one commentary was wrote by Michael Nock and Juris Meyer in Diabetes Care, and they explained how DPP-4 inhibitor can be useful in patients with COVID-19. And I just want to share you how DPP-4 inhibitor might give benefit theoretically. We don't have enough evidence except that a small RCT. Now you remember that DPP-4 is present in 2 forms. One is membrane-bound form, and one is soluble DPP-4, which is circulating in plasma. When you give a DPP-4 inhibitor, you increases the soluble DPP-4 level. So there is a possibility that if you increase the soluble DPP-4, the membrane DPP-4 concentration gets reduced. And if at all SARS-CoV-2 has got any potential to get binding to the membrane-bound DPP-4 inhibitor to enter into the cell, by using a DPP-4 inhibitor, because you are increasing soluble DPP-4 and reducing membrane DPP-4, the chance of entry into the target cell would be less in a DPP-4 inhibitor users compared to non-DPP-4. That's the probable mechanism cited by Professor Michael Nock and Juris Meyer from Germany. And this is a very good suggestion to understand how the DPP-4 inhibitor might be useful. But then the caveat, we don't have good data or a large RCT. Finally, I will take you through the 2 more molecules, SGLT2. This was prospectively studied in DARE 19 with dapagliflozin. This was a double-blind randomized controlled trial called DARE 19, done with dapagliflozin in patients with COVID-19. We thought that SGLT2 would be bad in patients with severe COVID-19. This study included moderate COVID-19 and find that dapagliflozin is not doing any harm. There is a suggestion of benefit, although it didn't achieve a statistical significance. You can see there was 20% less chance of organ failure and death on a dapagliflozin user compared to placebo. And on your right-hand side, you can see all the outcome. Remember, this is a large randomized controlled trial done with SGLT2 in an active COVID-19 patient. And contrary to the popular belief, SGLT2 did benefit rather than any harm, although it wasn't statistically significant. So simply this data suggests that, again, you can see the kidney endpoint or all cause. It was less in SGLT2 users than the placebo users in patients with COVID-19. Although none of these endpoints achieve a statistical significance, but clearly this data find that SGLT2 do no harm. If at all it is doing good. You can see everything is left of the unity, suggesting that there is no chance of any harm. There is a possible, suggestion of benefit. This trial is already going on, and we are waiting for the follow-up data. But basically, this trial finds SGLT2 is absolutely safe even in a COVID-19 setting, and that's the summary and conclusion of DARE 19. Finally, The last molecule to look after was the GLP-1, and we do have some small studies with GLP-1 as well in COVID-19. Majority of these studies find neutral outcome in patients receiving GLP-1, and this is one work we are going with, which is unpublished, and we looked into GLP-1 data. And if you pull the data of all patients receiving GLP-1 versus non-GLP-1 in patients with type 2 diabetes, there is suggestion that it could do benefit rather than any harm in patients with COVID-19 and type 2 diabetes. Ladies and gentlemen, I'm going to conclude my presentation simply to, what I understood from these trials is the data with metformin is mammoth, but then the only drawback that metformin, we could say that it reduces death in patients with type 2 diabetes and COVID-19 is the lack of RCT. These are the data mainly from retrospective study, barring the Coronado, which was a prospective study. We don't have, powerful evidence. Simply, I would say that don't stop metformin. They are not doing any harm. If there is any suggestion, it is a beneficial suggestion. For the DPP-4 inhibitor, the data are too good to believe. So again, I would say modestly that don't stop at least if someone is on DPP-4 inhibitor. I would not claim that DPP-4 do a miracle, but then I would say that don't stop. It is not doing any harm. So neither stop metformin nor DPP-4 inhibitor. And I have shown you the data from there. No question of stopping SGLT2 in patients with COVID-19 unless someone is totally hypoxemic on dyselectrolytemia, volume imbalance. These are the typical contraindication of SGLT2. Rather, so if you have got a stable COVID-19, please don't stop SGLT2. SGLT2 does a miracle. It protects heart and kidney. Remember all the CB outcome trials. GLP-1, they are safe. Don't stop. So if you recall the earlier speculation, stop metformin, stop SGLT2, stop GLP-1, they no longer exist at the moment. So safely, this data suggests that don't stop any anti-diabetic drug in particular. Remain as it is you are. If you have got a diabetic patients with COVID-19, don't stop any drug. We don't have any data at the moment that suggests that any anti-diabetic drug any harm. Continue with the drug. Very simple. 2 years of learning, and we learned that continue with whatever anti-diabetic drug is right now patient is receiving. There is no suggestion that any drug is doing any harm. Thank you very much for your patience.
Thank you, Dr. Avdesh Kumar Singh, for the nice lucid presentation. And as it seems that the initial apprehensions were unfounded, so we can safely use whatever anti-diabetic drugs the patient is on without any fear. Any questions from the audience?
Actually, there are no questions in chat box, but thank you, sir. That was much needed topic to be discussed in this era of COVID. So in summary, you are saying that no anti-diabetic drug should be stopped, only that new SGLT2 and metformin should not be added. And if at all the sugars are uncontrolled, the patient can be straightly taken on insulin treatment.
No, I did not say that don't give metformin and SGLT2. Use whatever drug you wish to use. I mean, there is no data that suggests that any drug is harmful. So it's the physician choice to add or subtract any drug. And whether it is adding metformin and SGLT2 is entirely the physician's choice in patients with COVID-19. There is no harm whatsoever. Possibly there is a suggestion of benefit rather than any harm. One question is there.
Actually, it's a comment, sir.
I have one small question, sir. How do we explain the increase in new onset diabetes due to COVID? Because of the inflammatory response, or what is it?
Yeah, so Dr. Joshi, we don't have any explanation to really understand. And to my knowledge, there is already one registry right now going on. And this job is not yet done. COVID-19 registry is on by the international team. And we all are giving our data to that international registry, led from US. We are still trying to learn how new onset diabetes is happening. We exactly don't know whether SARS-CoV-2 has got a direct propensity to gets attached to the beta cell in pancreas, or it is because of a stress hyperglycemia or the counter-regulatory hormones mediated increase in blood glucose. We exactly don't know. We have to wait for some time, and scientists are really looking after the best data. To understand new onset diabetes only would be in an autopsy setting. People who died, and we need to check their pancreas to understand whether there was a loss of beta cell. We need to stain a beta cell for change in beta cell damage due to the SARS-CoV-2 direct involvement. Unless and until we have got a autopsy data, we can't say that SARS-CoV-2 direct infect beta cell and causing new onset diabetes or even a type 1 diabetes like picture. At the moment, it looks like that a variety of factors has come into effect. Previously, to my knowledge, I think they were primarily undiagnosed diabetes. They were primarily pre-diabetes, and at the helm of affairs with use of unscrupulous steroid use, they have been potentiated pre-diabetes into diabetes. Many were undiagnosed diabetes. So collectively, there is no hard evidence to suggest that SARS-CoV-2 per se causes new onset diabetes. It looks like that they were masked diabetes, undiagnosed pre-diabetes. They were now landed because of a stress hyperglycemia, because of counter-regulatory hormone, because of misuse of a steroid, all factors taken into together.
Okay, thank you, sir. There's one more question in the chat box. I think this will be the last question we'll be taking it and conclude the session. Dr. Rupali is asking that can we add a SGLT2 inhibitor in COVID-19 patients if the patient is already not on it?
SGLT2, you mean?
Yeah.
Well, why not? So unless, see, the point is, we don't use SGLT2 in a critical care setting still at the moment. Forget about COVID. Even in a non-COVID situation, we stop SGLT2 in patients who are dehydrated, hypoxemic, and admitted in ICU setting because of the baggage that contain. I mean, stop those SGLT2, even what you do in a non-COVID situation. So I would not encourage you to use SGLT2 in a critical care setting, but then don't stop SGLT2 or don't hesitate to use SGLT2 in patients who are stable, irrespective of, the COVID status. So unless or until patient is in an ICU, in a critical care setting, where we don't use SGLT2, even in a non-COVID setting, don't use SGLT2. Otherwise, don't stop the drug. You can use SGLT2 if your patient has got a history of heart disease, heart failure, CKD with diabetes, even if he has got a mild to moderate COVID-19, don't stop the drug.
Okay, thank you. I think we'll conclude the session. I'll hand over back to the organizers. Thank you, sir.
Thank you, sir. Thank you very much, Dr. Unika.
There's one more question from Pramod Umarji. What about euglycemic ketosis due to SGLT2?
Yeah, that's what I've shown you the data. Even in the DARE 19 trial, I have shown you the safety data in DARE 19, which was a randomized controlled trial done with dapagliflozin in 1,000 patients on a SGLT2 inhibitor, and there was no such signal. Of course, there was a numerical increase in decay. This is expected that if you use SGLT2, the chance of getting euglycemic decay is higher. That's a well-known fact. But then, even despite there was a numerical increase in decay in the DARE 19, if you see the kidney function, if you see the liver function or heart function, they all improve in the dapagliflozin arm compared to placebo. So you have to be careful when you are using the SGLT2 inhibitor, but then that do not threaten upon the decay. You have seen the SGLT2 trial, DAPA-HF, DAPA-CKD, Impaired preserved, Impaired reduced. There was no signal of increase in DKA. And you have seen all CB outcome trial, Impaired, declared TB canvas. Where was the increase in decay in all the trial? So you have to be pharmacovigilant, but then that would not be a deterrent to use and take mileage of benefit in terms of heart and kidney benefit with the SGLT2 inhibitor.
Okay, there's one comment from Dr. Amit Bhakri. It is great. That was a great data and work. It's scientific treat to learn from you, sir.
Thank you very much. Thank you very much.
Thank you, sir. So this is the end of the session. Thank you. I would like to thank Dr. Atul Joshi
for chairing the session, and Dr. Avdesh Singh for imparting us with this knowledge. Thank you. So moving on towards our next session, which is Frontiers in Clinical Diabetology. To chair the session, I would like to invite Dr. Savita Bhatt and Dr. Sushil Chauhan. CV of Dr. Savita Bhatt, please. Dr. Savita Bhatt is a senior consultant in glaucoma, medical retina, and phaco-surgeon at Jelaram Diabetes Institute. She has completed her MS Ophthalm from CMC Vellore. She has done her fellowship in medical retina at Giridhar Eye Institute, Kochi. She has published extensively in the field of glaucoma with several publications in leading journals. She has won Best Research Paper Awards at national and state levels. Her paper was accepted in Asia Pacific Association of Ophthalmology. She has also participated in multinational clinical trials. So I would request Dr. Savita Bhatt to, our next chairperson, Dr. Sushil Chauhan. He's a MD Medicine, DM Nephrology. He's a well-known doctor in the city of Pune. His keen interest is in nephrology, especially in diabetic kidney disease. So I would ask the speakers, to the chairperson to introduce the speakers. Over to you, Dr. Savita.
So much for your kind introduction, and we'll move on to the next session, which is Frontiers in Clinical Diabetology. I welcome Dr. Manisha Sahai, who's with us online right now. She's a
Ma'am is an MD ophthalmologist from London. She's a professor and head department of nephrologist, and she's a head of the Department of Nephrology from Osmania Medical College, where she did her nephrology. She's been a vice president of Indian Society of Nephrology. She's editor-in-chief in Indian Journal of Transplantation, council member at International Society of Nephrology. She's a chairman at South Asia Regional Board, fellow of Royal College of Physicians, and she has also been an executive committee member at Indian Society of Organ Transplant. About 13 gold medals, from a national gold medal in nephrology in 2003, 90 publications in national and international journals, many orations, and more than 300 guest lectures, national, international, and zonal societies, examiner for DM and DME, and MCI inspector. Ma'am, we welcome you for your speech on pediatric diabetic kidney, ma'am. Over to you.
Thank you very much. So can I share my screen?
Yes, ma'am.
Yeah, okay. So is my screen visible?
Yes, ma'am.
Yeah, okay. So thank you. I thank the society for this great opportunity to talk about pediatric diabetic kidney disease. We all know that the incidence of type 1 diabetes is much lower in Asians. And type 1 diabetes constitutes up to less than 1% of diabetic population in Taiwan in one of the studies published. And in India, overall, it's less than 5%. However, the disturbing point is the incidence of newly diagnosed diabetes is increasing. What about type 2? We know type 2 is more common in adults as compared to children. But here also, the rise in childhood obesity has led to an increasing incidence of type 2 diabetes, even among children and adolescents, which at times parallels or at times exceeds that of type 1 diabetes among minority youth, especially after the age of 15 years. So type 1 is increasing, type 2 is increasing as well in children. Nephropathy occurs both in type 1 and type 2 to the tune of 30 to 40% that we all know. And among adults, we know that type 2 diabetes is the predominant cause of kidney disease. Almost 30% of all end-stage kidney disease is because of diabetes. However, in pediatric CKD, the contribution of diabetes is to a very less extent, but probably these numbers are underreported. And we may see a change here as well. We know diabetes now is not type 1, type 2 alone. We have a new classification. WHO has also defined many categories of diabetes. I'm not going to the details of that, but we know we have type 1 diabetes, where you have autoantibodies present. You have type 2 diabetes where you don't have antibodies. And in that second group, we have other diabetes as well, which may be genetic cause of diabetes, MODY, for instance, and then you have many other causes of diabetes. What are these many other causes of diabetes? You have, as I said, some of them are genetic, where you have genetic defects of beta cell function. You have various types of MODY here. You have genetic defects of insulin action. In addition, you have others, endocrinopathies, or you may have diabetes which is drug-induced or chemical-induced, or maybe some other genetic syndromes associated with diabetes, infections. So these three slides tell us that we don't have type 1, type 2 alone. You have so many diabetes, which may be because of genetic etiologies, infections, and so on and so forth. Type 1 and type 2, we know are the predominant forms. And type 1, we know that it presents with generally decay, it's severe, presence in childhood generally. And here the insulin secretion is deficient or absent. And here you know that generally only around 20-25% people may be overweight and pancreatic antibodies are present. Whereas type 2 generally occurs in older children or adults. Associated with obesity, ketosis is far less common. Family history is quite strong. And you know that here you have more of insulin resistance. And most of the children are obese who have type 2 diabetes, and pancreatic antibodies are generally not seen. So these are the two major types of diabetes. So you must be wondering why I'm talking about different types of diabetes for a nephrology lecture. This is because the point I want to highlight is nephropathy can occur in any of these types of diabetes. It's not only type 1 or type 2. Even MODY, especially the type 5, can be associated with renal disease. In fact, any of these diabetes which I have mentioned can be associated with kidney disease, and hence we need to be aware of this point. So coming to the case scenarios, where you have a diabetic child presenting with a kidney disease. So we have a 5 years female who comes to your clinic, type 1 diabetes, diagnosed at the age of 3 years when she presented with decay. Now she has come to you at the age of 5 years, that's 2 years after the onset of diabetes. Her sugar parameters are pretty well controlled. She's on insulin. She doesn't have any renal symptoms, no oliguria, no swelling, nothing. She has come to your clinic. She is your regular patient. Will you screen her for kidney disease? Yes or no? Remember, for all type 1 diabetics, screening should be done at least 5 years after onset. And if the onset of diabetes is somewhere near puberty, then the screening should be done right from that day of onset of diabetes for kidney problems. So remember this. So in the example which I have given, that child has come to you within 2 years of onset of diabetes, and screening may not be required for that type 1 diabetic. What about type 2 diabetic children? Remember, here it's different. Remember, you have to screen right from the day of onset of type 2 diabetes, because they may present with nephropathy and we may miss it. So type 1 diabetes, sometime maybe 5 years after onset, type 2 diabetes, right from day 1, please screen for kidney disease. So in the first case, do we need to screen for nephropathy? No. Coming to case 2, 9 years old. Here, the onset of diabetes was at 3 years of age. Duration of diabetes now is 6 years. Retinopathy is there. Still no renal symptoms, no oliguria, no swelling. Would you screen this child for kidney disease? The answer is obvious. I've already answered it. Here, the duration is more than 5 years, and it's better you should screen this patient for nephropathy. Fine. So we have understood when to screen type 1 diabetes and when to screen type 2 diabetes. What tests do you do? I mean, there are battery of tests, everything, ultrasound, CT, 24 hours, everything should be done. No. Screening tests are only 2. One is urine albumin and the other is creatinine. And based on creatinine, we calculate the GFR. Now, GFR calculation is very simple. As you can see, all of us are smart physicians. We should have a smartphone. And in the smartphone, you have these formula, the NKF GFR calculator. The last one is the revised bedside Schwartz formula. So this is used for children. And I've shown you for this child, suppose height 150 centimeters, serum creatinine, suppose 1.3 for this child, the GFR is 48. So normal GFR is about 90. So 48 is definitely low. And we would not have known had we not screened the child for a kidney problem. And this child had albuminuria of 566 milligram per gram of creatinine. So screening tests, what we did for the child, 2 tests, urine albumin, and we looked at the GFR using the Schwartz formula. So what is normal level of albumin? We all know 30 milligram per day, less than that, or 30 milligram per gram of creatinine. There are many methods of expressing. Don't get confused. Remember one, less than 30 milligram per day. And between 30 to 300, we call it moderate albuminuria, and more than 300, we call it macroalbuminuria or severe albuminuria. So this child, 566, we had severe albuminuria. Remember, one-time measurement is not sufficient. You have to document persistent albuminuria by doing 3 samples over 6 months period, and at least 2 of them should be positive. And another important thing about albuminuria is always rule out infections or hyperglycemia, ketosis, congestive heart failure. When the child is sick, don't test for albumin at that point of time. It may be falsely high. So this child, the second example, had albuminuria, persistent albuminuria, and also had a low GFR. So where was this child? This child was in the 3rd stage of CKD, where the GFR is less than 60. And the albuminuria category, we know A1, A2, A3. A3 is more than 300. So this child had 566 milligram, definitely had A3 albuminuria. So we call this child G3A3. So why do we look for albuminuria? Because albuminuria is one of the earliest indicators of kidney damage. 25% of children at 10 years and 50% at the age of 20 years after diabetes can have albuminuria. And it's important to pick it up because not only it indicates the renal disease, you can reverse it. 50% of cases almost can be reversed with proper management. And if you don't reverse it, it goes to macroalbuminuria. Even at macroalbuminuria, you can reverse it to a lesser extent. If you don't do anything, it progresses to end-stage kidney disease. So albuminuria is important. But at this point, I would like to highlight around 25% of diabetic children, like in adults, may not have albuminuria, and especially in type 2 diabetes. And this is called non-proteinuric diabetic kidney disease. So albuminuria is an important indication of the presence of nephropathy, but if it's not there, do not rule out the kidney disease. Look for other markers, do a creatinine and GFR as well. So thus case 2, what is the diagnosis for that child? Diabetic nephropathy in a type 1 diabetic, and the stage is G3A3. So let us see what we'll do with that child. So we have one child of type 1 diabetic nephropathy. This is another child, type 2 diabetes. Onset at 13 years, now 17 years, obese with retinopathy and poorly controlled. This child also has albuminuria and the creatinine is again high. This child also is in stage 3 CKD. So this child is different from the first child where the child had type 1 diabetes with nephropathy. This child has type 2 diabetes with nephropathy. So as I said, we can have nephropathy in type 1 as well as type 2. How do we treat them? Are both the nephropathies similar? Are they different? Let us see a tale of these 2 children. So let us look at their different stories. So for type 1 diabetes, remember the progression of nephropathy is slow. It passes through all the 5 stages generally, where you have hyperfiltration, then silent stage, then albuminuric stage, then you have over and GFR goes down, and then end stage. And this happens over 20 to 30 years. So slow course in type 1 diabetes. Type 2 diabetes, unfortunately, it's not very clear, and there may be early progression and the outcomes are poor. So these 5 classical stages may not be seen. So what's the difference between nephropathy, which occurs in type 1 and type 2? But in type 1, it's long duration of diabetes, latent period generally 10 years, all 5 stages are seen, and diabetic retinopathy is strongly associated. 90% can have retinopathy, and it has a relatively better prognosis as compared to type 2, which occurs after a short duration. Even at onset, it may be there. Latent period may be short or absent. Stages are not clearly defined, and diabetic retinopathy association is less, around 60%, and the prognosis is not that great. In addition, the type 2 nephropathy is more often associated with hypertension, dyslipidemia, obesity, more of left ventricular hypertrophy, insulin resistance, progression to diabetic kidney disease, and mortality is higher. So type 2 nephropathy, ladies and gentlemen, has a worse prognosis as compared to type 1 nephropathy. Fine. So we have understood that the course is slightly different between type 1 and type 2. Is the treatment same or different? How do we treat these? So let us look at it. We know that in adults, we are very familiar that how do we treat nephropathy, glycemic control, BP control, lipid management, smoking cessation, nutrition management, exercise for all patients. Most of the patients, RAS blockade and SGLT2 inhibitors, and antiplatelets for some adults where indications are there. What about this pyramid in children? Is it same or is it different? Let us see. So for both type 1 and type 2 nephropathy, the diet precautions are the same: restriction of salt, restrict to plant proteins rather than animal proteins, physical activity. If the adolescent is a smoker, insist on stopping the smoking, and BP control. The target BP control as per the pediatric BP guidelines. And remember, RAS blockade is very important in both type 1 and type 2, and use a maximum tolerated dose. We should not use minuscule doses, pediatric doses, which are not optimal. So whatever prescribed pediatric dose is that for that age group, that should be used. It's very important. In India, because of hyperkalemia, we come down on the doses, which is not correct. So this chart shows that use maximally tolerated dose, whatever drug you are using, either ACE or ARB. Fine. What about the glycemic treatment? Is this same or different? So diet is not different. The BP control is not different. RAS blockade is not different. Is glycemic management different? So in type 2 diabetes with nephropathy, what do? We start with metformin. And we all know that more than 60, no need for dose modification, please use. In between 30 to 60, you have to be more careful. You may need to adjust the dose. And less than 30 GFR, metformin generally we do not use. So these are the guidelines in adults as well as in children for type 2 diabetes with nephropathy. And another study has shown, today's study, that metformin may not alone be sufficient for control, and early combination may be the way to go. So you might need to add a second drug. Now, what drug should be the second drug to be started after metformin if you want to give a combination therapy? So in adults, we have so many drugs available: the sulfonylureas, GLP-1 analogs, SGLT2, DPP4, glitazones, acarbose, buglibos, glenides. Which of them are they all indicated in children? So in older children, most of these drugs can be used, but data is evolving, it's getting generated. So KDIGO says after metformin, what drug should be used as the second line? It's very clear that SGLT2 are the ones where you are talking about diabetic nephropathy. They are wonder drugs. They act by reducing the intraglomerular hypertension. They block the SGLT2, they cause loss of glucose and sodium in the urine. The sodium reaches the distal segment, stimulates the macula densa, and this macula densa then tells the afferent arteriole to send less blood into the glomerulus because I'm receiving more sodium, stop the hyperfiltration. And as a result, the hyperfiltration comes down, the intraglomerular pressure comes down. So wonderful drugs. This reduces the progression of chronic kidney disease because hyperfiltration is the main culprit. So these drugs, they, apart from being anti-diabetic agents, have multiple advantages. They are smart diuretics, they decrease the proteinuria, decrease renal work, they are anti-inflammatory, reduce the weight, reduce BP. They are cardioprotective drugs as well, very good drugs in adults, and they are the indicated straight after metformin. And there are multiple trials. We are all aware of Impaired, Credence trial, DAPA-CKD, 30% reduction in renal events. So in adults, nephroprotective. What about GLP-1 analogs? Can be used as a second drug or third drug after the SGLT2? Yes, again, adults trials show that they are nephroprotective, though the evidence is less strong as compared to the SGLT2 inhibitors. So they are also good drugs. What about the gliptins, DPP4 inhibitors? So Carmelina Sol trial has shown that what about children then? Type 2 diabetes, nephropathy, children, should we use these drugs? They are so important drugs for adults. What about in children? So in children, the trials are ongoing with GLP-1 receptor agonists, with DPP4 and SGLT2, all of them. You have ELLIPSE trial with GLP-1, you have SGLT2 trial, the DEPIC-2 study, but still they are ongoing. The results will be published in 2023. So what's the final take on SGLT2 in type 2 diabetes in children with nephropathy? Still we need more data, though some studies have been reported already. What about the other child with type 1 diabetic with nephropathy? We know that we use insulin. The diet management, BP management is same. What about the drugs? Insulin, no controversy, can be used. What about the other drugs? Are SGLT2 inhibitors being used for type 1 as well? So yes, there is a attempt trial where they are trying to study this very point, and this study will be completed by the end of 2023. So as of now, type 1 diabetic nephropathy, we use insulin or insulin analogs. So thus, what we've understood for nephropathy in type 1, lifestyle, BP, ACE inhibitors, and insulin. Type 2, same thing, lifestyle, BP, ACE inhibitors, metformin, plus maybe SGLT2 inhibitors. Okay, so this part is clear. Now suppose both these children, they do not respond to management, they are non-compliant and progress to end-stage kidney disease. Creatinine becomes 6 in both of them. What will you do? Again, is the treatment same or is it different? Treatment, we know hemodialysis can be done, peritoneal dialysis can be done, or kidney transplant, which is the best option in children. So these three modalities can be offered. Hemodialysis, a child has to go to the hospital thrice a week, get the dialysis done for almost 4 hours each day. And this has to be done till the child undergoes a transplant. PD, on the other hand, can be done at home. So this is the advantage. It's a home therapy. And very young children, less than 10 kg, hemodialysis may be cumbersome and peritoneal dialysis is a better option. So either type 1 nephropathy or type 2 nephropathy, if they go into end stage, hemodialysis, peritoneal dialysis is very much available in India. We have a huge unit. We do around 100 dialysis a day. Best option for type 2 diabetes with nephropathy, what is it? Kidney transplantation, isolated kidney transplantation. So this boy received a kidney from the donor and is subsequently doing well. So this is the type 2 diabetes with nephropathy. What about type 1 diabetes with nephropathy? Is the treatment similar? So hemodialysis, peritoneal dialysis, yes, it is similar. What about kidney transplant? Remember here, the standard of care is not isolated kidney transplant. It's a simultaneous kidney pancreas transplant where you are hitting two birds with one stone. At the same procedure, you are putting the pancreas, which produces insulin, and you are putting the kidney as well from a deceased donor. So kidney goes into the bladder. The pancreas can either be drained into the bladder, which is shown on the left side, or it can be done into the GIT. So kidney can drain into the bladder and pancreas in GIT, which is shown in the left side. And this is the standard of care for type 1 diabetic with nephropathy. And that type 1 diabetic patient at our college underwent simultaneous kidney pancreas transplant, which was done on 14 September 2016. And it was a successful transplant, no need for insulin post-transplant, and the patient was off dialysis. So that is the standard of care. So we have discussed type 1 diabetes in early stages where we used all the drugs and insulin. Type 2 diabetes we discussed with or without metformin and SGLT2 inhibitors. And then we discussed the end-stage kidney disease where we give hemodialysis, peritoneal dialysis, and transplant. Isolated for type 2 and simultaneously kidney pancreas transplant for type 1. So we have discussed about diabetic nephropathy. But remember, one important point, that all kidney disease in diabetic may not be diabetic nephropathy. Almost 75% is diabetic nephropathy, what we have discussed. But these diabetic children can have other kidney diseases as well, like any other non-diabetic person. And what are these kidney diseases? They can be pre-renal, they can be post-renal, and they can be inside the kidney. The vessels of the kidney may be involved in vasculitis, the glomeruli may be involved in glomerular diseases like IgA and PGN, FSGS, etc., etc. And the tubule and interstitiums can be involved in interstitial nephritis. So any kidney disease can occur in these diabetic children, and we may get confused that it is diabetic nephropathy. This is called non-diabetic kidney disease. So when will you suspect? The child will come with swelling, oliguria. When will you suspect? You should suspect non-diabetic kidney disease if there is no retinopathy, if there is hematuria, if the RBCs are present in urine, if the renal failure is very rapidly progressing. One day creatinine is 2, next day it's 5, 1 week it goes to 10. That does not occur in diabetic nephropathy. And if the proteinuria is nephrotic, huge proteinuria, then think that it might be non-diabetic kidney disease, it might be a glomerular disease. And if the patient has systemic features, example, rash, joint pains, etc. So we have 3 case scenarios from our hospital. 7 years female, type 1 diabetic, didn't have retinopathy, she came with swelling. So on the face of it, maybe diabetic nephropathy. That was the diagnosis when we got the referral. But this patient had RBC in urine, 4+ proteinuria, and 4,000 milligram of protein per day. Creatinine was normal. So what will you do? Suspect non-diabetic kidney disease and do a biopsy. And what did the biopsy show? It showed that the child had nephrotic syndrome, FSGS, and she responded to treatment with steroids. So if we had not done the biopsy, we would have missed it. It was referred as a case of type 1 diabetic with nephropathy. This case, 11 years old, type 1 diabetic again, and presented with fever, sore throat, swelling, high colored urine, and hypertension, again referred as nephropathy. Here again, the urine sediment was active. What is the diagnosis? Classical presentation. It is PIGN, post-infectious glomerulonephritis, or IRGN, which is quite common in children. We call it infection-related glomerulonephritis nowadays. Treatment is diuretics, control of BP, and they completely recover. So this is not diabetic nephropathy. The fifth case referred to as 13 years old, female, type 1 diabetes, again referred as nephropathy, but on history, she had hair loss, she had joint pains. Again, urine sediment showed RBC, lot of protein. SLE profile was positive. So this was SLE nephritis. She underwent a biopsy which showed the same, and she was started on steroids, mycophenolate, and HCQ, and she is doing very well. So suppose we had not treated her, just put her on ACE inhibitors, glycemic control, and BP management, she would have gone into end-stage kidney disease because of a disease which could have been treated. So this we should never ever miss. So few slides in the last, what's in the future? One thing is the role of biomarkers in pediatric kidney disease. So I told you sometimes the kidney disease, there may not be any albuminuria. How do we pick this up? We can look at biomarkers, for example, NGAL, cystatin C, KIM1, but these are things of the future. As of now, they are being done, but they are not commercially useful. We need to exactly define their place in childhood diabetic kidney disease. Other important point in the future is Finrenone. We already know Fidelio-DKD trial in adults. After SGLT2, Finrenone is very important drug for nephroprotection. And you'll be happy to know that such a trial has been initiated in children as well. And the third important thing in the future, the whole purpose of this conference where a nephro is talking at an endo and a physician meeting is collaboration. We have very little data on type 1 diabetic nephropathy as well as type 2 diabetic with nephropathy. We lack in follow-up. We have huge number of patients. India is a resource of diabetic patients. And it's high time we have registries for follow-up of these diabetic kidney disease patients in children. And for this collaboration between nephro, endo, diabetologists, and physicians is very important. The key word is a team approach. And I'm happy that this topic was put up in this conference. So take home points, ladies and gentlemen, type 1 and type 2, both are important cause of nephropathy. Type 2 nephropathy is different. It can occur at onset, can progress very rapidly. Early detection, whether type 1, type 2, early detection of nephropathy is important by looking at albuminuria and GFR. And the keywords are glycemic control, BP control, RAS inhibitors in appropriate dose. They are the cornerstones of management. Now, what comes in the future? SGLT2 inhibitors for pediatric diabetic nephropathy. For type 2 diabetic nephropathy shortly. Type 1 diabetic nephropathy also may be in the future. Some trials are going on in that area also. And for type 1 diabetic with kidney failure, what's the treatment of choice? Not isolated kidney transplant. It's simultaneous pancreas kidney transplant. And the last but not the least important message is we are all bombarded with diabetic nephropathy patients. And in the midst of them, we forget about picking up non-diabetic kidney disease patients. And this diagnosis rests with the physicians, with the endos, and with the diabetologists. So look for those pointers: hematuria, massive proteinuria, rash, absence of retinopathy, rapid progression. This should be a pointer that this case needs to be referred to the nephrologist for a biopsy. So thank you, ladies and gentlemen, for a patient hearing. I'll be happy to take any questions.
I think we'll have the question answers at the end of the session. Thank you for a very exhaustive talk. Thank you so much, Dr. Manisha, and I hope to have you at the end of the session for more questions. So we'll move on to the next speaker, Dr. R.M. Anjana, who's with us right now. Can I have the introduction slide of Dr. R.M. Anjana? So she's a managing director and diabetologist at the very famous Dr. Mohan's Diabetes Specialty Center. She's the vice president at Madras Diabetes Research Foundation, Chennai. She's also the winner of the Shakuntala Amir Chand Prize from the ICMR, New Delhi. And she's got several research publications to her credit. A warm welcome to you, Dr. Anjana, and over to you.
Thank you very much for the introduction. So at the outset, thank you, Unnikrishnan sir, for inviting me to this really good meeting. I was really enjoying the previous lecture from Manisha ma'am, and she was talking so much in detail about nephropathy. But now I'd like to kind of shift topics and go to something that is new and not something that is usually talked about. So let me try and get my slides, which I hope you can see. Yeah. So can you see my slides?
Yes, ma'am.
Yes.
Right. So I'm going to be talking about the new clusters of type 2 diabetes that predict diabetes treatment. And I have no conflict of interest to declare for this talk. So it all started off when in Scandinavia, when they started looking at and asking the question, is all type 2 diabetes the same? So for us, a patient comes in diagnosed with diabetes. We have our classification. We have type 1, type 2, GDM, other types, etc. But then in type 2, we have treatment recommendations that say, give metformin for everybody. And then there's second line, third line treatment. But then the question is, does this work for everyone? Are all type 2 diabetes the same? Well, of course not. So how can someone who's obese or younger onset be different from very thin, older onset, etc.? There are huge differences. Who gets retinopathy? Who gets nephropathy? We heard such a talk on that. Why do some people progress to ESRD so quickly, even with diabetes? Why do some people not have anything? Why macular edema? Why? So there are so many questions, the answers of which we don't know. So we started off by asking the question, okay, if we can try and subtype type 2 diabetes into various clusters, are there differences in treatment and prognosis to various complications? So this is the first clustering that was done. It was done the Swedish Scania cohort, about 9,000 individuals. They took all diabetes and used the following variables: GAR antibody, age, BMI, A1C, HOMA beta, and HOMA IR. So HOMA beta is an estimate of beta cell secretion, HOMA IR, insulin resistance. So this is what they did, and these are the clusters that they found. So the first one is, of course, SED, which is type 1, and we won't talk about that anymore in this talk. But the other 4 are the subtypes of type 2 diabetes. So there are 4 subtypes here. One is SID, which is severe insulin deficient diabetes. Then you have a severe insulin resistant diabetes, SERD. MOD is an obesity related diabetes, and MARD is an age related diabetes. So they had these 4 subtypes. They then replicated this in smaller cohorts, very small numbers in the other Caucasian populations. So the obvious question then is, can this be directly applied to the Asian Indian population? Do we also have the same clusters? Now, before we answer that, it's perhaps useful to know that the Asian Indian phenotype is slightly different from other types of diabetes that we could possibly see in Caucasians. And how are we different? So first of all, we seem to have a greater ethnic susceptibility to type 2 diabetes. Why do I say that? We have data from INDAB and so many other studies that say that the age of onset of diabetes is much, much lower than it is in Caucasian. So if you try and do a comparative analysis between Asian Indian and any Caucasian phenotype, you'll see that their diabetes starts like 50 plus. And that's when you start seeing diabetes. Whereas for us, it starts, the takeoff is in the age group of 25 to 34 years. So right in the 20s, people are, so that's a clear shift to left by a couple of decades. We also have the thin person developing diabetes. So if in a Caucasian population, someone develops diabetes at age 30, they have to be extremely obese. That's what we see. But in India, it's not like that. All of us have seen the very thin diabetic, younger age group, non-type 1, right? So these are type 2 diabetics we're talking about. They also have a characteristic dyslipidemia. We all know that there is low HDL. It's prevalent all over the country, high triglyceride, high small dense LDL, less adiponectin, visceral adiposity, increase in inflammatory markers. So suffice to say that we have increased risk of premature cardiovascular disease. So this is a study that is funded by NIHR. It's called Inspired, which stands for India-Scotland Partnership for Precision Medicine in Diabetes. So it's between the University of Dundee in Scotland and MDRF here in Chennai. So what did we do? The first thing we did was to
exactly replicate, the 5 variables I showed you, GAD, HOMA, beta, those exactly we tried to replicate in the Indian data. So if you look at this now, the severe insulin deficient diabetes, you'll see that they were the very thin people in the Scandinavian cohort. I mean, they were very thin, whereas the obese ones were like very obese, and A1C was highest in the SID, etc. Now try and look at India. Now what happened? Let's just look at the BMI column. So we had people who were thin in SID, but look at the MOD. The BMI was 25, whereas SID, the BMI was 32. Even MARD, the age-related, had higher BMI. So obesity was not sitting. A1C was all over the place. Suffice to say that it did not sit exactly, didn't separate out into the same 4 clusters in our population. So then we said, okay, if the exact same clusters don't work, then what can we do? Can we cluster on our own? And this was published in BMJ Open in July 2020. And this is what we showed. So we first took the database. The discovery cohort was 19,000 individuals aged 10 years and above with duration of diabetes less than 5 years at the first clinic visit at Dr. Mohan's. And here we clustered using the following variables. Of course, this is from the Asian Indian phenotype. We have age, BMI, waist, A1C, HDL triglyceride. We also included C-peptide for the original clustering. And these were the 4 clusters that came out. Now, 2 of these are very similar to what I described earlier. So the 2 ends, the SID, which is the severe insulin deficient diabetes, that one, and the MARD, the age-related diabetes, was similar to what we already saw. But then we have 2 novel clusters. Remember, all the issue was there in the obesity. So what we see is that for us, insulin resistance and obesity goes together, and they have 1 cluster that comes out. In fact, that's a very prevalent cluster. And then we have a novel and unique one called as CERD, which stands for combined insulin resistance and deficient diabetes. So this is basically in between the SID and IROD. All the features will be in between the 2, and this is novel, and I'll tell you why it's important in a bit. So these are the 4 clusters. Now, when we say age at diagnosis, for us, MARD, age-related diabetes, starts in age 50 itself. So remember, our onset is much younger. So by the time you reach 50, 55, already MARD is setting in. So that's what age-related diabetes is in our population. Now, if you look at the BMI and waist, it's least in SID, as you would expect it to be, highest in the obese insulin resistant or IROD. A1C highest in the insulin deficient clusters, which is SID, and combined, which is SERD, and so on. So then if you look at C-peptide and all of those, HOMA beta, you'll see that it is following the same pattern. So again, we had 4 clinically differentiable clusters that we defined. We also saw that the clusters remain stable when we use the year or newly diagnosed. Remember, I said 5 years since onset. Even if you made that 3 year or 1 year, it was quite stable. Now the question would be, okay, now this is a clinic population, and it's not really, you can't extrapolate this to the general population. So in order to do that, we validated it in the ICMR INDIAB data set. We had 6 of the 8 variables in the INDIAB study, which we used for clustering, and this is the result. So you'll see that up to decimal point almost, there was similarity in the clustering that we found. So age was around 55 years here. Again, BMI, waist, look at A1C. It pretty much follows the same kind of clustering, clusters that we obtained from the clinic population. Again, showing that these were replicable and stable at a national level. So what is the clinical relevance of this clustering? This would be in the complications. So here we've looked at progression to retinopathy, nephropathy, CKD, and the hazards ratios are shown here. So for SID, in retinopathy, you see it has a high progression, 1.56 hazards, and we also have it for SERD. So these are the insulin deficient groups. Remember, the A1C was high. Even after adjusting for that, it does have progression into retinopathy. Now, what about nephropathy? Remember, in leaf groups clustering, nephropathy was more for IROD that is the obesity insulin resistant group. For us, it came, so nephropathy and CKD here, one is GFR, one is albuminuria. So when you take nephropathy, it's 1.23, but then if you use the GFR, both the IROD and the combined group. So the importance here is that look at the combined group. Any way you look at it, there's the highest risk of microvascular disease progression. So hypoglycemia, quick progression, this is a group that requires attention early on, right from diagnosis. So now what about prescribing patterns and response to antihypoglycemic agents? So this is data. So long I showed you in-depth data set, I showed you the data set that was from Dr. Mohans. Now here we have taken help of data from all of the who's who of diabetology in India. And as you can see, we got data from all of these people. We received about 32,000 data from, and all these dots are various places where we got from. And the question we asked is, first, could we replicate the same question, the same clusters? Yes, we were able. I'm not going to show you all those tables again, but yes, we were able to replicate and found the same, again, decimal point differences, 4 separate groups that separated out. Now we wanted to look at treatment patterns, and for that, we had to see where baseline drug data was available. We needed a follow-up A1C, etc., etc. Finally, we had 13,000 individuals in the study for whom we could look at drug response. Now, this is the prescribing pattern in India. So we talk about newer drugs so much when we go to every meeting, everybody's talking about newer drugs. But if you look across the country, people are still using traditional agents. So number one, you still have sulfonylurea metformin combination. 25% of all new onset diabetes are being started on this, followed by metformin. And then among the newer drugs, we have DPP-4 that has come in. So this data is, again, SGLT2 is too new. Maybe we still don't have data on that, but this is what we have so far. Then we constructed models to see whether, now all the guidelines say that first line of treatment is metformin. Do any of the other drug categories do better than metformin? So our reference here is metformin. Do better than metformin in terms of bringing down A1C. And first I'm showing you cluster wise. I'm showing you the 2 insulin deficient clusters here. Of course, look at the effect of insulin here. It's really good. So you'll see that in the third combined category, 24% extra over and above. Naturally, you would expect that in the insulin deficient groups, okay? But here we also find that the secretagogues, so sulfonylureas, DPP-4, are doing fairly well in both of these categories. Now for IROD, look at the effect of insulin has gone down. So metformin again looks like a good one here. Here we did have some SGLT2 effect as well. And if you move on to MARD, look at it, almost no extra effect of insulin. So MARD is one category, maybe because the sugars are mild here. Almost all the drugs, including AGI, everything had an equal effect in bringing down the A1Cs. So you may ask now, okay, you talked about the clusters, you talked about drug response, you talked about different complication risk. How is this useful to a clinician? How do we use this in primary care? How do we use this anywhere? So in order to look at this, we have set up a tool called as DIANA, which stands for Diabetes Novel Subgroup Assessment. So what you do is as follows. You enter, remember those variables that we talked about, the 6 variables. If you have C-peptide, great. Otherwise, just A1C, lipids, waist, and BMI. You enter this, you click the predict button, and it gives you a diagnosis of which subtype of diabetes it is, SID-SERD. It also gives you the risk for complications as well as the treatment options. So I'd like to conclude by saying that for the first time in South Asia, we were able to cluster individuals with type 2 diabetes into 4 different categories. 2 were already described by the Scandinavians, the SID and the MARD, whereas we have 2 unique and novel clusters in the Asian Indian population. One is called IROD and the other is called SERD. The combined SERD is a novel cluster of particular importance because it is characterized by difficult to control hyperglycemia and increased hazards of kidney disease and retinopathy. We find that still traditional anti-hyperglycemic agents are being used popularly, and we still know that there are definite patterns. So one thing that we need to say at this point is that all that I showed you about drug responses has been done on retrospective data. So there is the confounding effect of baseline A1C, etc. And thus, right now, there's an RCT in place wherein prospectively we're looking at differential drug responses in the clusters, and we do need these in order to confirm which drug will be useful in which cluster. Thank you. That's it.
Thank you for a very excellent presentation, Dr. Anjana. We'll go on to our next speaker in the session, Dr. Munna Bhende. Can I have a slide here? So Dr. Munna Bhende does not require any introduction. She's a stalwart amongst our ophthalmology group. She's a very senior consultant at Shankar Netralaya, she's a deputy director of vitreoretinal services at Shankar Netralaya. She joined VR services in 1994. She's been involved extensively in the medical surgical management of various vitreoretinal diseases, and she has special interest in retinal imaging, academics, and research. She has several international and national publications to her credit. And I know her personally, that she has mentored many young ophthalmologists who have learned, used, and interpreted imaging. And she has very special interests in imaging retinal diseases. A very warm welcome to you, ma'am, and over to you.
Thank you, Dr. Savita and me. It's a unique opportunity to present in this prestigious meeting. I'll just share my screen.
Yes, ma'am.
Are you able to see my screen?
Yes, ma'am.
Yeah, I want to see your point, your timer.
The timer is visible to us.
Okay, fine.
20 minutes, so don't worry.
Yes, so I'm going to share a few images, cases, and examples on what is new in imaging and diabetic retinopathy with specific importance to the diabetologist. And these are the parts of my talk. I would start with the clinical applications. Fundus photography, I think, is the gold standard for any documentation of a retinal condition, where we are in the unique position of being able to see what's happening in the blood vessels. And what you see on top is the standard fundus image of the posterior pole showing a patient with diabetic macular. But what we see now is with advances in imaging, you can get an image of the entire retina 200-degree ultraviolet view, even through a non-dilated, which shows us right from the disc almost to the ora serratum 178. And this is a set of images which tells you the amount of retina that can be imaged. This is a single field, the classic fundus image with an NTDR at 7 standard field. And with our ultrawide field image, we are able to see the entire retina, additional 1, 2, 3, 4, 5 visual fields. So the chances of you picking up retinal lesions are more higher with the ultrawide field image. And we have two commercially available ultrawide field images available in India. There are a couple of new ones that have also come up, but our group had experience in comparing the true color Clarus image from Zeiss versus the false color Optos image from Optos. And we did find the chances of picking peripheral lesions were much better with the Optos image, but the chances of picking up lesions that were small and identified by color was better with the Clarus image. Another standard method of evaluation over the years has been fundus fluorescein angiogram, which involves an intravenous dye injection, and currently would be used in most centers to rule out neovascularization, to assess macular and vascular perfusion as a guide for laser treatment, and sometimes to understand unexplained visual loss. And this is a standard fluorescein angiogram picture of most commercially available angiography machines, and you see a patient with macular edema, and in the posterior pole you see leakage. This is with 30 degrees.
Can you be a little closer to the mic?
Is it better now?
Yes, yes, ma'am. It's better now. I'm sorry for the interruption.
And this is a 55-degree, a wider field where beyond the macula, you are able to see a little more of the fundus, and you're able to pick up neovascularization and vascular abnormalities outside the macula in a straight ahead view. Whereas now we have also, along with the clinical photographs, we have wide field fundus fluorescein angiogram, again, which shows us not only the posterior pole, it shows us neovascularization, it shows us the extreme periphery as well, all in a single frame, which does not require the patient to move in different directions. Now, this is a case example of a 65-year-old gentleman who would routinely come for his annual retinal checkup. His visual acuity was 6/6. He had no visual complaints. If one was to see his fundus, you would see just a few microaneurysms and hard incidents at the macula and nothing much. But with a careful look at the periphery, I noticed that he had a few retinal hemorrhages that were anterior to the equator. I got a wide field fundus photograph done, which shows the arrows are marking the peripheral retinal hemorrhages. If you see, there's nothing in the posterior pole. We did a wide field fundus fluorescein angiogram that shows a little bit of leakage at the macula. Again, you see most of the retina is okay compared to the 55-degree example I showed you earlier. But if you look in the extreme periphery, you see that there are leaking microaneurysms. So this is now a new method of classification of diabetic retinopathy where we may see fundus findings that are more confined to the periphery than the posterior. Coming to another traditional method of imaging, the optical coherence tomography that's available in most clinics. It's non-invasive and based on the principle of no coherence interferometry, you get an image quite close to a histological section and classically has been used to image the posterior pole. But with improving technology from time domain to spectral domain where we were able to see deeper into the layers of the eye, we now have the swept source OCT and OCT, which is deeper and also has a longer wavelength, so we get a wider field and it can work through a small pupil as well. So the parameters for evaluating a patient on OCT has been a quantitative parameter where we measure the thickness of the central retina and we can assess progression on consecutive scans. Here the heat map shows you that the central retina has become thicker. And even if you look at the cross section, you see that the edema in the center of the macula has become more. In addition, we have qualitative features as well as biomarkers, which may determine certain clues, which may give us certain clues and also determine the outcome. This is a middle-aged gentleman who was a type 2 diabetic on insulin, and he was referred for anti-VEGF injections for diabetic macular edema. Clinically, he had some swelling of the retina in the center and a few retinal hemorrhages, what looked like non-proliferative diabetic retinopathy. But if you look at his OCT, which is a traditional tool we would use in the evaluation of any patient who comes for treatment, you see that rather than thickening of the macula, there is a neurosensory retinal elevation in the central point. And this is not typical of diabetic retinopathy alone. It indicates that there may be some other systemic disorder playing a role. So we asked for his hemogram, which was abnormal, and he was diagnosed to have multiple myeloma. So we deferred treatment for diabetic macular edema. He was treated for the multiple myeloma. 6 months later, parameters were better, and you see the edema has reduced significantly. There is no fluid on the macula now. He then underwent a simple laser photocoagulation. So the clue here was bilateral neurosensory detachments indicating re-evaluation of the systemic status. Now, this is an elderly lady who was hypotensive, hypothyroid, and dyslipidemic and complained of poor visual recovery after uneventful cataract surgery. She had a few microaneurysms around the posterior pole in the right eye. You see this on fluorescein angiogram, and leaking microaneurysms with macular edema in the left eye, responsible for the poor vision. This feature was very typical of diabetic retinopathy, so we referred her to a physician. She was found out to have raised blood sugars. We reviewed her a month after she was started on diabetic medication. We found that the macula was still involved. There was still edema in the macula. She received one injection of an anti-VEGF agent, and the edema reduced and was subsequently stable. So certain clinical clues on imaging could give us the clue that diabetes may be present. And this is a 50-year-old colleague of mine who only complained of a distortion and scotoma in the central visual field of the right eye, which interfered with his surgery. When I asked him, he said he was otherwise healthy. The fundus photograph was normal practically in the right eye. The left eye was absolutely normal. If you look subtly, there's a little bit of discoloration of the macula that one would really have to look carefully for. But if you look at his OCT, you see that there's a little opacification in the middle layers of the retinal central to the fovea. And this indicates that there is ischemia in this area, and the commonest cause of this finding would be some kind of vascular retinopathy. So we asked him for a routine check, and he was found to have a raised fasting blood sugar. PBS was 328 and his average blood sugar was 300. So the clue here was the presence of ischemic changes in the central fovea, which prompted us to get him tested for diabetes and other systemic disorders. Now we know that fluorescein angiogram is invasive, it's dye-based and prone to reactions. So we do have a new technique which is based on the ability to image flow in the retinal vasculature, which is non-invasive, and this is an OCT angiography, which tells us that there are 3 capillary plexus in the retina: the superficial, the intermediate, and the deep capillary plexus. And this technique eliminates the need for a dye, reducing the injection-related complications. And we know that fluorescein angiogram is very dependent on the timing of visualization. So if the patient feels giddy or vomits during the procedure, you miss the crucial parts of the investigation because there is leakage which hides the vessels in the later phases. So this is one way in which we can avoid it using the OCT angiogram. And using swept source technology, it gives us a wide field, a faster imaging, and can be visualized even from smaller images. And it shows us 3 patterns of abnormality: new vessels, altered geometry, and absence of flow. Now, this is a gentleman who'd been on regular follow-ups with his ophthalmologist. He lived outside the country and had been diagnosed a few months ago to have non-proliferative diabetic retinopathy in both eyes. He came back to India and visited us complaining of slight blurring of vision in the right eye. If you look at his montage fundus photograph, it shows slightly dilated vessels, a few hard exudates, the macula and hemorrhages, and a little clue that there may be some fibrous tissue in the mid-periphery. We did a wide field OCT angiogram. This is the non-dye-based angiogram, which shows us that there was capillary dropout in the periphery. This is the normal appearing posterior pole, except for the dilated vessels. There was ischemia in the periphery and large areas of neovascularization. These are findings which would have been missed if we had used the conventional 30-degree imaging system. The dilated vessels gave us a clue that the patient also had a coexisting retinal vein occlusion. Now, this is the left eye, again looks very innocuous and normal. But if you look at his wide field angiogram, OCT angiogram, you see that he has proliferative diabetic retinopathy, mainly in the mid-periphery. The posterior pole that is traditionally involved is normal. So this patient underwent pan-retinal photocoagulation in the right eye with anti-VEGF injections, subsequently a steroid injection, and presented with neovascular glaucoma. At this time, we did the ultra-wide field imaging, which showed us that the peripheral retinal vessels were all thinned out and sclerosed. The posterior pole still looks normal. Few hemorrhages in the periphery. And you see the OCT angiography showing that the ischemia has got worse, but new vessels here have disappeared. Whereas the other eye, which had pan-retinal photocoagulation, looks fairly okay. So this is how wide field imaging has helped us to see things far beyond what we would normally see. OCT angiography also tells us subtle changes such as in the central retina, where you see the retina appears that there are few hard exudates and few hemorrhages. The OCT angiogram shows us that there is capillary dropout. And these arise with moderate red. Now, sometimes imaging can help us move further, as is this elderly gentleman with neovascular glaucoma in the right eye and an asymmetric diabetic retinopathy where changes had progressed despite aggressive treatment. This is the wide field fundus photograph of the gentleman showing that he had laser photocoagulation marks, proliferative diabetic retinopathy with the left eye absolutely normal. Now this asymmetry is what gave us a clue to image further, and the most common cause of the asymmetry is a carotid block or a stenosis. And this gentleman underwent imaging of the carotid and the central angiogram and showed high-grade stenosis of the right common carotid artery. So this gentleman was then put on medical management after weighing the pros and cons of surgery for revascularization, and he underwent additional treatment for the neovascular glaucoma and was on follow-up. So imaging can also be used as a screening tool after we've seen a few clinical applications. Why is imaging required as a screening tool? Almost half patients with diabetic retinopathy attending our units had already lost vision before the condition was diagnosed. Therefore, it's important to identify sight-threatening diabetic retinopathy and even early diabetic retinopathy in all diabetics. And Dr. Anjana has very beautifully shown us these novel subgroups of diabetes in Indians. And we know that not everyone has diabetic retinopathy, but there are a few categories very prone to it. There are various screening models. Most of them are community-based, which could be outreach programs, diabetes clinics, or mobile vans. You could detect diabetic retinopathy in vision centers or in primary health centers. Most of them require pupillary dilatation using a variety of cameras. And these are the AIOS recommendations that a camera should have minimal resolution of 6 pixels or 30 pixels per retinal degree. And these are the varying fundus cameras available for screening. We also had a study from India showing various smartphones being used for diabetic retinopathy screening. And though they had their limitations, it was definitely useful in an outreach setting to detect sight-threatening diabetic retinopathy. Now coming to AI. AI is everywhere, but why especially for diabetic retinopathy? Because there's a huge difference between the supply and demand. The number of diabetics versus the number of ophthalmologists, and the number of diabetic patients and ophthalmologists would need to screen per year, apart from all their other patients. So in Shankar Netralaya, we are proud to have been part of this landmark study, which developed and validated a deep learning algorithm for detection of diabetic retinopathy in retinal fundus photographs. And this was one of the top articles of the decade published in JAMA 2016. And we also were part of this study, which showed us that deep learning models performed well within a population of patients with diabetes in India. Now, what kind of AI would you want? Fully automatic or assisted? We know there are two categories of people other than the retina specialist who could be seeing a patient with diabetic retinopathy. One is the physician, who may have some knowledge of diabetic retinopathy, but is not expected to know the finer details. So for this category, one would need to upload the image and use AI as a diagnosis for reference. The second category is the ophthalmologist or the anterior segment specialist, who has a knowledge of diabetic retinopathy but is not involved in diabetic retinopathy screening or management as a routine. In this situation, you would use the assistive mode, where you upload the image with the ophthalmologist grading, and then the AI grading helps the doctor to augment his grading. How can we improve the efficiency of these algorithms? The first thing is, do you dilate or not dilate the patient? Many people talk about non-mydriatic fundus cameras, but there are very few of them in an outreach setting that work well. Most importantly, almost a third of images are ungradable in most outreach cameras, especially if the patient is over 60 with cataract and has poor vision. So in these patients, a mydriasis will be much better to evaluate. And this study suggested that all non-gradable photographs, the photograph should be retaken to see whether one could grade it better. You could also use the OCT, the presence of diabetic macular edema on OCT, along with the fundus image to improve the efficiency of the AI screening system. And it was found to have a better detection of sight-threatening diabetic retinopathy. And a combination of OCT and OCTA indices could improve early detection of diabetic retinopathy, especially when it comes to the circularity of the foveolae vascular zone and the vascular perfusion in the superficial vascular layers. So far we've used tools that probably are still useful in the clinical setting, some of them in occlusion. But what advanced imaging techniques have also shown is that we are understanding more about diabetic retinopathy as a neurovascular disease. Because many patients with no diabetic retinopathy do show changes both on microperimetry and spectral domain CT, indicating that there may be early neuronal dysfunction before the vascular changes set in. This is another study that showed that retinal sensitivity changes were associated with diabetic neuropathy in the absence of diabetic retinopathy. Now, comparing structure and function, we do see that patients with no diabetic retinopathy can have a normal multifocal ERG response in the center, and the OCT can be normal. But with non-proliferative changes, you can have structural changes on the OCT as well as reduced responses on the ERG. This is a patient with center-involving macular edema, again showing these blue lines indicating reduced response on the ERG. And these changes can be seen in the retina in the pre-diabetic stage. And this is importantly the circularity of the foveolae vascular zone and the vascular density. And we see that as retinopathy progresses, the retinal response is reduced, the contrast sensitivity can change. And we do see that these changes can depend on the location of the lesion rather than the number of the lesions. And finally, this article showed us that hyperglycemic and early diabetic eyes showed reversal of neurovascular coupling. The vessels dilate in the superficial plexus in light, whereas the deeper vessels constrict, basically because the metabolic demands are more in the inner layers, whereas this reverses in dark. But this entire thing is reversed in acute hyperglycemia and early diabetic eyes, indicates that there is a reversal of neurovascular coupling. This is also seen in the OCT, where you see that perfusion is less. You see in the early stages of diabetic retinopathy, flow is increased in the retina basically to compensate for these abnormalities. But if this is not corrected, then you have worsening of diabetic retinopathy, proliferative changes, upregulation of VEGF, which requires to be treated with laser and anti-VEGF injections. So to conclude, what is new in diabetes? We are more reliant on non-invasive and wide field imaging techniques, use of digital technology, AI and telescreening, and a better understanding of DR as a neurovascular disease using these imaging techniques. Thank you all for inviting me and for your patience.
Thank you, ma'am. That was an excellent lecture. Please do stay back for the final panel discussion, which is going to start in a second. In the meantime, I would like to invite Dr. Sushil Chavan, once again, our chairperson, to moderate the session, sir, along with Dr. Savita Bhatt. Dr. Sushil?
Okay. My first question is to Dr. Manisha. From your experience, ma'am, is there a pattern which you see when you see your patients with diabetic nephropathy? Do they, people with diabetic nephropathy, do they always have retinopathy? Do you find a pattern in them, or people with neuropathy always have retinopathy, something like that?
So actually the pattern is more clear in type 1 diabetic patients, but type 2, the association is not that strong. And in fact, we have published a study where we have done biopsies even for those patients who had retinopathy. And many of them, I mean around 20% of them also had associated non-diabetic kidney disease. So suffices to say in a line, generally type 1 diabetic with retinopathy, the kidney disease is generally a nephropathy. But the pattern doesn't hold true in type 2 diabetes with nephropathy. So any suspicion that it might be something else, we go for a biopsy.
So in your group that you presented, most of them had diabetic duration less than 5 years. Is that the reason there was strong suspicion of a non-diabetic etiology? And that's why you subjected them for biopsy?
So again, I have told you duration is one thing. I have told you 5 clinical indicators, which all of you, even the ophthalm people, or they be physicians or endos or whatever specialty, there are 5 clues. First thing is that diabetic nephropathy doesn't progress overnight. You have a deteriorating renal function, creatinine 0.6 one day, the next day it's 2, and within a week it's 5 or whatever. That's not diabetic nephropathy. If hematuria is there, gross hematuria is there, it's probably not diabetic nephropathy, provided you rule out urinary infection. And in case you have nephrotic proteinuria, 5 gram, 4 gram, that sort of proteinuria generally occurs with a glomerular disease. Then apart from that, if you have, say, systemic symptoms, a diabetic patient with some kidney problem comes with a rash and joint pains, the presentation itself shows that you have to suspect something else. Systemic features such as joint pains, rash and all are not common with diabetic nephropathy. So as I said, high index of suspicion is important. We are all clinicians. So it's not the presence or absence of one point. You have to look at the entire picture. And these are the 5 important clues which you should be tuned to. So whenever you know that it's not progressing the way, slow progression and all that, it's better to be on the lookout for non-diabetic kidney disease. Now, Dr. Anjana had given an excellent lecture about the clusters in adult diabetic people, but same sort of clusters, I did not find any studies in pediatric diabetic kidney disease. So maybe Dr. Anjana and her group would be in ideal position to look at that clusters as well, those clusters as well, because we see the end of the spectrum. And we say that it's the failure of endos or physicians if you send patients to us, the last stage. So I think looking at those clusters would be important. So we don't have description of those clusters as far as the nephro textbooks or published literature is concerned, because simply we don't have that many number of patients with pediatric diabetic kidney disease. Probably they are missed, they are not referred, or they die because of some other complications. Type 2 diabetes in adults, I mean, we are the masters, nephropathy, because that's the commonest cause of kidney disease in our country. It's horrible, horrifying, and it's the failure of the entire system, I would say, all of us together. We have so many tools to prevent the diabetic nephropathy in early stage, but the picture is we sit in the clinic with patients creatinine 10, 8, 9 coming to us, and you ask them diabetic for how long? 10 years, 15 years. Creatinine, how many times it was done? What is creatinine? Never done. So that should not be there. At least an albumin and creatinine should be done. And this should be done by the primary care physicians or GPs or anybody for that matter. I believe some things in clinical medicine are relevant for everyone, irrespective of your specialty, whether an eye specialist or a diabetologist or whosoever. Some clues, I think those clues, Madam also, Muna Madam will also agree with me, Anjana will also agree with me. So I think we should be on the lookout for kidney diseases in all diabetics, irrespective of their age.
I'm sorry, I have one last question to you. Supposing a kidney, end-stage kidney disease or a kidney disease patient comes to us, at what level should we aggressively start treating our retinopathy? Because generally once they reach an end stage, they are lost to us because their nephropathy and chronic kidney disease takes over and their dialysis and other things take over. So their retinopathy kind of takes a backseat. So is there a suggestion, like, where the creatinine reaches a certain level, that we start aggressively treating them for retinopathy?
No, in fact, the ophthalmologist should take the front seat, so as to say driver's seat, and try aggressively managing retinopathy from the word go. So in fact, retinopathy, whenever it occurs, irrespective of what stage of diabetes, you should aggressively treat retinopathy. The management of retinopathy becomes complicated when the patient progresses towards end-stage kidney disease. That we know, because many of the drugs used for management of diabetic retinopathy, the proliferative retinopathy and all that, we have a problem. They are nephrotoxic and cause problems. But as a nephrologist, the message to the ophthalm would be, please, treat ophthalmopathy, retinopathy, wherever. The first instance, when you get to see it, please do it. Even in end stage, please continue the treatment. And the treatment, it can be modified for whatever stages of kidney failure. So nothing is absolutely contraindicated. And another message is, whenever you see retinopathy in a diabetes, make sure to ask for urine albumin and creatinine, even though you are in an ophthalmology setup. And many of the setups may be OP setups, but refer the patient, because retinopathy, whenever that's maybe one chance when you can screen the patient for a nephropathy.
Thank you so much. Any other questions from the other panelists?
I had a question actually for Manisha, ma'am.
Sure,
Can I
sure.
just start? Ma'am, when you were saying that when the creatinine moves, per week, and you see differences and all that, but when would you say, ma'am, that, you have to think? So why I'm asking is, this type 1 of mine has been diabetic for many years. Adolescents developed type 1, now then became adult and all. Creatinine was stable. Then there was this period of time, it was careless, etc., etc. Then there was this period of rapid progression where, we couldn't hold it, now it's on dialysis within a 2-year period after, but it was not that long. It was like 4-5 years. And then there's a rapid progression. There was no retinopathy. There was massive proteinuria. The family couldn't and didn't do a biopsy. So it just ended up on dialysis now. He just crossed all those stages so quickly, ma'am. So in such cases, it's not exactly, there's a mix. Then what is your opinion?
So the thing is, the case you described, probably earlier part, the disease might have been nephropathy and was progressing as per the course predicted. Now, the latter 2 years, there may be two possibilities. One thing is retinopathy, the nephropathy itself, which progressed, which happens in diabetic nephropathy towards the end when they are reaching end-stage kidney disease, the progression is relatively faster. The other thing may be, there may be superadded glomerular disease. Now, unfortunately, we can never find that out, because glomerular diseases are very common. IgA nephropathy, FSGS, these are the glomerular diseases which occur in the age group which you described. So that would have worsened the picture, and they would have been picked up only by doing a biopsy. Because as you said, there was no retinopathy either. Yeah. Nothing was there. So if the family had consented, biopsy would have been the way to go. Many of the times we find surprises on biopsy. And that's the final gold standard tool for diagnosis in many of the cases, because the treatment is different. And it's important, because if we go for a transplant in that patient, for instance, suppose it is some form of FSGS, which recurs after the transplant, we would be ethically wrong doing the transplant itself. So now we do not have a diagnosis there, whether it's diabetic nephropathy, which doesn't recur so fast after transplant. Suppose it's FSGS, it might recur. So those things are important, and we should try to insist on a biopsy to determine the nature of native kidney disease. I do understand, Anjana, it's not always possible. We as nephrologists also many times fail to convince the family. So biopsy is an underused tool. And as I said, the diseases don't read books and your clusters and come. We can have mix and match sometimes. And whenever we feel uncomfortable with the whole thing, that's where experience counts. We should err on the side of aggressively investigating rather than letting go. So I hope that answers your question.
Yes. Thank you, ma'am.
Ma'am, this question is for Dr. Anjana. This is by a participant.
I think Dr. Manisha and Dr. Anjana really enjoyed your talks, and
thank you, ma'am.
We still have time for questions.
That Dr. Sahai spoke about, where you have SLE retinopathy, so it may appear that patient has diabetic retinopathy. So I think it's important to look at the urine parameters as well.
Absolutely. So that's one of the parameters in those 5 things. And I would take the help of an expert of TAL like Dr. Dr. Muna, because we are not experts in the field of retinopathy. And as you said, that might be a red herring. So always we look into the total picture into account, and urine examination is liquid biopsy. And many of the times the CUE is never done. So that should be done. You get a wealth of information, a lot of RBC there, definitely, and proteinuria and the RBC casts. We would be on the lookout for an active glomerular disease, and a female that age, type 1 with that sort of a problem, SLE would be high on cards.
And one more thing about patients with end-stage renal disease. One thing that's important is that laser photocoagulation does not have a systemic complication.
True.
The only thing is it takes time, it takes a little bit of patience compared to a monthly intravitreal injection.
Absolutely, absolutely.
It's probably not the forum, but I definitely would recommend a panretinal photocoagulation for any patient at risk, especially when I know their systemic condition is going to prevent them from probably coming to see me as often as I would like.
Absolutely, Dr. Mona, and to take that thing further, even administration of your VEGFs and all that. I mean, we don't have a problem. Only thing, it's better to screen them for the development of thrombotic microangiopathy, which is quite common. And simple bedside tools, again, looking at CUE, creatinine, and checking their blood pressure regularly. So the drug is not bad, but it should be used in a proper way. So even if that were to be required, it's not a definite no-no in patients of end-stage kidney disease can be taken. And as you said, panretinal photocoagulation, obviously, I mean, we are less scared of that. True.
And also when the patients are on dialysis, we find that the macular edema reduces over time. So we may not need to do anything about that.
Absolutely. Absolutely. That's why these collaborations are important. We learn from each other.
Absolutely.
Thank you, ma'am. This question is for Dr. Anjana by the participant, Dr. Devan Sanchania. Is cluster reliable even after a duration of diabetes more than 10 years?
Okay, so that's a really good question, and one that I don't get often, but it's a very important one. So the reason that it's difficult to answer that question is because human beings cannot be put in boxes. I did show you 4 boxes, but just like Dr. Manisha was saying just now, they don't read textbooks and they don't come and fall in the boxes. So for an individual person, if you take, there is the possibility of being this and that and mix, and there is always. So we have this biological movement between one cluster and another. So initially, during the initial diagnosis, new onset diabetes, we try and see which has the maximum possibility. So is it SID, is it SIRD? There will be mixes here and there, but you will have a 60% of this, 30% of this, 20 somewhere else. So that's how it works. And as you treat, this will change sometimes. Over time you'll gain a little extra weight. So the ideal time to do it, the people move between one and another after, especially after treatment. So the ideal time to do for prognostication is at diagnosis, and this does not hold as good for someone who's been on treatment and is having the side effects of drugs and all that. Things will start changing, LDLs will move, all this will start changing. So it's possibly best to do it as soon as possible in diagnosis, after diagnosis.
So much, ma'am. One final question to Dr. Munna. Madam, if there is a physician who's working in a remote area and he wants to buy one of the gadgets which will tell him with AI aided facility, there are several companies which have come up with this. Zeiss, I think, has, Remedio has. So which one would you recommend so that they know at least at a grassroots level whether they require a reference, whether the patient has retinopathy, what drug to treat them with from the physician's point of view?
Or would you recommend such a device at all? That's also on the table, because there are so many of them.
And may I just add an extra question? Sorry, before you answer, ma'am. What is the ethics of this? I have lab groups now who are saying along with lab, we will take one photo and all that. But as long as they're in clinic, we know we'll do something if we find. But what if we have an AI tool? It's not like all our patients are all very obedient types and all. So what is the ethical concern also with this?
Yeah, okay. Now, as far as the machine that they can use, I think a lot of it will be driven by affordability. There are a lot of people doing smartphone imaging. There are a lot of people who are supporting these AI ventures. But I think we need to remember that most of them in an elderly person are going to miss almost a third of it. So if a person has low vision, if the view of the retina is not clear, then I think the diabetologist should send the patient to a physician. In fact, I think the American Diabetes Association guidelines say that patient who has poor vision should not be subjected to this AI method of screening. That's one of the guidelines. I think that is the most important. If the patient is not able to see the last line of the chart, then I think he needs to see an ophthalmologist rather than a diabetologist. And I did show you examples of wide field imaging, where a gentleman came from a very much so-called much more developed country than us, being managed as non-proliferative diabetic retinopathy, because he was seeing an optometrist who was just looking at the posterior. Wow. Okay, so there is a problem, but definitely if the patient has poor vision, you don't rely on these tests.
Thank you so much for a very interactive and excellent session, and excellent session by all the speakers. Thank you once again. Thank you very much, ma'am.
Thank you. Thank you.
Thank you so much.
Thank you very much.
Welcome, Dr. Varsha.
Now that we are done with this session, let's move on to the next one. The topic is going to be about basal insulin and oral drugs. I would now like to invite our chairperson, Dr. Harshal Ekapur, please. So Dr. Harshal Ekapur is an MD physician in endocrinology. He's a consultant endocrinology and diabetes. He practices at Ruby Hall, Pune, and he has about 8 years of experience. He had lots of oral papers and poster presentation, multiple publications. He has been the primary investigator for various regional and multi-center trials, a member of Endocrine Society of India and Indian Society of and Mineral Research. Without further ado, I would like to invite Dr. Harshal Ekapur so he could introduce our speaker. Dr. Harshal, are you there?
Yes. Yeah, I'm there.
Yes, sir. Could you please go ahead and introduce Dr. Varsha Jagtap, our speaker?
Yeah, I have to do the introduction. Hello.
Yes, sir. Can you see the CV slide?
Yeah, I can see. Yeah.
Yes, sir. If you could introduce ma'am, she will start the topic, sir.
Yeah. So good afternoon all. It's my pleasure to invite Dr. Varsha Jagtap, madam. She's a good colleague of mine. She's a consultant endocrinologist practicing in city of Pune for more than 10 years now. She has done her DM endocrinology from KM Hospital, Mumbai, and there has been multiple presentations in a peer-reviewed, multiple publications in peer-reviewed journals to her name. So with that, I welcome Dr. Varsha Jagtap, madam, for a talk.
Thank you, Harshal, for the introduction. So I'll just start by sharing the.
Ma'am,
Hope my slides are visible.
No, ma'am. You said white screen.
Okay, I'll stop the share and I'll start sharing again.
Once you click on share screen button, you see multiple windows there.
Can you see slides now?
Yes.
Yes. Okay, thank you. So first of all, let me start by thanking Dr. Unni sir for this opportunity. And congratulations to Team CDI. This has been a very well conducted conference on time. So let me start today's topic. I'm going to be speaking on basal supported oral therapy for diabetes mellitus. Let me tell you that though the topic name sounds complex, it's not so. It's a strategy for diabetes management that we all routinely practice day in and day out. So what it basically means is that, a patient has been on oral antidiabetic drugs, and then because of the uncontrolled or because of certain other parameters, which I'm going to discuss now, then you decide to add the patient on a basal insulin. So this is what we mean by the basal supported oral therapy. So if we, I mean, if I were to talk about the overview of my today's talk, the first part I'm going to discuss about the prevalence of diabetes and how glycemic control is important. And then I will be speaking on how we can initiate the insulin therapy, and amongst the different insulin therapies, how basal insulin is convenient for our patient and how we can use basal insulin in coordination with the other oral antidiabetic drugs that we have. We'll also touch base upon the clinical evidence that exists, and we'll do this all depending upon, and also considering one of our representative clinical cases. So if I were to talk about prevalence of diabetes, we all know that all across the world, number of people are suffering from diabetes. And if I were to speak regarding India, then the numbers in India are projected to double almost from 77 million to 134 million. And this is by the year 2045. And across world, 1 out of 10 people are living with diabetes. And if we speak about diabetics in the world, then every sixth diabetic person in the world is an Indian. So huge numbers of diabetic population, and obviously the huge number of complications that follow. So we have heard all our previous speakers talking about the nephropathy, retinopathy. So all these complications are going to go up because we know that chronic hyperglycemia is a state of low-grade inflammation. It causes atherogenicity. And the good news is that if you're able to reduce the HbA1c by just even 1%, then we can reduce the risk of these complications. So the Wikipedia's data tells us that every 1% drop in HbA1c can reduce the death due to diabetes by 21%, can reduce the chances of heart failure by 16%, stroke by 12%. So the conclusion is that basically that we need to strive for a better control of diabetes in majority of our patients. So this is a very typical case that we all come across. 52-year-old gentleman, type 2 diabetic for past 5 years, and he visited the clinic with complaints of frequent urination, tiredness, and increased thirst. So all the symptoms of polys, he was not able to get through his daily course of work, and he was tired throughout the day. So that was his main presenting symptom. He was obese with a BMI of 27.3. He did not have any other medical history. His family history, mother had type 2 diabetes. And if you look at his current medications, he was taking 4 milligrams of glimepiride and 1 gram of metformin. So in spite of these high dosages, his sugars were very uncontrolled. HbA1c was around 9%. Fasting PP values were high, as you can see here. He was on 10 milligrams of rosuvastatin, and the lipid profile was as is shown here. His creatinine was 1.04. So what should be your next plan of management for this patient? Now, we all would agree that we definitely want to intensify his therapy. We cannot, he has got the symptoms of hyperglycemia, polys, he's tired, fatigued, A1C is 9. So definitely you want to intensify his therapy. But how would you do it? I mean, would you want to add a third oral antidiabetic drug? Would you want to combine his oral antidiabetic drugs with a basal insulin? Or would you just want to discontinue all his oral antidiabetic drugs and just start him on insulin, either a basal bolus insulin or a premix insulin? So none of these options are what we could say absolutely wrong. But depending upon the patient scenario, we would choose one or the other. And in this scenario, let me remind you that the patient is complaining of poly symptom, is fatigued all the day, and his HbA1c is quite high. So this patient would be an ideal candidate to start a basal insulin or a premix insulin. Now, when we are initiating insulin, basal insulin is one of the most convenient initial insulin regimens. So ADA recommends that in the presence of ongoing catabolism, or if the patient has got symptoms of hyperglycemia, or if the HbA1c is more than 10%, or if the sugars are very high, then insulin initiation should be done. And amongst the different insulins, basal insulin is the most convenient initial insulin regimen. And it can be added to the different oral anti-diabetic drugs. Excuse me. So how does basal insulin act? Basal insulin basically limits the hepatic glucose production, and it will prevent hyperglycemia. And this is mainly the fasting hyperglycemia, and in between the two meals hyperglycemia that will be reduced by the addition of basal insulin. So, whenever we discuss with the patients about starting insulin therapy, there'll always be the question as to, doctor, can't I take another oral antidiabetic drug? Why don't you add me one more third oral antidiabetic drug? And how do you actually, counsel your patients that no, at this point of time, when you are having symptoms which are suggestive of polys and catabolism, it's better to be on insulin to prevent the glucotoxicity. So we need to tell our patients that there is going to be a progressive loss of beta cell function as your diabetes progresses. And when you have features of glucotoxicity, basal insulin or insulin initiation is the proper way to do it. Adding a third oral antidiabetic drug would basically has a limited capacity to reduce the HbA1c. When my current HbA1c is 9.9 and my target is below 7, it's unlikely to be reached by any oral antidiabetic drug. Plus the increased side effect profile, the regimen complexity, and the increased expenses would all, just add on to the complexity of the regimen without giving the benefit to the patient. So insulin initiation is the answer here. So once the patient agrees that you want to start the patient on insulin, and we have decided on the basal insulin as the initial insulin because it is convenient. And so this patient of ours got ready, and we initiated him on insulin glargine. So the initial dose that was started was 10 units per day. And then every third day, depending upon the fasting blood sugar values, the insulin dose was up titrated or down titrated. So basically the target is to keep the fasting between 90 to 130. So depending upon this target, you would every third day take the decision of, what needs to be done for the insulin glargine at bedtime. And the OADs of these patients were continued. He was put on a 1 milligram of glimepiride and 1000 mg of metformin FDC twice a day. And then thereafter, he was asked to monitor his sugars there often, and then report to us again after a few weeks. So what is the rationale for early or timely insulin therapy? We all know that early insulinization can delay or reverse the residual beta cell function. And as I have told in this case, or there could be some other case scenarios where patients are too frail or sarcopenic, severely insulin deficient, and obviously they are the candidates for timely insulin treatment. We also know that there could be patients with glucotoxicity where the sugars are very high to start with. And, early insulin here will keep their metabolic memory or a glycemic memory in a proper manner and as a legacy effect will reduce the long-term complications of this patient. And hence for such patient, it is important to initiate insulin timely. And with insulin initiation, we can target the blood sugar levels to our desired range. So this is what has been reiterated again in the expert opinion, the Be Smart expert opinion, that timely insulin initiation is important to prevent the complications. And basal insulin is one of the convenient options for insulin initiation. And it can be, given after 3 to 6 months of inadequate control of optimal use of 1, 2, or 3 glucose lowering agents. And to begin with, you can start with 10 units per day, and then thereafter, depending upon the blood sugar levels, you can go on increasing the dosages. So after 4 weeks, this patient of ours comes back to us. He is much better. He has, he's able to get through his daily routine without any complications. And his fasting and PP values have also come down. He has had a single episode of hypoglycemia in this past 4 weeks. He was given the hypoglycemic education for the same. And then thereafter, considering the benefit and the patient tolerance, we decided to continue with the same therapy. Patient came to us follow up on a regular intervals. Then at the end of 6 months, So the HbA1c had come down from 8.9 to 7. The fasting and PPs were in target zone. So the patient continued to take Glargine with glimepiride and metformin. And the patient did not have any significant weight gain or did not have any further significant or serious episodes of hypoglycemias later on. So this patient could tolerate the drugs and the insulin combination very well, and it was quite effective as well. But what about the clinical evidence? So what do the studies tell us? So different literature available to us tells us that insulin glargine is a insulin of choice for basal insulin because of its long duration of action, and it can be initiated after 2 or 3 oral antidiabetic drugs, and it can be used safely in combination with these drugs. And when it comes to the sulfonylureas or the oral antidiabetic drugs to be added on to the glargine, then modern sulfonylureas like glimepiride or glyclazide are good options because they have CV safety. They do not lead to too much amount of weight gain as the older sulfonylureas did, or they do not cause severe episodes of hypoglycemia like the older ones. And they are also able to reduce the HbA1c to a larger extent. So they are CV safe without any major side effects. And this one particular study talks about a combination of different combinations. So one group was, metformin with glargine. The second group was glimepiride with insulin glargine. And the third group was metformin, glimepiride, and insulin glargine. And these 3 groups were then, followed up for up to 6 months. And then they were assessed in terms of the glycemic efficacy, the body weight, insulin dose, and hypoglycemia. So this was a good study. And what was seen at the end of this study was that towards the, at the baseline, and if we compare the endpoints, and definitely adding insulin glargine helped the patients, and their baseline HbA1cs were higher and the endpoint HbA1cs were much lower. So that is expected. But what was seen is that amongst these 3 groups, that is one with metformin alone or with glimepiride alone, and those who were taking the combination of metformin and glimepiride, the ones which were on the combination had the highest drop in the HbA1c. So they had a good HbA1c control and with the least amount of insulin dosages. So the chart on your right is telling the insulin dose which is required towards the end of the study. So the least amount of insulin requirement was in those patients who were on both metformin and glimepiride. And the risk of hypoglycemia or the weight gain did not really differ amongst these 3 groups. Another study, similar design. So one group is a combination of glimepiride and metformin with glargine, and the other is glimepiride alone with glimepiride alone with glargine. So this is GM with glargine, and this is G with glargine. And then again, studied for a duration of 4 months about the glycemic targets. And as you can see, the HbA1c reduction was better in the GM group as compared to the glimepiride group alone. Okay, fasting PP did reduce in both the groups, though not clinically statistically significant, but the HbA1c reduction was definitely statistically significant in the glimepiride and metformin combination. So basically the take-home message from this slide is that the fixed dose combination of metformin glimepiride was quite efficacious in addition with glargine to reduce the HbA1c. And another real world observational study, where 7,000 odd subjects were studied. This was done in Indian cohort and across 378 centers. And it was seen that patients who were treated with this combination of metformin, glimepiride, and glargine insulin, then from the baseline HbA1c of 9.5, at the end, the HbA1c came down to 7.7. And if the physician survey was done as to how many number of physicians actually felt that this treatment was efficacious as well as tolerable, then more than 96% of the physicians said that they rated this treatment from good to excellent. So the physicians were also quite happy with the patient's efficacy and the tolerability. So when we combine sulfonylureas with insulin, should we do so? So the answer is yes, because so suppose if you're going to combine a basal insulin with sulfonylureas, then they are going to take off 2 different cares. So, the basal insulin will control your fasting blood sugar. The sulfonylureas can control the fasting as well as the PP sugars. And both together you will ultimately require lesser amount of insulin. And if you titrate the dosages properly, you would be able to prevent the hypoglycemia as well. So improved glycemic control with reduced insulin requirement can be seen with this combination. So there have been multiple studies published till date about basal insulin or premix insulin with different oral antidiabetic drugs. And with SUs, if you see, there is data with glimepiride as well as with glyclazide, where this combination has been successful in reducing the HbA1c, and it has also given the patient satisfaction in terms of lesser incidences of hypoglycemia and a convenient regimen as well. So the International Task Force recommendations also suggest that when basal insulin is to be initiated, the SUs can be continued with appropriate precaution. And so suppose if the patient has to move on to another second set of therapy where premix insulin is required, then premix insulin, say once a day, along with a SU taking care of the antipodal meal can be done. Or if the patient is, say, on a premix insulin twice a day, then maybe giving a short-acting SU or a glenide along with the third meal will also be able to take care of the patient's sugar. So this patient of ours comes back to us after 6 months, and as it is with all our patients, even if they get good results, they want to know, doctor, how long do I need to continue this insulin therapy? Can I actually stop it? So what do you tell this patient? I mean, so do you just combine the basal insulin, or do you say that no, HbA1c of 7 is not good, let's try to reach a target of 6.5, and do you actually intensify the insulin, or you just increase the OADs, or what do you do? So this patient, we could choose either of these options and not be very wrong, but we'll have to tell our patient that ultimately whatever he or she does, monitoring the sugars, maintaining the target range without symptoms is the key. And so if the patient is able to do it with a basal insulin and a combination of OADs, so be it, and it will be helpful in the long run for the patient, and this is how we'll counsel this patient. So to summarize, this patient that I presented to you had diabetic, was uncontrolled HbA1c of 9 in spite of OAD, metformin and glimepiride, and then basal insulin was added, and the combination of basal insulin with metformin and glimepiride helped him to achieve the target without any serious side effects and without further weight gain. So to summarize, near to normal glucose control is crucial in the management of type 2 diabetes and prevention of micro and macrovascular complications. Controlling hyperglycemia with signs of catabolism, even at the time of diagnosis of diabetes, necessitates initiation of basal insulin. And if the glycemic goals are not attained, basal insulin can be considered in combination with the oral agents. And early insulin initiation can delay or reverse the residual beta cell function and loss, promoting better treatment to target glucose control. And a combination of SUs and metformin with basal insulin has found to be efficacious and safe for achieving the glycemic control. Thank you.
Thank you, ma'am.
Hello. Yeah, thank you, Dr. Varsha, for the excellent presentation with lots of insight into the basal insulin. Now, if at all any questions, I think there are few questions in the chat box, which I can see. Yeah. Okay, so one question regarding the outline of management of diabetes in CKD with increased creatinine level, and drugs apart from SGLT2 inhibitor like RAS inhibitors can be used to retard the progression. Dr. Varsha, your comments on the same.
Yes, thank you, Harshal, for the question. I think the question was actually meant for Dr. Manisha Sahai for the earlier presentation, but I would take the liberty here to answer this question. So, yes, I mean, for with the increased creatinine level, then the ball is in the nephrologist's court. But as long as the creatinine levels are okay, but as Dr. Manisha earlier pointed out very well, we have to do the job of prevention. So preventing the patient from going from micro to macro is my job, and to do that, I will use the RAS, I will use SGLT2 inhibitors, I will control the patient's HbA1c, I'll control the patient's blood pressure and the cholesterol, and that is what that we we need to do. With increased creatinine, it's best left to the nephrologist, because there is a fine balance of the fluid and electrolytes, and which they have to monitor. And it's not a good thing to just change the antihypertensives or add SGLT2 inhibitors just because we have heard in a new talk that it is a good agent to add. So I mean, it is with increased creatinine, I think we should work in collaboration with the nephrologist.
I think there is one more question regarding the highest dose of basal insulin used and the glimepiride.
So when it comes to combination of basal insulin with sulfonylureas, we can go as high as 0.5 to 0.6 units per kg per day. And when you tend to go more in terms of more than 0.5 units per kg per day with glargine, you need to be, sometimes you tend to see hypoglycemias. So it is better to sometimes to, even split the glargine, but that is not a routine policy that we would otherwise do. For majority of our patients, it is once a day glargine, and we can go up to 0.5 to 0.6 units per kg per day.
Okay. Thank you, ma'am, for answering the questions. I have one question from my side regarding the sulfonylureas. Like when we shift the patient to the basal insulin, is it prudent to consider short-acting sulfonylureas along with the basal insulin rather than long-acting ones like glimepiride or extended release of gliclazide ones? Because the prandial needs, I think, can be addressed better with the short-acting ones.
So what we have seen, Harshal, is that theoretically what you're speaking is correct, that so suppose if I have a basal insulin taking care of the fasting hyperglycemia, why not give a short acting SU? But in practice what we see is that when we give long acting, the newer modern sulfonylureas, and the reason being that they have other host of advantages. So that means they have lesser weight gain, they have lesser hypoglycemia, they are cardio safe. Then the chances of hypoglycemia actually happening, or the amount of PP sugar control that you would get with a short acting SU versus a long acting SU doesn't really differ much. And you can get the same amount of PP blood sugar control with a long acting or the modern SU in addition to the basal insulin. So I don't think we can really think in that manner that a short acting SU there would be giving us more advantage.
Thank you, madam, for the insights. I think there are no more questions, so I hand over to the organizers. Yeah.
This question regarding you have talked about glimepiride, sulfonylureas, metformin, and basal insulin combination. What about DPP-4 inhibitors, SGLT2 inhibitors, and basal insulin combination? Are there any studies regarding this?
So there are enough studies, and DPP-4, SGLT2 drugs as such can be definitely used with basal insulins. And so when I say basal insulin supported oral antidiabetic drug therapy, I don't mean just SUs or just metformin. I mean the whole gamut of the oral antidiabetic drugs that the patient is taking, and that includes DPP-4 inhibitors, and that includes SGLT2 inhibitors. And definitely when you when you have continued all these oral antidiabetic drugs and added a basal insulin, then it will give you an additional advantage, and you should continue with the DPP-4 and SGLT2 inhibitors when you start basal insulin. That will help you in the requirement of insulin will be less, and the weight gain, that which is the side effect of insulin, will be reduced when you combine it with a SGLT2 inhibitor. So yes, you should continue these drugs.
So what is better combination in your opinion?
So better is, I mean, there's no such thing as better. It's all depending upon what the patient demands. So suppose, for example, if the patient is getting controlled on 1 milligram of glimepiride and a metformin combination of say 500 twice a day, and has got a single tablet which is a combination of SGLT2 inhibitor and a DPP-4 inhibitor and one basal insulin at night. So someone could get control on that. Some patient may be just on a metformin glimepiride along with insulin without any of the DPP4 or a SGLT inhibitor. So it actually, I mean, nothing is better. It depends upon what the patient's scenario is, and according to that, you will decide.
There are questions in a chat box by Dr. Amol Inamdar. Any standards to titrate dose of sulfonylureas in combination with basal?
Yes, so that's a very good question. So whenever your patient is on an oral antidiabetic drug, say a metformin and a SU combination, and you have now decided that you want to add on basal insulin, then always remember that insulin, there is a risk of hypoglycemia. Sulfonylurea is a secretagogue. So again, there is a risk of hypoglycemia. So whenever I'm initiating insulin, I might be a little, on the dose of sulfonylurea, I might go less. So suppose, for example, if the patient is taking 2 milligrams of glimepiride, I might reduce it to 1 milligram to start with. Then I may, once the patient is being monitored, then I may again increase the dose of sulfonylurea later on as the patient's requirement is. So basically, when you're starting it with a combination of insulin, then you have to be careful about hypoglycemia, and you might err on the lower side, give a lesser dose of SU, and then if the need be, go on increasing the dosages as you are titrating the patient's sugar.
Thank you, ma'am.
Thank you.
Okay. So, any more questions? Okay. There is also one question by Dr. Sonali Tondikar. Highest dose of basal insulin with sulfonylureas?
I think we have taken that question. So basically, it's 0.5 units per kg per day. I can see one more question there in the chat box, and that I think we haven't yet discussed. It is about what should be the next option when the PP is not under control with the use of basal insulin. So that's again a very practical question. So you have gone with the highest dosages of oral antidiabetic drugs. So suppose, let us assume that your patient is on 2 milligrams of glimepiride twice a day, that is, say, 4 milligrams of glimepiride, plus the patient is on 1 gram of metformin twice a day, that is full dose of metformin. The patient is on DPP4 and a SGLT2 inhibitor, and you are giving the patient basal insulin. And so suppose you have reached a basal insulin your dosages of, say, 0.4 units or 0.5 units per kg. And you see that with that, what happens is that the fasting comes down to 80-90, but the PP is 220, 230. So in such a scenario, if the patient is already not on a AGI, that is alpha glucosidase inhibitor, like say maybe a voglibose or a carbose, you can try adding that to control the PP sugars. If that is already on board, and or in spite of adding that, if the PP sugars are high, then this is the time to intensify insulin further. So you would either go on a premix insulin twice a day, or you could go on a basal bolus therapy. That means, say, along with the basal, whichever PP values are high. So suppose, say, only the post lunch is high, but the post breakfast are not very controlled. They're not very high. Then you would add a bolus insulin only at the time of lunch. So that is what we call as a basal bolus regimen. So that is something that you'll have to do later.
Okay. Thank you, ma'am.
Thank you. Thank you.
Thank you for such an excellent presentation. I also thank our chairperson, Dr. Harshal Ekatpure, for giving your time. Thank you. So moving ahead to our next session, which is in diabetes therapy, expert speakers in diabetes therapy. I would like to invite Dr. Manish Deshmukh as a chairperson to chair this session. Manisha Deshmukh, sorry. Dr. Manisha Deshmukh is an MD Medicine. She is an honorary physician and head of department. She has selected for World Diabetes Foundation and International Working Group on Diabetic Food's prestigious and ambitious project Step by Step. Fellow of Diabetic Food Clinic, King's College Hospital, London. Awarded the State of Art Food Clinic Award in National Diabetic Food Conclave 2017. So welcome, ma'am. Over to you. Please introduce the speakers of this session. Thank you, ma'am.
Yeah. Thank you so much for this kind introduction. And first of all, I would like to thank Dr. Unnikrishnan and the CDI team for giving me this opportunity to chair this very prestigious and important session. So the first topic is bone health and diabetes. This bone is as neglected in diabetic people or in, amongst doctors also as the foot is. So today I'm going to invite Dr. Amrish Mittal. He doesn't need any introduction. He's very well known in this medical fraternity. He's MD and DM, Padma Bhushan and BC Roy awardee, member governing council, Indian Council of Medical Research, chairman and head of the endocrinology and diabetes, PanMax Hospital. And there are many, he is recipient of fellowship from Japan, International Cooperation Agency Fellowship Boy Frame Award of the ASBMR, IOF Emigan Health Professional Award, and the Springer Citation Prize for his paper on global vitamin D status in 2013. He received recently the IOF President's Award. So we have with us Dr. Amrish Mittal. Over to you, Dr. Mittal, for your talk.
Hello, friends. Today I'll be talking about bone health and diabetes, which, as some of you might be aware, is one of my favorite subjects, which brings together the two conditions that I'm most interested in, that is osteoporosis and diabetes. And the image here just shows something which is very relevant to what we're going to talk. This is a cross-section of a bone, and this is a cross-section of someone who had osteoporosis with diabetes. This is normal. Osteoporosis without diabetes and osteoporosis with diabetes. And you can see the major cortical porosity in the bone in the image to the right. And this is exactly what is typical of diabetic bone disease or diabetic osteopathy, and really reflects the poor state of bone health in people with diabetes. So, of course, who else would first describe an association? Everything that we read has been described by Albright and Riefenstein and the same period in Boston. And in the American Journal of Medical Sciences, they spoke about or wrote about an association between diabetes and reduced bone mass. And of course, they were largely, people were talking of juvenile diabetes, and the fact that in people with juvenile diabetes, there is a significant reduction in bone mass. And as people later realized, a much greater increase in fractures, because initially people with juvenile diabetes weren't living that long to give enough data. But as that data began to emerge, one realized that. Also, people started realizing that type 2 diabetes per se could also lead to significant abnormalities in the bone. And therefore, one author went to the extent of calling it diabetic bone disease in 1991 itself. And I think that shows that this has always been lurking in the background, but now it is right at the forefront of our work and research and clinical care. A systematic review of type 1 and type 2 diabetes and risk of fracture. This is from 2007 actually, and it showed a relative risk of 1.7. More recent reviews put this risk at around 1.5. There's a brilliant review in the Lancet this week actually, which does that. But nevertheless, the risk is more than about 1.5 times, which means, you know, it's less than 2 times, but still very significant increase in risk of fracture in people with type 2 diabetes. And of course, with type 1 diabetes is much, much higher, but today we're talking primarily of type 2 diabetes. We know this in this meeting, everyone knows chronic disease, diabetes, neuropathy, nephropathy, retinopathy, but there is no mention of osteoporosis. By and large, in our meetings, in our clinic, forget meetings, in our clinic, osteoporosis management in diabetes takes the backseat. I don't think anyone can deny that. Of course, there is some gap in understanding of how obesity and diabetes affect the adult skeleton. But regardless of that, there is some gap in our understanding. Also, you have to realize that in the last 3 odd years, there has been huge amount of progress in this, in the mechanisms, and we'll detail some of them today. But the idea is that that has to translate into clinical understanding and clinical benefit to our patients. So we need to start applying osteoporosis algorithms for people with diabetes, which are slightly different than those for those without diabetes. So this presentation will focus on type 2 and one of our own studies with Dr. Mohan's group, the famous Impaired study, which actually looked at the increased prevalence of self-reported fractures in Indian patients with diabetes. From the Impaired study, of course, we know that 54,000 people who from where this information was gathered. And if you look at that, the prevalence of fractures in diabetes was clearly higher than pre-diabetes or no diabetes. Right? So very clearly, there was a higher prevalence of fractures in this group. And if you look at the multivariate logistic regression analysis, you find that diabetes was a significant factor in addition to, of course, age, alcohol, urbanization. Diabetes in this study was a significant risk factor even in a multivariate analysis. These are self-reported fractures. They don't distinguish traumatic and non-traumatic, just fractures, because it's a questionnaire-based thing. So diabetes does increase the risk of fractures, you've seen that, but does diabetes control matter? It does seem that as we go from A1C of 6 to 10, there is a progressive increase in risk of hip fracture. As the follow-up time increases, the risk of fracture increases. And this is again important. This does not necessarily mean that poor control of diabetes is producing or is directly reflecting an increased risk of fracture. It may just mean that people who are poorly controlled with diabetes could also be sicker, having more complications like neuropathy and other musculoskeletal complications, joint problems, eye complications, making them more prone to fall. So this one just showed that poorly controlled diabetes, whether it was the direct effect of diabetes, possible, or simply a reflection of overall poor health, but there was a greater risk of fracture. The other curiosity with type 2 diabetes, I remember when many years ago, when we were studying osteoporosis for the first time, it was always, oh yeah, diabetes, osteoporosis, no problem, because there is increased risk of increased bone density in people with type 2 diabetes. Increased bone density means that we just shut ourselves off from the risk of fractures in type 2 diabetes. Hip and spine bone density is 4 to 5% higher. And this cuts across all racial groups and age groups, that people with type 2 diabetes seem to have a higher bone density. This has been correlated by some with hyperinsulinemia, which is a feature of type 2 diabetes. And this hyperinsulinemia may actually be acting like a growth factor and therefore producing increased bone density, but that's not a proven thing. That's just what people have suggested. But although the bone density is higher, there is also an increased rate of bone loss in people. Let's look at this. This is the rate of bone loss in people without diabetes, the pink lines. And this is the rate of bone loss in people with diabetes. So people with diabetes lose bone more steeply than those without diabetes. And I think that's important to understand, that although the bone density baseline may be higher in type 2 diabetes, the rate of bone loss is actually higher. So it means that they are actively losing bone, and they would obviously then, by inference, be prone to osteoporosis. But it's, as I said, it's not just bone that's doing things in diabetes. It could be increase in fall risk, determined by sex, age, BMI, frailty, anti-diabetic medication, which can also cause that. Fracture risk is, of course, there. So bone turnover, bone mass, bone quality. So numerous factors. What I'm trying to say is that bone mass is just one component of the fracture risk. It is bone quality, and it is fall risk. So bone quality, because of reasons we'll discuss, but some are listed here. GI hormone abnormalities, and we'll discuss that too. Osteocyte dysfunction, very important. Insulin deficiency, advanced glycation end products, all of them would affect bone turnover, bone mass, and bone quality. One group. Then we have fall risk, which would be affected by neuropathy, by retinopathy, and by other joint issues. So all these things will cause significant increase in fracture risk. And a delightful authoritative review has come out on this. I don't think it's very sharp there, but bone fragility in diabetes, novel concepts and clinical implications just this week, actually. And this talks of diabetes and chronic hyperglycemia. So I can't go through all the details, but the systemic impact of diabetes and chronic hyperglycemia, reduced insulin signaling, reduced incretin effect, increased oxidative stress, reduced Wnt signaling, increased AGEs, we know that, obviously increased chronic inflammation and reduced blood supply, right? These are obvious processes that are underway in people with diabetes anyway, regardless of bone or no bone. And it has skeletal impact. It increases bone marrow adiposity. It reduces osteoblast function. So you are producing bone obesity and you're not forming enough bone because osteoblast function is impaired. Osteocytes, which are very critical in signaling, they send the first signal for bone formation. These are cells embedded in the bone, which actually trigger our repair process by producing various signals that will do that. But what happens in diabetes is that osteocyte function is impaired, sclerostin is actually increased, senescence is increased. So osteocyte dysfunction is one of the major factors in type 2 diabetes. In the bone disease of type 2 diabetes, osteoclast. So all three cellular functions are impacted. What is efferocytosis? Efferocytosis is the ability to remove apoptotic cells. So cells that are apoptotic are reduced by efferocytosis. That mechanism is called efferocytosis. That is also reduced. So if dead cells are lying there, there will be more inflammation and more damage. So removal of dead osteoclasts is impaired in type 2 diabetes. Endothelial cell dysfunction, bone vasculature, blood flow, reduced oxygen supply, and of course, the direct impact of AGE accumulation on collagen, matrix quality. So this is kind of the whole spectrum here of the impact of diabetes on the bone and the actual mechanism of that impact. So if I were to summarize this, bone matrix accumulation of advanced glycosylation end products, osteocyte senescence, increased sclerostin production, suppressed osteoblast function, expansion of pro-inflammatory adipocytes in bone, accumulation of microdamage, increased cortical porosity, inhibition of efferocytosis. And this image, again from the same article, shows that, well, okay, this is an X-ray of a lateral image of someone with the diabetes who underwent this compression fracture without any trauma. At the same time, you can see some aortic calcification. It's a good clinical exercise for diagnosis. This gives you a clue. And these are the cross sections through a normal organ donor, a normal person, control, where you see this is what the cortex and the trabecula looks like, right? And this is the porosity. And here, in someone with diabetes who has diabetic bone disease, there is trabeculization of the cortex. So much of the inner cortex here actually becomes like trabecular bone. So that solid cortical bone becomes spongy trabecular bone. And in addition to that, overall, there is increase in cortical porosity, and you can see these red lines reflect that increase in cortical porosity. So increased cortical porosity, more or less trabeculization of the cortex, is the hallmark of diabetic bone disease. So coming to the clinical part, how do we predict fracture risk and how to treat skeletal fragility? We won't take you too much into detail because we just highlight some key points which are important for you to remember. Of course, diabetes-related risk factors for fractures, type 2 diabetes for more than 5 years, so newly diagnosed is not a candidate. Poor glycemic control, A1C more than 7.9 in type 1 and more than 9 in type 2. So poor glycemic control, that has been shown in studies. Those who have microvascular complications, obviously neuropathy, retinopathy, we already spoke about it. And treatment with thiazolidine for sure. We know that they produce bone adiposity. So they're clearly drugs that increase the risk of fracture. Sulfonylureas and insulin don't directly harm the bone, but by increasing the risk of hypoglycemia and subsequent falls, they can also have an impact on diabetes-related fractures. So these are the groups of drugs. This is the list of risk factors specific for diabetes that can influence fracture risk. So we use bone density to predict fracture, but you also know that I just told you bone density is higher in people with type 2 diabetes. But within the diabetes group, you will find that there is still a correlation between bone density and fracture. So if you take people with diabetes, still those with lower BMD will have greater fracture risk. And I think that's important for you to understand that it doesn't always mean that those who have greater bone density, because diabetics have greater bone density, there is no correlation of bone density with fracture. No, within people with diabetes, loss of bone density or lower bone density correlates with greater fracture risk. Overall, at each T-score level, the fracture risk is 50% higher than somebody without diabetes. So I think this is important to remember. The relationship is maintained, but the risk is higher for the same BMD. Again, showing the same thing, I think we'll skip that. How to predict fracture risk? You know that we also use FRAX to predict fracture risk. The thing is that lower limb fractures, for example, are more frequent in people with diabetes and not specifically predicted by FRAX. So basically, FRAX does not work so well for people with type 2 diabetes in predicting fractures. We still use it, and sometimes you can substitute rheumatoid arthritis with diabetes and change that, and then you get a reasonable FRAX score. Bone turnover markers are again problem. Bone turnover markers means they are usually reduced. So you don't get classic high bone turnover in people with diabetes. Right? So again, you've got to be careful there. People are using novel markers like pentosidine. Bone structural alterations as judged by trabecular bone score in vertebrae. And I have friends in Vellore in Chandigarh. I have some experience with this. Basically, trabecular bone scores may predict fracture better in diabetes than just a BMD. It seems to work independent of the bone density. A trabecular bone score is done using the DXA method. Nothing more than that. Just a different software, but the same technology in terms of acquisition of scan is applied here, and you get the same images. Just a pixel level sort of analysis of the bone image, and that tells you the trabecular bone score. And that trabecular bone score may be a good predictor of fracture in diabetes, independent of the BMD, but it's not like a firmly established clinical guideline yet. Again, same thing, trabecular bone score as an indicator for skeletal deterioration, and correlation of trabecular bone score and spine fracture in people with type 2 diabetes. Look at that. Right? So trabecular bone score clearly here is always to the left. So if there is a reduced trabecular bone score, you will always get a higher fracture risk. Here. That's the trabecular bone score here, right? Low TBS significantly correlated with prevalent vertebral fractures, independent of BMD. And it's not just that, we all know as clinicians very well that type 2 diabetes patients have poorer outcomes after surgery, greater risk of hip fracture, post-hip fracture mortality, and hip fracture free death. So really, quite clearly, those who are, people with diabetes have poorer outcomes of fracture as compared to those without diabetes. And you can see that these are people with diabetes and these are people without diabetes. This is the hip fracture incidence, and you can see the outcome. So not just risk of hip fracture, but post-hip fracture mortality is death incidence after hip fracture. Let's look at it here. And you can see quite clearly how the green lines are always ahead of the red line, which means that that is the people with diabetes have a greater mortality, greater risk of fracture and greater mortality. And if you look at the medication I've already highlighted, all others you can forget. Thiazolidine are important. There is some issue about sodium glucose, the SGLT2 inhibitors, transporter inhibitors, but I think it is more or less settled that they don't cause much. I would still wait for the final word in this, although many colleagues say that it is now proven that they don't have any impact, but I think we need a few more years to be certain about that. But definitely glitazones do have an impact, and sulfonylureas insulin, the story is about either hypoglycemia or sometimes that people who take insulin are actually much sicker and have diabetes of much longer duration, which is why their risk is increased. We give calcium, vitamin D. We won't talk about that. Just remember, in our environment, supplementing vitamin D should be to the tune of almost 2,000 units a day, not 10,000 units a day, and not 400 units a day. Somewhere in the zone of 1,500 to 2,000, you will ensure good vitamin D level for your patient. So that you need to remember always. Adequate, correct amount, neither more nor less. And of course, appropriate calcium. All drugs that work for people without diabetes also work for people with diabetes. So there is no big formula. There is no big variation in the treatment. The variation is in the risk calculation and the diagnosis. And this is one approach that the IOF, the bone health group that I was part of, that suggested if you have diabetes and if you have a fracture, of course you're there on treatment. If you don't have a fracture, or you have a non-osteoporotic kind of fracture, look at risk factors, do a bone density, and if the T-score is less than -2, below -2, meaning -2, -2.2, 2.3, such a patient may be a candidate for therapy even without reaching -2.5. In fracts, of course, you will use country-specific intervention threshold. But if someone does not have a fracture and doesn't have any other risk factor, then you can let them be. But no fracture with some risk factor or age more than 50. So according to this guideline, all people who have diabetes and are over 50 should have a bone density, men or women, right? And then if the T-score is -2, go for treatment. Now that's a bit tricky and a bit impractical in our population, although this is a very solid group of workers that have recommended this. So we tried to write this up last year about type 2 diabetes and bone fragility, and I will end with these recommendations. We suggest performing a BMD measurement between the age of 50 to 60 only for those who have either had diabetes for 10 years or have other risk factors. The risk factor means frailty, strong family history, smoking. But we suggest that if you've had diabetes for 10 years or have other risk factors for fracture, then definitely, but maybe not for everybody. This 10 could be 5, but still I would stick to 10, because otherwise you'll be ending up doing bone density for a whole lot of 50-year-olds without any confirmed sort of increase in risk. So probably 60 of everybody, no question. 50 to 60 people with diabetes, if they have either 10-year history or associated complications, other risk factors. I mean, remember that in India, the diabetes starts at 30, 35, 40. So there'll be many patients at 50 who will have 10 years history. It's a little different from the West. That's why we modified this. And lower the T-score by 0.5. So your threshold intervention threshold should be higher in the sense that you intervene at a higher T-score. And if you're using facts, then click rheumatoid arthritis in that if your patient has diabetes. And of course, I firmly believe that doing lateral spine X-ray is very, very important for all our people with diabetes. And if you find some compression, some suggestion somewhere, in all your older people with diabetes, you should do a lateral spine X-ray. Even if you don't have access to the X-ray, many of them you'll find asymptomatic vertebral fractures. Limited studies are available regarding treatment. There is actually no difference in treatment, right? So I'm not going to bore you with that. Bisphosphonates, denosumab, teriparatide, whatever is appropriate for your patient, you use that. So this is an area where knowledge is increasing dramatically.
Actually the time
But
is
still,
over.
there are huge sections which are missing. There's a huge gap in our knowledge. So I think very wise Chinese saying that to know what you know and what you do not know, that is true knowledge. Sometimes we don't know what we do not know. And it is good to know that we don't know this. Good to say we don't know this, okay? But as I said, knowledge in this field is advancing rapidly and much more is moving towards what we know rather than what we don't know. A snapshot of the spring in Delhi. Thank you very much.
Thank you so much, Dr. Ambrish Mittal, for this really enlightening talk. And I'm sure we must have learned that we have to see or check these patients, whosoever is coming to the clinic for diabetes, for fracture related risk, which we hardly check. We screen for, say, diabetic neuropathy, nephropathy, cardiac issues, but never for the bone. But we know what happens when the patient is admitted with fracture. So I think that is a very, very important complication of now diabetes also, which is actually ignored by the patient as well as by the doctors. So we need to work on that. So we'll take the questions after the second talk, right? Yeah. So now I would like to invite Dr. Vijay Vishwanathan, again, another stalwart in his field of diabetic foot. He doesn't require any introduction, but I have to introduce him formally. He is the head and chief diabetologist of MV Hospital for Diabetes and Professor M. Vishwanathan Diabetes Research Center, Chennai, WHO Collaborating Center for Research, Educating and Training in Diabetes. He is president of Diabetic Foot International based in Belgium and consisting of experts in diabetic foot. He is a national vice president of RSSDI 19 to 22, completed 30 years of diabetology practice. He is PhD in diabetic nephropathy from T and Dr. MGR Medical University, recipient of the first Vivian Foncier Award from the American Diabetic Association for the research paper on diabetes and TB. So he has published over 200 original research papers in diabetic foot, diabetic nephropathy, diabetes and TB, and socioeconomics in diabetes. So Dr. Vijay Vishwanathan, over to you for your talk.
Thank Professor Unnikrishnan for this opportunity to speak on a very important subject. And what I'm going to do in the next 15 minutes is to give you a global view of the problem of diabetic foot. And we know that foot ulceration is very common. It affects about 25% of people with diabetes during their lifetime. This is statistics from Dr. David Armstrong, Benjamin Lipsky some years ago, and even today it is very much applicable or it is relevant. So what I'm going to do in the next 15 minutes is to first of all talk to you on the burden due to diabetic foot across the world, and then what are the solutions to reduce the burden due to the diabetic foot. And in the last 3 minutes, spend some time on the International Working Group guidelines for diabetic foot. Many people all over the world present at this stage of diabetic foot infection, when you have ischemia, necrosis, and when nothing is possible to salvage the foot but to amputate. So this is a stage in which many people across the globe present to their physicians or surgeons. This was an example, I'm just giving you an example of what happened during lockdown 2 years ago. A patient came with infection, with full of maggots in the wound, and which needed to be debrided. So we debrided the wound, and then after say a month or so, we skin grafted. So patients come at this stage, we can do something about it. And if they come later, then we can't salvage the lips. First, I'm going to talk to you about the developed world, developed countries, and you can see that people with diabetes, even in England, are 23 times as likely to have a leg, foot, or toe amputation. So it is a situation which is seen across the globe. This is in Italy. You can see that the rates per 100,000 persons with diabetes is the major amputation is shown in the continuous lines, and the dotted lines are the minor amputation. You can see that the rates from 2001 up until 2010, it's higher. The major amputation rates are very high, and even the minor amputation rates are very high. Hospitalization rates are very high. This is a situation in Italy. What I mentioned earlier was England. Now let's move on to the developing world. In China, for instance, you can see that diabetic foot is a leading cause of chronic wounds for hospitalized patients. And it has increased several fold from 4.3 to 35.3% in 2008 from 1996. And not only that, the mortality rate is very high. You see 40% of the Chinese diabetic patients who have had an amputation died within a 5-year period. Vietnam also is a developing country. You can see that just as in China, you have diabetic foot as a major problem because of the lack of specialist foot clinics. And there are very high major amputation rates. And in many countries, there are no podiatrists. Vietnam is one example. Now in India, we found that this was a study which we did among 1,985 patients from 31 diabetic centers. And you can see that most of the amputations which happened were due to infection. And the cost of amputation in India is very high. So we have compared people who have had amputation versus people with diabetes who do not have any amputation history. You can see that the cost is about 4 times, if you calculate the expenditure for 2 years. The cost in people, among people who have had several amputations, is about 4 times that which is seen in people who do not have amputation. This was a study which is interesting, which we published in 2005 in the official journal of the Diabetes UK. We compared people with diabetes from a Caucasian population in Germany with a population in Africa, Dar es Salaam, and a population in Chennai in India. the Asian population. So Asian, African, and Caucasian population. We found that though the peripheral arterial disease was much higher among the people in the Caucasian population compared to the population in Africa and India, the amputation rates were higher in people who had the initial foot lesions in Africa and in India. We found that the high amputation rates in Tanzania and Africa and India, the Asian population, was very high in spite of the fact that there was a lower prevalence of peripheral arterial disease. And infection seems to be the important factor for amputation. And here we are talking about preventable amputation, because if somebody has neuropathy, he gets infection and he goes in for an amputation. If your peripheral arterial disease is much more complicated. So in Tanzania and India, you can see that we had high amputation rates in spite of the fact that there was a lower prevalence of peripheral arterial disease compared to people from Germany. Which brings us to the second part of my talk. What do we do in the developing world? We have seen that in Vietnam, China, England, Italy, India, there's a very high burden of diabetic foot infection and amputation. So this was a beautiful algorithm given by colleagues from the King's College in London, where we have different stages in the evolution of an amputation or a gangrene. Stage 1 is a normal foot when somebody with diabetes who has normal sensation, no sensory loss, normal blood flow. High risk feet is they either have neuropathy or they have less blood supply to the legs, absent pulses, pedal pulses, or they have deformity, or they have a past history of an amputation. Ulcerated foot is they have neglected high risk foot and they have ended up in ulceration. The infected foot is something where they have ulcerated, they have neglected it, and it's gone to the stage of infection. And many people whom I showed you a picture of ended up in stage 4, and we could not salvage the foot because they very soon went into necrotic stage or unsalvageable foot in stage 6. One of the important things which we need to do both in the developed world and in the developing world is to make an early diagnosis of high-risk feet. The Riedel-Seifer tuning fork, which we showed in 2001, is nothing but a 128 Hertz graduated tuning fork, which can assess quantifiable assessment of the vibration perception, and you can make a diagnosis of the at-risk feet. So this is how it looks. It's nothing but a 128 Hertz tuning fork, and you vibrate it and keep it on the medial malleolus or any bony prominence on the foot. The patient cannot feel up to at least 6. The number 6 is shown here, and I'm pointing towards the number 6. If you can't feel up to 6, it means you have the patient having high-risk feet or loss of sensation. We showed in a paper again in 2005 in the Journal of the American Diabetic Association that if you educate patients who have a high-risk feet, you can prevent an amputation. So there is a positive impact of foot care education. So in the developing world and also in the developed world, what we need to do is 1, make an early diagnosis of the high-risk feet, 2, provide proper foot care education. The IWGDF guidelines have been written for several decades now, and they have been translated into many languages like Chinese, Portuguese, Spanish, and so on. And they are guidelines which cover different aspects of diabetic foot, written by many experts. You can see many experts from across the globe who have written these guidelines. I was fortunate enough to be included in the IWGDF guidelines for offloading. The 2019, these guidelines come every 4 years, and we have written the last guidelines in 2019, and we are now writing the guidelines for 2023. And these 2023 guidelines will be released in Netherlands in 2023. The editorial board consists of 6 members. There are 6 working groups, and there are 50 experts from all over the globe, 40 countries, 5 continents, and so on. One of the chapters in the IWGDF guidelines is the risk stratification. It's very important. You categorize people with diabetes with different risk categories of 0, 1, 2, 3. And the chances of getting an ulcer is very low if you have category 0. If you have category 1 patients, they have a low risk. Category 2 patients have a moderate risk, and category 3 patients have a high risk. Category low is there is no loss of protective sensation, LOPS. There is no peripheral arterial disease, which is similar to the figure, the algorithm I showed you from King's College. Low is where they have loss of protective sensation or a peripheral arterial disease. Moderate risk or category 2 is where you have loss of protective sensation plus peripheral arterial disease, or you could have loss of protective sensation with a foot deformity, or you could have peripheral arterial disease with a foot deformity. Now, who's considered to have very high risk or category 3 according to the IWGDF classification? This is someone who has loss of protective sensation or peripheral arterial disease and has a history of a ulcer in the past or present, who's giving you a history of a lower extremity amputation or end-stage renal disease, and so on. The importance of this IWGDF risk stratification is the regularity with which the people with diabetes, people living with diabetes, and have all these risk categories should meet the physician, the podiatrist, or the surgeon. And if you have somebody with a very high risk, you should meet the podiatrist and the diabetologist every 1 to 3 months. Whereas if you are in very low risk of getting a foot ulcer, you can see your diabetologist or podiatry clinic or foot clinic even once a year, annually. As I said, I was part of the IWGDF guidelines. It is available in the website iwgdf.org. All these chapters are available of the 2019 guidelines, and these are the guidelines written for offloading. Offloading is a very important concept where you remove the pressure from under the foot in somebody who's got a plantar ulcer, and you facilitate healing. So these were the other members of the group, and I was a part of that, and I'm also a part of it in the 2023 guidelines. My last 2 slides are important. We may be not in a position to fix a problem until we know that a problem exists, and we should acknowledge it. Now, if you have a callus, if you have a high-risk feet, you should know that such a problem exists. If you don't know, you can't tell the patient, and the patient also will not take care. So the patient should also know, the physician should also know, the physician must inform the patient. So the tap, you see it's leaking, and if you don't detect the tap leaking at a very early stage, you can end up in a very messy problem. Similarly, if you have LOPS or peripheral arterial disease or deformity or a persistent ulceration, you should know that such a problem exists, and you should try to fix it. Strategies aimed at preventing foot ulcers are cost effective. So these are John Applequist's words of wisdom, that you should try to prevent a foot ulcer. It's cost effective, it could cost saving, and that needs education, effort, and so on. People from all over the globe, from Africa, from South America, North America, Europe, should come together to save limbs. Saving limbs, limb salvage, is not one country's responsibility. It is the responsibility of the entire world. I would like to thank all the regional chairs of the DFoot International, of which I'm the president. We have the regional chairs from different parts of the world, from South America, North America, Middle East, Western Pacific, Southeast Asia, and so on, Africa. So they have all contributed to this talk. They gave me the slides. So as I said, my last words are diabetic foot problems and diabetic foot amputations is not limited to just the developing world, but also the developed world. Italy, England, I showed you data. So everybody must work together. The International Working Group on Diabetic Foot is one such linking method to link different countries with guidelines. The DFoot International is supposed to implement these guidelines per IWGDF. So this is what we have been doing, and this is what we will continue to do. And I would like to thank you for your attention, and I hope I have conveyed some important messages to you.
Thank you very much, Dr. Vijay Vishwanathan, for this lucid lecture. Now I would like to take some questions in the chat box. How to interpret data scan report? This question is for Dr. Mittal.
How to interpret?
DEXA scan report. DEXA scan reports.
DEXA.
So, you know, the interpretation of the report is the same, but if you're talking of specifically for people with diabetes, the interpretation can be different in the sense that you will take a -2 t-score as equal to -2.5, which means that normally you would ignore a -2 t-score, or maybe just call it osteopenia. But in the setting of diabetes, you would consider that as evidence of osteoporosis. So a 0.5 difference in a t-score is important. And remember that at the age of 60, above 60 is when we start looking for osteoporosis typically, and when people get osteoporosis. At that stage, in metros, you know, 30–40% people have diabetes. So you need to be very alert about interpretation of DEXA in people with diabetes.
So one question from my side to Dr. Mittal, that when the patient comes, can I ask one question?
Yes, yes.
Yeah. So when the patient comes in the clinic, we give him a list of, you know, things to be screened for complication prevention, like retinopathy, nephropathy, ECG, stress test, and like this. But this bone health is nowhere in the list of the screening things.
Which is why I gave this
What
talk.
is your recommendation for that?
So which is exactly why I gave this talk, because as I keep repeating that diabetes is like a flag. It's like an index abnormality. It's, some people call it a vital sign, but whatever. So if someone has diabetes, it is just a marker for many other things, like you all do for all your patients. But certainly we need to add two things to that. We need to add screening for liver fibrosis, but that's separate in selected patients. And we certainly need to add in selected patients screening for osteoporosis. Screening for osteoporosis should be done by a bone density measurement if possible. If not, then at least a lateral spine X-ray for dorsolateral spine, plain X-ray.
Okay.
Just look for undiagnosed fractures. Now, who should undergo? We see hundreds of diabetics every day. We can't have people undergo. So those over 60 should definitely, we should get men and women. So what I do is, because it becomes too much of a load on the patient, they already do so many things, we flag it and say, when things are better, we'll also get this done. But I write it on the prescription. You know, isko karenge aage, we'll do it. But it's important for you. Okay, number one. The second is those who are below 60, above 50 and below 60, between 50 to 60, and they already had 10 years of diabetes. They're also falling in that group. You know, or those who have other risk factors. Someone is a smoker, family history of fracture, you know, clear evidences of other risk factors, then we screen them between 50 and 60, otherwise above 60.
So would you recommend this calcium tablets and vitamin D to everyone, whosoever comes in the clinic with diabetes of say 10 years or more duration?
So no, we generally are not doing that to everyone. In an ideal world, we should be checking if they are taking enough calcium or not. So with calcium, we normally try to do it through diet only. At least when that our nutritionists talk to them, they do talk about calcium intakes in the diet, right? Now, for vitamin D, it's very difficult to get it through diet. So in general, not just for people with diabetes, in general, we do try to maintain our patients at least above 20 nanogram, that is 50 nanomoles. So often we end up giving a low maintenance dose of vitamin D to everybody above 50. It's something like 60,000 units sachet or pill once a month, which is nothing. Or as some data suggests, 2,000 units every day. So, but that adds to the pill burden, and you know, it may be marginally superior, but giving it once a month also suffices. So I would do that for all people over 50.
Very important.
Amrish, can I ask a question? Why was this concept of vitamin D 60,000 all came in the last 10 years? Where was this theory 10 years before? Was it that we were missing the bus? Why so much enthusiasm now?
So the concept of vitamin D, about 20 years, I would say, but more accepted in last 10 years. So the vitamin D levels have clearly changed for the worse, had changed for the worse, because of increasing urbanization, because of pollution in North Indian cities, at least not allowing oxygen, not allowing UV rays to reach the skin. Okay. And because of people staying more and more in air-conditioned environments and inside. So our vitamin D deficiency became a big issue. The other thing is that we also understood the concept of chronic disease, chronic latent disease. You know, it's not necessary with D deficiency to be treating only rickets and osteomalacia, which are frank clinical diseases, but also the fact that a lifetime of D deficiency would result in weaker bones, result in greater osteoporosis, poorer skeletal development. That's why optimizing D levels. Now, what happens, unfortunately, Vijay, in this, people go overboard. So they are pumping people with 60,000 every week for everybody, you know, all those kind of things. You need just about 2,000 IU a day for an adult to maintain optimum D levels. And if someone is really out in the sun all the time or is using only fortified food, maybe you can avoid even that. Now, for young patients, you must still avoid, okay? But I think that in the growing age, that is childhood adolescence, and then newborn childhood adolescence, and then in those over 50, we should certainly be supplementing some amount of vitamin D, because at least in cities, because we don't make enough.
And another thing is, do you think that this impact exercises are highly we hardly talk about the impact exercises, which are very, very important for bone deposit, mineral deposition, calcium deposition?
Absolutely. There is no scope to talk about the whole thing, but exercises are a very important component of our bone, preserving our bone health. And exercises done in erect posture, which are weight bearing or light weights, they are all very, very good for our bone. So it is like any chronic disease, like diabetes. You need diet, you need exercise. In the same way for osteoporosis prevention, you need all those things. There is no doubt.
One question to Dr. Vijay Vishwanathan. You are a part of this International Working Group for Diabetic Food. So what is your opinion about the diabetic food care in India compared to West when it comes to the treatment given by the doctors? I mean, treatment wise.
Manish,
What do we have any lacunae from doctor's side? Because now we have access to everything. I mean,
Manisha, you are a diabetic foot expert yourself. So
that's why I'm asking, is there any lacunae which I am not aware of, which we are here facing here?
What does the United States not have? You know, they have everything, but they have the same problem of amputations and so on. So India also is far ahead, but somewhere between the lines, reading between the lines, the care is very bad in India. People do not, it is a Cinderella of all the complications. People are worried about the kidney, worried about the heart failure. Nobody is worried about the foot. All the pharma companies are interested in the heart failure and in kidney and not the foot. So the foot, as Andrew Bolton says, is the Cinderella of all the complications. So that's the problem.
Those from doctor's point of view, are we lacking in something?
No, I
from
think
doctor's point of view, not from the patient's point of view.
we have to educate the public. We have forums like RSSDA which can take up the foot as a major issue. So I think last year, RSDA did a program on 1 million tests. This year, the theme is going to be on foot care. So they have asked me to arrange a program where one particular day, so many feet be examined. So I think we need organizations, associations, doctors to talk about foot care also. Thank you, Manish.
I think the same is also true for bone health. We hardly talk about bone health on this kind of forums, and when it comes to patient education, hardly anybody talks about bone health or except this vitamin D thing. Otherwise, nothing is talked about. I think that is also because of pharma is more interested in vitamin D. So these are the two very important topics, but very badly neglected, and which actually affect the patient's life to no extent. Morbidity is too much with that. So any more questions? I don't see any questions.
Due to time constraints, we cannot take any more questions, ma'am. Sorry for that.
Yeah, there's nothing now. Thank you so much.
Thank you, Dr.
Thank you,
Manisha.
Dr. Manisha, Dr. Amrish Mittal, sir, Dr. Vijay. Thank you all for being here for us, for our conferences year after year. Thank you so much.
Thank you, Uni. Bye.
Thanks, Vijay. Bye, Uni. Bye. See you.
Bye.
Thank you, everyone. So moving ahead with our next session, that is on in-hospital glucose control. To chair this session, I would like to invite Ms. Nikita Sarkar, who is a certified diabetes educator, currently working at Chelaram Hospital since 7 years. Ms. Nikita Sarkar has co-authored article on telemedicine in pandemic period, co-authored reviewed articles on management in gestational diabetes. Ms. Nikita also co-authored an article in 2022 for Chronicle of Diabetes Research and practice on a pilot study on glycemic variability and other risk factors for diabetic retinopathy. She has published chapters from the Handbook of Inpatient Glucose Management. She has published articles in Diabetes Health magazine. So over to you, Ms. Nikita. I would request you to introduce our speaker. Thank you.
Thank you, ma'am. So I would like to introduce next speaker, Dr. Ashutosh. He is MD Medicine, consultant physician and diabetologist at Chelaram Diabetes Institute, MBBS from MIMSR Medical College, Latur, MD Medicine from KIMS Hospital, Bangalore. He has 4 scientific publications in national and 1 international medical journal. Over to you, Dr. Ashutosh.
Good afternoon, everyone. I'm Dr. Ashutosh, currently working as a consultant physician and diabetologist at Chelaram Diabetes Institute. I welcome you all participants, faculties, my dear colleagues to this 6th International Diabetes Summit Virtual 2022, which is being conducted by Chelaram Diabetes Institute, Pune. Now, in this session, we are going to discuss regarding how to develop your own in hospital insulin infusion protocol. So before starting this topic, which is a in hospital insulin infusion protocol, so let's see in a brief what we are going to discuss in this topic. So in this we are going to discuss first is what is the exactly is the insulin infusion protocol, what is the need of insulin infusion protocol, why you should have this insulin infusion protocol when you are working at your hospital, either you are working in a corporate hospital or if you have your own setup, why it is a needed. Then next is what are the components, elements of the insulin infusion protocol. And at the end of this topic, we are going to see what protocol we use here at the Chelaram Diabetes Institute. So let's begin with our today's topic. Now, as we all are aware, the inpatient hyperglycemia and the adverse outcomes, they are well documented. And thus the insulin is the preferred treatment modality in a hospital setting. And though we can use the oral antidiabetic, but whenever the patient or whenever the person is hospitalized, and that too particularly when the person is critically ill or in ICU, so at that time insulin is always preferred. So why it is so? Because insulin, it is the most potent agent. Be you use it in a IV form, IV insulin, or in a subcutaneous route, but the insulin per se, it is the most potent agent to reduce or to lower the blood glucose level. And also it is rapidly acting and we can easily titrate it. And also as such there are no absolute contraindications to the insulin, whereas when you use the oral antidiabetic medicines, there are certain scenario or certain cases where we will require a dose modification, but as such there is no contraindications to insulin. But at the same time, this insulin, it comes under the high alert medicines, means in case if you don't use insulin or to the patient, or if you don't give insulin judiciously or properly to the patient, or if the patient receive a slight higher amount of insulin, so chances of a hypoglycemia are there. And that's why there should be a proper or standardized protocol which will minimize the risk of hypoglycemia and thus maximize the benefit to the patient. Now, as compared to the subcutaneous insulin, intravenous administration of insulin, it has the advantage of accomplishing adequate control with the small insulin doses. And also this IV insulin, it results in a continuous, safe and effective maintenance of a blood glucose level. At the same time, it also reduces the ketone production faster. Now this insulin infusion, it is the best way to control or to manage the blood glucose level whenever the patient is in ICU, or when the patient is critically ill, or when the patient is nil by mouth. And the target glucose level for the ICU patient or those who are critically ill is 140 to 180 milligram per deciliter. Now coming back to our topic, now what exactly is this insulin infusion protocol? Now this insulin infusion protocol, it is the protocol for giving intravenous insulin in a patient, in an inpatient who are critically ill or are in ICU. And this intravenous insulin or in IV insulin infusion, it is the best and easiest way to control the blood glucose level. Now intravenous infusion, as I said, we usually use this intravenous insulin in a ICU setting or in a patient who are critically ill, but the same intravenous insulin outside the ICU or for a non-critical patient also we can use, particularly this we can use as an alternative to basal bolus regimen, and we can use this for perioperative patient, those who are not eating well or having an NPO status, and those patients who are having poor glycemic control in spite of giving subcutaneous insulin. So in such setting, outside the critical care or outside the ICU also we can use this IV insulin infusion. Now this insulin infusion protocol particularly, it should be set up in such a way that this protocol we can give to our RMO, who are the resident medical officer, and the nurses, and these two people or these two persons together, they can manage the blood glucose level with the minimal disturbance to the physician. It means that in the protocol it should be that easy that this RMO or nurses together they can manage without disturbing the physician. Now, why one should have this insulin infusion protocol? What is the need of insulin infusion protocol? We can use the oral diabetes medicine or we can use the subcutaneous insulin. Why particularly we should have this IV insulin infusion protocol? Now, as I discussed in the previous slide, the glucose control is very important in ICU, and particularly the target as given by a NICE sugar study is 140 to 180 milligram per deciliter. It should be there, and at the same time, whenever we are using this insulin infusion, at the same time we should avoid the hypoglycemia, and also controlling the sugar, controlling the glucose, particularly in the critically patient. It also reduces the mortality, inpatient complications. It also reduces the length of a stay, overall hospital cost, and at the same time it improves the patient outcome. Now, these are the component, or we can say the ideal insulin, ideal IV insulin protocol should consist of these points. First of all, it should be easily ordered. In the sense, anyhow, we are going to discuss in an upcoming slide regarding the protocol which we use here at the Chelaram Diabetes Institute. So that time we will understand better. But in general, this insulin infusion protocol, it should be like easy, very easy to understand, and at the same time it should be that effective, or it gets to the goal quickly, and it should be the safe with the minimum risk of a hypoglycemia, as we discussed in the previous slide. Also, it should be easily implemented, and it able to use hospital wide. It is not like it should be particularly stick to the tertiary care hospital or where there is the infrastructure. Any person can modify this insulin infusion protocol or make the insulin infusion protocol as per the hospital where you are working, how is the infrastructure and all. Now, we saw what is insulin infusion protocol, why we need the insulin infusion protocol. Now, as many of us are aware, when we use particularly this IV insulin, so these are certain examples where we use the IV insulin. And as I said in a previous slide, particularly in a critical patient or those who are in ICU, we use. So conditions such as diabetic ketoacidosis, or the patient is having hyperglycemic hyperosmolar state, or HONC, hyperosmolar non-cotatic coma, when the patient is critically ill, nil by mouth, or when there are peri-operative period, and when the patient is on total parenteral nutrition. And as well as we can see here, prior to the insulin pump initiation also, we use this insulin infusion so as to get the total daily dose requirement, and also a dose finding strategy before converting patient to subcutaneous insulin. So these are certain examples when we use IV insulin infusion. Now, coming to the components of the protocol. Now, as I said, depending on the infrastructure where you are working or your setup, how it is, so this protocol, it should be individualized. It is not like whatever we are using at the Chelaram Diabetes Institute, it is a generalized protocol or anyone can use, or there is no as such a standard protocol, but you should individualize your own protocol. You should make your own protocol based on the infrastructure. How is your infrastructure? How is your setup, whether you are working in a medical ICU, whether it is your neuro ICU, or whether it is a cardiac ICU, we are working at a tertiary care level or some taluka place, where exactly you are working, what is the class of patient, how is their affordability. So based on that, this insulin infusion protocol should be individualized, and as much as possible this protocol should be simple and easy to understand, because this, as I said, this protocol is particularly for the resident medical officer and the nurses, so that they can understand it easily and they can implement it. So as much as possible it should be easy to understand and simple. And as I said, if you are working in a smaller hospital, you can relax the goal and you can relax the monitoring frequency and all these things. And if you are working in a neuro or cardiac ICU, you might require a different insulin infusion protocol. And also the training of a doctor and nurses, it is very important while having this protocol. And now in the upcoming slides, we are going to discuss the insulin infusion protocol, particularly which we have made and which we are using and implemented in the Chelaram Diabetes Institute. Now, the elements of the protocol, so the following points it should at least have, such as there should be clearly mentioned about what is the glucose target. So as I said, in a critical care, 140 to 180 is our preferred target, but if you are working at the hospital, or how is their infrastructure, so based on that you can relax the target. So there should be proper mentioning how much is the target, and also what should be the rate of insulin infusion infusion, and at what rate you should increase the insulin infusion rate or reduce it depending on the blood glucose level. Particularly, what is hypoglycemia, what is the definition, what exactly you will do if the person develop hypoglycemia, and what is the ketosis, and what will be the management, or how you will manage if the person develop ketosis. So at least these elements or this point should be mentioned in any standard protocol. Now, what all types of insulin we can use for the IV insulin infusion? So ideally, usually the only regular insulin is preferred, though the other analogs such as the faster acting aspart or lispro, these all also we can use, but ideally only the regular human insulin is preferable. Now the target glucose, as I said, for the ICU setting, it is 140 to 180 milligram per deciliter. And if you can avoid the risk of hypoglycemia, you can reduce the, or you can lower the target value. And in a non-ICU setting, the target is pre-meal sugar, pre-meal glucose should be less than 140, and post-meal glucose should be less than 180 milligram per deciliter. And what is the threshold for initiating the insulin? It should be when the blood glucose level are more than 180 milligram per deciliter. That time you should initiate the insulin. Now, coming coming to how to prepare insulin infusion. So these are the steps where you, in which I will show you how to make a insulin infusion. So for this thing, like we can take 40 international units of a short acting insulin, and we can add that to 39 ml of a normal saline. It means ki 40 units of insulin, short acting insulin, it will be there in 40 ml. So 1 ml of a mixture will contains 1 ml of a insulin. And in the priming, many of you were, if you are not aware, the priming bolus we usually calculate as a 0.1 unit per kg of the body weight. And why this priming bolus or priming dose is required? It is to saturate the IV tubing with the insulin. So it is calculated as a 0.1 units per kg body weight. And then give a bolus insulin, which is calculated as a current glucose divided by 100. In our coming slides, we are going to discuss with the example for your better understanding. But whatever is the XYZ or insulin, whatever XYZ is the value of glucose at present divided by 100 will be the bolus dose of insulin at what we are going to give it to the patient. And then set the hourly infusion rate, which is again calculated by current blood glucose divided by 100. And then we will have to readjust the dose of insulin infusion hourly based on the blood glucose level. And at the same time, as we discussed, we will have to prevent the hypoglycemia and then stop insulin infusion accordingly. Now, let's see. Now, this is the, as I was telling, this is the standard protocol, or this is the protocol we follow in a Chelaram Diabetes Institute, and this protocol is being made by us. So, yeah, so see now here what are the elements. So here we have mentioned the patient identification, the point is given. Then how to step one is to how to prepare the insulin infusion. Then the how what is this priming bolus? I mentioned in the previous slide how to calculate this priming bolus. What initial infusion rate will be there, which is based on the current blood glucose level divided by 100. Then glucose monitoring we are going to do every hourly, and this in the below chart we can see the time and the current glucose monitoring, and these are the points or table which we have made, and then we follow this protocol here. And this is the next page of the same thing. Here we have given the maintenance of the insulin infusion protocol or insulin rate, so that the RMO doctors and nurses, they can easily understand how to reduce the rate of the insulin infusion, or when to increase the rate and by how much they should reduce or increase the rate, when to stop, and also it is clearly mentioned here. So we are going to see this again in the next slide, upcoming slides. Now, as I mentioned in the previous slide, how we will start at the initial starting rate, it is the current glucose level divided by 100. For example, if the patient glucose level is 500 divided by 100 means 5 units we are going to give as a bolus, and followed by 5 units per hour as an infusion. Here in an example we are seeing that the patient blood glucose level is 300 milligram per deciliter. So the infusion rate, how we are going to start, 300 divided by 100. So 3 units as a IV bolus, followed by 3 units per hour as a infusion rate. So this is the example. Now, when we ideally this infusion we continue till if the person is, so for example, having a diabetic ketoacidosis. So if the person is a ketone positive, till the person becomes ketone negative, we continue this insulin infusion, and it depends on case to case when you want to stop. So ideally before stopping this insulin infusion, so you should give subcutaneous insulin at least 2 hours prior to stop, before stopping this insulin infusion. And this is very important, total daily dose. So how much insulin you have given in a 24 hours is your total daily dose. And of this total daily dose, 80% we can use through like whatever we have given a total daily dose, out of that 80% is we can calculate, and that we can transfer when shifting the patient from insulin infusion to basal bolus or any other therapy or any other method. Now these are certain examples when we stop the insulin infusion and when we switch the patient from insulin infusion to the bolus or basal therapy. So if the patient is eating properly and if we want to switch the patient to basal bolus therapy, so how we will distribute the TDD, which is the total daily dose. 50% ideally we should use as basal insulin, and 50% we should use as a nutrition insulin or pre-meal insulin. If the patient is NPO or nil by mouth, so in such scenario, obviously the basal insulin, the same 50% of the TDD we are using, but as the patient is a nil by mouth, so the nutritional or pre-meal insulin is not required. If the patient is on continuous tube feeding or such as a RT feeding, so as we are aware, the RT feed we give more frequently, every 2 to 3 hourly we give this RT feeds. So in such scenario, the nutritional insulin we should give more. Ideally the preferred is a regular insulin, which we should give every 6th hourly. And then here also the basal insulin will be 40% of a TDD and the nutritional insulin will be 60% of the TDD. Similarly, if the patient is on a high dose of a systemic corticosteroid which have the hyperglycemic properties, so in such scenario, out of total daily dose, 30% we should use as a basal insulin, 70% as a nutritional insulin. Now in this previous slides we saw what is the insulin infusion, what is the need of insulin infusion protocol, what are the elements, what are the components, how you can set up your own insulin infusion protocol, and what are the indication or when you particularly start this IV insulin infusion. Now in the coming slide, let's discuss this with the case so that it will be really helpful for you to understand this. So this is some random case we are going to discuss. So here it is a 64-year-old gentleman who is a known case of a diabetes, post CABG status, having a diabetic neuropathy along with the peripheral artery disease and retinopathy. So he is admitted in ICU with the complaint of fever, loose motion, abdominal pain and vomiting since 2 days. And these are his previous medicines. So as we can see, he is already on insulin, basal bolus insulin regimen he is taking along with the oral anti-diabetes medicine. Considering his post CABG status, he is on antiplatelet medicine along with the statin and other medicine for neuropathy and peripheral vascular disease. Now on examination, this patient having a temperature of he is a febrile with the temperature of 100 degree Fahrenheit, tachycardia is there, he is in a shock with the BP of systolic 80 mm of Hg, his room air oxygen is 88%, he is dehydrated, having an abdominal tenderness. Now these are the investigation. Here we can see the random blood glucose is very high, 528 mg per deciliter. Ketones are positive. ABG is suggestive of acidosis with a low bicarb. Urine, it is suggestive of a ketone 1+. Creatinine is deranged and his WBC count is 18,500, while the other investigations are within a normal limit. Now what is our diagnosis? So based on this case, we have diagnosed this as it is a case of acute gastroenteritis with the shock. Also the patient is having a diabetic ketoacidosis, and apart from that he is having type 2 diabetes mellitus with hyperglycemia, post CABG status, retinopathy and peripheral vascular disease. Now as I discussed in the previous slide, the target here should be 140 to 180 mg per deciliter. IV insulin infusion is the ideal step because the patient is critically ill, admitted in ICU, having a diabetic ketoacidosis, and here the short acting human regular insulin should be used for the IV insulin infusion. And those patients who are critically ill and on insulin infusion, so this capillary blood glucose testing ideally we should perform every hourly, or if not, so every 2nd hourly. And in some critically ill patient, capillary blood glucose may not be reliable, especially when there is a poor perfusion or perfusion issue. In such cases, we can take the blood sample from the veins or arteries. Now the intravenous insulin infusion, so it should be initiated when, as I discussed, when the glucose levels are more than 180 milligram per deciliter with the target of 140 to 180 milligram per deciliter. So here in our case, the blood glucose level at the time of admission is 528 milligram per deciliter. So how we have calculated 528 divided by 100, that is approximately 5 units we have given as a basal insulin, followed by the we can either continue the same 5 units per hour as a infusion rate, or other method is we can calculate as a 0.1 unit per kg per hour, and then we can continue this as a rate of the infusion, and then hourly we should monitor the blood glucose level and change the titration rate according to the blood glucose level. Now this is the chart which we follow in the Chelaram Diabetes Hospital, the Chelaram Diabetes Institute, and this is for the same patient. These are the how we have monitored this patient and how we have treated this patient. So these are the level of this patient. So here we are going to discuss in a brief. Now this patient, he was having the blood glucose level of a 528. So we have started with the 5 ml stat and followed by 5 ml per hour. Now the next at 4 p.m. the patient's blood glucose level became 566, which has increased by 38. So now what should be your ideal step? What should you do? Whether you will continue with the 5 units only infusion rate, or you will increase, and in case if you want to increase, how much you are going to increase. It is not like randomly we will make, instead of 5 we can give 8, 10 and also there should be some standardized protocol. So what will be your next step? Now this is the protocol we use here. So as per our protocol C, so now this patient's blood glucose level, it has increased. So and here there is a value, so it is more than 241. So ideally we should increase the insulin infusion rate by 3. So yeah, so we should increase the insulin infusion rate by 3. So we made from 5 ml per hour to 8 ml per hour infusion. Then the next time the glucose became 351. Now how much you should reduce? From it was 8 ml per hour. Now how much you should reduce? So again come back to our protocol, and here we can see the glucose level, it has reduced by more than 30, and value is still more than 240. So there should not be any change in the rate. So we continued with the 8 ml per hour, and then these are the subsequent reports or subsequent blood glucose values we have monitored hourly, and as we can see by 10 p.m. the blood glucose was 105. Now it is ideally, as I said, the target value is 140 to 180, but in case if you can avoid the hypoglycemia, you can lower the target. So as we are seeing here, now the blood glucose is 105. So what you should do? You should stop the insulin infusion, or you should lower the insulin infusion rate. Now, so here as we can see, so the blood glucose is between 90 to 109. What protocol we use here? So ideally we should reduce the rate by 50%, and thus we made it from 2 ml, we made it 1 ml, reduced by 50%, and subsequently hourly when the at 11 p.m. the patient blood glucose became 87, and this time now as per our protocol we can see here when the patient blood glucose is 70 to 90, we should hold the insulin infusion and recheck the blood glucose level after 30 minutes. So similarly we did here, we stopped the insulin infusion, and after an hour again we checked the blood glucose level, it was 188, and again we started this insulin infusion. So this was the protocol which we used in Chelaram Diabetes Institute. Now as I said, based on this insulin infusion protocol, or based on this infusion rate, we can calculate how much amount of insulin the patient required in last 24 hours, which we call it as a total daily dose. And while transition from IV insulin to subcutaneous insulin, as I mentioned, subcutaneous insulin should be given 2 hours, minimum 2 hours prior to stopping this insulin infusion. And once patients start eating, mealtime bonus also which should be provided. Yeah, so now this was the my session where we discussed what is the insulin infusion protocol, why you required insulin infusion protocol, what are the components, what are the elements, and what are the indication of IV insulin infusion, and subsequently we saw it with the example for your better understanding. Those colleagues or those participants who want to learn more about the insulin infusion protocol, as I said, this protocol should be individualized. The same protocol what I showed here should not be, it is not like it will, you can implement this in your hospital. If you want to learn more about how to prepare your own insulin infusion protocol, so we do have our one book named as a Handbook of Inpatient Glucose Management. So this book is available on Amazon. You can purchase from the Amazon. In this book you can find in details how to prepare your protocol and other management of a patient, also those who are inpatient particularly, you can find out this book. So this is the reference, and I would like to thank all the participants for your patience listening. Thank you.
I think there is no questions in the chat box. So I have a question from my side. So what is your opinion on sliding scale, which was an older practice where insulin infusion has to be managed by using sliding scale?
Okay, it's a good question. So preferably means in a Chelaram Diabetes Institute, we don't encourage the sliding scale, because as you said, it is the old method of giving the infusion. And here usually we have our own setup of a protocol which we follow. And even in the patient who are not critically ill, there also those who are in IPD, we don't encourage the sliding scale. There we prefer the basal bolus insulin regimen, where we usually give one or two shot of a basal insulin and bolus insulin, which is also called as a pre-meal insulin, which we usually give prior to breakfast, lunch, and a dinner. So definitely we don't encourage, because the sliding scale, it is not as such a standardized protocol, and usually if we see, it leads to more glycemic variability or more fluctuation. Sometimes the patient get the hyperglycemia, and at the other point they also get the hypoglycemia. So personally, we don't encourage the sliding scale.
Thank you, sir. And I really appreciate your talk on how to develop your own in-hospital insulin infusion protocol. That was a good talk. Thank you so much.
Thank you.
So we'll move on to the next session, which is a special guest lecture. So I would like to welcome to chair the session, Dr. Mahesh Kulkarni. He is a senior principal scientist and Biochemical Science Division, CSIR, National Chemical Laboratory, research areas, mass spectrometry based chromatic protein glycations. And he has done his MD medicine from Pune, post-MD fellowship in diabetes from Pune, worked as consultant in Chelaram Diabetes Institute, presently working as associate professor in medicine at Maiman Medical College, and practicing as consultant physician and diabetologist at Talegaon. So over to you, Dr. Valimbe, to introduce our speaker.
Good evening, everyone. At the outset, let me thank Chelaram Diabetes Institute for inviting me to be the chairperson for this session. We are going to have 3 lectures just now. I'll request Dr. Sudham to introduce Dr. Juliana Chan. Dr. Sudham, are you there?
Sir, you can introduce.
Dr. Valimbe, you can go ahead and introduce.
Okay. She's an internationally acclaimed clinician and researcher. She's the founding director of Hong Kong Institute of Diabetes, Obesity, and is a professor of Prince of Wales Chinese University of Hong Kong. She's a member of Steering Committee of Prevention of Non-Communicable Diseases in Hong Kong. For her outstanding contribution, AD has conferred the Harold Rifkin Award to Dr. Chan in 2019. And may I request Dr. Juliana to start her lecture on metformin. Thank you.
Thank you, Dr. Amit, for the introduction. And I also wish to thank Dr. Uni for inviting me to this very exciting conference. You know, the program is really very, very rich, covering all areas. And congratulations on putting this annual conference, which really provided excellent updates for the multiple areas in terms of diabetes management and pathophysiology and beyond. So I have been asked to give a talk on metformin. Let me just share my slides. Can you see my slides?
Yes, ma'am.
Okay, thank you. So my topic is organ protective effects of metformin and beyond. So these are my disclosures. Metformin is really one of the most popular drugs in the field of diabetes. Metformin has been in clinical use since 1958. It's a very memorable year because this was the year when the Suez Canal was open. It was also the year when the World Health Organization and International Diabetes Federation formally joined hands to fight against diabetes. However, the drug was really the glucose-lowering drug, the glucose-lowering effect of the plant, okay, that really contains the active ingredient, which is the Garlica officinalis, was actually first discovered to have glucose-lowering effect in 1772. And subsequently, the active component, which the guanidine, was discovered and then synthesized. Of note, actually, in the 1940s, guanidine was actually developed and used to actually treat malaria and also for influenza, etc. So this is very relevant to what I'm going to talk about, and that is, apart from this glucose-lowering effect, the anti-inflammatory effect of metformin has long been recognized and has been used to treat infections. In 1958, metformin was formally introduced in UK to treat diabetes in other European countries. And of course, I think a series of landmark studies, notably the Diabetes Prevention Program published in 2002, and also the long-term benefit of metformin in preventing diabetes and also cardiovascular disease, have now put metformin as one of the drugs that can be used to treat or prevent diabetes. The long-term benefit of metformin has also been reported in the UK PGS studies, and this really, this wealth of evidence have supported the use of metformin as the first-line drug in the treatment of diabetes. And in 2011, metformin was introduced, included in the WHO as one of the essential medications. So over the last 20 years or so, many investigators have really studied the mechanism of this very fantastic drug. So some of you might realize that actually metformin, one of the major actions of metformin is it actually inhibits the function of mitochondria, which is of course the powerhouse of the body, and it generates ATP from AMP. So metformin actually reduced the conversion of AMP to ATP, and as a result, the accumulation of the AMP to the ATP ratio would activate the AMP kinase, which have a series of actions, and mostly it actually inhibits anabolism. In other words, actually reduce energy storage. So it reduced protein synthesis, it reduced lipogenesis, and it also reduced glucose production, particularly the raised AMP, the raised AMP to ATP ratio is actually inhibit the function of glucagon, which of course causes hepatic glucose production. So all in all, this has been thought to be one of the most important actions of metformin by actually activating the AMP kinase. However, more recently, it has been shown that actually the effect of metformin in the gastrointestinal tract might be very important. In fact, 80% of metformin are absorbed, about 20% of that go into the intestine. And there's now very good evidence suggesting that metformin can actually interact and modify the composition of the microbiota and increase the abundance of some of the health-promoting microbiota, such as the Echinacea. These microbiota would actually promote the utilization of energy in the gut by the bacteria. Also, it would increase the synthesis of short-chain fatty acid and also reduce the synthesis of secondary bile salts formation, which improve the lipid profile. Importantly, it also releases the GLP-1, which augments insulin secretion. So this is an interesting an action that needs watching. The other important actions is also it depressed the conversion of monocytes to macrophages and also reduced the circulating cytokines, And this inhibitory effect on the immune system results in a reduced neutrophil to lymphocyte ratio. Indeed, in patients who've actually got cardiovascular disease, whether they are undergoing a PCI or undergoing bypass operation, it has been shown that a neutrophil to lymphocyte ratio increased the risk of mortality. It's associated with 2 times increased risk of mortality after adjusting for other baseline parameters. So an overactivity of the inflammatory response is associated with adverse outcome. In this very interesting study, the researchers actually looked at 2 cohorts. One is actually the diabetes register, the Gold Dust Diabetes Register from Scotland, as well as the data from a randomized clinical trial, the TASI trial. So in the Gold Dust Diabetes Register, the researchers actually looked at the patients who were put on metformin and patients put on sulfonylurea, and they found that patients who were put on metformin actually had a lower neutrophil to lymphocyte ratio compared to the sulfonylurea users. This is associated with due to an absolutely higher neutrophil count in the a lower neutrophil count in the metformin users compared to the sulfonylurea users, and also a higher lymphocyte count actually in the metformin users compared to the sulfonylurea users. Apart from these baseline differences, the changes in the NLR, the neutrophil to lymphocyte ratio, 8 to 12 months after the initial therapy, was also associated with a metformin. So a lower lower NLR is actually associated with metformin usage prospectively. In the TASI trial, which actually looked at the effect of metformin in people without diabetes on the risk of heart failure, so it's an ongoing trial, but they also found that patients treated with metformin actually have a lower incidence of, have a lower concentration of these cytokines. So suggesting that, metformin indeed might have anti-inflammatory effects. So these clinical data are supported by experimental studies. In this particular experiment, researchers found that the bone marrow cells, collected from the mouse, these are bone marrow derived macrophages obtained from the mouse. And those cells which are treated with metformin or biogonized, when they're exposed to the lipopolysaccharides, which are the antigen of some of the bacteria, actually express a lower level of interleukin-6 compared to the untreated bone marrow derived macrophages. So we now know that actually metformin, so these studies suggested that the anti-inflammatory response might be really quite important in determining clinical outcome. Indeed, we now know that actually there's a lot of meta-analysis suggesting that metformin actually reduces all-cause death. And most of these deaths are not just cardiovascular disease, but also renal-related diseases, cancer, and infection. We have observed actually declining rate of cardiovascular diseases, particularly due to the increased use of blood pressure lowering drugs and lipid lowering drugs. So the rate of cardiovascular disease is declining, but CKD is going up in many places because of competing risk of mortality. People are living longer, but in this meta-analysis, it's interesting to note that metformin is also associated with reduced all-cause mortality in patients with mild to moderate CKD, and there's also a tendency towards significance in patients with most significant impairments in terms of eGFR. So about 20% reduction in terms of a mortality rate. So some of you might be aware of this national or rather a territory-wide diabetes register. Now it is becoming a territory-wide diabetes database. In all these patients, they're under structured assessment. So we have very good baseline data to help us understand the causes, the consequences, and also the trajectories of patients with diabetes. So we published a series of papers, and in this particular study, we looked at nearly 0.8 million people with diabetes who were followed up between 2001 and 2020, 2016, and we could see that there is a decline of nearly 70% of all-cause deaths in these patients. The 3% death rate has gone all the way down to 1.3% death rate on an annual basis. And this is very much due to the decline in terms of cardiovascular disease. This is coronary heart disease, stroke, and also heart failure. Although recently the fall has been plateauing, and also hypoglycemic crisis. However, what we are not actually seeing improvement is in the arena of infection. In fact, now pneumonia is the leading cause of death among our people with diabetes. And here you could see that over this 16 years period, there was this flattening in terms of pneumonia rates. This one is, these are hospitalization, not death, but these are hospitalization due to pneumonia. And there is a worrying trend that there is actually increased, a rising trend of hospitalization due to influenza, and really raising the point of vaccination in order to prevent this infection, because we know that once people with diabetes have an infection, influenza particularly important, of course, they have a higher chance of deteriorating to have pneumonia. And very importantly, the pro-inflammatory response associated with pneumonia and infection will activate a lot of the thrombotic pathway and increase the risk of myocardial infarction in about a post-pneumonia 1 month period. So, you know, the vaccination, the benefit of vaccination in these high-risk individuals go beyond prevention of pneumonia, but also cardiovascular diseases. We also see a reduction in urinary tract infection. However, the kidney infection seems to have gone up more recently. So there is still major unmet needs among these people with diabetes. And when we compare the infection rates among the people with diabetes with people without diabetes, using again the Department of Health data, we found that people with the diabetes have 1.3 to 1.4 increased risk of pneumonia and 3.2 to 4.9 increased risk of kidney infection. So are we seeing similar situation in the countries? This is the Danish Diabetes Register, which looked at 130,000 patients with type 2 diabetes. They were put on glucose-lowering drugs between 2005 and 2012. And they actually looked at two areas. Firstly, they looked at the community-based antibiotics used. And so you could see that these people often need antibiotics for all kinds of infections, not just pneumonia, respiratory infection, urinary tract infection, and also GI infections, a lot of skin infections, and also viral and fungal infections. So these people, people with diabetes have really altered immune status and making them more vulnerable to infections. And also about 51 per 1,000 patient years are at risk of having hospital-treated infections. So if we use metformin as the reference, then it's interesting to note that both the sulfonylurea as well as the insulin use is associated with higher risk with all kinds of infections. So this is not really saying that the sulfonylurea or insulin is increasing the risk, but probably it is the metformin which is associated with reduced risk. And when you look at the Kaplan-Meier curve, you could also see that actually among these three major classes of glucose-lowering drugs, metformin, this is the blue line, actually have the lowest risk of hospital-treated infections and also community antibiotic usage compared to sulfonylurea and also insulin. So we took the opportunity, we leveraged the sort of very comprehensive data in the Hong Kong Diabetes Register and asked the question whether what is the risk association between metformin and also pneumonia, which was published last year in Diabetologia. So essentially, the register was established in 1995, but in 2000, we started to have a lot of the drug database, very comprehensive dispensing data, actually on a territory-wide basis. So we tracked these patients and then we censored them in 2019, and basically the first pneumonia hospitalization death, okay? And we actually look at the people who have ever been exposed to metformin and those who have not been exposed to metformin, as well as patients who were put on metformin after they have been registered, and in order to avoid some of the confounding, and then really adjusting for all the time varying variables, for example, all the laboratory tests, the lipid, the glucose, the use of RAS inhibitors and other drugs, as well as hospitalizations for other causes, as well as some of the baseline parameters, and then try to see whether we can we can discover any independent risk association between metformin and also pneumonia. So in this database, about 20,000 people, you could see that really the majority of people have been exposed to metformin. Really only 1,000 of patients who have not been exposed to metformin throughout the studies. Overall, metformin-treated patients were a bit younger. They have a slightly shorter disease duration, and also they generally have a better lipid profile, glucose, and also a lower EGFR, a higher EGFR. However, after overlap weighting, these are using propensity score overlap weighting, trying to balance the baseline parameters, okay, using some of the statistical method. And after this statistical adjustment, essentially there was a minimal difference between the baseline parameters between the two groups, mimicking a randomized trial where some of these patients are receiving metformin and then not receiving metformin. So again, before the matching, people with treated with metformin tends to have a lower cardiovascular risk and also less likely to have stroke and less likely to have heart failure and cancer. After overlap weighting, again, these risk profiles, these comorbidities and medication use were also similar between the two groups. In this profile, it's also very useful to look at the pattern. So here, about 50% of these patients were on 2 drugs or more. By the way, because of the severity of disease, we do exclude patients who were treated with insulin in this cohort. About half of these patients were put on RAS inhibitors, and about 1/4 of patients were put on antiplatelet agents, and with about 2 A1C measurements per year. So again, after overlap weighting, the profile, the distribution of this drug usage were actually similar. So with that analysis, we found that actually metformin exposure was associated with a very consistent, about 40% reduction in terms of hospitalization due to pneumonia. And on subgroup analysis, this was very consistent when we analyzed by gender, or by CKD stages, whether they have mild kidney impairment or more moderate kidney impairment, or whether these patients were treated with 1 drug or 2 drugs. And then when we actually look at the pneumonia-related deaths, again, we see similar pattern. Metformin was associated with nearly 50% reduction in terms of pneumonia-related death. Again, similar trend among analyzed by CES, by CKD stages, and also by the pattern of drug usage. We then also look at the association of long-term use of metformin in terms of the dosage and also the duration of exposure. And using spline analysis, we actually found that the more period of time, okay, that these patients were exposed to metformin during the follow-up were associated with a reduced risk of pneumonia, hospitalization, or pneumonia-related death. And we also look at the dosage, and people who were treated with higher dosage of metformin also had a lower risk of pneumonia risk over time. We also look at the hematological results in these people, and we found that metformin users, like in the previous studies, have a lower neutrophil to lymphocyte ratio when they were admitted with the hospitalized, when they were admitted with pneumonia, 12.8 versus 14.8 in those people who were not exposed to metformin. The risk of metformin-associated lactic acidosis was indeed very low, with 2.5 per 100,000 persons years, and similarly low rates has been reported in other studies as well. So in these patients, we also look at the new user cohorts. Okay, so these patients to avoid all the confounding by indication, etc. And again, we also saw similar characteristics that actually metformin use was associated with, again, 30% reduced risk of first pneumonia hospitalizations, as well with a very similar pattern, whether analyzed by SES, by CKG stages or treatment regimen. So again, similar pattern, okay, when we actually look at pneumonia-related death. So metformin exposure, whether they are actually prevalent users or incident users, or now if we just look at people who were newly started on metformin after enrollment, we saw these persistent benefits associated with metformin in terms of reduced risk of metformin. So after all, these were observational studies. So what about randomized clinical trials? In this randomized clinical trial, which lasted for 12 weeks, the researchers asked the question, they wanted to explore the metabolic effect of metformin versus placebo in patients who were treated with systemic steroids for various conditions, rheumatoid arthritis, or for example, psoriasis. And interestingly, they found that people who were treated with the metformin, they actually have lower visceral fat. Okay, so they were measuring the visceral fat in these individuals, and then they also were less insulin resistant. This was the HOMA IR. These patients had actually better insulin response. This is the HOMA IR with the disposition index. So with reduced insulin resistance, the insulin response is better. As a result, they have a lower A1C. So note that many of these patients did not actually have diabetes. They were also more likely to have a lower HDL cholesterol. They were less likely to have fatty liver, okay, as indicated by the ALT. These patients treated with metformin were also, less likely to express hunger. We know that patients put on steroids were more likely to crave for food. So patients seems to actually reduce their craving for sugar and also their hunger feeling. What's interesting is when they actually look at the adverse event, okay, since this is RCT, so they have to report all the adverse events, whether it's serious or non-serious. So as expected, the patients treated with metformin were more likely to have diarrhea compared to the placebo group. But very interesting, there was a stark difference in terms of the pneumonia rates, with 7 people in the placebo group having pneumonia versus only 1 in the metformin group. And taken together, this metformin was actually associated with a significant reduction in terms of serious adverse events. And when they actually look at the lysis titer, which is of course a indicator about the viral infections, here you could see that metformin users were less likely to have viral infections compared to those who were treated with placebo. And again, this is reflected by a lower hsCRP throughout the study. So I think these studies again support the anti-inflammatory effects of metformin in an RCT setting. Now, of course, we are hit by the by COVID-19. Hong Kong is badly hit at the moment because of the low vaccination rates among the vulnerable, particularly elderly, and of course our very, very overcrowded situation. Our living conditions don't help. And over the last 2.5 years, many researchers have actually looked at the pattern of COVID and also, the effects of different medications in these individuals. We know now for sure that people with metformin, people with the diabetes, whether type 1 or type 2, have 2 to 3-fold increased risk of having COVID, particularly if they have poor glycemic control, if they're obese, or if they have comorbidities. There have been very inconsistent reports regarding the different kind of drugs, glucose-lowering drugs on the risk of COVID-19. Although we know people who have good glycemic control actually have better outcome. In this study, which is Coronado, which is from the French, it's a French territory-wide database, and they actually look at 2,500 patients type 2 diabetes, and about 1,500 of them were actually on metformin. 900 of them were actually not exposed to metformin. And then you could see that actually patients who were exposed to metformin actually have a longer time from the onset of symptoms, suggesting that maybe the disease are actually milder. And they also have less likely to have severe COVID. And in fact, when they look at the death rate at 28 days, people who were exposed to metformin was 16% versus 28% in those who were not exposed to metformin. After propensity score matching, metformin usage was associated with 30% reduction in terms of COVID-related mortality. So, in fact, this observational study have also been supported by a meta-analysis. This include about 8,000 patients or so, and these are data coming from USA, China, France, and very consistently, again, showing that patients treated with metformin had about 30 to 40% risk reduction in terms of severe COVID in terms of death. So, ladies and gentlemen, I think taken together, metformin has pluripotent effects in modulating the lipid and glucose and energy metabolism. But importantly, I think this anti-inflammatory effect of metformin require further exploration. And maybe a very important mechanism which might explain, the benefits of metformin in terms of reduction in all-cause mortality, cancer, anti-cancer effects, as well as cardiovascular protective effect. My talk was particularly focused on pneumonia and infections, because this is now becoming a leading cause of death in people with diabetes. Real-world evidence based on registers and nationwide cohorts suggests reduced risk of pneumonia events with metformin, and our data suggests that there is also a dose-dependent and also duration-dependent relationships. In a randomized clinical trial, the metformin improved metabolic and inflammatory risk factors with reduced risk of serious adverse events, including pneumonia in patients who received systemic steroid treatment. So, and then taken together, I think it is important to emphasize once again, there are very few drugs which are like metformin, very powerful, very cheap, very safe, that should remain as the preferred first-line glucose-lowering drugs, and which have, pluripotent benefit and the reduced risk of pneumonia, as I said, is becoming a leading cause of hospitalizations and death in patients with type 2 diabetes. Thank you very much.
Sudham?
Yes. Good evening, ma'am. Do you have any experience regarding the effect of metformin on any malignancy in the research? What is the effect of the metformin in the malignancy, cancer cells?
Yeah, I think there are actually, I will be giving a talk on cancer tomorrow. Yeah, we will have actually used our register and found that actually metformin was associated with risk of all sites cancer, particularly in patients who actually got low HDL cholesterol. So as a marker of insulin resistance. So I think insulin resistance and hyperinsulinemia play quite an important role in promoting cancer growth. And I think and of course, inflammation is a very important factor as well. So I think there is actually an ongoing study, a randomized clinical study is now looking at the effects of metformin in patients with gynecological cancer. So I think there's many meta-analyses suggesting that metformin is associated with reduced risk of all sites cancer, and the particular gynecologic like breast cancer, ovarian cancer, and colorectal cancer. Those are the few ones. But we need to see some of the randomized clinical trials to show that.
Another question is that what do you think in clinical practice, up to what stage of eGFR we can continue the metformin, and what stage of CKD we should stop the metformin?
Yeah, that's an interesting question. In fact, the FDA, because I think there aren't that many RCT data, right? You know, looking at the use of metformin in patients with CKD, and there are a lot of observational data supporting its safety in patients with eGFR above 30, and so in fact the FDA has has actually given instructions that guidance that metformin can be used up to eGFR 30 or more, and then with some dose reduction, okay, and with more frequent eGFR monitoring. So we recently have done again using our very big database. Of course, one of the things is there's a confounding because people do not actually use metformin when they have when they have low eGFR. So sometimes the benefits associated the reduced cardiovascular disease or renal disease with metformin might be due to the fact that they're just not prescribed in patients with low eGFR. But after we have done all the matching and also adjustment, we did actually found that metformin was associated with reduced risk of development of end-stage kidney disease in patients at all stages of eGFR. But I think there's a need to reduce the metformin to about 500, maybe if you are in stage 4, and if it is stage 3, maybe something like 850 to 1 gram or so. So we hope the paper will get published. It's a very big cohort. And I think this is another area where metformin might actually have a renal protective effect.
Thank you so much, ma'am. Is there any question?
Just one thing, what madam said is absolutely true, that metformin can be used up to 30. But I would say that below 45, we should not initiate it.
Yes,
If patient is already taking metformin, you can continue up to 30, but once it goes below 30, you need to stop it. Another important issue is that once we stop metformin, the sugar control goes very haywire, that we have seen, because metformin is a wonder drug for sugar control. So if it is allowed and permitted within the limits of eGFR, I think we should use it whenever possible, unless there are contraindications.
Well, in fact, actually, according to the KDIGO guideline and even in the ADA guideline, we can actually initiate metformin up to eGFR 30. So even in patients with eGFR above 30, we can initiate the usage of metformin, right? Yeah. So I think I think it is you certainly lots of these new CKD trials, many of these patients were actually on metformin. But maybe you will use it at a lower dose. Yeah.
Definitely.
So I think this is something that we and I think even in America they will continue to use the high dose, but I think in Europe they will ask people to reduce the dose. But the important point is we should monitor the eGFR. And anyway, I think we should be monitoring the eGFR, if not half a year, every year, and more frequent if for patients with lower eGFR. But according to the KDIGO guideline, we can actually initiate metformin even if the eGFR is 30. Below 30, we don't initiate. But if you initiate at 30, you can initiate and then monitor. It doesn't cause deterioration in the eGFR, and you just keep it like that.
Okay. I think thank you, ma'am, for this wonderful lecture. If there is no more questions, we'll move on to
there are some questions, sir.
You can take some 1 or 2 questions. Yes.
Okay. So, ma'am, how often to monitor that eGFR when we are starting metformin when eGFR is less than 45 or say up to 30? So, how often you need to monitor eGFR?
Well, we do not really expect metformin, actually would deteriorate the renal function. I think what people concerned about the use of metformin is lactic acidosis, right? So I think, in people who are very, and the reason the increased risk of lactic acidosis associated with metformin usually occurs in the context of multi-organ failure, okay? Because lactate is actually cleared by the kidney, okay? And then also lactic formation is increased in hypoxic situation. So in patients who's got respiratory disease, in patients who've got heart failure, where you might expect hypoxia, or in patients who got significant renal disease, then there might be accumulation of lactic acidosis. But in an ambulatory setting, when the patient is not really, very ill, I don't think, there's particular concern about the eGFR. But I think when people have an eGFR like 45 or 30, depending on the control of other risk factors, the eGFR might decline, right, at the rate of 3 or 4 ml per minute per year. So, the eGFR can decline, and as a result, the theoretical risk of lactic acidosis, particularly in the presence of acute stress, might increase. So, I think with so many new drugs being developed for kidney disease, where albuminuria and eGFR become a very important indicator for use, I think this kind of annual assessment for eGFR and albuminuria become very important, and it will also guide the use of metformin.
Okay. One more question, sir, ma'am.
Thank you, ma'am, for patiently explaining. One more question I have. Could you please elaborate on the effect of metformin in fatty liver disease?
Metformin in?
Fatty liver disease. Fatty liver disease or NASH. Non-alcoholic fatty liver disease.
Oh, non-alcoholic fatty. Oh, yes. So we have been reviewing some of the literature. Interestingly, there have been a large randomized trial, comparing pioglitazone and also metformin. I think there have been anecdotal report showing that metformin is associated with improvement in NAFLD and also NASH. And in part, this is because of the reduction in body weight. We know if we can reduce body weight, that we can improve NAFLD. But actually, when it is head-to-head comparison with pioglitazone, then actually metformin does not really reduce the fatty liver so much. Whereas actually the TZD, which actually have a different mechanisms, right? Because it actually promotes the differentiation of pre-adipocytes to adipocytes. And as a result, you can shift the ectopic fat, okay, from the liver to the subcutaneous fat. And so, that improves reduce the fatty infiltration into the liver. But I think metformin itself does not really directly improve the fatty liver. It's more by weight reduction, yeah. And of course, the improvement in glycemic control overall, right? Yeah, but when we have two drugs which are head-to-head comparison with slightly different mechanisms, then metformin doesn't do so well for fatty liver.
Okay, ma'am, also one more question. What is the role of metformin in obesity in persons without diabetes, just for obesity and for patients with PCOS?
Oh yeah, I think the usage of metformin in PCOS is well recognized, right? And certainly it improves the ovulation and really increase the chances of pregnancy. So I think by improving the insulin resistance and that actually altering a lot of the other steroid profile, that has a beneficial effect. I don't think it can be used as a obesity drug, right? Because to be called an anti-obesity drug, I think you need to have at least 5% reduction in terms of body weight. So I think it is associated with reduction in body weight, but maybe just 1%, a couple of kilograms. But it's really not like 5 or 10 kilogram reduction like some of the really anti-obesities like GLP-1 or so. But it is a very, very good base therapy, right? Actually, for all the other drugs, that we can use. And I think this is an important message because now we have a lot of new drugs, and then sometimes they were even saying that we should actually replace metformin with, for example, SGLT2 inhibitors. And I think the audience need to be reminded that all these cardiovascular and renal outcome trials, the patients are actually on this standard therapy, which is metformin, maybe sulfonylurea, DPP-4 inhibitors, statin, and also RAS inhibitors. So I think it is against that background, then those new drugs comes in. And this is very important, particularly in, given the evidence and finite resources.
So you personally won't recommend use of metformin for non-diabetic obese patients?
Non-diabetic. Now, having said that's right, but of course, metformin can be used in people with pre-diabetes, right? Most of these obese patients, the majority of these obese patients have either IGT or, IFG, right? Of course, you see the DPP, the Diabetes Prevention Program, they are mainly IGT individuals, right? But I think there have also been some small studies showing that metformin also reduced the metabolic profile in patients who have prediabetes or metabolic syndrome. So, so I think, if patients have got prediabetes, you should use it as well.
Okay, thank you, ma'am.
Okay. Thank you. If there is no more question, thank you, madam, for this wonderful lecture. I think we'll move on to our next lecture on the. Sir, has joined?
Yes, sir. His session is recorded.
So,
you can
please go ahead.
Go ahead,
Sir.
Yeah. So we'll move on to our next lecture on the real world evidence on type 2 diabetes management insight from Jade registry. We have a senior endocrinologist from the Pune, Dr. Uday Padke, to talk on this topic. So I will invite Dr. Uday Padke, sir.
And I'm very glad to be a part of this meeting of Chelaram Diabetes Institute. And today what I'm going to present to you is an interesting study, which is a real world evidence of sulfonylurea usage in Asian patients with type 2 diabetes. And what we are doing here is we are using data from what is called the Joint Asia Diabetes Evaluation Register, and the acronym made is JADE. Now, the background really is that we have lots of diabetes in our region, particularly the Asia Pacific and the Southeast Asian region. And sometimes an impression is carried that sulfonylureas are not really the most important treatment anymore, and they are being replaced by many other treatments. So this study is actually about the type of usage of sulfonylureas with sulfonylureas and what advantages they bring. This is obviously an observational study. This is not a randomized study, but because of the strength of numbers, I think we get a very good information out of it. We know that 1 in 10 adults in the world have diabetes, and the Asia Pacific region contributes to more than 50% of global cases. And these are the figures in front of you. They're quite massive. And you'll see that a lot of them come from the Western Pacific region and Southeast Asia. However, in spite of these large number of diabetics, we have little real world evidence on sulfonylurea usage in the Asia Pacific region. And the data needs were to find the treatment patterns in Asian people with type 2 diabetes, how many were using sulfonylureas and how many were using non-SU based therapy, and what were the patient profiles between the two groups. And this study was hoping to provide new data regionally on SU use in real life in Asia and the effectiveness and safety of sulfonylureas in general and glycoside use in the real world. Again, as I said, using the registry, which is called the JADE registry, or the Joint Asia Diabetes Evaluation, JADE. And these are the experts who sat on the entire evaluation of the evidence that was collected. It was led by Professor Juliana Chan from Hong Kong, and then there were diabetes experts from Malaysia, Hong Kong, China, Korea, Thailand, and Dr. Unikrishnan was here on the expert panel from India. And I'm also glad to share that I was a part of this entire data collection group, which led to the overall JADE registry. Study protocol was very simple. The population included patients with type 2 diabetes who were treated with oral glucose lowering agents, or the OGLDs. They had to be more than 18 years, and they were enrolled in the JADE register between January 2007 and December 2019. The main study objectives, as I've already said, was to describe the pattern of OGLD use in patients with type 2 diabetes in Asia, including a description of sulfonylurea and non-SU based therapy, and to evaluate the effectiveness and safety of SUs in Asian patients with type 2 diabetes. And this was a breakup of the entire study population. So patients were recruited in JADE between Jan 2007 and December 2019. And some had to be obviously excluded from the study because they had type 1 diabetes, or the type of diabetes was unknown, or their age was less than 18, or the information on their age was not clear. And that led to a clear type 2 diabetic population. But then people who were on injectable drugs like insulin or GLP-1 receptor agonists were also excluded from the study. And so were people where data on what type of oral glucose lowering drugs they were using, these were also excluded from the study. And this left really a total of 62,512 patients, of whom 54,783 patients were treated with some kind of oral glucose lowering drugs, and 7,729 were not treated with drugs. They were probably treated with lifestyle alone. If you look at the patient demographics, they seem to be roughly similar. They are matched in age. So these are three groups that we have now: treated with any kind of oral glucose lowering drugs, treated with any SU, and treated specifically with gliclazide. We're trying to find out also how many we treated with gliclazide versus other SUs. So if you look at the data based on age, based on the BMI, based on diabetes duration, based on their eGFR, based on the comorbidities like hypertension, dyslipidemia, chronic kidney disease, diabetic retinopathy, and coronary artery disease. So most of them were matching except hypertension, which probably there was a slight preponderance in people who were treated more, who were treated with gliclazide versus non-gliclazide SUs, slightly more proportion of non-gliclazide SU use here. But otherwise, more or less across the entire group, the demographics were very much matching. And these are the patterns of the oral glucose lowering drug use. So you'll see here that most patients received 1, that means in 37.5%, or 2 in 44% of people received the oral glucose lowering drugs. Metformin, as is expected, was used by 84% of treated patients, followed by sulfonylureas, 59.4%, and DPP-4 inhibitors, 23%. And the remaining, of course, there were smaller numbers of alpha-glucosidase inhibitors, azoridine-diones, and SGLT2 inhibitors. This is probably because SGLT2 inhibitors, when the study was started in 2007, these were not necessarily used very commonly. And as I showed you, the data is also there about how many were using 1 versus 2 versus 3. And many people were actually using 2 or more oral glucose lowering drugs. If you look at people who were treated with sulfonylureas and break them into, be treated with the oral glucose lowering drugs and just divided by sulfonylureas versus non-sulfonylurea drugs, you see that the sulfonylurea based therapy was used in almost 60% of patients. So that's quite a large number. And that is again very typical of what we see in our country as well, where sulfonylureas are used very commonly. What is the pattern of use of these sulfonylureas? So we have breakup of glycoside versus glimepiride versus glibenclamide, Bedside, and others, which probably meant meglitinides. If you see the breakup data, we see that amongst the sulfonylurea users, we see that glycoside was the most commonly prescribed drug, followed by glimepiride and glibenclamide. Now, there were some regional differences based on which country was studied. For example, in Vietnam, in Singapore, in Malaysia, in Hong Kong, we had a lot of glycoside use, where in certain other countries, glimepiride use was slightly more common. But by and large, if you look at the entire data, glycoside was used in 47% of patients. This was the most commonly prescribed sulfonylurea. If you look at the binary logistic regression of patients who were taking glycoside versus those who were not taking glycoside, you see here that patients taking glycoside, HbA1c value, the odds ratio for reaching HbA1c value of less than 7 was better for glycoside users, and also the self-reported hypoglycemia, the odds ratio favored glycoside users, means more number of people using glycoside had better A1C reduction to less than 7%, which is the target, and more could have less hypoglycemia. So the hypoglycemic tendencies of glycoside were better than the other sulfonylureas. So to conclude, the SU usage in this entire large Asian population of almost 55,000 patients, 59.4% were using SUs, 79.5% were using SU plus MET. And amongst the SU users, glycoside was probably the more commonest, 47%. And when you compare glycoside versus non-glycoside, less patients had to take 3 OGLDs or more when they were using glycoside, 20.6% versus 35.6%. This is a statistically significant difference. Glycoside users were 9% more likely to achieve HbA1c of less than 7. And also, as I said, glycoside users had 19% lower risk of self-reported hypoglycemia. So thank you for
Are there any questions, Mr. Nima?
The recording is interrupted. Can you continue?
Okay.
Dr. Fatke is recording.
We will continue with our next keynote lecture on the vitamin D deficiency at 2020 update. I will invite Dr. Sanjay Badada for his keynote.
Fatke's recording was interrupted. So we will continue with Dr. Fatke's recording. Just give us 2 minutes. We are sorry for this interruption.
I think Dr. Fadke's recording got interrupted, so he could not finish. So let's, maybe we can start a little bit earlier also, maybe, so that the overlap is not there.
Please give us 2 minutes.
These are pre-recorded or what?
Yes, sir.
This particular session is pre-recorded. So Dr. Fadke, I think the recording got interrupted. So try again once more.
It suddenly got over.
I think that there's some technical issue.
patterns that we see in our patients over a period of time. And this is called glycemic variability, a very important consideration in diabetes management. This is going to be the agenda of my talk. I will introduce what glycemic variability or
No,
GB
sorry,
means.
this is not the talk.
What are the different
This is not the
important
talk.
metrics for assessment of GB?
This is not the talk. This is a different one.
Yes, this is his talk for tomorrow. So I think there was a technical error. The name of the talk is Real World Evidence on Type 2 Diabetes, Insights from the JADE Registry.
JADE Registry.
Yes.
Sir, this video started with this topic only.
Yeah.
Yeah, I think let's start from the beginning, and then let's make sure that it plays fully.
Okay, okay. We reached somewhere here. I think this is correct.
Yes. No, but this is showing again the.
This is not the talk.
Well, it is in the same video.
The name of the talk is Real World Evidence on Type 2 Diabetes Management, Insights.
Yes, this one.
Correct. Start was correct.
Yeah, this is a correct talk. Let's play it from the beginning. Don't worry.
Just go slowly ahead.
Just go ahead a little bit.
This was correct. You can go ahead by a minute or so.
Thank you, Dr. Walimbe.
I think this is where we left.
Yes, let's play it now.
Yeah.
Diabetes
No, you can
experts
go
from Malaysia, Hong Kong,
I think
China,
we are
Korea,
quite
Thailand,
ahead.
and Dr. Unikrishnan was here on the
Yeah, you can
expert
go
panel
ahead
from
by a minute
India.
or so.
This was a breakup
Yes.
of the entire study population.
Go ahead.
So patients were recruited in JADE between Jan patients, of whom 50 and coronary artery disease. So
Go ahead.
most of them were matching except hypertension, which probably there was a slight preponderance in people who were treated more, who were treated with glycoside versus non-glycoside SUs, slightly more proportion of non-glycoside SU use here. But otherwise, more or less across the entire group, the demographics were very much matching. And these are the patterns of the oral glucose lowering drug use. So you'll see here that most patients received 1, that means in 37.5%, or 2 in 44% of people received the oral glucose lowering drugs. Metformin, as is expected, was used by 84% of treated patients, followed by sulfonylureas, 59.4%, and DPP-4 inhibitors, 23%. And the remaining, of course, there were smaller numbers of alpha-glucosidase inhibitors, azolidine-diones, and SGLT2 inhibitors. This is probably because SGLT2 inhibitors, when the study was started in 2007, these were not necessarily used very commonly. And as I showed you, the data is also there about how many were using 1 versus 2 versus 3. And many people were actually using 2 or more oral glucose lowering drugs. If you look at people who were treated with sulfonylureas and break them into, be treated with the oral glucose lowering drugs and just divided by sulfonylureas versus non-sulfonylurea drugs, you see that the sulfonylurea based therapy was used in almost 60% of patients. So that's quite a large number. And that is again very typical of what we see in our country as well, where sulfonylureas are used very commonly. What is the pattern of use of these sulfonylureas? So we have a breakup of glycoside versus glimepiride versus glibenclamide, glipizide, and others, which probably meant meglitinides. So if you see the breakup data, we see that amongst the sulfonylurea users, we see that glycoside was the most commonly prescribed drug, followed by glimepiride and glibenclamide. Now, there were some regional differences based on which country was studied. For example, in Vietnam, in Singapore, in Malaysia, in Hong Kong, we had a lot of glycoside use, where in certain other countries, glimepiride use was slightly more common. But by and large, if you look at the entire data, glycoside was used in 47% of patients. This was the most commonly prescribed sulfonylurea. If you look at the binary logistic regression of patients who were taking glycoside versus those who were not taking glycoside, you see here that patients taking glycoside, HbA1c value, the odds ratio for reaching HbA1c value of less than 7 was better for glycoside users, and also the self-reported hypoglycemia, the odds ratio favored glycoside users, means more number of people using glycoside had better A1C reduction to less than 7%, which is the target, and more could have less hypoglycemia. So the hypoglycemic tendencies of glycoside were better than the other sulfonylureas. So to conclude, the SU usage in this entire large Asian population of almost 55,000 patients, 59.4% were using SUs, 79.5% were using SU plus MET. And amongst the SU users, glycoside was probably the more commonest, 47%. And when you compare glycoside versus non-glycoside, less patients had to take 3 OGLDs or more when they were using glycoside, 20.6% versus 35.6%. This is a statistically significant difference. Glycoside users were 9% more likely to achieve HbA1c of less than 7. And also, as I said, glycoside users had 19% lower risk of self-reported hypoglycemia. So thank you for
I think it again got over at that point only.
Yeah, you're absolutely right, sir.
If I could just physically complete this in a couple of sentences.
I think you're there. That's better.
I'm here. So the whole point was that the sulfonylurea use was different across different regional zones. In some countries, it was higher, for example, Singapore, Malaysia. And in some countries, it was not as high as the glycoside use was not very much. It was more of glimepiride use, or there were other sulfonylureas as well. Now, the main thing that actually came out of this particular study was threefold. Number one, the number of patients reaching a HbA1c target of less than 7 with glycoside use were definitely more than non-glycoside users. This was statistically significant. Less number of people using glycoside had hypoglycemias, particularly severe hypoglycemias. And the third important thing was that persons who required more than 3 oral glucose lowering drugs to achieve a target HbA1c was less in the glycoside users versus the non-glycoside users. So this was the main thing which came out from this particular study. It was an observational, non-interventional study. So that's how these are just the observational results. Thank you.
There were a few questions. Why was glycoside taken as a separate entity and versus the other these things?
That was because of two things. Number one, Serdia had also given an educational grant into this study. And secondly, there is a lot of evidence saying that glycoside has definite benefits, let's say, or is it slightly different from other sulfonylurea users? One, there is head-to-head comparison between glycoside and other sulfonylureas, particularly glimepiride, in terms of hypoglycemia. And also, glycoside has been extensively tested in the advanced studies about its cardiac safety. So there was interest to see if glycoside performs slightly differently as compared to the other drugs.
Okay.
There are a couple of more questions in the chat box. Please go ahead, sir. Please ask the questions.
Is there any comparison between the doses required to achieve the HbA1c level? Same HbA1c.
That can never be compared because they are two different sulfonylureas, and the dose cannot be compared because the maximum dose of glycoside is 120 milligrams of extended release glycoside, and here it is 8 milligrams. So that way you cannot compare. The potencies are completely different.
Another question is, were there two sulfonylureas used in one patient?
No,
is illogical.
No, it's illogical.
This study will be done with like that. Two medicines from the same class.
Cannot be used.
Cannot be used. Okay. Thank you, Dr. Uday Phadke, sir. It was a splendid presentation on the JADE registry.
Thank you very much.
Thank you very much. And now we go to the next session, next lecture in this session. It is by Dr. Dr. Sanjay Badada is a well-known endocrinologist and more than 160 publications. He is the president-elect Endocrine Society of India. He is a member of various academic bodies like API, ESI, RSSDI, IBS, ISBMR, Indian Menopausal Society and Indian Thyroid Society. He is the secretary of Indian Society of Bone and Mineral Research. He is the founder secretary of Punjab and Chandigarh chapter of RSSDI. Over to you, Dr. Sanjay, for your presentation.
Thank you for that introduction, sir. One quick comment. Sir has not joined yet. So in the meantime, there are a couple of more questions for Dr. Phadke. Dr. Phadke, are you still available, sir? Hello.
I'm here.
Yes, sir. The question I have here is, what are the clinical insights from glycoside use in elderly, sir?
So particularly in glycoside use in the elderly, as I said, there are head-to-head studies with glimepiride showing a substantial reduction in hypoglycemia. And therefore, particularly in the elderly where this can be a problem, glycoside use is very much recommended.
The maximum dose in elderly, probably 60, would you say, sir?
Well, there is nothing like a maximum dose.
Whatever is tolerated.
Would guide that. And one of them would be renal function. And I would only say that if the renal function is deteriorating, it is more prudent to use the immediate release glycoside rather than the sustained release glycoside, so that the action is finite and does not last too long. So I would rather use immediate release glycoside in elderly patients, particularly with slightly subnormal renal function.
So if the EGFR less than 30, would we still continue 30 milligrams of glycoside?
You can use a glycoside at any EGFR.
Okay. So it is contraindicated maybe in stage.
You need to look at hypoglycemia incident.
Exactly. It's not contraindicated, but I would be careful.
Contraindicated, but you can use it with caution.
Yes.
Your take on glycoside versus glimepiride, sir? I understand from JADE study, glycoside seems to be performing better, but generally from your experience?
So as far as the glycemic efficacy is concerned, there are no differences.
Okay.
There are no head-to-head studies really speaking on glycoside versus glimepiride in terms of cardiac safety, not randomized control trials. There are observational studies where glycoside has performed slightly better in registry studies. In hypoglycemia, for sure, there is a clear head-to-head trial designated to look at this particular thing, and clearly it scores there. Otherwise, if in younger patients where you're only looking at glycemic control, I don't know if there is a true difference that has not been studied, but clearly we have evidence. So first we used to say that there is no evidence on sulfonylureas. Now we do have evidence from Carolina for the glimepiride. We have evidence on glycoside safe 3 through the advanced studies. So both of them are safe, I would say. But the hypoglycemic part clearly matters. And as I showed you from the JADE observation, more number of people seem to have got to A1C of 7 and below, and they required less number of drugs, which seemed to suggest in an observational study that it is probably more efficacious. But I would caution not to, jump to such conclusions from observational, non-interventional, non-randomized studies. But this is just an observation.
Okay, thank you, sir. And one last question. What is the future of sulfonylurea that you think in this clinical work?
It's very bright. I don't think sulfonylureas are going anywhere at all.
Definitely.
Considering the pathogenic mechanisms of diabetes, there are so many mechanisms. How can you take away a drug which actually stimulates insulin release? So I don't think it's going anywhere. New drugs may be added. The hierarchy of using drugs may change a little bit based on the complication list. But clearly at some point of time, you will need to push the pancreas into a little bit of action. And sulfonylureas are not going anywhere at all. I'm sure they're not.
And the efficacy to reduce the blood sugar with the help of sulfonylureas, I think no other drug can match it. The only concern is the point of worsening of pancreatic function or exhaustion of pancreas, durability, and another important thing is the side effect. So the newer molecules will come with better safety profiles, and so sulfonylurea will always stay in the market in the treatment for type 2 diabetes, no doubt about it. The only concerns is you have to use it cautiously and looking at the safety issues.
Thanks again. Now that Dr. Sanjay Parada has joined, I would like you to introduce him quickly, sir. Thank you. Can you put the CV slide again?
Okay. Let us welcome Dr. Sanjay Parada. He's a well-known endocrinologist with more than 160 publications to him. He's a president-elect of Endocrine Society of India. He's the member of various academic bodies like API, ESI, RSSDI, ISBMR, Indian Menopausal Society, and Indian Thyroid Society. He is the secretary of Indian Society of Bone and Mineral Research. He is the founder secretary of Punjab and Chandigarh chapter of RSSDI. So, Dr. Parada, over to you for your talk.
Thank you, sir, for your kind introduction. At the outset, I would like to thank my friend Dr. Unnikrishnan and Dr. Savita for this opportunity to talk on an important topic, that is vitamin D and update. So let me share my screen. So my slides are visible. I am audible?
Yes, sir.
Okay. So thank you. So what I am going to do is that because the title of the talk is vitamin D deficiency and a 2022 update. So I am going to discuss mainly publications, those who are basically published in last 1 year. And we know that lot of publication in vitamin D is related to the COVID-19 only. So I'm going to discuss few articles related to COVID-19, vitamin D deficiency, something on diabetes, fracture, as well as the malignancy, because vitamin D is implicated everything under the sun. So it is difficult to cover the vitamin D update in just 15 or 20 minutes, but all I am trying to do is covering these following topics. So vitamin D deficiency or the
Sorry to interrupt, Dr. Sanjay. Can you be a little louder or take your mic a little closer? Thank you.
Hello. So the definition of vitamin D deficiency is defined by two bodies. One is the Institute of Medicine definition and another is Endocrine Society definition. And there is little bit difference between these two societies. Definition one is by IOM. They says that deficiency vitamin D level is less than 12 nanogram per ml. Insufficiency is 12 to 20 nanogram per ml, and while sufficiency is 20 to 30 nanogram per ml, and toxicity they consider more than 50. I think it may not be that appropriate because nowadays in COVID time, 50 nanogram per ml is very common one. And on the contrary, the Endocrine Society definition is deficiency considered less than 20. So it's overlapping with the insufficiency by the IOM definition. And insufficiency is 20 to 30 and sufficiency more than 30, while the toxicity they say is more than 150 nanogram per ml. I'm sure audience know this conversion factor, but just to recapitulate that there is a conversion factor of 2.5. So meaning by that 1 nanogram per ml is equal to 2.5 nanomole per liter. So that is important because various publications and various journals use the different units, and that is sometimes can cause confusion. Those are not dealing day and day with vitamin D levels. So this is a conversion factor. So now coming to the first deficiency of vitamin deficiency in Europe. So they say that is a kind of pandemic, and when they define the vitamin D deficiency on various levels, like they say percentage of serum vitamin D less than 30 nanomole per liter versus less than 50 nanomole per liter. So when they are talking less than 30 nanomole per liter, in various studies, the yearly vitamin D deficiency is varying from 12.5 to somewhere 22.1%. And again, there is a variation in the winter as well as in the summer. So in winter, obviously, it is more expected deficiency because of sunlight is less. And if sunlight is there, even this body is covered with the clothes because of the winter. So the vitamin D deficiency is more common in the winter season as compared to the summer season. And when this vitamin D deficiency cutoff is used differently, obviously less than 50 nanomole per liter, then this obviously deficiency in winter as well as summer is more as compared to when it was considered less than 30 nanomole per liter. So yearly deficiency, if we take mean, so approximately in the European countries, 50% of the population is having the vitamin D deficiency. Now coming to the what is the status of vitamin D deficiency in Asian adults. So it is a systematic review and meta-analysis. And in pooled data from these 5 countries, Southeast Asian countries, Pakistan, Bangladesh, India, Nepal, and Sri Lanka. So you can see the pooled data says that approximately 68% of the population is having vitamin D deficiency, while among these 5 countries, the least vitamin D deficiency is 48%, and the maximum in Pakistan is 73%. So meaning by that in Southeast Asia, the vitamin deficiency is more prevalent as compared to the European countries. So we did one study that is with the name of the CUBE study or Chandigarh Urban Bone Epidemiological Study, and what we found is that vitamin D deficiency in 65% of the individuals from the Chandigarh people, and we know that Chandigarh is one of the state where the highest per capita income is there, and milk and milk product consumption is very high in the Punjab and Chandigarh area, and still the vitamin D deficiency is very common. So there is no doubt that vitamin D deficiency is still very common in our country. In spite of that, lot of vitamin D prescriptions are there. And then we looked at is this vitamin D deficiency having any effect on this osteoporosis and diabetes. So we screened the around 250 adults with type 2 diabetes, duration more than 5 years, that creatinine was normal. And what we found is type 2 diabetes patients with vitamin D deficiency 33% and insufficiency was 24%. So meaning by that, again, in the individuals with type 2 diabetes, the deficiency or insufficiency is contributing approximately around 55%. So again, that is proving that vitamin D deficiency is common. Then we did another interesting study in the hip fracture patients. We measured the vitamin D deficiency and we found there's high prevalence of vitamin D deficiencies there. And the significant number of population is having osteomalacia also. Though that we have to take this information to pinch of salt, that is very high prevalence of osteomalacia. Probably we need a better technique to look for this osteomalacia, and there is a negative correlation between vitamin D deficiency and the osteomalacia as expected. And on histopathology, we found that serum vitamin D level is directly correlating with the histopathology. Say if his vitamin D deficiency is very severe, then this abnormality, histopathology abnormality related to osteomalacia is severe, and that you can say from 0 to 20 nanogram per ml, that was moderate to severe abnormality was there, while in case of 40 to 60 nanogram per ml, that was a very few patients are having the histopathological abnormality that is suggestive of the osteomalacia. So now coming to the COVID-19 and the vitamin D, because when I was looking at the literature, a number of studies are published on vitamin D deficiency in COVID-19 time. And we also concluded some studies. And so the prevalence of vitamin D deficiency in the COVID-19 era. So let's see what is the situation. So a few questions are there that the vitamin D deficiency or insufficiency has been implicated in COVID-19 infection, or it is associated with COVID-19 disease severity, or it is having an effect on the COVID-19 outcome. So these are the three important questions with relation to vitamin D and COVID. So here in this particular slide, what I am trying to show is that the global distribution of vitamin D deficiency. So you can see the vitamin D deficiency is very common in the USSR, also Russia, as well as India, and then China. And on the contrary, this part of world is having less vitamin D deficiency. And when we look at the global distribution of COVID-19, so it is almost mimicking the COVID-19 and the vitamin D deficiency. You can see it is kind of overlapping. And the vitamin D deficiency is less common in these African countries relatively. And similarly, the COVID-19 infection is also less, but it is not going hand in hand in the USA. That maybe behavior of the people might be responsible for the, in spite of good vitamin D level, but high chances of having COVID-19 diseases. So from our data that we compared the COVID-19 patients and the previous cohort to look for the vitamin D deficiency. So we divided these patients on the basis of the vitamin D level. One is severe vitamin D deficiency, and other is less severe vitamin D deficiency. And when we looked at their vitamin D levels, so what we found is that in a group of vitamin D deficiency as well as severe vitamin D deficiency, the prevalence of COVID-19 infection is in patients of the non-severe COVID-19 patients, and both the group vitamin D deficiency as well as severe vitamin D deficiency was high as compared to the control. So meaning by that, there is some association between the COVID-19 patients and the vitamin D deficiency. So here is an interesting systematic review and the meta-analysis. And in this particular meta-analysis, the author tried to look into the mortality in COVID-19 with relation to the vitamin D levels. And what they have shown is that in this meta-analysis that there is 2.47 times, or the 2.47 odds ratio is there for the mortality and vitamin D deficiency, meaning by that vitamin D is associated with increased mortality of approximately 2.47 times. And again, in this meta-analysis, looked at these four important parameters. One is the mortality, another is hospital admission, as well as the ICU admission. So you can see the mortality was high, as I shown in the previous slide, and the hospital admission was also high with the vitamin D deficiency, around almost twice, and the ICU admission was also more frequent in people of the vitamin D deficiency. So meaning by that, vitamin D deficiency is associated with increased mortality and hospital admission, ICU admission in patients of the COVID-19. So here is very interesting study that is linked to the vitamin D binding protein, free vitamin D and COVID-19 mortality in hospitalized patients. So this particular study, what it is showing is that a U-shaped curve is there. So on the x-axis, there is vitamin D level in the nanomole per liter. On y-axis, there is 28 days mortality in COVID-19 patients. And what it is showing is that if the vitamin D level is less than 25 nanomole per liter, the mortality is approximately 50, maybe 40%. And when vitamin D level was between the 15 to 74 nanomole per liter, the mortality was this. But when the vitamin D level started rising, again there is increase in the mortality in the mortality with the COVID-19 with the high vitamin D level. So you can see that is obviously U-shaped curve is there with the vitamin D and the COVID-19 mortality. So it is less than very low vitamin D, the mortality is high, or very high vitamin D levels, the mortality is again high. So this is that. So maybe they can, from this particular study, you can say this optimal level of vitamin D may be 50 to 74 nanomole per liter. If you want to convert into nanogram, then you have to divide by the 2.5. So now coming to that, does vitamin D supplementation reduce the risk of COVID-19 or improve clinical outcome? So very interesting study published from our institute, PGI Chandigarh, and in which what we did is that we have given the high dose vitamin D supplementation in COVID-19 hospitalized patient and compared with the placebo patients, with the placebo control. So these patients are actually non-severe COVID-19 patients, and those having the entering into the study, there is having hypovitaminosis, and they are given the vitamin D in a dose of 60,000 international units of polycalciferol for 7 days, and with the therapeutic target of increase to more than 50 nanogram per ml. So in 14 individuals randomized to intervention, 16 in the drug arm and 24 in the control arm. And what we found is that in this particular study, the greater proportion of individuals turned SARS-CoV-2 RNA negative with a significant decrease in the fibrinogen on high dose polycalciferol supplementation. So though these numbers are very less, or you can say this limited number, but this giving some information that COVID-19 patients, if you get the vitamin D, that may be useful. Then we did another meta-analysis, that is vitamin D supplementation clinical outcome in COVID-19 patients. So in this analysis, meta-analysis, what we found is that if we supplement with the vitamin D in COVID-19 patient, the mortality is less, and it will be what you call odds ratio is 0.41. So this vitamin D supplementation is reduces the mortality. On further analyzing this study or this meta-analysis, so what we found is that vitamin D supplementation pre-COVID-19 diagnosis. So the vitamin D is supplemented before COVID-19 diagnosis, there may not be a significant benefit. The odds ratio is just 0.71. But after developing the COVID-19, if vitamin D is supplemented, then it is useful, and this odds ratio is just 0.35. So meaning by that, COVID-19 patients, if given the vitamin D, outcome will be better. And just a slide on the pathophysiology, how vitamin D is useful or reduces the mortality in COVID-19 patients, is that we know the SARS-CoV-2 or COVID-19 patient is associated with cytokine storm. So vitamin D actually reduces the cytokines and reduces the non-inflammatory mediators. Then vitamin D, so COVID-19, we know that is associated with increased renin level and reduced ACE2 level, while the vitamin D is known to increase ACE2 level as well as reduces the renin. And similarly, there is some another defense mechanism which is actually used in the SARS-CoV-2 and which is taken care by the vitamin D. So these are the proposed mechanism that how vitamin D is helping to reduce the mortality or the giving the benefit. Now, recent studies on vitamin D supplementation disease outcome other than COVID-19. So that is another interesting study, that is V2B study published in NEJM, vitamin D supplementation prevention of type 2 diabetes. So in this, adult patients were enrolled, and the enrolling criteria was that at least 2 of 3 glycemic criteria for pre-diabetes were there. And these patients were randomized to receive either vitamin D3 or polycalciferol or placebo. And the vitamin D3 given was at a rate of 4,000 units per day. So that is almost a maximum dose. And the baseline vitamin D in this group of patients was 28 nanogram per ml. And this was a good follow-up, approximately 2.5 years of median follow-up. And what this study shows is that as compared to the placebo, patient with vitamin D supplemented group has a probability of diabetes-free survival is more as compared to the placebo. And the hazard ratio is 0.88. So there is some indication that if you supplement with the vitamin D, that can prevent to develop to the diabetes-free survival as compared to the placebo group. So another study that is called the D-Health trial study, a randomized control trial of the effect of vitamin D on mortality. So the study was conducted in Australia. Indians more than 60 years were randomized to 1:1 ratio, and they were given 60,000 units of or the placebo on the monthly basis. And the duration of intervention for 5 years. And at baseline, less than 50 nanomole per liter vitamin D was observed in 24%, and more than 50 nanomole per liter in approximately 76% of the patients, meaning by that significant number of patients are vitamin D sufficient at baseline itself. And mean 25 hydroxy concentration during follow-up with the vitamin D supplementation once in a month of 60,000 international units. So placebo group, the vitamin D level 77 nanomole per liter, and the vitamin D supplemented group, it was 150 nanomole, 50 nanomole per liter. So what this study showed is that the mortality was, you can say this is almost comparable. Hazard ratio is 1.04 as compared to this is almost comparable. No significant effect of vitamin D supplementation on the mortality. So the reason may be that because the significant number of patients are already vitamin D sufficient at the time of entry into the study. So, and in same study that will be another exploratory analysis, and of course they expect first 2 years of follow-up, and then they look for the cancer mortality, and what they found is that patient those who received the vitamin D had a numerically higher hazard for the cancer mortality than those with the placebo. So earlier studies were there, the literature says that vitamin D prevent from certain malignancy or the reducing the risk of malignancy. But this particular study, which is recently published, that shows that though there is not statistical significant difference in there, but at least numerically there is higher cancer mortality there. So we need to explore that why, how it is happening that. And then the effect of vitamin D supplementation on the respiratory tract infection, and all the was from the same study. And the what they found from this conclusion from this study is that it did not reduce the overall risk of acute respiratory tract infection. So, so there's earlier studies were there that vitamin D deficiency is associated with the reduced respiratory infection, but this study says it is not actually true. And then another study that effect of long-term vitamin D supplementation versus placebo on the risk of depression or clinically relevant depression symptoms and change in the mood score. So is a study included 18,000 patients aged more than 50 years and the without depression or clinically relevant depressive symptoms at the baseline. The vitamin D supplementation given was the 2,000 internationals per day. So that is approximately 60,000 per month versus placebo. And there's no difference in incidence and recurrence of depression or clinically relevant depressive symptoms or change in mood score over a 5-year treatment period with or without vitamin D supplementation. So again, we're showing the same thing what I said in the previous slide, that total depression, incident depression, as well as recurrent depression, there is no difference between the vitamin D supplementation group and non-supplementation group. So what I would like to say is that vitamin D is clearly not a panacea and is most likely efficient only in those who are deficient, but those are sufficient. There is no need to say do lot of vitamin D. And I remember there is few things I heard or I make that is vitamin D is indeed honestly effective in patients of the problem with the metabolic bone disease, but it is kind of hope with the some of the metabolic issues like pre-diabetes, diabetes, and remaining thing it is high for hypocrisy in the remaining disorders that vitamin D plays any role. So I end my presentation by saying, concluding here that even today the vitamin D deficiency is still rampant, and we have seen that in India or in Southeast Asia, approximately two-thirds of population is having vitamin D deficiency in spite of the plenty of sunlight. Hypertension more prevalent in South Asian countries compared to European because we don't have a clear-cut food fortification program. And ISBMR is coming with the idea, and I think it is almost about to implement that vitamin D should be given in form of what is like iodine in the salt. So similarly, vitamin D in the milk or in the oil or in the wheat flour. So that is a program ongoing. Vitamin D levels inversely associated with COVID-19 severity, and vitamin D supplementation improve the COVID-19 outcome, although data are inconsistent and the most of the meta-analyses are not are actually contradicting their results, that benefit versus no benefit. And at least I would like to say that we should not do indiscriminate vitamin D supplementation because it may not be useful, and especially is not useful in the vitamin D deplete population. And we have seen that the U-shaped curve in a certain condition, and it is not uncommon in our clinical practice to develop the vitamin D toxicity because everybody is prescribing vitamin D starting from endocrinologist to gastroenterologist to urologist to orthopedic surgeon to gynecologist. Everybody is prescribing vitamin D, and unfortunately vitamin D is available in various formulations in form of syrup, in form of tablets, in form of sachet, in form of injection. So patient is also not clear that what he is taking, and he is keep taking this vitamin D from different stresses from different department, and that actually causing the vitamin D toxicity. But fortunately, oral vitamin D supplementation is not significantly associated with the vitamin D toxicity, but injections are having the definite problem. So we should discourage using injection, or if we are prescribing injection, we should tell the patient very clearly that this injection is once in 3 months or once in 6 months. So thank you very much for this opportunity to talk on the vitamin D deficiency and update on 2022. If there is any question, comment, I'll be more than happy to take up this question.
I have good evening. I have one question, sir. This vitamin D deficiency has been correlated with its in most of the diseases, starting from the prevalence of diabetes to the malignancy, depression, CKD, in India, tuberculosis and vitamin D, from there to COVID-19. So should we test the vitamin D level from each and every patient who is coming to hospital and supplement to vitamin D to this patient?
So I think it's a very, very valid point, sir, and a very clinically relevant question. So in our clinical practice, we do not ask for a vitamin D level estimation because the problems are multifold. First and most important thing is vitamin D estimation is not that easy. The many laboratories does not have good facility to estimate the vitamin D. That is one. And second thing is that if you look at the literature, approximately 75% population is having vitamin D deficiency.
Yes.
So what I do in my clinical practice is I prescribe vitamin D, but that is not very high doses. That is once per week for 8 weeks and once a month, not more than that. But many times people prescribe high doses every day for 10 days, then once weekly, and then injection very frequently. So if we are not following that kind of aggressive nature, then oral vitamin D is okay, and there is no need for the missing the vitamin D in each and every patient. Of course, a patient who is having problem related to the metabolic bone disease, I suggest there should be vitamin D estimation is required, and so that you can supplement accordingly, or you can reach the clear diagnosis. Say like this rickets or osteomalacia is because of vitamin D deficiency or because of some subsequent metabolite deficiency like 1-alpha hydroxylase deficiency or vitamin D receptor problem. So in that case, we definitely require the vitamin D level, but otherwise in each and every patient coming to hospital does not require vitamin D estimation.
Another doubt, sir, another question is that many times we do the initial vitamin D level, and depending upon the deficiency, we start the vitamin D supplementation. But many times we don't follow the patient regarding their vitamin D level, and we just continue for a few days, maybe like initially weekly for a month or so, and then monthly. So for how long we should continue this supplementation, a really deficient patient? How should we frequently monitor that?
Simple to answer your question is that once per week for 8 weeks and once a month. So if they are following this schedule, then there is no need for the measuring the vitamin D levels, and they can continue maybe lifelong. There is no problem. But we know that even if you ask me, somebody asked me to take this vitamin D in this way, I am not going to take vitamin D every monthly. I will forget in between. So I think that will also help us to maintain their vitamin D levels that they're taking once a month or once in 6 weeks. Also, it will be okay only.
Thank you.
What you said, sir, is absolutely
Can
true.
I have a question?
What you said, sir, is absolutely true that everybody should take vitamin D. That way, our exposure to sun is hardly anything. So what you said is absolutely true. All diabetic patients should receive vitamin D initially in the therapeutic dose, and then maybe once a month for lifelong. So that will definitely help the vitamin D levels. And I think once somebody is deficient, I think he needs to take it maybe lifelong.
Can I have a question to Dr. Birtade?
There are a lot of questions in the chat box. Dr. Amit, would you like to ask them?
Yeah.
Can I ask a question to Dr. Birtade?
Yes, sir. Yes, sir.
Can you hear me?
Yes, sir. I can hear you.
When you are giving vitamin D, you supplement calcium along with that? Supplemental calcium, therapeutic calcium? How safe is this therapeutic calcium?
So I think it's another very important clinical question. So the recommended calcium intake per day is 1000 milligram per day. So often I ask patients that how much milk they are taking. If their milk and milk product is around 500 to 700 ml per day, that group of patient does not require any vitamin D, any calcium supplementation, because our requirement is fulfilled with the diet requirement itself. But elderly patients, maybe about 60 or 65 years, having osteoporosis, and they are receiving the treatment for osteoporosis, definitely they will require the calcium supplementation, because with age the calcium absorption is actually reduced. So in that group of patients, they require the calcium supplementation. But anyhow, the dose, the recommended daily allowance of calcium is 1000 to 1500 milligram per day, not more than that. So it will depend how much it is you are taking by the diet, and how much, if it is a gross deficiency, in that case you can supplement with the oral also. But the best policy is that 1 tablet of calcium around 500 milligram elemental calcium is okay. Remaining often it is taken by the oral diet.
There is some increased incidence of CAD by 24% or so.
Okay,
there are
so
some
I think
reports.
that, right, you are talking about a paper that is published in the BMJ, and that shows that calcium intake can cause the coronary calcification. So actually that paper says that there is some caveat in that paper. That paper says that if you are taking calcium alone, actually that is causing a problem. If you are taking calcium with vitamin D, then it is not causing the problem. So I think that is only one study that says that calcium intake is causing a problem. There is not much literature. So I think what I feel is that we can take calcium definitely with vitamin D. There is no harm in that.
The question from a chat box. What is the logic behind the U-shaped curve of vitamin D in COVID mortality?
I think it's a very, very interesting question, and the cause may not be yet clear. Why it is in the low doses, it is clear that with the low dose it is causing the problem, because there is cytokine storm and all these things there. But how at high doses it is causing a problem, so I am also not sure about that discussion, why how high doses is causing a problem. Maybe the mechanism which is at optimum level, but the U-shaped curve is true for many conditions, like what it is true for HbA1c, It is true for the blood pressure, everything U-shaped for the U-shaped curve. U-shaped curve is, you can say, the nature. So we are going against the nature, it will be harmful. Either it is a very low, it is a very high.
Question from the chat box by Dr. Sanjay Mangrulkar. How were the normal levels of vitamin D calculated? How can it be that 50% of the population is vitamin D deficient if the normalcy is calculated by the population studies and plotting normal curves? It is said that vitamin D deficiency was computed by giving vitamin D in such doses that the parathormone levels would be zero. If that be so, does this not amount to supranormal dose delivery to people? And would it not hence lead to abnormally high false incidence of vitamin D deficiency? That's a question by Dr. Sanjay Mangrulkar, sir. Could you please address that?
I think he by mistake, I think. He just left just now.
Oh.
Probably by mistake, I think he must have left.
I think it's a connection issue more than anything else, I suspect.
Is it possible for the team to help him rejoin? Let's just give a couple of minutes for him to rejoin, if possible. Looks like we are having trouble having him reconnect. Let me go ahead and thank both the chairpersons and all the speakers who had given your time and helped this successful session. Thanks again, Dr. Sudham Ketkar, Dr. Amit Malimbe. Oh, I guess we were able to get him rejoined. Thank you, sir. One last question. Let me go ahead and ask it again. This is by the by Dr. Sanjay Mangrulkar, sir. It's a long question. Are you there, sir? Can I go ahead and ask the question? You have to unmute yourself, sir.
Yeah, I did.
Yes, sir.
I did.
Let me go ahead. As I said, it's a long question by Dr. Sanjay Mangrulkar. How were the normal levels of vitamin D calculated? How can it be that 50% of the population is vitamin D deficient if the normalcy is calculated by the population studies and plotting normal curves? It is said that vitamin D sufficiency was computed by giving vitamin D in such doses that the parathormone levels would be zero. If that be so, does this not amount to supranormal dose delivery to people? And would it not hence lead to abnormally high false incidence of vitamin D deficiency?
So thank you, Dr. Mangrulkar. I think this is one of the best questions I have so far heard. And I know it's difficult to answer this question, but I'll try myself to explain it. So first and most important thing is that you said that PTH is zero. No, I think this is not the correct concept. PTH is not zero, but PTH in the normal reference range. Or you can say mid-normal reference range. So not zero, that is not a correct idea. So this says that obviously the normal vitamin D level is calculated on the basis of the vitamin D PTH equation. The vitamin D level, which suppress the PTH to around 40 picogram per ml, that is considered an ideal vitamin D level. Now here there is a one catch that the PTH vitamin D relationship is not a linear relationship. In many patients in the last database, we found, and in our clinical practice also, we see many patients are having vitamin D just 10 nanogram per ml, but their PTH just 40 nanogram, 40 picogram per ml. So it is not true actually. And if somebody give me some money funding, then I can answer this question better way. And that is that ideally we should do the bone histomorphometry in the patients of various, say, vitamin D level and their bone health, and the vitamin D level is maintained for a period of 6 months in the same level. And if we do the bone histomorphometry and we can calculate there are the various bone indices actually. And as I mentioned in my talk that vitamin D is actually useful for the bone and mineral metabolism. Elsewhere, it is just an idea that because everybody is doing research on vitamin D, that's fine. But it's useful in vitamin D. So the best would be do the bone turnover markers, do the bone histomorphometry, and relate with this vitamin D level. And other thing is that unfortunately or fortunately, we are following all Western data that what is the vitamin D level. In Indian studies, no such histopathological studies available. So you are true, you are correct, Mangalurkar sir, that this answer is not there yet, but yes, definitely it can be answered. Dr. Shah is giving a smile. Dr. Pankaj, you want to say something on this aspect?
No, I agree.
Yeah. So, yes.
Again, sir, for a wonderful lecture. I would like to thank all the speakers, Dr. Juliana Chan, Dr. Uday Fatke, and Dr. Sanjay Badada for patiently explaining the session. Thank you so much. And
Thank you, everyone. Thank you very much.
Thank you, Dr. Sanjay. Thank you for sparing your valuable time. I know you were very busy today.
Yeah, I was.
Yeah. And Dr. Juliana Chan, our good wishes to you for everything. I know, given the pandemic situation, good wishes to you and all the people there, and good wishes for health, wellness, and see you soon in the next academic session.
Thank you.
Thank you.
Thank you. And now we will be moving on to the next session on hypoglycemia. We are really grateful to all the chairpersons and speaker who has been with us very patiently throughout. Let me have the pleasure of introducing and inviting our first chairman to the session. The session is on hypoglycemia, and our chairpersons are Dr. Sonali Bhujne and Dr. Shashi Kumar Nair. So, Dr. Sonali Bhujne has done her MBBS from MIMER Medical College, Pune in 2003. She has done a PG Diploma in Diabetology from MB Institute of Diabetes and Research Center, Chennai in 2012, and Stonebridge University, England in 2009. She is a director of Nectar Diabetes Care and Weight Loss Center at Satara Road, Pune. She is also a visiting consultant to multiple hospitals across Pune. And her primary areas of interest is prevention of diabetes and its complication, especially food subset. Welcome, ma'am. And our next chairperson is Dr. Shashi Kumar Nair. He has done his DM endocrinology from our Institute of Medical Sciences, BHU Varanasi. He's a consultant endocrinologist at Department of Health, Dubai, and is currently at consultant endocrinology, NIMS, Medicity, and Indian Institute of Diabetes, Toronto. A warm welcome to both of you, and over to you to carry on this session on hypoglycemia with Dr. Pankaj Shah. A warm welcome to Dr. Pankaj Shah as well. And thank you so much for waiting on us to start your session.
Persons like to introduce Dr. Pankaj Shah.
Yes, CV is already there. I think he doesn't require any introduction at all. Probably I met him in 90s at All-India Institute of Medical Sciences when I was a second year DM student at Institute of Benares, Institute of Medical Sciences Benares. When I came there to All-India Institute, you were on the top of the world, having done your DM. I think it was in 91 or so. Young, flashy, awesome looking gentleman. We were surprised at the great knowledge he had even at that time. We were very surprised. You may not remember Dr. Shah. Let's go to the topic. Today we have a very important topic, hypoglycemia in non-diabetic person. Over to Dr. Shah.
If we're concerned about hypoglycemia, the first question to ask is whether the patient has diabetes or does not have diabetes. If there is diabetes, the path is straightforward. We treat and then of course take measures to prevent it from happening again. But if there is no diabetes, as far as possible, we should not treat but draw blood for venous plasma glucose. By drawing blood, we can diagnose hypoglycemia, which, based on Whipple's triad, requires number 1, symptoms of hypoglycemia, especially neurological symptoms. Number 2, low plasma glucose at the time of symptoms, not at any other time, and not capillary glucose and not sensor glucose. And number 3, relief of symptoms when plasma glucose is raised to normal. We measure glucose to document Whipple's triad, and we measure beta hydroxybutyrate, the ketones, and glucose response to injection of glucagon, and by this we get insulin action. Let me explain to you. Insulin, by its action on muscle, liver and fat, causes low glucose. But insulin, because of its action on liver and fat, suppresses ketone production. In addition, insulin by its action on liver causes storage of glucose as glycogen. And we inject glucagon, this stored glucose is released. Therefore, a release of glucose after injection of glucagon and suppression of ketones as measured by beta hydroxybutyrate are very good markers of insulin action. Therefore, if beta hydroxybutyrate is suppressed and glucose response to injection of glucagon is robust, we believe insulin action is causing hypoglycemia as documented by Whipple's triad. If that is present, we want to know if there is insulin present that is causing insulin action by measuring insulin. And if insulin is present, we want to know if insulin secretion is causing insulin action. And how do we do that? By measuring C-peptide and proinsulin. Let me explain again. For each molecule of insulin generated, a molecule of C-peptide is generated in the secretory granule of the beta cells. Therefore, for each molecule of insulin released in circulation, C-peptide is also released in circulation. In addition, proinsulin is also released into circulation directly. Therefore, proinsulin and C-peptide are good markers of insulin secretion. Therefore, if C-peptide and proinsulin are not suppressed, that means insulin is being secreted, which is causing insulin action and hypoglycemia. If there is insulin being secreted, we want to know if there are agents in blood like sulfonylureas or meglitinides that are causing insulin secretion. Let's start with the case. Patient with spells suspected to be from hypoglycemia. She had home meter glucose numbers that were less than 40 and underwent a so-called 72-hour fast, in which about 48 hours into the fast, she had typical symptoms of sweating, palpitations, tremors and anxiety. And at that time, the capillary glucose concentration went down into 40s. What should we do? Should we draw plasma glucose? Should we draw plasma glucose and hormones and agents, sulfonylurea, etc.? Should we do all that and feed patient or inject glucagon and see the response of glucose? Or do whatever blood tests and proceed with 4D CT of the pancreas? Just think about it. Well, as you think about it, let me tell you what happened. The spontaneous resolution of symptoms occurred within a few minutes or so, and with that the capillary glucose concentration went up on its own. We don't measure capillary glucose concentration only, we also measure periodic venous plasma glucose. And as you can see, plasma glucose concentration was well within the normal range when capillary glucose concentration was low. And therefore the right answer here is measuring plasma glucose. Patient did not even have Whipple's triad. Therefore, there was no hypoglycemia, and if there is no hypoglycemia, there is no purpose of measuring other things. Next is the case of a 21-year-old man with acute leukemia and a plasma glucose of 21 mg per deciliter on routine morning blood test. Patient was not symptomatic. Actually, the previous day's glucose was also 23 and patient was not symptomatic at that time. What could this be? Insulinoma, Addison disease, hypopituitarism, or drug-induced hypoglycemia, or any or none of the above? Actually, the right answer is none of the above. Patient did not have symptoms of hypoglycemia and therefore patient did not have hypoglycemia. Actually, patient had leukemoid reaction with very high white cell count and the glucose was being consumed in the tube. Point of care capillary glucose was actually 85 mg per deciliter. So we collect blood, sort out whether this is hypoglycemia or not before moving further. Next is a 23-year-old woman with acute pancreatitis, hospitalized receiving intravenous antibiotics. This is her lab glucose, and we were called in when the glucose was 41 milligram per deciliter and she had some symptoms. These are insulin levels, C-peptide not suppressed, and beta-hydroxybutyrate and cortisol, liver kidney function was normal. What could this be? Could this be insulinoma, non-insulinoma pancreatogenous hypoglycemia, sulfonylurea, any or none of the above? Actually, the right answer is none of the above. Why? Because patient was actually receiving moxifloxacin and blood should not have been drawn for hormones and other things. She was sick. So if there is hypoglycemia, the next question is whether the patient is sick or not. And if the patient is sick, you will get more information from medication history and history than from any of the tests. Next is a 24-year-old woman whose sister has type 1 diabetes and had documented plasma glucose low when she came to us. She had a supervised fast. 36 hours into the fast, she had typical spell. Low plasma glucose, documented. Beta-hydroxybutyrate was suppressed, and there was a good more than 25 milligram per deciliter response to injection of glucagon. That means good insulin action. There was good insulin action causing hypoglycemia, but there was no insulin, and there was no insulin secretion. So what was this? This was an insulin action causing hypoglycemia, but not by insulin. So what was that? What should we do? Should we look for malignancy, look for IGF-2, screen for hypoglycemia agents, or talk to Dr. Ravinder Singh of our lab medicine at Mayo Clinic? And right answer, of course, is talk with Dr. Ravinder Singh. Let me show you the data. This is point of care capillary glucose and this is plasma glucose, and both of these were low when patient had the typical spell. At the time when she had hypoglycemia, beta-hydroxybutyrate declined to undetectable. Insulin and C-peptide also became undetectable and proinsulin went down. Dr. Singh's lab went ahead and measured aspart, detamere, glargine and list proinsulin as well as bovine regular insulin, and none of these were present in circulation. However, glulicin concentration dramatically increased at the time of spell. This was insulin analog induced hypoglycemia. So the patient is not sick. We want to know if there is insulin action. And if there is insulin action, we want to know, well, if it's not insulin action, something else is causing low glucose. Even starvation can cause low glucose. If there is insulin action, we want to know if insulin is inappropriate. If insulin is present despite hypoglycemia, well, insulin is causing insulin action. If it is not, insulin is not around, insulin is suppressed, well, it's not insulin that is causing insulin action, but it's like insulin-like substrate that is causing it. For example, insulin analogs. Next is a 27-year-old nurse with spells of low glucose, classical symptoms, blood drawn, hypoglycemia, check, insulin action, check, insulin, check, but there is no insulin secretion. Well, then this is insulin-induced hypoglycemia caused by insulin, but it is not being secreted. So it is injected insulin. So when insulin is inappropriate, we want to see if C-peptide and proinsulin are suppressed. If they are suppressed, insulin has been injected and that is what is causing hypoglycemia. Next is a 57-year-old woman with spells of low blood sugars that have been documented. Low glucose, check. Insulin action, check. Insulin is present and insulin is being secreted. So now this is endogenous insulin-induced hypoglycemia. What could this be? Sulfonylurea, insulinoma, non-insulinoma pancreatogenous hypoglycemia, or any of the above. And the right answer is any of the above. All of these will cause release of insulin that will cause hypoglycemia. And this patient actually had glimepiride in her blood, and that was what was causing hypoglycemia. So if C-peptide and proinsulin are present, we want to measure sulfonylureas and meglitinides, and if they are present, it is drug-induced hypoglycemia. This is a 71-year-old man, hypoglycemia, documented, insulin action by suppressed beta hydroxybutyrate and robust response of glucose to injection of glucagon, documented, and insulin is being secreted. By the way, insulin levels are not very high, and we can discuss this later on. Hypoglycemic agent screen was negative. Therefore, now what we have is spontaneous, endogenous, insulin-induced hypoglycemia. So now, if sulfonylurea and meglitinides are absent, we know that we need to go for surgery, and surgeons of course want to know what part of pancreas they should work on. So we proceed with 4D CT of the pancreas, endoscopic ultrasound, selective pancreatic arterial calcium stimulation test, or dotatate PET scan as required. Next and the last case is a 43-year-old woman who underwent gastric bypass and has postprandial symptoms that are compatible with low glucose and low capillary meter glucose. Actually, outside material that patient brought along with us showed that she had undergone a glucose tolerance test and had low glucose at 32 mg per deciliter with high insulin concentration. She underwent a 72-hour fast and it was essentially normal. Glucose hovered around 60 mg per deciliter after about 48 hours or so. Beta hydroxybutyrate kept increasing, implying no insulin action, and there was no robust response of glucose after injection of glucagon. This is essentially normal fast. So this is asymptomatic low plasma glucose with no insulin action at that time, which essentially is normal 72-hour fast. So what did we do? We asked the patient to get a blood drawn when she has classical symptoms. She couldn't. And the day before she was leaving the town, she decided she has to do it. So she consumed donuts and an alcoholic drink. This drink has sugar and alcohol in it. And there we documented low plasma glucose, insulin action, insulin and insulin secretion. So now what do we have? We have hypoglycemia caused by insulin secreted after consumption of fast-acting carbohydrates and alcohol after having had a gastric bypass surgery done. This is some data from Austria on glucose tolerance test in women undergoing gestational diabetes screening. Glucose concentration in normal healthy women can go below 60 mg per deciliter at baseline or 2 hours after glucose tolerance test. But similar data in women who had undergone gastric bypass shows that glucose concentration peaks rather high after consuming glucose and goes low, such that about half of the women have glucose concentration going below 60 mg per deciliter. A few of them have glucose concentration below 30 mg per deciliter, and these are not being screened for hypoglycemia. They are just routine tests for screening for gestational diabetes. Therefore, glucose tolerance test has no role in diagnosis and differential diagnosis of hypoglycemia. Let me explain to you the physiology of gastric bypass. Glucose in normal stomach or food in normal stomach is held in stomach and gradually released into small intestine where it is absorbed. Upon absorption, glucose appears in systemic circulation, and in response to that, we release insulin. The sum total of that is that glucose concentration goes up and then goes down, such that sometimes it can go slightly lower than what it started from. What happens after gastric bypass? That the food goes straight into small intestine, and same thing happens after gastrectomy. With this, the absorption is rather rapid, and if there is sugar to be absorbed, all the sugar is absorbed in a smaller period of time, and there is a period of time when sugar is not being absorbed, which is the time it takes for stomach to empty if there is a valve, because here the valve has been bypassed. Because of all the glucose appearing in short period of time, we release a lot of insulin, and because of these two, there is a very high concentration of glucose after eating, followed by very low concentration because of insulin, and this is what we call dumping syndrome or endocrine dumping syndrome. So quick delivery of the food into the intestine can lead on to rapid absorption of glucose, hyperinsulinemia and hypoglycemia called late dumping syndrome. But the rapid delivery of nutrients into small intestine can also cause release of hormones from small intestines or from small intestines, and this can also cause symptoms which sometimes are very confusing and they may look like the symptoms of hypoglycemia. And these two are not separate entities. They occur in the same person and there is a big overlap between the two as well. So if there is hypoglycemia type of symptoms after GI surgery, we want to collect blood and find out if there is hypoglycemia or not by documenting Whipple's trial. If there is hypoglycemia, we want to find out if there is insulinoma or not, and if there is insulinoma, well, we proceed with surgery. If there is no hypoglycemia, we consult GI and proceed with dumping management. Or if there is no insulinoma, we proceed with dumping management, which can be common between the two for some of the things and includes dietary changes, using edible gums to slow down the intestinal transit, short-acting somatostatin to slow down intestinal transit and reduce insulin release from pancreas. And if hypoglycemia has been documented, we can slow down digestion of carbohydrate or release of insulin from beta cells using acarbose or diazoxide. And if none of that works, we may want to proceed with reversal of the gastric surgery if possible, though this is not always successful. So today we discussed about hypoglycemia. If diabetic, treat. If non-diabetic, document hypoglycemia. Find out if the person is sick or not. If sick, is it caused by insulin action? If there is insulin around, if so, insulin is being secreted. If so, if there are chemicals that is triggering release insulin. And if not, proceed with imaging before proceeding with surgery. Also, we discussed that after gastric bypass and certain other gastric surgeries, there are multifactorial symptoms in the postprandial phase from GI dumping and from endocrine dumping, which is hypoglycemia. These are precipitated by fast-acting carbohydrates, drinking fizzy drinks, drinking with water, alcohol, etc. And the solution is to avoid precipitants of these episodes. Edible gums and somatostatin can slow down gastric emptying, somatostatin can decrease insulin secretion, and acarbose can inhibit digestion of carbohydrates, though it's not well tolerated. And I also emphasize the importance of understanding that oral glucose tolerance test has no role in diagnosis, differential diagnosis, or management of any type of hypoglycemia. Thank you so very much for your patient listening.
Thank you, Dr. Shah. Now the topic is open for discussion if there are any questions. Dr. Shah, you have not mentioned about the autoimmune mediated, antibody mediated hypoglycemias.
So antibody mediated hypoglycemia is exceedingly rare. We do screen for insulin antibodies in everybody. And in situations, pardon me?
It should be part of the routine workup for hypoglycemia?
It is part of the routine workup for hypoglycemia if the patient has hypoglycemia. So if there are symptoms, I don't start with antibodies. So we have a system of an urgent blood draw in which the patient gets a card which says urgent blood draw. So they go to lab when they are having symptoms, blood is drawn. And if the blood is drawn for everything, but glucose is low, then other things are measured, which includes hormones and antibody and this and that. If the glucose is not low, there is no point measuring insulin and C-peptide and stuff like that. That is where we measure antibodies. We don't routinely measure. Now, there can be rare circumstances where there is insulin-like action, but no insulin, and that could be receptor antibody. So that's a different thing, and that is exceedingly rare. We have a handful of cases, and Dr. Basu had done some review on that and had some cases, but it's exceedingly rare, and we don't do an assay in Mayo Clinic. There are some people in Germany who do these assays, so I'll have to defer it. I haven't personally diagnosed one yet. I see hypoglycemia 3 times a week for a living.
You must be seeing a lot of cases of bariatric surgery. People say that the incidence of hypoglycemia is to the tune of 9%, 10% in these patients. But very often you find that the onset of hypoglycemia is very late. It may take 8 months, 9 months. Why it is so late, the presentation of hypoglycemia in these type of patients?
So that very interesting question I did not discuss in my presentation is that if hypoglycemia starts at the time of preparation for bariatric surgery or immediately after bariatric surgery, we are actually dealing with an insulinoma. So we had a patient who was a physician assistant, and she was trying to get into bariatric surgery. So before bariatric surgery, we follow strict diet and preparation to bariatric surgery, so they understand what they're getting into. And she started having episodes, and classical episodes documented, found insulinoma, etc. So that is one entity that occurs immediately before or after bariatric surgeries. That's insulinoma. The other group is the one that develop hypoglycemia down the line. Why don't they develop early on? I suspect part of it is that their progression to diet is very slow. Initially, they are hardly eating anything. They are taking small meals, drinking. Initially, and then progress is over. Next 3 to 6 months, they start progressing. And initially, they have been taught to not to drink water with it and be careful this way and that way, take complex food. Now, gradually, they get sort of, into the habit of taking things that they shouldn't be taking, I should say. And that is where the trouble starts. Especially alcohol, very small amount, even a small glass of wine can cause alcohol concentrations going so fast, so high in these people that can cause symptoms of hypoglycemia, and that can actually cause severe hypoglycemia as well. So alcohol is a big issue here. But other real hypoglycemia is often caused by drinking Coca-Cola type of thing, sugar type of things. They drink that and have it immediately. But I don't quite know why it doesn't happen within a few weeks. It does take 3 to 6 months at least.
Yeah. Yes. Are there any questions from the audience?
Yes. Can I ask one question?
Please go ahead.
So recently we had an elderly lady diagnosed with insulinoma. Her age was 80. She had recurrent hypoglycemias. Can you hear me, sir?
Yes.
So
yes.
elderly lady with hypoglycemia diagnosed to have insulinoma, and relatives are not willing for surgery because they feel that at the age of 80, we are not going to take that risk of anesthesia and surgery. So how to go about it means pharmacotherapy in such cases.
So let me bring up a case here. So it doesn't matter. So we had a patient who developed hypoglycemic symptoms first time when she was 80 odd years old. She was so we first do CT scan. If CT scan shows a tumor, we don't do anything further. So CT scan was negative. So I sent for endoscopic ultrasound, and we had a good new faculty who had extensive experience in endoscopic ultrasound, etc., who joined our gastroenterology group. And my mistake, I did not talk to him in advance. So he had biopsied that tumor that he saw on endoscopic ultrasound. That caused pancreatitis. It always causes a small little pancreatitis, but surgeons don't want to operate on the person who's having pancreatitis. And she's having hypoglycemia. So what we had to do was to tell the family to keep feeding her, and she got 1 o'clock at night, she got up and ate. 7 o'clock at morning, they had alarms to feed. The family lived close by. She gained about 5-6 kilos over the next 6 weeks because she was eating so much. And now what happened was that this tumor was in a particular position that could not be injected with alcohol externally. So then what our surgeons did, they opened up the abdomen and they injected alcohol directly into the tumor. The tumor did not go away anywhere. Tumor is still there, except it is not making enough insulin to cause hypoglycemia anymore. And if it does not bother her for the next 15, 20 years, we are done.
Can you ask questions from chat box?
Yes.
Sir, there are about 4 questions from the chat box. I'll start with the first one by Dr. Sanjay Gandhi. What is the incidence of hypoglycemia in massive solid tumors? Is the mechanism similar to the hypoglycemia in acute leukemia?
So there have been instances of massive tumors consuming glucose, and the case that I presented from acute leukemia is not hypoglycemia because patient was not symptomatic. But sometimes there is tumor mass is so big that it consumes glucose, and then usually also lactates are high, etc. That can cause hypoglycemia. But these are terminal patients, and the oncologists don't call us. They just give glucose and they just give enough nutrition for that. So they don't call us, and I cannot tell you how frequently that happens, but it can happen with massive tumors. Tumors can also make IGF-2 that can cause insulin-like action and can cause hypoglycemia. Once again, exceedingly rare if tumor is not known. So usually tumor is already known, and then it is besides the point they are taking care of tumor anyway. So my role comes in if I'm changing the management. If I'm not changing the management, then the oncologist will take care of it. So that is the answer to that question.
One more question,
I can
sir.
keep reading my question. One of my patients with fasting hypoglycemia always that what antibodies to be tested. She had antibodies. She in fact had antibodies detected. So all type 1 diabetes antibodies are useless in this particular clinical situation. All we are looking for is insulin auto antibody, and we don't do assays for receptor antibodies. So they isolate the globulin area and then put it with insulin receptors to see if it is working. So those are the assays that will be of clinical value really to find out the cause of that. Yeah. The next question is what treatment be given if antibodies are positive? There is not an easy treatment. Once again, my role is to see if there is a tumor or not. If there is tumor, surgery. If there is not tumor, you manage. And how do you manage hypoglycemia? Take complex carbohydrates, take whole grains, add fat to it to slow down the absorption. If you want to have long action of carbohydrates, on the other hand, you want to treat, you don't want to add fat, you want to give sugar or fast acting carbohydrates, you don't want to give complex carbohydrates. So you just have to manage it some or the other, but keep calories low, because if I keep eating, I gain weight. Why wouldn't anybody else? So that is all. So if there is tumor or no tumor, I think that is the only thing. I have known that people have used immune modulator agents for this. I haven't personally used it. We have had a couple of patients of insulin antibodies over the last 10 years, and we have been managing it without immune modulation or glucocorticoids, frankly.
Thank you, Dr. Pankaj. For want of time, we have to stop here. But thanks again for an excellent session, and thank you for patiently answering all the questions. Once again, we are very happy to have you over. We are really looking forward to having you over again next year, sir.
Oh, you're very kind. Thank you so much.
Thank you
very much. Thanks, Kavita.
Thank you, chairpersons, Dr. Sonali and Dr. Sasikumar. Thank you. We are moving on to the next session now. Over to Dr. Veda.
So next session is Insulin Symposium. We will be having Dr. Vaishali Deshmukh to chair the session. She will be joining us very soon. The first speaker is Dr. Gagan Priya. Can I have her CV slide, please? And she will be talking on breaking barriers of insulin initiation in tune with Indian patient needs. So Dr. Gagan Priya, she is endocrinologist at Fortis IV Hospital, Mohali. She has received IJEM Award for Best Review Article, and she has received Professor MMS Ahuja Award, Fellowship Asia Pacific Pediatric Endocrine Society 2007 from Thailand, and she has been co-editor of Hypothyroid Disorders, a practitioner's guide, Knowledge Bridge, which was published in 2020, and also section editor in Endocrinology Urja, The Power of Her in 2020. Over 65 publications and 25 book chapters. She is founder of FLAME, which is Forum of Ladies in Medicine. Thank you so much, ma'am, for joining us. Over to you.
Yeah, thank you so much. And sincere thanks to Dr. Unikrishnan for such an academic feast and inviting me to be a part of it. So at the outset, I would want to put in my disclosures. What I'll be talking about is breaking barriers of insulin initiation in tune with Indian patient needs. So this symposium has been sponsored by Novo Nordisk. but there is no actual or potential conflict of interest because what we will be discussing is pure science and evidence-based information. So what we'll discuss over the next few minutes is the what are the challenges in management of type 2 diabetes in India, especially when it comes to with respect to insulin therapy. And then we'll discuss what are the innovations which suit Indian reality and how our approach should be different from that of a Caucasian population. Now, looking at glycemic control, I think we've been debating about what should be the HbA1c cutoffs, what should be our targets, and we've come to a kind of uniform opinion that yes, glycemic control does matter. It does reduce microvascular complications. It does reduce long-term cardiovascular disease rates, especially if the treatment is started early on in the course of type 2 diabetes onset. However, once the glycemic burden has already built up and macrovascular complications have begun, going into intensive control may not help that much. So early intensive control is what really would make the difference. And there is a reduction in diabetes-related mortality. We've seen it across the trials, mortality rates, right from the beginnings of 1970s and 80s trials to current trials, they are coming down gradually. And this also would be important from the cost perspective, because when diabetes-related complications and mortality come down, the cost of treatment and the burden of disease will come down. Now, looking at various therapeutic options, we all know we've made huge advancements in therapy, both in terms of oral agents and injectable agents. And the average glucose lowering for oral antidiabetics, by and large, the A1C lowering is between 0.6 to 0.8 in a nutshell, but for metformin, this goes higher up, especially when started early in disease. Then we have GLP-1 receptor agonists with impressive glucose lowering capabilities, but maximum glucose lowering efficacy is still with insulin. However, looking at data from across the world, whether it is the rest of the world or Indian countries, we know the average A1C is nowhere close to target of 7%. Average A1C in India is still around 8.5, and the same holds true for rest of the world. That means despite having a basket of so many medications, effective medications, and possibly medications that change the pathogenesis of diabetes and its complications, we still do not have good control. And when it comes to, with regard to insulin, the grim reality is only about half of the patients who need insulin are being offered insulin. And the average glycemic burden by the time insulin is begun is around 5 years of A1C of more than 8% and 10 years of more than 7%. Almost 1/3 of the patients who are prescribed insulin will not continue insulin. They will discontinue it for some reason or the other. 60% patients will tell you they miss their insulin injections, and 20% will miss it on a regular basis. So what are the barriers? One, to insulin initiation, and then of course with intensification we have another set of barriers. We can discuss these factors in terms of what are patient factors, where in their psychology is the insulin resistance. So I'm not talking of insulin resistance from the point of view of it being a pathophysiological defect in insulin action, but psychological insulin resistance is the resistance to accept the idea of insulin among patients. Then there are physician factors, the most important being therapeutic inertia. That means we delay the onset, the initiation of insulin to the last possible moment, and that does feed into the patient factors as well. Then there are, of course, social factors and the healthcare related factors. Huge burden in our clinics does not allow us to really discuss the idea of insulin in a timely manner and address the myths and misconceptions properly. So from a patient perspective, what are the factors? The biggest problem is that people think insulin is sort of a last resort and it's only being given because they've gone very bad by now and they fail to manage that properly. This can be addressed very early in the course of diabetes by educating patients about what is going to happen with insulin secretion as time goes by and why they are eventually going to need insulin. There are worries about insulin not being safe, some of them being genuine in the form of, the risk of hypoglycemia is real. So we need to address that. Flexibility becomes an important issue, and it is important to tailor therapies to, in tune with the lifestyle of the patient and not tailor the lifestyle to the therapy. So another fear is pain of injections. In fact, this is called trypanophobia. And this fear, if you look at studies, is actually very, very rare. So very few patients will actually say, it's a painful injection, so I will not take it. Now, looking at physician barriers, we are worried that the patient might refuse and move on to another doctor if we offer insulin. We are worried they will not comply with therapy, and whatever oral we are giving, they might not take that also. Hypoglycemia, the risk of adverse effects, weight gain, the impact on quality of life, these are real issues. For certain subgroup of patients, we understand that insulin can be very demanding, especially elderly patients or patients with comorbidities and polypharmacy. Then concern over comorbidities is also real because the risk of hypoglycemia goes on to increase in people with comorbidities. And a very big challenge is lack of resources, lack of having support staff to educate about insulin. The cost of drug therapy and SMPG is going to add up when you start insulin, and the skills to initiate and intensify treatments. So most physicians tend to delay insulin until and unless it's absolutely necessary. Looking at it from the social and healthcare system, our society has a lot of myths, misconceptions, and taboos about injectable therapies, which need to be addressed. And then, of course, cost of therapy, lack of educators in our clinics, heavy patient load. And at the physician level, we still have to know that most of the diabetes management is being taken care of by primary care physicians. And quite often, they may not have the adequate training and experience with the newer advancements in insulin therapy and what would serve better where. So how do we break these barriers? So if you ask me what are the 3 best approaches to break the barriers, the best approach in the order of 1, 2, and 3 is education, education, and education. I am taking a cue from Vidya Balan's entertainment, entertainment, entertainment. So for us, it is an education, educate, educate. And education has to be both for the patient as well as the healthcare provider in terms of why insulin is needed, how it is helpful, how it will reduce complication risk, and the safety, etc. Another important thing is to motivate patients rather than to have, just dictate treatment is not going to work. A motivational approach is what will work. The most important part of education is patient empowerment. That means they should have the necessary skills to start insulin, to be able to do monitoring, and to self-titrate insulin, and also troubleshoot as to how to recognize hypoglycemia, how to prevent hypoglycemia, and how to manage it effectively. The next important aspect, which we will talk of in the next half of the talk, is the next important 3 steps of breaking these barriers, and that is innovation, innovation, and innovation. So we want newer insulins which minimize hypoglycemia and weight gain, which do offer flexibility to the patient. As I said, it's important to tailor the therapy to the patient's need than to tailor the patient's lifestyle to the therapy. We need to address unique needs of a particular person or a population, and that is where the difference between Asians and the Caucasian population comes in, and it has to have easy administration, titration, etc. So we all agree that across the world, basal insulins have been recommended for the initiation of insulin. Now, when we talk of basal insulins, why they are offered in type 2 diabetes for initiation? Because it's an easy once-a-day injection, easy initiation and titration using fasting plasma glucose. The intensivity of SMPG monitoring is less when we are initiating with just a basal insulin dose. So you don't have to do a 5 or 7 point monitoring when starting with basal insulin. The risk of hypoglycemia is lower compared to the other more intensive regimens. The weight gain risk seems to be lower with drugs like insulin detamir or insulin degludec. This has been shown in studies because they tend to be hepatoselective rather than there is greater action in the hepatoportal system than in the systemic circulation. Then newer basal insulins like insulin degludec or U300 glargine offer the flexibility that if an injection is missed at a particular time, it can be taken within a window of 3 to 4 hours. Now, coming to particular challenges that we do face in India, and we'll ask this question, is basal insulin the appropriate therapy here? We do know that Asian Indian phenotype is distinct from Caucasians in that there is greater waist circumference, total and visceral body fat, more degree of hyperinsulinemia, and possibly insulin resistance also tends to be higher, as has been assessed from the inflammatory cytokines, etc. Now, the carbohydrate intake of Indians on an average is much higher than the Caucasian population, and the initiation is quite delayed. So we've already seen that by the time insulin is initiated, the average A1C is 9.5%. And we also need regimes which are, simple, convenient, and we can start with one regimen and possibly build up with only that. Now, looking at Indian studies, we do know our carb intake is very high. In fact, the starch study, which was a beautiful study conducted across all the corners of India, did show that average carb consumption is somewhere between 61 to 70% of the total caloric intake. And in other studies, we've seen that there is a high amount of white rice consumption and even wheat consumption in India. So North India has more wheat and South India has more rice consumption, and the risk of diabetes does go up. Other studies have shown that the average PPG for Indian population is much higher than the Western population. Looking at data, we have this concept that was built up by Monia et al. That at higher A1Cs, the A1C is largely accounted by basal hyperglycemia or fasting plasma glucose. And as the A1C is lowered, the contribution of PPG increases. But now we have data from Asian Indian population showing that this is not entirely true for Asian Indians. The contribution of PPG remains high even at the higher A1Cs. So there's a significant burden of postprandial hyperglycemia, which will not come down properly when you start reducing fasting plasma glucose. So that fix the fasting first approach might not work for Asian Indians, and we will need to target both fasting and postprandial glucose simultaneously. So does basal insulin address our questions? Is it suitable for people with high carb diet? Does it offer PPG control? Would it be suitable when the insulin is already delayed by 5 to 7 years of when it should have been initiated? And does it offer a control of both fasting? PPG means total control. Possibly the answer is not. So what is the answer for that? We can use a basal bolus regime or a basal plus regime, but that makes the regime complicated. And we know the shortcomings of pre-mixed insulins, whether they are conventional premixes or premix analogs like the premix Espart or premix Lispro. We already know the shortcomings of that. So the answer lies in a co-formulation of a basal plus a true bolus insulin. So understanding this co-formulation, we have seen, we've been using IDEG as co-formulation for a while now. Not to go into details of its pharmacology, it is 70% insulin degludec, which is an ultra long-acting basal insulin, and 30% of rapid-acting insulin, that is Espart insulin. Now, what is the beauty of this mixture is, unlike a mix, pre-mix 30-70 formulation, which might have Espart with protaminated Espart or Lispro with protaminated Lispro, the hexamers of these remain distinct in the formulation. What will happen in premix insulin, whether it's regular conventional premix or Espart or Lispro, when you combine this in a 30-70 or a 50-50 ratio, some of the regular insulin also changes its PK/PD profiling to that of NPH. So the curve is not entirely a smooth bolus and basal, but there is a shoulder effect for the rapid-acting insulin. That means its duration of action gets prolonged a little bit, increasing the risk of hypoglycemia. And of course, the basal insulin is protaminated insulin with all its shortcomings. Now, in this formulation, the two hexamers remain distinct in that they do not affect the PK/PD of each other. So what you have is a true basal insulin with a very flat profile. So from the chain of hexamers, IDEG hexamers will form a poly chain and they will get slowly absorbed into circulation, while aspartate will get absorbed very rapidly into circulation. So what you're getting is the prendial component, which is rapidly absorbed, has a short duration of action. It will provide the meal cover for at least one of the meals or two of the meals when the dose is being given, and a basal insulin, which has a flat and stable and a very predictable profile once it reaches steady state. So as we can see here, from the glucose infusion rate after a single dose of Idegasp, you have a clear mealtime bolus and you've got a flat basal insulin, which does not, they do not interact with each other or affect the PK/PD profiles of each other. Now, there was a long clinical development program called the BOOST trials, phase 2, phase 3 development program, which Idegasp has undergone in varied patient populations. So type 1, type 2, insulin naive, on insulin. And what it has shown is, if you look at one of these trials, comparison of Idegasp with just basal insulin in insulin naive patients. So for insulin initiation, that was the question we were asking. The Idegasp co-formulation offered better glycemic control and similar fasting control, but almost with 70% of the basal dose as the other arm had. So total basal insulin dose was lesser, but the average control was more, was in fact superior. So looking at the PPG, this was given in this trial, a single dose was given at the dinner meal, and there was a significant reduction in the postprandial glucose values at night, but it did not increase the risk of nocturnal hypoglycemia, which remained almost comparable in both the groups. And if you look at the basal profiling of both the insulins, whether it was basal or Idegasp, you saw a similar level of fasting plasma glucose, but HbA1c was better. And we know these PPG excursions are important because it is these excursions which drive oxidative stress and the risk of complications. What about the risk of hypoglycemia? It was not increased. Rather, numerically, the risk of hypoglycemia was lower with Idegasp, despite it being timed at the dinner meal and getting a lesser post-meal bedtime value. So almost 70% more patients achieved target A1C without experiencing a hypoglycemia. More recently, we have had this real-world study, that is the ARISE study, which looked at patients in real-world practice. So around 1,000 patients, their data was collected across 6 countries. India was one of these countries, and we had a comparatively large Indian cohort of 185 patients. This team was led by Dr. Manish from Guwahati. And what they found was that the reason given by the physicians to initiate insulin, the biggest reason, of course, for choosing Idegasp was to improve patients' control. Some physicians also chose it because it was lesser number of injections compared to a more intensive regimen. It offered flexibility. It lowered the risk of hypoglycemia. So these were some of the reasons. Looking at the A1C reduction from baseline, so patients who were on OADs alone when initiated on Rhizodeg, almost a 2% reduction in A1C was seen. Patients on only basal insulin, when shifted to Idegasp, once or twice daily, the A1C reduction was around 2%, and it was still good for all other subcategory of patients. Because of this reason, the most recent clinical practice recommendations that came from RSSTI and ESI do give the option of Idegasp as an initiation regimen. So in addition to giving basal insulin or premix insulin, this is another choice that is recommended for insulin initiation. But it's also important to take care of the other inertia factors that we discussed earlier on, that is anxiety, myths. Do not use insulin as a threat. So that's very important. You can initiate with once daily and intensify to twice daily. When starting with once daily, the idea is to start with the major meal of the day for whichever the major meal of the patient is. Another thing we can do is also look at where the PPG is highest. Start with a ballpark figure of 10 units, but I usually prefer to go with that per kg body weight dose, even for Idegasp, as we use for basal insulin. And then we can target based on the SMBG profile. So if fasting is high, you can add 2 units. If fasting is below target, you can reduce 2 units. When Going with BID doses, again, you can look at pre-dinner and pre-breakfast values and adjust. The pen technology is another advancement because it makes insulin delivery convenient, error-free, and it is easier for patients with problems or morbidities, such as problems with the hand or eyes, vision. They can use the pen devices conveniently. So with that, I'll just summarize that iodic gas, comparing for an Indian population, it is suitable for initiation in people with high carbohydrate diet. It does offer fasting and PPG control. It is useful when the insulin initiation has already been delayed. So offering both the basal and prendial components is good, and it is simple and convenient for intensification. So I'll conclude here. Thank you.
Thank you so much, ma'am, for the excellent presentation. We will have the next lecture, and after the 3 sessions, we will have question answer session, ma'am. So the next session is by Dr. Shehla Sheikh. The topic is positioning PIR in diabetes management, role of near-basal insulins. Dr. Shehla Sheikh is endocrinologist attached to reputed Mumbai hospitals like Saifi Hospital, Bokhard Hospitals, and Prince Ali Khan Hospital. She is a great academician and excellent orator. And over to you, ma'am.
Good evening, everybody. And at the onset, I would like to thank Dr. Unikrishnan for making me a part of this very prestigious 6th International Diabetes Summit. And it is indeed both a pleasure and a privilege to be a part of this meeting. Today, I am going to be talking about where do we position time in range in diabetes management and what is the role of the newer basal insulins as far as time in range is concerned. These are my financial disclosures. And what I am going to be talking about is what is this entire concept? Why are we increasingly talking about time in range? What are its implications? Do we, with the application of time in range, get additional information than what we were conventionally getting with the fasting PP HbA1c? Is this what you see very often in clinical practice, where you would have patient 1 with a similar HbA1c as patient 2, but very differing glycemic variabilities? For example, if you look at patient 1, you would realize that there is a huge amount of glucose variability in patient 1, whereas with patient 2, you realize, yes, the glycemic variability is lesser, but when you look at the average 3-month HbA1c, you would realize that both of these patients have a similar HbA1c. So is it that when we are looking at these snapshots, when we're looking only at fasting, which gives a snapshot of sugar, when you're looking only at post-meal, which would give you another snapshot, and of course, when you're looking at your average 3 months HbA1c, is it that we are somehow missing the boat? Are we getting insufficient information? And as a result of this insufficient information, we are really not able to treat our patients as well as we should, and we are often not able to reach targets. So what is time in range all about? Time in range actually refers to something very simple. It is the time which an individual spends in target glucose range, which is usually 70 to 180, but can change according to, for example, situations. In a patient with CRF, your target glucose range may be different. In a patient who's pregnant, the target glucose range may be different. In a pregnant lady, for example, your target glucose range would be much lower. And occasionally you may decide that your target range should also be 70 to 140. Now, the percentage of time that you spend above this range indicates hyperglycemia, that is the time above range, and the time below that you spend is known as time below range, which is actually hypoglycemia. Increasingly, time in range is being used as an endpoint in clinical research for all of us. We are now doing trials which utilize time in range as an endpoint. We are using time in range as a measure of glycemic control in patients with diabetes increasingly, trying to understand how molecules work, how lifestyle changes work, and where we could make a difference as far as our patients are concerned. strong evidence emerging that time in range is inversely correlated to the risk of developing micro as well as macrovascular complications in patients with diabetes. So what is the international consensus report on CGM and TIR all about? Mind you, this gives us guidelines, it gives us recommendations for not only clinicians and researchers, but also people with diabetes. In practice, we are increasingly realizing that a number of our patients are now using sensors. They have readers available. They're looking at glucose trends. They are trying to understand, and mind you, doing a pretty good job of understanding what kind of lifestyle changes, what kind of medication is making what kind of difference. And they are helping us as the healthcare providers make better decisions for effective diabetes management. 2012, the first recommendations on the, by an expert panel on standardization of CGM metrics. 2019, current update was that the international consensus at the ATTD did develop CGM targets based on currently agreed upon CGM metrics. And one of the CGM metrics that we use is time in range. We all know there are a number of other CGM metrics, be it MAGE, be it coefficient of variation, etc., etc. But what we are using in clinical practice very, very simply, very, very easily is time in range. And how do you interpret this CGM data? If I put it very simply, one parameter is the target range, which would be 70 to 180. And the other parameter is the time for which you need to be in the target range. That is at least more than 70% of the time. That is approximately more than 16 hours, 48 minutes. Anything above this time in range would be time above range. And the target would be that you should be less than 30% of the time above range. Definitely less than 30% of the time above range. Time below range, definitely you do not want hypoglycemia, and your target would be to keep it as minimal as possible. And you definitely want it to be less than 5%. That goes without saying. Now, these targets, as I said, change in situations. For example, older patients, higher risk patients, you would change this target range. You may widen the target range. You may change the time for which the patient remains in these different target ranges. These are very, very individual decisions which you would make. The decisions are different when you are a type 1 diabetic patient and pregnant. There you would want a target range. And of course, type 1 diabetic patient and a pregnant patient, you would want a target range to be between 63 to 140 milligram per cent, for example, more than 70% of the time. And you would allow a target above range less than 25% and a below range again less than 5% of the times. In your GDMs, in your type 2 diabetics, you again want them to be as much as possible in target range. Now, what does this actually tell you? How do you correlate? I'm using a conventional parameter of HbA1c, and now I am talking about target and range. How would I correlate them? If you look at this very, very simple chart, what you would realize, friends, is if you look at a patient who is in range 70% of the times, for example, which we are talking about, that translates into an HbA1c of 6.7%. So there is a good correlation between HbA1c and percentage target in range across a broad range of subjects, be them type 1 or type 2, ages and technologies across 18 studies. Mind you, for every absolute 10% change in the percentage of time in range, there was a 0.8% reduction in the HbA1c. So that's a pretty good correlation between HbA1c and time in range. Not only that, what we realize that for every amount of time that you increasingly spend out of range, your risk of microvascular complications increase, be it retinopathy, be it microalbuminuria, or even when you look at your CIM2, you realize that there is an association. Every 10% increase in TIR was associated with a 6.4% lower risk of abnormal CIMT. And we all know CIMT is a predictor of future cardiovascular events. So we need to see to it that our patients do stay in range. We need to see to it that we are able to, with the help of lifestyle, medication, insulin, keep our patients in target as much as possible, mind you, without having them either above range or below range. Now, when you look at MACE, you would realize there is also an association between derived time in range and MACE. And if you look at this graph, you would realize that when you look at the derived time in range more than 70% versus the derived time in range less than 70%, there is a reduction of almost 27% as far as risk of MACE goes. We need to keep this in mind. We need to understand that, yes, you now have increasingly parameters which, if we manage to keep our patients in this range, it does make a difference to them as far as not only microvascular complications go, like, for example, end-stage renal disease, severe vision loss, but also as far as macrovascular complications go, like myocardial infarction. And you would realize that if the patients, the longer the patients remain in range, for example, if you compare these two columns of 58% time in range vis-a-vis 80% time in range, the first part is type 1 diabetes, and the second part is type 2 diabetes, again 58% vis-a-vis 80% time in range. There is a significant difference between these parameters, and you realize that the rate of complications, be it micro or macrovascular, 10-year cumulative incidence does reduce for as much time as your patient stays in range. Now, with this kind of evidence, what do we do? Do we have newer analogs which would help our patients remain in range? Do we have newer insulins which would reduce the time spent either below range or above range? What possibly could give us this benefit? Now, when you look at degludec, we all are using degludec. And we all are also using glargine U100. What we are at this point of time increasingly beginning to understand, that degludec actually gives you an absolutely flat and uniform glucose lowering effect throughout the day. And why is that? That is because of it has a twice as long half-life compared with glargine U100 that you and me use so very comfortably in clinical practice. And that does translate into that benefit of reducing glycemic variability. And that is the reason why it has 4 times lower glycemic variability when you compare it with either glargine U100 or glargine U300. What do the RCTs show? What does real-world evidence show? When you look at real-world evidence, when you look at some of the RCTs, be it Begin, be it Switch, be it Devote, you would realize that when you compare when you compare your insulins, when you compare your insulin degludec with your insulin glargine U100 and conclude compared insulin degludec with insulin glargine U300, what was seen? Yes, I agree. In the Begin, Switch and Devote data, we did not have a significant difference as far as HbA1c was concerned. But when you look at the fasting, you would realize that statistically significant difference both in Devote and Conclude. Also, when you look at the hypoglycemia, mind you, that is when you're looking at the time below range, whether it is Begin, Switch or Devote, a significant reduction compared with the comparator. When again you look at EU Treat, Confirm or Reflect, what did you see? These studies reflected a reduction in the HbA1c, a statistically significant difference as far as the HbA1c was concerned, and most importantly, a reduction in dose as well as a reduction in hypoglycemia. Now, this was real-world evidence, which showed that yes, friends, there is a reduction in the time the patient spends below range, and this reduction is not at the expense of having worse control, this reduction is along with better control, along with a reduction as far as the HbA1c goes. So when you realize sorry about that. So when you realize and you look at the Switch Pro RCT where degludec is compared with glargine U100, what do you see? A very, very interesting trial. And the reason I'm saying a very, very interesting trial is because over here you would realize that when you are screening these patients, one of the important parameters which was done in the run-in period was the FGM to evaluate the patient's adherence to wearing a sensor for 14 days. 613 patients were, mind you, screened. And 498 were randomized to receive treatment per protocol. That is, 448 patients received degludec vis-a-vis glargine, which was received by 448 patients. What was seen in this? Initially, when you look at the entire data, initially, when the patients were randomized, one arm in the treatment period was on degludec vis-a-vis another arm on glargine. And then between week 16 to 18, these patients again underwent flash glucose monitoring. Subsequent to this period, at 18 weeks, there was a switch in dose. That is, the patients who were on the glargine arm went on the degludec arm, and the patients who were on the degludec arm came on the glargine arm for a period from 18 to 36 weeks. Again, between 34 to 36 weeks, there was FGM which was done. The trial ended at 36 weeks and there was a follow-up visit at 37 weeks. This was presented in the ESD 2020 by Goldenberg R. et al. And what did the data tell us? What the data very, very categorically tells us is that when you compare degludec with glargine U100, there is a treatment difference. And this treatment difference is a significant 1.52%. That is 21.9 minutes per day favor degludec over glargine U100. That is overall time in tight glycemic range. That is significant. Now, when you realize not only did more patients achieve clinically significant improvement in time and range with degludec, what was very, very important is that the time below range, which is actually what you and me worry about as clinicians, be it nocturnal level 1 or be it nocturnal level 2, was lower in patients with on degludec vis-a-vis patients on glargine U100. And that means that these patients, when you combine nocturnal level 1 and 2, spent 12.7 minutes less in the time below range vis-a-vis patients who were on insulin glargine. So yes, time in range provides a complete visualization of the person's glycemic status, aids in better glycemic control, definitely reduces micro and macrovascular complications. And now with newer and newer data coming in, we are seeing data which shows when you compare degludec with glargine U100, there's improved time in range, improved, mind you, tight time in range, lower nocturnal time below range level 1 and 2, and more patients achieved clinically significant improvement in time and range. So we are fortunate to be in an era where we can use molecules which would potentially reduce our patients' time below range, reduce the risk of hypoglycemia. One of the biggest side effects in diabetes management when we're managing our patients with insulin, especially nocturnal hypoglycemia, that worries each and every one of us when we are either initiating or titrating insulin subsequently, that is intensifying insulin. Thank you very, very much, friends, for your very, very patient listening. It was an absolute pleasure interacting with all of you. Thank you very much.
Thank you so much, ma'am. And please stay with us because we will be having discussion after the last lecture of Dr. Chitra Selvan. She will be talking on intricacies of IP hyperglycemia management, inpatient hyperglycemia management. Dr. Chitra Selvan is consultant endocrinologist at MS Ramaiah Memorial Hospital, Bangalore. She is one of the leading endocrinologists in Bangalore and she has several publications to her credit. Over to you, ma'am.
Thank you so much. Thank you for the kind introduction, ma'am, and my absolute joy to be sharing the stage on the eve of Women's Day with powerhouses of women power of endocrinology in this country. And Dr. Gagan and Dr. Sheila have made my job extremely easy. I'm going to be spending the next few minutes talking about the intricacies in inpatient hypoglycemic management. So we've spent yeah.
Sorry to interrupt you, ma'am. You shared whiteboard.
Okay, just give me 1 minute. Okay. Can you now see my slide?
Yes, ma'am.
Perfect. I'm sorry about that. So we will now move a little bit and focus on the intricacies of inpatient hyperglycemia management. I think the COVID pandemic has taught us that IP care is also something that we need to pay attention to, and sometimes it could spin a fast one at us. To begin with financial disclosure, this is an Novo Nordisk sponsored symposium, and the agenda for this conversation will be about what is the guidance for optimal management for hypoglycemia in non-critical care? How do we go about calculating the dose? What is the best regimen that we can use? What is the benefit of having newer analogs in the context of inpatient care? And then a reflection on a clinical case, and then how we might calculate and effect all that we've learned. So moving into a guidance for optimal management of hypoglycemia, I think this is evidence which we've known for a few decades now. If you compare individuals who come in with normal blood sugars with people who come in with a known history of diabetes versus people who are newly discovered to have hyperglycemia in the first time at their emergency visit, and look at the comparison with their in-hospital mortality levels, you see that there's a 16% increased risk in mortality in individuals with newly discovered hypoglycemia as compared to people who have normal glycemia. So this is one important aspect. So if you want to improve outcomes for your IP patients admitted for any reason, all kinds of hyperglycemia has to be taken care of. And why have we distinguished it into people with known history of diabetes? Because there's also another condition called as stress-associated or stress-induced hypoglycemia, in which their HbA1cs might be normal, but there might be hyperglycemia during that admission itself. All hyperglycemia is associated with increased mortality, and it is something that we must treat. So when you will talk about hypoglycemia in, let us say, critical care, we all know that intravenous insulin is the way to go. But we're now looking at, for this conversation, individuals who are hospitalized but not in the critical care. And in that situation, we do know that subcutaneous insulin is the best way to move forward. I think the entire audience is well informed enough to agree that oral agents are definitely not recommended during hospitalization, especially metformin and SGLT2 inhibitors. So we've had a few decades of use of sliding scale in the IP setting to treat hyperglycemia. We do know that the sliding scale is not a scientifically designed method of inpatient glycemic control. We do know that it does not mimic physiology. It is a reactive approach in which we are trying to chase blood sugars. And I think the most problematic concern with sliding scale is that once blood sugars come down to normal range before a meal, we are very likely to skip that insulin dose, which essentially leads us on a chase because the post meal is definitely going to be high. And another important aspect is the fasting sugars are never going to be under control on sliding scale, primarily because there is no long-acting insulin which is there in this particular regimen at all. So what's superior to sliding scale? It's always basal bolus, because we're trying to mimic the physiology of the body. The basal insulin acts for 24 hours continuously and takes care of your fasting sugars and suppresses your hepatic gluconeogenesis. And your bolus dose, it could be 3 if you're doing 3 meals, it could be 4 if you're doing smaller meals, to deal with the post-meal excursions, as Dr. Gagan has highlighted. And we do know those are all very important things to consider. And while we go about bringing blood sugars under control, it's important that we want to have very few hypoglycemic episodes as well as very few hyperglycemic excursions as well. Now, how do we go about starting basal bolus regimen in non-critical care? Now, there are many ways of calculating the dose. The scientific way of doing this is to do a per kg body weight dosing. So anywhere between 0.2 to, let us say, 0.6 unit per kg might be the total daily dose requirement for your particular patient. Now, which patient are you going to calculate 0.1 and which patient are you going to calculate 0.6 is going to depend on numerous factors, one of them being the BMI, the second being whether there's an ongoing infection or not, and third, are there increased risk for hypoglycemia or not? I think we all know the parameters which contribute to it. But when in doubt, always start low. You can always come back and tighten up the dose if required. Whatever you calculate by this percentage is your total daily dose. Now take that number, divided into 2. 50% of that is your basal dose, and then the other 50% will be divided into 3 bolus doses, because most of us are on bolus 3 meals per day. So those are 3 boluses to cover the post meals which occur after each meal. Now, during hospitalization, it is recommended that we check blood sugars at least 4 times a day, 3 meals a day. So you check before each meal and you check 1 bedtime or maybe post-dinner value. So that's 4 measures of blood glucose per day. Now, in case your blood sugars are coming high, then you need to titrate the specific insulin. But the most important thing to remember is your basal insulin controls your fasting sugars. So if your fasting sugars are going high, and then you need to titrate up your basal insulin. I hope this was clear. And once you've started an insulin regimen based on this total daily dose calculation, it doesn't remain static there. The whole process needs to be dynamic so that we can fine-tune the insulin dose so that we bring the blood sugars to target. Now, how do we increase the insulin dose? That is referred to as the correctional insulin dose. And that's exactly why I said, if you're not sure, if you're worried, it's always okay to start low. We can always come back and correct it. Now, if your pre-meal sugar, you want it to be around 100 to 140, and it is at 100 to 140, it is important to not skip the dose or not miss the dose, but to give the same dose that was given the previous day. If the blood sugar levels are off target, let us say they are in between 180 and 220, you might need to increase the dose by 4 or 6 or 8 units. Now, who's going to get 4, who's going to get 6 depends on whether your patient is insulin sensitive or insulin resistant. Again, this depends on primarily 2 factors, BMI and whether there's an underlying infection, whether there's use of medication which can increase your blood sugar levels like steroids. So again, if you're not sure, go with a lower correctional insulin. So whatever was the dose that was given previous day, so let's say 8 units were given the previous day, it becomes 8 plus 4 for an insulin sensitive person, 8 plus 6 if they are normal resistance, and higher dose if they are insulin resistant. So quickly to summarize thought, basal bolus is the way to go, offers effective glycemic control, low risk of hypoglycemia, and it's flexible. Let us say you have to shift the patient out for a CT at 3 o'clock in the afternoon. All you have to do now is reduce the dose of the afternoon pre-meal insulin or skip it if he's expected to remain nil orally, and then shift the patient for CT. As your patient comes back and is ready to eat his meal at 5 p.m., you can give a bolus and continue with your insulin titration. Now, what benefits do newer analogs bring in IP care? And here I'm going to draw heavily on what Dr. Shaila and Dr. Gagan have taught us. Dr. Shaila did a great job of taking us a comparison of the Degludec, which is the long-acting insulin, with insulins which are the original molecules or the first molecules in the market. And we have a host of evidence now to suggest that as compared to glargine, degludec is comparable, if not superior in the RCTs, but we have real world evidence to suggest that the HbA1c reduction does favor degludec over glargine U100, Detimer, NPH in all the real world data which has happened. But what is more important to notice is the fact that the risk of hypoglycemia is the lowest with degludec, both in RCTs and in real world evidence. And I think you and I both understand the importance of hypoglycemia. We do understand that increased risk of hypoglycemia, especially in vulnerable population, can increase risk of CV death even in the hospital setting. Another concern with using a longer acting degludec in IP setting could be that you're wondering that since it's ultra long acting, does it mean it will take a longer time to reach steady state? Does it mean it has a slower onset of action? And this has been put to rest now because we have evidence to suggest that insulin degludec has a rapid onset of action. In fact, it starts acting by 0.5 to 1.5 hours and reaches a steady state by 2 to 3 days, which is much better than the glargine U100 or glargine U300, if not at least comparable. So I don't think those should be concerns which would hold us back from starting degludec in the IP setting. And very recently, in June 2021, an RCT was published which looked at comparing degludec and glargine in the IP management of individuals with type 2 diabetes, which went on to show that there's rapid attainment of glycemic control with insulin degludec in hospitalized individuals, even as early as 24 hours after initiating the insulin itself. And this is another study which was published in 2017, which looked at hypoglycemia risk in individuals who received degludec versus others. This was an observational study. Up to 48% of individuals were elderly, again vulnerable, up to 35% hit CKD. And what they noticed was that degludec demonstrated good HbA1c reduction with very low risk of hypoglycemia. The IDEO study was also an important study, and this was also shared with us by Dr. Shaila. They included 65 patients at the start of the study, divided into 2 arms to receive glargine and degludec. And along the way of the study, up to 30 patients who were in the glargine arm were switched up to receive, 20 patients were switched up to receive degludec. So this provides a very unique setting in which you can compare pre and post in this unique group, which first started with glargine and then switched to degludec. So what they tried to look at was this. Here they're trying to look at subjects with hypoglycemia. In the left panel of the graph, you see that people who received degludec had up to 80% of people who had no hypoglycemia and 0% of people who had nocturnal hypoglycemia, whereas people who received insulin glargine, up to 72% only had no hypoglycemia, which means there were 26% people who had hypoglycemia, which was diurnal, about 2%, which was nocturnal. Now, when they switched people up to degludec from people who received glargine, notice that up to 85% of subjects did not have hypoglycemia after switching to degludec. I think this design of study can easily tell us how in that particular patient, with all the circumstances remaining the same, switching the insulin alone could reduce the incidence of hypoglycemia. So this is something to think about, especially when you're choosing long-acting insulins in vulnerable population. This is primarily because there is lesser glycemic variability with degludec, and this is data from CLAMP studies, which tried to look at the area under the curve of insulin after injecting insulin degludec, which is in dark blue. Notice that the bars are all flat over a 24-hour. Whereas with glargine U100, there is a peak. We've known this from medical school that there is a peak which happens with U100 glargine. But in the second panel, you see that they're comparing degludec with U300. Again, you see that the blue bars are all flat and U300 does show a peak. Maybe the peak is blunter than the U100, but there is definitely a peak. And just a small comment on mealtime insulin. And Dr. Gagan did tell us about postprandial hypoglycemia and its relevance in the management. This is a simple study which looked at what is the best time to give faster acting aspart. So you see 3 different bars there. The light blue is the one in which you are giving the faster acting aspart 20 minutes after a meal. And the other is 5 minutes before and the other is at meal time. And what you notice is that there is a comparable HbA1c reduction, and there is a similar postprandial blood sugar reduction as well, even if you administer the insulin 20 minutes after. And you and I both know that this is an important attribute of insulin in the IP setting, because the patient could be having nausea, poor appetite, vomiting, has a return back from a radiological intervention, and is not really sure how much he or she is going to eat. So it's definitely going to increase our ease of administration of medication. And we also do see that there is a lower risk of overall and nocturnal hypoglycemia with faster acting insulin aspart as compared to insulin aspart itself. So the flexibility of faster aspart is that it can be given up to 2 minutes before the start of the meal or up to 20 minutes after the meal itself. So which means it gives you an opportunity to calculate your dose precisely, get an absolutely accurate estimate of the amount of food your patient is eating. Also helps in individuals who might have low cognitive impairment, or anybody who's drowsy and might not be able to quantify their hunger and tell us what their meal is going to be. A quick pause to reflect on a case and then how to implement all that we've learned. So we have a 40-year-old male who's admitted in the hospital for fever. He's had diabetes for 8 years now, and he's on metformin 2 grams per day with sitagliptin 100 milligrams with telmisartan 40 milligrams. His BMI is 24.6 kg per meter square. His RBS on admission is 150 milligrams per deciliter with a HbA1c of 7.5%. Fairly well controlled. Total count is 12,300. Now, these are his blood sugar values. Of course, all the OHAs were stopped, and then insulin was started, basal bolus. His weight was 80 kgs. So calculating at a rate of 0.4 unit per kg, that's up to 32 units. So if you break that down into basal, that will be 16 units basal, and up to the other 16 units gets broken down into 3 meals. So that's how the insulin regimen was initiated. And of course, the correctional insulin chart was also developed based on the fact that there's an ongoing infection, that he's 44 years of age, does not have any organ dysfunction, which could increase his risk of hypoglycemia, and also his BMI is on the higher side. So with this, this was the dose that was decided. And these are the sugar readings on day 1. On day 1, his fasting reading was 180. We wanted to be slightly on the lower side. And his before lunch reading was 250. So the dose which was decided for him was 6, but going by the correctional insulin chart, he needed 4 additional units. So he received 10 units on the first day, and all the other doses continued as before. Now, because the fasting insulin was, fasting sugars were off target, the degludec, which is his basal insulin for that day, was increased by 2 units. And that's day 2. And we noticed that as we went about it, his sugars got better. Again, before lunch, his reading went up to 220. So he received another additional correctional insulin of 2 units. And because his pre-lunch was consistently higher, his breakfast dose was increased to 8 units. With that, blood sugar levels got much, much better. So by day 5, his 24-hour glucose values looks like this, all of them on range. It's recommended that in your IP setting, we try and maintain blood sugar levels between 140 to 180 to optimize all outcomes. But if you have an individual who's young with a low risk of who can handle hypoglycemia well, you can move your targets lower to up to 120, which was exactly what was done with this particular patient. So quickly to summarize, there is no role of sliding scale in IP hyperglycemia management. Basal bolus is absolutely the way to go. If your fasting sugars are low, start with a very, very small dose of basal insulin, but please do make sure that your patient is receiving basal insulin. Degludec, an ultra-long acting insulin, is an effective, safe option as a basal insulin of choice for IP care. And faster acting Fiasp offers you flexibility in IP care, which could sometimes be turbulent and unpredictable. With this, I thank the organizers and hand back over to the chairpersons. I'm sorry if I've exceeded time.
Perfectly on time and excellent presentation. I would like to welcome Dr. Vaishali Deshmukh. She is here, renowned endocrinologist of the city of Pune, and she is the first lady endocrinologist in Pune. She is, Vaishali, are you here? Yes, I can see you. Over to you, Vaishali.
I think, yeah. So we are just having a couple of minutes, and I think we'll just, I think the three eminent ladies have presented very important, vital topics which are relevant for practice. And I would like to ask Dr. Gagan as to what is her personal experience or view on initiation with IDAGASP and intensification also. Do you think that in your practice also it makes a lot of importance as the data shows?
Yes, so I think I find it a very convenient regimen to start with, especially when the patients are on having both fasting and postprandial significantly elevated. So we know that with basal insulin, we're never really going to be able to target the PPG, and once daily IDAGASP seems like a convenient solution to start with one injection a day and target at least one meal value. For my North Indian patients, which are more parantha eaters, I think it's the breakfast meal that we use the IDAGASP most commonly. And patients also, though logical or not, patients are comfortable not taking an injection at night, rather in the morning. So psychologically, they feel more comfortable taking it in the morning, and it takes care of the PPG post-breakfast values, which seem to be highest, at least in my practice, for majority of my patients. So it's convenient.
Yeah, I agree with you that wherever you have a postprandial surge expected, the IDAGASP has better offering than the other basal insulins. So Dr. Shaila, you spoke about TIR and glycemic variability. Do you think that it's high time that we give up the concept of glycemic triad and move over to glycemic variability and TIR in our practice so that it can be more relevant in terms of diabetes control?
Vaishali, I think we'll have to use everything to our advantage because we are still not reached a point of time in the real clinical world, in the real world, where we are using a lot of CGMS data, where all our patients have access to the sensor. There are cost issues, there are applicability issues, there are interpretation issues also, if you honestly ask me, with a large amount of intraday and interday variability also. So I think we need to, at this point of time, we need to do everything that we have to be able to get our patients at goal. We would definitely be continuing using our triad of fasting PP, HbA1c. And then in our situation, in the Indian situation, we would use CGMS data as an additional parameter as and when and where we need it. And again, it would depend upon the patient's affordability. It would depend on the patient's education level, the patient's motivation level, the clinician's understanding about the entire situation. So though apparently it looks very, very good, and it is, of course, it is going to parameter we are slowly going to move towards, but I don't think we are going to be using only TIR. I think we are going to be using everything together in tandem, because honestly, we need everything we possibly have to get our patients to goal.
Yeah, so I also agree with what you say, that TIR is an addition to whatever we are using, and probably it will help improvising the strategies for control. I just want to share a practical point that we do commonly. If I have patients taking around 100 readings in 2 months' time, I tell the patient to see how many times he's been in range. So even that is good enough a practical alternative where we don't have the CGMS and other options. So I think patients are very careful in understanding that 7 out of 10 times they have been in control or out of control. Even that can be translated into a good TIR, I guess. Yeah. So Dr. Chitra, what do you feel in your personal practice? Degludec has something better to offer as compared to the other basals, or you feel they are equal at par in the inpatient setting?
I think the analogs are definitely easier to work with in the IP setting, but of course, cost is a constraint. So whenever the insurance cover is present, we are very likely to choose analog. Of course, we have to be sensitive that IP care, if you're paying out of pocket, can be huge and large. But definitely analogs are definitely easier to titrate. You don't have to worry about hypoglycemia. And you also, I think the dawn effect is much less pronounced when you're using analog insulin as compared to, let us say, NPH. So
And do you find differences in the analogs per se? The basal analogs, you have many in the market currently. Do you feel there is a difference in terms of the basal bolus requirements, the glycemic control, the glycemic variability?
So I think that is a question which is too nuanced to figure out during one IP admission, but I think all analogs would, for that matter, work well. I'm saying this just after I finished speaking so much about degludec being better than glargine, but I think that's a little nuanced. But anywhere you are struggling with, let us say, a Somyoghi effect or Dawn effect, or maybe even in type 1, switching to degludec definitely helps. Like I say, it's the basal insulin that I reach to when I'm struggling with fluctuant sugars, especially with fasting sugars. I would like to know what the rest of the panel thinks. But for where you don't have a specific problem, I think all of the analogs do work just as well.
The best solace I get is when I discharge my patient on a basal insulin and oral drugs. That's the time when I'm more comfortable writing a degludec alone rather than writing a basal bolus. So Dr. Gagan, what is your concept on total control in terms of IDEGAS? Do you think that total control is better when you're using the prandial along with the basal component?
So I think at the outset, I'll say total control is a goal that we are still struggling to find. So we haven't found the holy grail in diabetes care. Even on insulin pumps with partially closed loops, none of our patients who really have glycemic variability are able to get total control. But these innovations are a step forward in that direction. So we know with basal insulin is a good initiation regime, but especially for our population, we are not able to target PPG. So you have to add another insulin or add therapies for PPG control. So an innovation in that direction would be either combining basal insulin with a GLP-1RA in a single formulation or 2 separate injections that we have already on board. And the other option would be combining it with bolus insulin. Now, using 2 different insulins can sometimes be confusing. So if you can put them together in one pen and have the patient administer, the ease of administration acceptance does increase. So I think when we say total control, what we're talking of, what Shaila has highlighted, fasting control, post-meal control, control of A1C, of course, but also controlling the variability. And the time and range has to be in goal. So our idea of total control is going to a more holistic approach, and to add to it, the risk of hypoglycemia should be low. The psychological impact of insulin should also be less.
Okay, so I can't agree beyond this. I think everybody of us will be on the common ground in what Dr. Gagan said. Now, Dr. Shaila, do you feel that in your practice also you find a difference between degludec and glargine? You showed a lot of trial data where both differ. Do you feel that there is a TIR and GV glycemic variability difference between the two?
Actually, I think the long half-life of degludec does have an advantage. My biggest advantage in a city like Mumbai, where people reach home at different times with executive lifestyles, where the biggest constraint of insulin is when you have to more or less have a time constraint when you're taking the basal insulin. The prandial insulin, most of our patients take according to the meal. So if you're using a short-acting or an ultra-short-acting insulin to cover the meal timing, you're pretty sorted out as far as that is concerned. So if you have a basal insulin, which gives you that additional advantage of having that time advantage where, like, for example, if I'm giving degludec to a patient, I tell the patient you can take it any time in the evening hours, whatever time you want to take it, according to your convenience. What I have realized is psychologically it helps my patient a lot. My patient doesn't feel that constrained when I start a basal insulin then. They feel, okay, it's okay. I can take it at any point of time whenever I reach home. So that is quite fine. And it gives me the reassurance that yes, the patient is definitely going to be taking the insulin. So that is one. And the other advantage is sometimes a lot of our patients, for example, if they're doing reasonably well with the bolus basal dose, have this issue of in the night, if their post-meal sugars, if they're monitoring the post-meal sugars, if those sugars are less than, say, 120 or 130, they have this psychological block about taking their basal insulin in the night. So those patients then in situations like where they've not eaten very well, where the post-dinner sugars are a little on the lower side, they're uncomfortable taking, they can also take degludec next day morning. So you have that kind of variability when you're using degludec vis-a-vis the other your insulins. With U100, sometimes I've had the problem with glargine U100 in my patients. There's a tailing off effect by the time 24 hours come on. For example, if you're using it at 10 p.m. in the night, next day by the time it's around 8 p.m., the effect sort of slowly wears off, and I may not get a truly 24-hour control. So there's a limited group of patients where we have been using glargine twice a day also. There are some patients of mine where I have been using glargine twice a day. And those patients now I have shifted them to this once a day Degludec. So there is a certain population where, yes, it does give us a very big advantage.
Yeah, I can see Dr. Unni getting restless, but on quick last question to Dr. Chitra.
No, you have all the time.
Yeah. So last quick question to you, Dr. Chitra, that if you can help us with the indications where basal bolus is recommended in IP and where you prefer using FASP and Degludec into your practice, which conditions?
So I think basal bolus is recommended for all patients in the IP setting. I think that is easy. But I think the faster acting aspart, I think, has a specific role, especially when you're looking at flexibility in your mealtime dosing, right? So if you have somebody who's had a GI procedure or a GI condition going on, if there is chemotherapy which is ongoing, if there is CKD with dialysis, and you're not really sure exactly when they're going to be shifted for dialysis, if you have anybody with liver disease, chronic liver disease, whose intake might not be exactly predictable, I think those would be places where you would definitely like the flexibility of faster acting FASP. I think Degludec, I think Dr. Shaila has covered all the indications why you would prefer it over, let us say, Euglargine or U300.
I think thank you all for that wonderful discussion and answering those questions in the spur of the moment. And over to you, Dr. Unni, for the proceedings.
Well, this was a wonderful session for two reasons. One is I was so happy because Dr. Pankaj Shah from the Mayo Clinic has said that these were three wonderful sessions. And second is, I have been seeing panel discussions, especially symposia where everybody, all are male, and some people are calling this manels, MANEL, all male panels. And this is one panel discussion where all the five participants, all the six participants, Dr. Chitra, Dr. Shaila Sheikh, Dr. Gagan Priya, Dr. Vaishali Deshmukh, Dr. Vedavati Purandre, Amrita Kulkarni, all were women. And that makes me very happy because I think there is a need for more women to come into science. And that's one of the reasons I feel very happy with this particular discussion. And I hope we have more symposia, not because of anything else. I feel that, frankly, I feel women are not just better doctors, but they are also better speakers and men, and they prepare better and they present better. I can't thank Dr. Vaishali enough for staying so late into the evening, and Dr. Chitra, Dr. Shaila, Dr. Gagan Priya, and Dr. Veda, Amrita, Dr. Pankaj Shah, all the way from Mayo, listening to us. Thank you all. It's been a lovely evening.
Thank you, sir. Thank you.
And wish you all ladies a happy Women's Day, and all the men also a happy Women's Day in the family.
Well, I didn't remember. Is this today's Women's Day, is it?
No, 8th March. 8th March.
Oh,
so it's the eve of the Women's Day. So you have more celebrations to come.
Yes, that's great to see.
So thank you so much.
Bye-bye. Good night.
Dr. Pankaj Shah, sir. So we close for today, and tomorrow morning we'll meet at 9 o'clock. Thank you so much.
Thank you.